good morning to you and a very warm welcome. And on behalf of Rainbow Children Hospital, I would like to extend a very warm welcome for you to take out time and making it on this Sunday to be part of this auspicious occasion and moment. I'm Melody Austin and I will be your host for today. So it is our pleasure and privilege to welcome you all to the last day of our 3-day academic feast. And here's a quick recap. We conducted workshops on new neonatal ventilation, sonic workshop, point of care ultrasound, and recent advances in neonatal and pediatric neurocritical care, which took place on the 15th and 16th of July. That was attended by more than 120 plus participants from all over India. So Rainbow Children's Hospital and Birthright by Rainbow is an exclusive women and childcare hospital with a nationwide footprint. Our full-spectrum, consultant-led women and childcare services are driven by 22 years of experience and have transformed the lives of women and children across the cities of Hyderabad, Vijayawada, Bengaluru, Delhi, Chennai, and Visakhapatnam. In Bangalore, we have the state-of-the-art tertiary care pediatric facility across 3 centers in Marathalli, BG Road, and Hebbal that offers pediatric super specialities that includes newborn and pediatric intensive care services, pediatric surgery, pediatric neurology, pediatric gastroenterology, pediatric pulmonology, pediatric nephrology, pediatric hemato-oncology, pediatric endocrinology, and more under one roof. So today, as we start this conference on updates in specialty pediatrics, we're looking forward to learn from some of the most experienced national and international faculty about topics and advances pertinent to child health. The conference has brought the opportunity to network with experts in the field. Over the past decade, the field of pediatrics is on the cusp of transitioning into a subspecialty-led service. With numerous updates in these subspecialties, general pediatricians who are the pillars of child health often find themselves at crossroads while encountering complex disorders. Conference on Updates in Specialty Pediatrics aims to provide clarity on the important updates that have changed pediatric practice recently, with the multidisciplinary perspectives from international and national speakers. We are hoping that this conference will add value to the pediatric practice and ultimately serve to improve child health. And we would like to congratulate the organization committee for curating such an educating and first of its kind academic feast. So on this note, of course, we're going to start off with our very first session, and I want to wish each and every one of you a very informative and insightful day ahead. So our very first speaker, I would like to introduce, of course, needs no introduction. She's going to be on virtual today, and I'm hoping you're going to gain a lot from Dr. Nandana Bala. She's a consultant in pediatric allergy and respiratory medicine at Rainbow Children's Hospital in Bangalore. She's a specialist pediatric training from London Deanery, a consultant at the prestigious Guy's and St. Thomas Hospital in London, Tin Respiratory Pediatrics, and at the King's Hospital, College Hospital in London as an ordinary consultant in pediatric allergy. So we're going to hand it over to Dr. Nandana Bala, and we can give her a big round of applause for starting off our very first session for this Sunday. She will be speaking on the topic, food allergy, is it preventable? Thank you so much. Yes, you are. And Nandana, before you continue, I quickly would like to introduce our chairpersons onto the stage so they can be part of the session as well. And I would like to invite Dr. Dinesh Chirla, Dr. Nanamurthy, and Dr. Shrikant Reddy. Round of applause for our chairpersons for this first session. Thank you. Yes, I'm confirming that you're audible and your slides are visible. I hope that's okay with you.
Absolutely.
Thank you.
Good morning, everybody. Very good morning, chairpersons and everybody in the audience. I'm really disappointed that I couldn't be there in person today because due to unavoidable reasons. But I'm glad that I'm able to do this talk as it's something I'm very passionate about. And I think it's extremely important that all of us pediatricians are aware of this topic. So, food allergy, is it preventable? Let's find out. So I'm going to talk about a little bit about what is food allergy. Is it on the rise, and so why? Can we prevent it? And if so, how? And what is already known? So what is food allergy? It's an adverse immunological reaction to food, and it can be IgE or non-IgE mediated. Now, like other atrophic disorders, food allergies have increased over the last 3 decades, particularly in countries with Western lifestyles. So we're calling this the second wave of allergy epidemic. The first was asthma. And worldwide estimate of prevalence ranges from 1 to 10%. And up to 6% of children experience food allergy reaction in their first 3 years of life. So this is a staggering number. And also of great concern is that peanut allergy prevalence has tripled just over the past decade. Now again, that is a very, very large number. So why bother? So we all know that in India, the incidence and prevalence of food allergy, thankfully, is not very high. So why should we worry about this issue at all? The reason is that developing nations are fast moving towards a Western lifestyle. And peanut allergy is becoming apparent in Africa too, and Asia as well. And while most children outgrow their milk and egg allergy, most children will retain their nut and seafood allergy for life. And this is very worrisome. There is as yet no cure for food allergy. So prevention is all we have. Certainly it is better than cure. So a quick word about health nuts study in Australia. Now, when we look at literature of food allergy, we will see a lot about health nuts cohort. This is an amazing cohort of 5,300 children, and they have been studied for many years now. I think they're coming up to 15 years now. And this cohort has provided us a lot of valuable information. And why are a lot of studies being done in Australia? It's because Australia has the highest prevalence of food allergy worldwide. And they are very keen to understand why this is happening and can they do anything to stop it. So the information we have from the health nuts cohort, they have been publishing pretty much every year since 2010. So I'll just highlight some of the summaries. So 10% of 1-year-old infants in Melbourne, Australia had food challenge proven food allergy to one of the common food allergens. And at 4 years, this prevalence reduces to less than 4%. And we all know that as young infants grow older, they do tend to outgrow their milk and egg allergy. Infants with vitamin D insufficiency were infants who were exposed to cow's milk formula just for the first few days of life and breastfed afterwards were at a much higher risk of developing any food allergies and allergies in general too. But this is a space to watch. So I can't conclude without highlighting the IAP action plan for complementary feeding, guidelines for feeding infants beyond 6 months of age. Now, IAP very strongly recommends exclusive breastfeeding till 6 months of age, and this is really, really pertinent in our country, especially. And this is an amazing resource for us pediatricians and for parents. And this pretty much covers everything. And if we follow this to the dot, I think we are going to stop the food allergy incidence and prevalence in our country from going up. This very much highlights the use of local, seasonal, affordable foods that are part of the family's diet with no restrictions for the mother, lactating mother or the pregnant mother, and pretty much no restrictions for the baby in a form that is easily acceptable for the baby. And there's also a section of regarding food allergy, and I just wanted to highlight this. So what this very correctly says is that consult your pediatrician if you feel that your child is allergic to a particular food. So here, the responsibility and the onus is entirely ours to give the parents the right advice. Unfortunately, we all see that even today, parents are being advised to avoid certain foods because the child has some minor symptoms, be it eczema or coughs or recurrent viral infections. And unfortunately, foods are being delayed or withheld from the child. And it's very much our responsibility to see that this does not happen. Thank you very much for your kind attention.
Big thank you, Dr. Nandana Bala. If you have any questions, we've got mics placed on either side of the light stands. So if you have questions, you could quickly ask her.
Thank you. It's a paradoxical situation where a teacher is delivering a talk and our student is chairing the session.
Thank you, sir. That's very kind of you, sir.
She was my teacher when I did take up the course in asthma and allergic specialized course. It was conducted by through MedTrain, and she's a wonderful teacher. She really spoke very well on anaphylaxis topic. I still remember every bit of it. Of course, today she brought out very clearly about the prevention of food allergy, but it would have been nice if she had included the mechanism of food allergy. Of course, that would have been a different ball game where it needs a lot of time. And in one of her slides, I was a bit worried when she said, mentioned about American Academy of Pediatrics, where it mentioned to avoid tree nuts and peanuts till the age of 3 years, and that really caused a little panic in us. But in our recommendations, as she brought it very clearly with evidences against American Academy of Pediatrics, where early introduction of peanuts or any introduction of the nuts early in life would lead to some sort of a tolerance and also some sort of a desensitization, I would say, and later on they will come up with into tolerance, one. And number two, she clearly stressed upon how the food allergy goes, mainly through skin barriers other than genetic, gastrointestinal tract. So what she clearly mentioned is, if you start introducing through gastrointestinal tract early, they would go for good tolerance. So this is all what I could say about her. And if there are any questions, it's open to house, and she'll be happy to explain. Yeah, yes, sir. Dr. Deshpande, sir, senior pediatrician. Good morning to you, sir.
Ambience and hall and
Volume, please.
Every day we see patients, the mothers are telling, my child is allergic to curds, banana, and a lot of useful things, but especially banana and curds, which we think are the most nutritious. How to avoid this problem, how to convince them?
If you don't mind, actually those are the days when we were practicing for last 35 years, when we would tell from our own experience or our own experience what we have with our own food habits. We would tell the patients to avoid chocolates, we would say to avoid peanuts, we would say avoid some nuts or something other, with our own thoughts, without having any evidences. Now, there is a clear-cut picture to say, and to pick up roughly to what you are allergic, and specifically we can address it. Isn't it, Dr. Bala? You could add more to it.
Absolutely, sir. Absolutely. I completely agree, sir. So unfortunately, lots of advice against, giving certain foods are, given out to parents. And I think partly it is because parents expect it from us. And there is this very much ingrained, ingrained concept in our, parents and grandparents particularly, that there are certain foods which are cold foods and they shouldn't be given to children, particularly during illness. And, really there is no scientific basis for it. So what I practice personally is that, instead of completely antagonizing them, which doesn't go down very well with most parents, is that I just say that if you strongly feel that your child is not tolerating this during the time they have a cold or cough or whatever, don't give it now. But when the child is well, give it, and you will realize that actually nothing happens. The child is absolutely fine. Sorry. And I find that this goes down quite well. And when they realize that they've given it and nothing has happened, they themselves accept. And of course, we have to stress on the nutritional importance of fermented food like curd. So I think if we Indians are very lucky that we have, natural probiotic as a part of our daily diet. And certainly discouraging this, should not be done. In fact, we should encourage the use of natural fermented foods.
Very true. Actually, on often in our office practice, we can never be sure to what you are allergic to. So simply we cannot brand every food as an allergic and tell them avoid so, like what most of our other system of medicine practices. Because if you look into the mechanism of allergy picture, each, especially in food, you have what is called as IgE mediated, you have a cell mediated, we have both IgE and cell mediated, and you have food intolerance. So, and each one has a specific clinical picture. Say if it is IgE mediated, most of them go picture something like anaphylaxis or very near to anaphylaxis. There you have to pick up. So we have to go with the clinical background. Just because a person is food intolerance, we cannot totally avoid it. Maybe if the low quantity, they can tolerate it. See, we are simply depriving the happiness of a child from eating a good amount of nutritious food, or maybe once in a while they want to have some fun, we're missing their happiness, isn't it? So I think we need to be specific. Let us not offhand label any food as a food allergy until otherwise is proved.
Hi, Bala, wonderful lecture. Congratulations. I just wanted to ask one thing, maybe for everyone. See, sometimes when you have this cow's milk allergy, some of these newborns, we introduce them hydrolyzed formula, and these parents come back, and as you know, this is very expensive, isn't it? What's the right time to reintroduce the regular formula? Because that's always a question. They come back. Is it 1 month? Is it 3 months? Is it 1 year? And you have parents coming from different backgrounds, and it can get very expensive for them. Is there a scientific way to approach them, or is it sort of trial basis?
Yes, sir. Really relevant question. Thank you, sir. So essentially what is, so I'm just going to talk on the Indian context. What we used to do, in London, for example, was, a little different. But what I have done since being here for the last 7 years is, kind of adapted that practice into what is practical here in our scenario. So what I do is I stick to breastfeeding as much as possible. And I must admit that in about 99% of the children, I'm able to do that with maternal milk exclusion, complete exclusion, to the extent of no tea, no coffee, no, nothing, even a biscuit with, milk protein in it. I tell them to avoid it completely. And we find that the infants do extremely well if we are able to do that. And very rarely have I then had to switch over to an extensively hydrolyzed formula or anything else for that matter. So sometimes, unfortunately, when breastfeeding isn't possible for whatever reason, I've had a handful of mothers like that, where we've had to go on for extensively hydrolyzed formula. Now here again, I have to mention that a lot of the times people directly go for amino acid based formulas, which are even more expensive and even more unpalatable. And this should be avoided if possible. And the reason being that it is much better that if the child is able to tolerate an extensively hydrolyzed formula, they stay on it. because there is some evidence to show that they are likely to outgrow the cow's milk protein allergy faster than those who have just been given amino acid formula. We will use amino acid formula in very rare cases when they have had the most severe manifestation of the cow's milk protein allergy. And then once we think they're better, we can move on to extensively hydrolyzed formula. Now, this period is a little bit tricky, as you rightly mentioned, Dr. Chirla. So what is proven is that if it is a non-IgE mediated cow's milk protein allergy, which fortunately most of our babies are, it's not usually IgE mediated. Most of the ones we will see in clinical practice will be the non-IgE mediated ones. By the time they are about a year old, most of them have outgrown their allergy. Some of them might still have it. So most of the guidelines will say to avoid any trial of reintroduction of, if you're on extensively hydrolyzed formula, for example, going on to a partially hydrolyzed or a completely cow's milk based formula, not for 9 months at least, or 1 year, whichever is later. So that is the general rule that we will follow.
Just a last question, because in one of the slides I saw that you mentioned about vitamin D3 would prevent, to a certain extent, a food allergy. But of late, most of us in practice, we're using, of course, in urban center, in the, up to 2 years we're using vitamin D3, but I don't know whether we made a difference in not getting food allergy. But are there any good evidence study to support your claim?
Yeah, so sir, so I think you will remember that on this, this was just a part of the health nuts study. The vitamin D is still a hypothesis. So in the health nut studies, what they found is that children with vitamin D, proven vitamin D insufficiency, actually had a higher prevalence of multiple food allergies. So they did not actually prove causality. So it was just, multiple food allergies versus single food allergy. And here we're talking about proven insufficiency. So it doesn't apply to the general population. At least we don't have any evidence of yet to apply to the general population. But it makes sense that, if there is somebody who is vitamin D insufficient, we will treat it. So I think we should just keep it at that for now. But beyond that, at the moment, there is no conclusive evidence.
Thank you, Dr. Bala. And
but very much work under progress, sir, because, it might have a role, yeah.
Thank you, Dr. Bala. As usual, you made a big note for the beginning of the day of this big scientific mela, and thank you again.
Once again,
thank you very much.
Applause for Dr. Nandana Bala. Of course, we'll have to adhere to our time slots. So it was a really informative and insightful session, and thank you so much. I'm sure all of us are going to take back a lot from your presentation. Thank you once again. Before we move on to our next session, I would like to take this opportunity in welcoming each of our chairpersons for our very first session. I'd like to start with Dr. Dinesh Kumar Chirla. He's a member of the Board of Directors and the Director, Intensive Care Services of Rainbow Children's Hospital. He's a highly qualified neonatologist, having vast overseas experience in neonatology. And of course, being the director of the intensive care services, he looks after the administration of both neonatal and pediatric intensive care services, also the national faculty in many teaching programs in neonatology and pediatric critical care. And he has authored several national and international publications. Big round of applause for our chairpersons for this morning, Dr. Dinesh Kumar Chirla. Next up, we have Dr. Nanamurthy N. He's the President, IAP Bangalore from 2011, President, IAP ID Chapter Karnataka 2014, JT Chief IAP Action Plans Coordinator 2018 to 2019, and the CIAP Chief Election Officer 2020. Big round of applause for Dr. Nanamurthy as well. And our final chairperson of our very first session, Dr. Shrikant Reddy P. He has an MBBS and post-graduation in pediatrics in JJM Medical College, Davangere. He's the best outgoing student in MBBS and post-graduation, IAP Andhra Pradesh State Vice President 2022 and 2020, and also the IAP AP State COVID Task Force member. Big round of applause for our three chairpersons for our morning session. We now move on to our next presentation, and I'd like to welcome Dr. Saumil Gore. And he is the consultant pediatric transplant nephrologist, Center of Excellence of Kidney and Transplant in Children, Rainbow Children's Hospital, Marathali. He has multiple publications in national and international journals. He established nephrology services along with renal transplant program at Center of Excellence for Kidneys and Transplant. He's the program director of Pediatric Nephrology Fellowship Program at Rainbow. He has expertise in infant pediatric hemodialysis and CRRT in AKI, CAPD-HT, and transplant in CKD kids. And he has a special interest in congenital anomalies, nephrotic, nephritis, RTA, HUS, CKD, and a whole lot more. Please put your hands together and welcome Dr. Somal Gaur. He's going to be touching upon the topic bedwetting, truth revealed. Thank you.
Thank you so much. Good morning, everybody here, and I welcome once again everybody on behalf of our Rainbow Children's Hospital that we have all braved this Sunday morning and be right there on time and start our proceedings. So after, do I have a pointer? Yeah. Light changer is also. Okay. Right. So, so bedwetting is a topic which is quite close to my heart, and it all started in 16-17. We had started Rainbow in Bangalore at Martha Hurley in 2015. It has been phenomenal 7 years of journey now. And I was seeing children who were sent to our center with bedwetting with the hope of getting treatment, because there was hardly any center in our city, in our state, where these children were getting their due or getting treated in an appropriate way. And then it made me think, it made me to think that, are we going in right direction? What are the lacunae in our approach? What are the treatment strategies available? Are there enough RCTs? Is there any data, research? And I was surprised that not much work has happened in this particular field. I was very happy to hear about all those trials which Dr. Nandana Bala was talking about in food allergy, but it's a very sorry state that not much work has happened globally in this particular topic of bedwetting, and count on me, it leads to unmeasurable suffering in all those kids and their families who are actually down with this. So I'm going to take you on this journey of the truth, which I revealed to myself and was taught to me by those patients only. When I started talking to them, I started learning about bedwetting. I started thinking about the bedwetting in a lateral way, not from our books. Maybe I started connecting more with physics and a lot of non-biological sources. And then I started getting some answers, and then the journey literally began. So we went on and established a small bedwetting clinic, and this truth which I have revealed for myself, I'm going to share with you. It will not be of too much of RCTs, nothing much, but the practical things which I am doing or in our team is doing in our center, and I'll take you on that journey. So the outline of the talk is, what is the magnitude of bedwetting problem in our country or state? Do we really have the data? The next question is, why do we really treat? Why do we have to treat bedwetting at all? Sometimes people may say, there is an annual resolution rate of 15%. That means out of 100 children who are doing bedwetting at 6th birthday, 15 of them will stop by 1 year, one more year by 7th birthday, but 85 will still remain. And those out of 85, again, some will reduce, some will still remain. Who will be those 15%? We don't know. But the suffering continues. So we'll understand, why do we need to treat? What is the right time to start treating? How to treat and how not to treat also I have learned. And where to treat is a very big question. Which is the right place? So let's understand this magnitude of this problem. We look at this case. This was a girl, 15-year-old teenage girl from Davangere, was doing bedwetting every night, was feeling low and sad about this, was hiding secret from her friends and relatives, was avoiding family trips with the family, at night, was using rubber mats at night in bed. And one day the secret came out because one of her friends visited the house and she sat on the bed, she finds the rubber mats, and next day this girl is the talk of the whole school. Very sad. Father incidentally had bedwetting till 16 years and he feels nothing to worry about and he feels that she will improve on her own. So he doubts the evaluation and he feels that do we really need to treat this child? If you look at this another case, this is a 10-year-old girl passing urine every 1 hour, was bedwetting, frequently was finding difficult to travel for long family drives. Every 1 hour she will ask the father to stop the car, I want to pass the urine somewhere. There was complaint from the school also where the school teachers were concerned why this girl is asking to go to washroom again and again. Had met her regular pediatrician for this in 16 and was told to wait for next 1 to 2 years and to see if she recovers on her own. By that time she was already 6 to 7 years. She meets again her pediatrician and this time he thinks that this is a psychological disorder because by now the child was withdrawn. The child was not very interactive and was sent to a psychologist. Psychologist did some psychological work and was referred, and he referred the child to a urologist who is an adult urologist who also says, I don't have anything to do with you and refers the child for hypnotherapy. Incidentally, the urologist also told them to go and meet an endocrinologist as he suspects polyuria. And endocrinologist was with us at that time. Dr. Kavita Bhatt was there with us. She rules out all the endocrinal causes and then finally she refers the child to us. So this was the journey of this unfortunate child. And if you look at this bedwetting diary, this is what the performa which we fill. This child was doing bedwetting 4 to 5 times per week and was even on diapers. She was keeping a secret at heart. If you look at the right side, she had developed psychological issues, low confidence, was feeling ashamed, was keeping secrets, but she was somehow living. This is the magnitude actually. But this is a magnitude individually, right? This is a suffering. But how about the data? If you look at the data, there's a worldwide prevalence of enuresis between 6 and 12 years. It ranges from 1.4% to 28%. It's a wide number. We don't have accurate data because most of the people do not come out in open. They keep it silently to themselves. Even right now, if you do a school survey, there will be children who would come out, who would be doing bedwetting, and no medical attention they are being offered. So they don't get captured. The prevalence in India in these studies which came out by Solanki et al., Srivastava et al., D'Souza et al. Was roughly between 7.6 to 16.3, and I can round it off to 10 to 12%, which is quite a big number. That means 1 in 10 child could be having bedwetting in the schools. And surprisingly, they found that higher prevalence was there in rural children than urban children. Could it be because the urban children want to keep the secrets more or they don't want to discuss out in open? That was one of the confounding factor there. So having understood the magnitude, let's try to understand how do we define bedwetting. So it is defined as enuresis, primary enuresis and secondary enuresis. Primary enuresis is if a child is doing bedwetting more than 3 times a week for 4 consecutive weeks. And the child has crossed 5 years of age and never had previously been dry. Very simple. Sometimes, like last week, I had a family who came to me with bedwetting. They were very sensitive. And they came to me with a bedwetting of once in a week. That made it 4 times in a month. And I told, I think you wait it out, you will be all right. But otherwise, if it is more than 3 times a week, these children need treatment. And secondary enuresis is very simple. A child which has been previously continent at night, but now has developed since the last 6 months. So these definitions are very important for us because we have to filter out whom to treat and whom we don't have to. So why there is a need to treat bedwetting? And as I mentioned earlier, it leads to low self-esteem and confidence. They avoid night travels, they keep secrets. Big children have to wear diapers. Imagine an elder child who is 10 or 11 years of age is wearing diaper, while the younger brother who is 4 years or 5 years of age is diaper free. The whole family ridicules this, sometimes that's the seniors in the family do not understand that this is a medical issue and the child is pounded every day morning Why you did not wake up to pass the urine? Why you are so lazy that you keep sleeping whole night? You make your mother work hard. Every night she gets up twice to change your dress, change your bed sheets. There was one father, he was from, I remember he's an IT professional and they are from Bagdogra in Sikkim. And he comes and tells that their shelf life of mattress was just 1 year. Every 1 year they had to change the mattress because of 365 nights the mattress was not getting dry completely and it was getting bugs and all. So these are hidden. All we have to give is our ears to these children, and they are the hidden troubles which they have. So we did a small survey. I mean, this was long time back, I think 4 or 5 months back, and we rolled out a small Google form to various pediatricians across the city, and I'm glad that 46 of them could respond out of their busy schedule. And the question was that, do you feel that bedwetting is a psychological disorder and needs psychological or psychiatric evaluation for cure, and would you end up refer to them? And if you see, around 41% of our colleagues still feel that this is a psychological disorder and these children should be sent to psychiatrists. And it is not true. Actually, untreated bedwetting leads to psychological disorders. And then these children, unfortunately ends up going to psychologists. My basic question is, what psychological disorder would work at midnight? I'm a father of 2 boys. Many times I scold my elder son and a younger one. And then maybe they would have had a bad day in school, bad day at sports, or bad day with me. And then they slept off. Once we are sleeping, there is no psychology operating. It's a subconscious mind. The conscious brain operates the psychology, but not the subconscious mind. So it is not a psychological disorder. And this is what was the first truth which got revealed to me when I started seeing these children. And then it changed the practice for me, where no more psychological treatment for such children. So rather, as I have emphasized earlier, this is what happens. They cry in their hearts and then they become psychologically withdrawn. So bedwetting gives rise to psychological disorders. It is not that psychological disorders give rise to bedwetting. So let's talk to them, empathize with them, give them confidence and belief, and become their hero. They really look up to us. They need our help. And we should promise ourselves that we will be looking in a little scientific way from now onwards. So next question is, what is the timing of onset of, treatment of bedwetting, right? I missed that word, treatment. Again, did the same Google forms which we had sent, and we got the responses. And we found out that 73.9 or 75% rounded off children of our colleagues, pediatricians, feel that I think after 5th birthday, the child needs some bedwetting treatment. While 1/4 of us still believe, I think we can wait it out. Then we analyze what would be the appropriate age. If not 5, what is the age at which you would want to treat? And if you see, around 63% of them feel 5 to 7 years they should be started on treatment, which is very correct. But still, a sizable number, 1/4 of our colleagues feel 8 to 10 years we can wait. But please understand, by 8 to 10 years, the psychology is developing. The more we mate, the more we are hurting their self-esteem and self-confidence. Surprised to find even sizable number around, if you see in the green, a huge number is still there who believe that we can wait till their teenage life among us colleagues before we treat the bedwetting. So this was a review article which is the only article which is available, which is published by International Children's Continence Society. And the truth in their article is not most of the truth which I believe, because this was not constructed on some RCTs. There are no RCTs, no well-designed studies, but still they end up in this statement, they mention that active therapy is recommended from the age of 6 years. So at least for us to understand that 6 years is a cutoff. 5th year you meet a child, fine, you can wait it out for 1 more year. By 6th year, children should be moved forward for some sort of treatment. And what is the aim of treatment? Currently, as per the ICCS statement, they mention a child who we have to achieve a consecutive a period of fortnight or 14 dry nights when the child is completely off bedwetting. And then we can announce this child to be cured. But the truth is, this may not be correct. Children who have temporarily responded in those 15 days may relapse again, and I've seen this in the last 4 years. I'm sorry, I'll take 5 minutes more. Right? Please give me time. Now I'm in a flow and I won't stop. Right? Okay? So absolutely dry nights. And this is what is the aim which I have kept for the children in our bedwetting clinic. Absolutely dry nights, undisturbed for the child and the family. That means nobody is waking up the child. The whole family sleeps is the aim which I chase, lasting for at least 60 nights on treatment and even beyond after stopping the treatment. That is the set of standards which we have kept in our bedwetting clinic, and then we declare somebody completely cured. And how do we evaluate? We evaluate them by very basic history, anthropometry, to rule out that there is no underlying CKD, because if they are very short height, CKD can give rise to nocturnal polyuria, nocturia, and they can mimic bedwetting. Family history should be taken. We should examine the genitalia to rule out the secondary causes of bedwetting. CNS examination is very important, just to be sure that you are not missing out any neurogenic bladder. And basic evaluation include bladder diary, ultrasound KUB, urine routine, sugar, protein, and specific gravity, just to rule out any underlying diabetes. I had one child out of many very recently who presented to me with bedwetting, and he came out to be, he was a 6-year-old child, and he was actually diabetic. A baseline RFT, electrolytes, and fasting blood sugar. And please understand that uroflowmetry, urodynamics are not required routinely. Only if we feel a child is having neurogenic bladder, we need them. This is a bladder diary of the same child from Davangere. And if you see how beautifully she has made it, she was passing urine at lower volumes, 75 ml, 60 ml, 100 ml, multiple times. This is very low capacity bladder. And hence the void volume calculation turned out to be only 30% of expected bladder capacity. This was a sign of detrusor overactivity, and then the diagnosis of overactive bladder was made in this child. So this child at 15th birthday was living with an overactive bladder, which was giving rise to bedwetting, and hence it was an untreated case of bedwetting. So ultrasound evaluation is very simple. It's non-invasive. We have to check certain volumes. We are working on a new volume, we call it as first bladder sensation volume. There is no data available on this, and we are doing our analysis. We will soon have our data, how this volume helps us. And we have to ask specifically from the radiologist about these volumes. If you just send a child with an ultrasound to a radiologist who is having bedwetting, he will just do some numbers and send it back to you. If you don't ask them, they don't do it. I am just getting it done because my wife is a radiologist and somehow I have tuned with her. So I'm lucky. But if you don't ask, they don't do it. So how do we proceed? Again, the same data. So we asked that what is the appropriate treatment strategy for bedwetting in your practice? 62% of them felt in the purple color that evaluation-based combination therapies would be better. However, 9.4% felt we will directly start on desmopressin. Some around 28% of felt only I am happy with alarm therapy and behavioral and motivational therapy. I'm going to give the child some motivation, stars, don't pass the urine at night, and thinking that the child will not pass the urine at night. And then there was some discomfort among our colleagues that they feel that pharmacotherapy is not very effective, and they feel that motivational and behavioral therapy is still okay. If you see, the opinion is divided, 58 versus 41%. So let's understand what are the treatment options. And these are all enumerated in O.P. Ghai, in Nelson, in all the textbooks. But the reality is, when we start using them, the reality comes a little differently. So we all know about alarms, motivational, conditioning therapy, and some hypnotherapy. And we have pharmacotherapy in the form of ADH supplementation like desmopressin, anticholinergics like roxabutanine, solifenacin, mirabagrone, and then this is imipramine, which is something which I'm very uncomfortable with, antidepressant. So we have combination therapies also, where the combinations of enuresis alarm, bladder training, and motivational therapies have been rolled out, and combinations of desmopressin and anticholinergics have been rolled out. I'm going to discuss in 1 minute about that. And then one more truth evolved to me as I was going in this journey, that I started thinking, what is the moment, it was just a similar feeling I had one day, which Mr. Newton or Mr. Archimedes had years ago. What is the truth of this alarm therapy? We are all fascinated. It has been ingrained in our learning, alarm therapy. First thing what we tell is alarm therapy. But what is the truth? So let's connect to the evolution. And even on that evolution phase, we husbands were being dragged by our wives. But still, we have to understand that the brain is the most important organ of our body, apart from heart. We have to sleep undisturbed from 9 p.m. to 7 a.m. approximately. We are all programmed to sleep completely. And when we are sleeping, some organs don't have to disturb us. What are those? One is our urinary bladder and one is Mr. ADH. They need to cooperate to ensure that we survive well the entire period of our sleep, because we have to be wide and awake next day morning. So ADH has a circadian rhythm which comes at night. It gives signal to the bladder, to the kidneys, not to make the urine. And then we survive the whole night because there is no waterfall effect. But what happens to the bladder? The bladder has to have an enough capacity so that it keeps collecting the urine the entire night and we survive the whole night. So if we look at from this scientific angle, there is a moment of truth which awaits, we have to think about the reality check on alarm therapy. Is it physiological to break the sleep 1 to 2 times at night for a child? Is it justified when by evolution we are programmed to sleep the entire night? Wouldn't lead to lack of concentration in the morning, because it does happen. I see children who say that I was woken up 2 to 3 times a night, I'm not getting proper sleeps. It is frustrating for parents also. Making the child wake up, dragging the child half asleep in the bathroom. Is it curing the child in reality? We are just preventing the bed sheets from becoming wet. We are not curing the child. And as I mentioned earlier, when a subconscious mind is untrainable, what is the real utility of alarm? It is not physiological. And we all are parents. I have 2 boys and both of them sleep completely night through and through. So work has to happen on this aspect, where we need to understand that we have to have scientific thought process on advising the therapies to our patients and know whether are we really doing justice with them. And this is the last one, that we did analysis, who is the right practitioner to evaluate and treat the bedwetting with children. And you can see the whole lot. Endocrinologists, psychologists, psychiatrists, surgeons, everybody, OBG even. Everybody is treating. And this was a very interesting case where this is a girl who was being, if you see on the right side, was being treated by gynecologists, pediatricians, psychiatrists, psychologists, neurologists, priests in the temple. And that priest tells, I'll give you one bangle, put that bangle on your hand, and then once the bangle gets the shine, you will be all right. She underwent an MRI also on the behest of a neurologist, underwent extensive psychological counseling. The psychologist told, make a brand new house for the child with the colors. The wall colors should be what she likes, and then when she sleeps in those colors of the room, the bedwetting will stop. 2.5 years the child was still passing the bedwetting, sleeping in those. I think this is where, please, do you want me to go, audiences? Yes? They want me to go. Can I continue? Take 1 more minute, right? The house is on my side, right? Okay, so where to treat? The answer lies in bedwetting clinic. So we had a small journey. These are the last 3 slides. So journey of our bedwetting clinic started in March 18. We have recruited almost 152 children till now. We did not find any sex preponderance. Majority had failed alarm therapy, biofeedback, motivational therapy. Nothing has worked. What motivation works at midnight when a child is sleeping? Majority had sense of hopelessness at the time of arrival. And this is a small slide of our data where we had around we had an age group, 63% of children were between 5 to 10 years, 30% of children were between 11 to 15 years, and still sizable number of children were between 15 to 18 years, even low. They were the most aggrieved ones. The most common diagnosis which we had was overactive bladder, 80%. Less number are of primary ADH deficiency. And this is again the moment of truth, because we all are programmed to understand the first treatment is desmopressin, which may not be the case. We need to evaluate each case, find out what is the operating mechanism. And then we had around 12% of children which were having combined. They had a bladder issue plus they had an issue with their ADH levels also. As of now, around 60% of them have been cured. They are at home. 44% of them are still under treatment. Lost for follow-ups, there were 12 of them. 5 children were refractory. I know all 5 children by names. They are still close to my heart. I have not been able to help them. And every day I am thinking about them, what more I can do about those 5 children. An average duration of treatment was around 3 to 9 months, and most of them got better with that. And please understand, none of them were on alarms. None of them. This electronic alarms, that moisture, putting that circuit in the underwear and the child wakes up, this is all non-scientific. There is no science. 1 month later, that child came, and if you see, the bedwetting has completely deleted and she was all right. So what worked for us was detailed history and examination, logical conclusion of the cases with bladder diary and ultrasound, regular follow-ups, continual assessment of response, helping them, soft hand holding, and self-help groups. And this is where the last slide states that there is need to be increased awareness about bedwetting. That is why there is something known as World Bedwetting Day, which is celebrated on the last Tuesday of every May month, every year. We need to have bedwetting clinics in all the medical colleges and institutions at state and national level. Indian Academy of Pediatrics, it is my request to them to please pick it up. It should not be left to lurch. Physicians should enjoy the bedwetting clinic, and trust me, it is immensely gratifying when the child thank you for curing from bedwetting. Thank you so much. With this, I think I had been hunted down, and I won't take much time. Thank you. Thank you, sir.
Thank you, Dr. Saul. He has explained us in detail, and it was a very lucid talk, and because of lack of time. And if at all, still if you have any doubt, because he cleared many points and he brought out, okay, well, last question from Naveen.
Can we take questions on one-to-one? He's around, so because we really need to keep with the time.
Yes.
Yes?
Go ahead.
Thank you so much. And once again, big round of applause to Dr. Somal Gaur. I know you had a lot to share with us. I wasn't hunting you down. I was put on the spot. We need to keep the time, but thank you for that excellent presentation. I would now like to request Dr. Arvind Shenoy, our Clinical Director, Rainbow Children's Hospital, Marathali, to kindly come up on stage and felicitate our chairpersons. I think those cheers can be a little bit more louder. Yes. Dr. Dinesh Chirla. Dr. Nyanamurthy. And Dr. Shrikant Reddy. Thank you so much. We now move on to our next session, and this is going to be presented by Dr. Lavanya Padmanabhan. She is a consultant in pediatric gastroenterology and hepatology, Rainbow Children's Hospital, right here in Bangalore. She has a pediatric gastroenterology and hepatology from King's College Hospital in UK, a consultant in pediatric gastroenterology, the Royal London Hospital in UK, and her special interests include inflammatory bowel disease, pediatric liver disorders, intestinal failure, and nutritional rehabilitation, pediatric liver transplant. Let's put our hands together and welcome Dr. Lavanya Padmanabhan. Thank you.
A very good morning to the dignitaries and all the delegates present here. I'm going to give you a brief overview of pediatric inflammatory bowel disease. What is this condition? How do these children present? And how we manage them? Bear with me a second, sorry. Thank you. So what is IBD? It denotes chronic inflammation of the gastrointestinal tract. It could be anywhere, right from the oral cavity to the anus. And what is PIBD, or pediatric inflammatory bowel disease? Disease that has an onset before 17 years of age is called PID, because there are quite different phenotypic characteristics, and hence this kind of classification. And children who have disease onset less than 6 years of age, it is called VEO-IBD, or very early onset IBD. And the very young age children, less than 2 years of age, unfortunately, if they develop this condition, it is called infantile onset IBD. So as I said, most often, it's quite an aggressive phenotype, very extensive on presentation, and the process continues to evolve over a period of time. So the types broadly classified as ulcerative colitis, Crohn's disease, and IBD unclassified. So unclassified is often a colonic disease where at the outset we can't say this is Crohn's or a UC. So the first picture here, it denotes, sorry, just going back, the first photo shows a colonic mucosa with kind of granular, inflamed, and that is classical of ulcerative colitis. The next two, very badly inflamed, again colon, with a lot of pus and cobblestoning, and this is classical of Crohn's disease. So what is UC? I'm sure we all know this. Just to refresh quickly, it's a disease that affects the colon only, continuous inflammation, circumferential, and it does not cause skip lesions. It's mostly continuous. It's a mucosal inflammation, so it doesn't penetrate transmurally. And in the histology, we don't expect to see granulomas. And these children usually don't have significant oral or perianal disease. And often the presentation is abdominal pain with diarrhea, quite bloody sometimes. So Crohn's disease, this is a condition that can affect any part of the gut, right from oral cavity to the anus, quite patchy disease often. So that's what we call as skip lesions. The inflammation is transmural, and we expect to see granulomas, but it is present only in 30 to 40% of the cases, not all the time. So they are not necessary for a diagnosis of Crohn's disease. And many children do have oral perianal disease, and the problem is sometimes they evolve into complications such as strictures and penetrating disease leading to fistulas and abscesses. So how do these children present? Most of the time, the classical triad that is described is abdominal pain, weight loss or poor weight gain, and diarrhea. But this is not always the case. Only a small percentage will come to you with all of these symptoms. So these two pictures, the first one on the top shows a nasty ulcer in the cecum. To be precise, that's the appendiceal orifice from the inside. And the bottom picture shows a deep ulcer in the terminal ileum. So how prevalent is this disease? As you can see, this world map is colored very differently. So the orange shade that kind of most of the Western world, America, North America, and Europe, here the disease is quite prevalent. Already they have huge numbers on their list. Now most of the Asian countries, including India, shaded yellow, here the incidence is increasing at an alarming rate, accelerated incidence. And most of Africa and some parts of Asia colored green. That indicates the disease is just emerging in these countries. So is it because of still under recognition or under-reporting? or under reporting? We have to wait and see. So when I was just looking at the literature about what is the Indian scenario, it was very interesting when I found this paper. First published case series of chronic ulcerative colitis from India in 1939 in the Indian Medical Gazette. So they talk about 120 cases where they had specific clinical, pathological findings, but they couldn't find a bacteriological cause. And since then, a lot of work is still going on. And in the last 10 to 15 years, we do have a lot of literature coming through, case series as well as studies. So 2005, there was a small case series from the south of India, and that was the first published literature about Crohn's disease in children from India. So they talk about 10 cases, and 50% of these children were already treated with ATT, anti-tuberculous treatment, before they were diagnosed. The next published report in 2009, they looked at 34 children, again from south of India, with Crohn's disease, and there was unfortunately a 15-month delay in the diagnosis. So this was a questionnaire-based survey published in 2014, and it was nicely done, including 7 big tertiary pediatric gastroenterology centers, 3 from north of India, 4 from the south. They looked at 221 cases from all of their centers. There was more cases reported from south of India, more of Crohn's disease in south compared to more of ulcerative colitis from the north. So how does this disease evolve? It's a complex interplay of few different factors. An abnormal gut microbiome, or what we call the gut dysbiosis, with an altered immune response by the gut, often triggered by an environmental risk factor and in a very genetically susceptible host. Having said that, the genetics do not play a major role as far as we know so far. Over 160 genes have been reported or identified, and this list is ever increasing. But still, it explains only 1/3 to 1/4 of the disease occurrence in children. So environmental risk factors play a huge role compared to genetics. Genetics is more relevant in the context of children who have very early onset disease, aggressive disease, and children who develop Crohn's disease. So the risk factor increases if both the parents are affected, and the risk also increases if they have an affected sibling. But interestingly, in dizygotic and monozygotic twins, the concordance rate is not very high. It's less than 50%. Some studies report only 20 to 30%, even in monozygotic twins, and it's much less for those in dizygotic twins, and the concordance rate is even smaller, less than 15 to 20% in children with ulcerative colitis. So what are some of the environmental risk factors? Now, I've given a list, and this is not exhaustive, and clearly there is a lot of conflicting literature with regards to each of these factors. So lack of breastfeeding, dietary choices, unhealthy dietary choices, antibiotic exposure, not just in early life, and also repeated courses of antibiotics in future, vitamin D deficiency, that's something that people are looking into in more and more detail, use of NSAIDs frequently, stress, we all know it's a very important risk factor for both pathogenesis as well as in the flares. Smoking, more in the context of adults, but in children we should remember and look for passive smoking. It's a very well recognized and documented risk factor for Crohn's disease. And urbanization, as we all know, the hygiene hypothesis, lack of exposure to the common germs in the childhood, and air pollution, a lot of other factors. Westernization of diet, as Dr. Nandana was nicely describing. So this is just a slide. I'm not going to go through all the pathogenesis, just to highlight some of the pro-inflammatory diets. So omega-3 fatty acids present in some of the vegetable oils, the kind of high sulfur, sulfate containing foods, the processed meats, the food additives, the refined sugars. So these all, either they alter the gut microbiome or affect the immune response of the gut, or a combination of both. So what are some of the protective factors that have been identified? Foods rich in omega-3 fatty acids, like your fish and seafood, a diet that is adequate or having an adequate level of vitamin D, dietary zinc in adequate quantities, they've all said to be protective factors. And most importantly, dietary fiber also. Fiber content from plants and fruits have been said to be really helpful. So how do these children come to us? Now this list again may not be conclusive, and any single child will not come to us with all of these symptoms. It might be one of these symptoms or a combination of few. So we need to have a high index of suspicion and look for IBD. So abdominal pain, diarrhea, chronic diarrhea more than 4 weeks, blood in the stools, weight loss, recurrent fever. That is something I see commonly in India compared to my experience from the UK. So there we don't see much of recurrent fever as one of the presenting symptoms. But here in the last year, I've seen so many children presenting predominantly with intermittent ongoing fever with no other explanation. Oral ulcers, recurrent oral ulcers, perianal disease. 10th compartment of abdomen examination, we all know, is the genitalia, the perineum. Look at the bottom, ask them, adolescents, if you don't want to examine. Look for skin fissures, tags, any abnormal discharge or swelling. Anorexia, fatigue, very non-specific, but this could be the early indicator of a disease that's evolving. And unexplained anemia. And of course, most important, growth failure. If you see a child and who's not growing as you would expect, and you don't find any alternate explanation, look for anything sinister like an IBD. So extraintestinal symptoms, they are again common. Various studies have given different numbers from 20 to 30, 40% incidence. So quite varied also, various systems being involved. The skin can be involved. You could see an erythema nodosum, pyoderma gangrenosum, rarely vasculitis, arthritis, both peripheral axial arthritis, sacroiliitis, ankylosing spondylitis. Eye involvement is more common. Obviously, most of these manifestations are more common with Crohn's disease and some of them with UC. So look for episcleritis or a uveitis, a child coming with a painful red eye. Don't dismiss it as an infection. It could be something else. And hepatobiliary involvement, the gastrointestinal tract and the liver very closely connected anatomically as well as functionally, physiologically. So we often see liver involvement as part of IBD. Renal, it's not very common, but occasionally I've seen a few obstructive uropathies secondary to extensive abdominal Crohn's. Look for renal stones in a child who has got a significant ileal disease, calcium oxalate stones, and an immune-mediated nephritis. And anemia is also being classified as an extraintestinal manifestation in many of the studies. So this is a case just to briefly highlight the importance of having a high index of suspicion. 8.5-year-old girl with history of on and off fever for 3 months. No other symptoms were reported by the family at that stage. She had high inflammatory markers, as you can see, anemic, and her growth was not appropriate, as you would expect. She had a thorough investigation looking for infections, common autoimmune rheumatological conditions, and nothing came back positive at that stage. She had, of course, TB workup. The father had a history of having been treated for abdominal tuberculosis 2-3 years ago. So all that was negative. She was started on colchicine, considering probable periodic fever. A few months later, after stopping the colchicine, she came back with similar history of fever, but this time she has diarrhea and abdominal pain. And now her inflammatory markers have gone up further. Her calprotectin is more than 1,000, and CT shows some significant changes. So we scope her, and this is a picture of the terminal ileum. Nasty ulcers with a lot of pus exudates, and she had a significant inflammation, pan-GI with non-caseating granulomas. And of course, we always send tissue for TB as well, again, which was negative, and that clinches your diagnosis of Crohn's disease. She's now doing well on maintenance treatment. So how do we diagnose this condition? Here comes the problem for the gastroenterologist, because there's no one test that could give you the answer. The Espegan-Porto criteria states, to get an accurate diagnosis, please look at the history, look at the physical findings, look for some basic lab parameters, and definitely endoscopy, what we call as top and tail, both upper and lower GI endoscopy with biopsies, because that's very, very important. And sometimes imaging, especially when you're looking for a Crohn's disease. Most important point, you have to exclude enteric infections, especially in our Indian context. So commonly helpful, very commonly done lab parameters, CRP, ESR, platelet counts, look for nutritional status, hemoglobin. The albumin is a very helpful indicator. It not just indicates nutrition, or malnutrition, sometimes even protein loss in the gut, because IBD is a very well-known cause of protein-losing enteropathy. So look for your albumin, look at the other nutritional markers as appropriate, and definitely infection screen, stool, look for C. diff, the common infections, TB screening, very important. Calprotectin in the stool, it's a very useful non-invasive marker of intestinal inflammation. It does not tell you whether it's an infection or IBD, but it tells you something is wrong with this gut. And other serological markers, they are very low, have a very low sensitivity. So if they are positive, it might help, but if they are negative, it does not exclude a diagnosis of IBD. So this is a nice slide that I always like to look up myself when I have a doubt. So what are the IBD mimics? A number of conditions can lead to chronic inflammation in the gastrointestinal tract, be it granulomatous or non-granulomatous. And they've nicely classified as infectious and non-infectious. So that's why it's important to look at all the other possibilities before saying this is Crohn's disease or UC. So this is again a case just to briefly highlight the diagnostic difficulties, challenges we have. So 9-year-old with fever, abdominal pain, raised inflammatory markers, all the features classical of an IBD. So we did a scope. Unfortunately, we didn't find anything. Both upper and lower looked normal, and the histology also, as expected, mild non-specific inflammation. And to be honest, I was disappointed, parents were equally disappointed because we still don't have an answer. And obviously, before going to this stage, this child had had a thorough investigation looking for all infections and TB, which was all negative. So thinking out of the box, where is this inflammation coming from? Is this child harboring a malignancy somewhere that we're not able to identify? A PET CT, which showed some non-specific inflammation in the jejunum. So what do we do next? Do we do an enteroscopy, do a laparoscopic biopsy of the jejunum because we really need tissue diagnosis? Or do we empirically treat? If we empirically treat, what? Treat as intestinal TB, which is quite common here, or do we empirically treat as Crohn's disease? While we're having these ongoing discussions and family obviously frustrated looking for alternate forms of medicine, we get this report. The intestinal tissue that I sent for TB culture had grown Mycobacterium tuberculosis. In fact, rifampicin resistant after 4 weeks. But the preliminary AFB staining, tissue gene expert, and all that we could do, everything negative. So very fortunate that we got this report. This child is now on ATT, doing really well. So this is just an interesting study published 2 years back from one of the tertiary pediatric gastro centers from our country. They had looked at a lot of features of all their children diagnosed IBD from 2001 to 2016. And one interesting point that I found, intestinal tuberculosis is rampant in developing countries, and obviously it's a great mimic. So with all the battery of investigations that we could think of and do, we may not be able to differentiate. Just a minute. And most of the time empirical ATT is started, but fortunately with increasing awareness, use of empirical ATT is significantly coming down, and that is something we have to bear in mind. So how do we manage this condition? It's a lifelong condition with remissions, exacerbations, so that's something the family needs to understand, and you've got to support them throughout their journey. A number of drugs that I've mentioned here, and it's beyond the scope of discussion today. So what is the long term? Of course, the first question we would face is a worry about medication side effects, but you look at the number of complications, and these are just a few that I've listed. There are a number of others that I couldn't incorporate in this slide. So it's always about how you maintain a normalcy, both in their physical health, mental health, and their social life. So my take-home message is, IBD is certainly not uncommon in India. Incidence is increasing in an accelerated way, and we are recognizing, diagnosing more. Early recognition is very important. So you get them into remission early. They may not come to you with all the classical symptoms, so have a high index of suspicion and a low threshold to investigate. Fecal calprotectin is a very useful non-invasive marker you could do in the periphery. It's important to exclude enteric infections, and most of the time, by the time they come to us, they've had several courses of antibiotics and nothing has worked. And please avoid empirical use of ATT when you've got a strong suspicion. Please investigate. Thank you.
Nicely elaborated, madam. Nowadays, we are seeing on and off IBD cases also. Last year also, I have seen one case presented with fever. So we should think about IBD. Previously, we used to think IBD is for adults only. Now it has come to pediatric population also. We should think over about this. Thank you very much, madam. Any questions?
We'll keep the questions for later. Dr. Lavanya will be around, so you can have a one-on-one with her. Thank you so much for that excellent presentation. And big thank you to our chairpersons. Request you all to kindly take your seats right in the audience. Thank you. We now move on to our panel discussion, and I would like to welcome on stage our moderator, Dr. Rakshay Shetty. He's the Head Pediatric Intensive Care Services Academic Director, Department of Pediatrics, Rainbow Children's Hospital in Bangalore, also the founder of PediStars India. He's been the past Board of Director, International Pediatric Simulation Society, IPSS. He's been awarded the Fellowship in Point of Care Ultrasound by American Ultrasound Leadership Academy. He conceived and conducted simulation workshops across the country. He's the national convener of IAP TIPS workshop, multiple publications in international and national journals, and he has also been an invited speaker in national and international forums. His areas of interest include critical care physiology, critical care sonography, point of care simulation. Let's put our hands together and welcome Dr. Rakshay Shetty, our moderator for the panel discussion, Aftermath of COVID in Children, Long COVID Immune Dysregulation. And of course, I'd like to invite the panelists as well, Dr. Ravi Chander, Dr. Raghavendra Kumar, Dr. Nagbhushan, Dr. Satish Kumar, and Dr. Karthik N. Going to hand it over to you, Dr. Rakshay Shetty. Thank you so much.
So, good morning, everyone. This panel discussion is going to focus on after effects of COVID. So, can we switch on my slides, please? So many of us, over the last couple of years, have heard a lot about COVID, and we've had 3 waves. And now the question comes, as pediatricians, as someone who takes care of children, what are its long effects? I mean, we all know about MIS-C. We all have heard about it. And we all have heard about what are the acute effects of COVID. And the one most common post-COVID symptom problem we have heard and we have managed has been MIS-C. But is it just limited to MIS-C? Does it have anything beyond MIS-C? We have heard a lot of adults who have suffered COVID to have long COVID symptoms, and that has contributed to a significant amount of morbidity. So today, what we are trying to discuss in this panel discussion is trying to address those concerns which are not commonly addressed. So let's look into what are the complications which have been reported in literature, and also look at people's own experience after seeing children who have COVID, whether they have had any symptoms like long COVID or other symptoms which could be attributed to COVID. To discuss this panel, I'm glad that we have eminent panelists, Dr. Ravi Chander. Sir is he joined Armed Forces in 1979 as a medical officer. He has served in various parts of the country, including high altitude area in northeastern border of the country. He became a specialist in pediatrics and served in various small, mid-sized, large-sized hospitals in defense forces, and serves currently in MBJ Medical College, and he was a chief naval staff medal for standing first in pediatrics. Thank you very much, sir, for joining for this panel discussion. It's also my privilege to welcome Dr. Nagbhushan. Nagbhushan sir is one of the visiting professors at Rainbow Children's Hospital, Bangalore. He was the national convener for the asthma training module. He was editor-in-chief for Asthma by Consensus in 2011-2019, a national convener for United Airways module by IAP, and has contributed in IAP textbook and Atlas Recent Advances. Welcome, sir. Thank you so much for joining us. It's also my privilege to welcome Dr. Karthik. Dr. Karthik is a pediatric intensivist at Rainbow Children's Hospital, Chennai. He's done his MD and DM from PGI Chandigarh. He has a lot of interest in vasoactives in septic shock, ultrasound in PSU, biomarkers in severe sepsis, and a lot of low-cost innovative strategies. So welcome, Karthik. And it's also my privilege to welcome Dr. Satish Kumar. Dr. Satish Kumar is a professor of pediatrics and consultant pediatric rheumatologist from CMC Vellore. He's done his fellowship at SickKids, Toronto, very reputed place to do a fellowship program in rheumatology. Assistant editor for IJR and IJRD pediatric section, reviewer of pediatric rheumatology and rheumatology journals, and lots of publications in national and international publications. Thank you very much, sir, for joining. Finally, I would also welcome Dr. Raghavendra. Dr. Raghavendra has done both his MD psychiatry and in child psychiatry and trained from Apex Institutes and is very passionate about child mental health. So welcome, Dr. Raghavendra. So the thing about, we spoke about MIS-C a bit, about how we all know about MIS-C, but what it appears like the effect of COVID is not just related to MIS-C. It sounds like it causes too much of immune dysregulation. And this study, which looked into blood samples of those who are suffering from long COVID, those who are suffering from mild COVID, and then those who had other kind of coronavirus infection, not the SARS-CoV-2. And when they looked at their blood samples, and what they noticed was, in those who had long COVID, they had a persistent immune dysfunction. So they noticed that the interferon levels persistently remain high, and that can remain high as long as 8 months. So it sounds like more and more evidence is coming that the dysregulation is not just limited to MIS-C. It seems like the inflammatory condition can persist for much longer period. So let's discuss with the first case. Now this case is a child who had a pain in the right wrist and a restricted movement. He received paracetamol outside. On day 2, he had fever for 24 hours. Then he became afebrile, had subsequently pain abdomen, vomiting, and the wrist pain resolved. And the blood test done on day 4 in the outside hospital revealed a low platelet count. Dengue rapid done there was negative. He was subsequently had a recurrence of fever, and then again the blood test was done. This time the CRP was quite high at 115. They did a COVID RT-PCR, it came negative. And then he was started on antibiotics, ceftriaxone and amikacin. Subsequently, they got an ultrasound done. It showed gallbladder wall edema and pleural effusion, and the platelet counts were quite low. And he received an STP transfusion there, and subsequently, because of altered sensorium, he was referred to us. So this is the story before he came to Rainbow Children's Hospital. And when he came to us, he was in altered sensorium, quite sick looking. There's a petechia on his left hand, there was edema on the face, and there was reduced air entry. At this point in time, we thought, okay, are we dealing with sepsis, MIS-C, dengue, and rickettsial fever? This was our differential diagnosis. And this was an initial report. His CT brain was normal, ultrasound showed bilateral pleural effusion. And what you can see in this report is ELISA dengue was IgG positive, COVID serology was IgG positive. You can see a high ferritin, high LDH, deranged D-dimer, and elevated pro-BNP levels. And LFT also was quite deranged, and the CRP was quite high with a low platelet count of 22,000. So this is what the summary of this whole patient is. So looking at this conglomeration of issues, we thought, okay, we are dealing with probably one of these, sepsis, dengue, or rickettsial fever, or whether we are dealing with an inflammatory condition like MIS-C or HLH. So he had a very turbulent course. This child was started on 3% saline infusion in view of his altered sensorium, but it was worsening, so was subsequently intubated. He received a pulse methylprednisolone 30 mg per kg. Neuroprotective measures were started. He was worsening renal parameters. We started him on RRT, and then he had a new onset purpura. There was falling hemoglobin and decreasing platelet count. So he was subsequently continued on mechanical ventilation. Because of dropping platelet count, he was started on double volume exchange. He developed hypertension subsequently, then he transitioned to single volume exchange. Methylprednisolone was continued, and few sessions of plasma exchange happened. He received also ongoing renal support therapy. Subsequently got extubated. He was off RRT, off plasma exchange, stable platelet count, and then was subsequently discharged. So this is what his clinical picture looked like, quite edematous and a lot of these purpuric spots. This is something we do see in sepsis. We call as thrombocytopenia associated multi-organ failure because of microangiopathy, a described phenotype. So now the question, I think to both Dr. Karthik and Dr. Satish is, this is something we normally see in sepsis. But what we saw was the COVID serology also was positive. We saw the ferritin levels were deranged. The extent of derangement, what we saw in ferritin levels, generally is not very typical of MIS-C. It's generally around thousands. This was quite more. So question is, was it just purely sepsis and with a TAM of phenotype to start with? Or do we think it was a variant of MIS-C phenotype? Or was this that COVID serology and immune dysregulation changed the manifestation of that sepsis? So just would like to hear, might be from Dr. Karthik and then from Dr. Satish.
So this kind of a presentation we are now seeing off late after this COVID. Like typically MIS-C is described like something which happens in 3 to 4 weeks of COVID infection. But usually we don't get a history of COVID infection in these children, they just land up. And they typically present like sepsis with thrombotic microangiopathy. As intensivists, we treat the pathophysiology and we also look into the diagnosis, we send cultures. If we get something positive, we say it is sepsis. If we are not getting any organisms, we treat the inflammation, which is the pathology. So in this case, that was what rightly done. So whether this is due to COVID-19 infection or it is due to MIS-C is very difficult to practically ascertain nowadays. But we often are seeing that in fact, in my experience, I have seen children with severe thrombotic microangiopathy leading to vascular gangrenes and loss of limbs in peripheral ganglions. And one more thing what we have also observed is, in an era of genetics, sometimes these children, they have an underlying inflammatory condition also. So we have seen cases with the Duncan's disease, X-linked lymphoproliferative syndromes, also presenting in a similar fashion. So it's a very confusing scenario, practically. Attributing it to COVID-19 would be very difficult because it is a phenotype. We can say it is a phenotype which expresses in various pathophysiology which causes a hyperinflammatory syndrome.
Thank you, Rakshay and Chandrika, for inviting me here. So, as Dr. Karthik said, nowadays everybody will be COVID antibody positive. So don't look into that COVID antibody, don't worry about the diagnosis. See as a child as a whole, as a syndrome. What I feel, this child has got definitely dengue, IgM was positive, which was done on the 7th day.
IgG was positive.
IgG was positive. Yeah. On day 3 it was negative. But this child, presented like a typical like a sepsis, went on to something called cytokine storm syndrome. Because here you see Rakesh showed you that this child has received methylprednisolone 30 mg per kg. So instead of making a diagnosis, whether it is COVID induced or dengue induced, see this is what sometimes differ from the ICU person from the general pediatric side. ICU people, Karthik said, use the word, they treat pathophysiology. We treat the diagnosis. Pediatrician or rheumatologist, we treat what is the diagnosis, what is the treatment. So they are given how sick is a child, they gone up to CRRT, they are given plasma exchange. So overall it looks like a cytokine release syndrome. You call hemophagocytosis, secondary hemophagocytosis, cytokine release syndrome, which has incited, whether it is a dengue incited, whether it is a COVID incited, both of things, don't worry about the name. Ultimately, what we need is you see the child as a syndrome and you treat appropriately what this child needs. If you put only a sepsis with DIC, you would have missed this child. The ideal time to recognize when this child is going to cytokine release syndrome, which is shown here by low platelets, high CRP, high ferritin. We have to start treating them with immunomodulation, especially with steroids. If you are worried about that, I am still thinking infection is a more. IVIG is we give IVIG upfront than giving steroids because you still think it is due to infection induced. So don't worry about the name. You see as a child as a whole, as a pattern recognition and as a whole child and treat accordingly.
Okay, so what I gather from inputs from both of you is don't keep worried whether it is COVID-induced, sepsis-induced, dengue-induced. Try to understand what disturbance it has done in terms of pathophysiology point of view. So in this particular case, we know it has caused microangiopathy. And the treatment for microangiopathy, when it's associated with multi-organ failure or progressive organ failure, is plasmapheresis. So treat that, and with the steroids, that will make a difference rather than worrying about this, that, because the specific therapies are not there anyway. So it's more of pathophysiological-based, phenotype-based treatment. Is that right?
Yeah.
Yes.
So this TMA part, I'm not. The child shows any cystocytes in the peripheral smear?
So LDH was high, and sometimes there will be. I'm not.
So renal failure also I couldn't see. It's only 0.8 would create.
So the renal failure was quite significant. He needed a renal replacement therapy for 3 to 4 days. And there was a progressive renal dysfunction with the altered sensorium. And with the LDH, dropping platelet counts and dropping hemoglobin with the rising.
Hemolysis was there?
Yes.
Non-immune hemolysis,
yes,
DCT
yes.
negative? Okay. So again, as I said, plasmapheresis will help even if it is cytokine release syndrome. Plasmapheresis will help if the steroid doesn't work and all other immunosuppression doesn't work.
The only difference in plasmapheresis and cytokine release syndrome, in cytokine release syndrome you have biologicals, like you can treat with biologicals, whereas in thrombotic microangiopathy, you don't have biologicals. Like if there are at least 5 criteria you can get from your routine laboratory reports, the remaining 2 like soluble, complement 5 to 9 and all, you have to send it specifically. But if you have a new onset anemia, new onset thrombocytopenia, elevated LDH, schistocytes, and your child is going in for oligoanuria, then you have to suspect thrombotic microangiopathy in any hyperinflammatory phenotype, and the treatment is plasma filtration.
Yeah.
Because there is no biologicals here. Here, if you want to search for biological, it is eculizumab, which is probably not available.
Yeah, so I think various kinds of disturbance can happen with sepsis. Therapy depends upon the phenotype, whether to use biological or plasmapheresis depends upon the phenotype they present. I'll have to just stop our panel discussion because I think our Honorable Chief Minister is going to come for inauguration. What we'll do is after inauguration, we'll again assemble back and continue our panel discussion. So thank you so much for both of you for answering those questions. So we'll again reassemble after the inauguration ceremony.
Thank you so much, Dr. Rakshesh Shetty. Of course, like you mentioned, we will be back because this is a very momentous moment for all of us, an unforgettable moment when we have our Honorable Chief Minister, Shri Basavaraj Bomme, gracing us with his presence. I would now like to invite on stage Dr. Arvind Shenoy, the Clinical Director of Rainbow Children's Hospital, Marathali, to kindly give us a welcome address and, of course, invite our special guests and dignitaries on stage. Dr. Arvind Shenoy. We request 2 minutes of your patience. We're just waiting for our Chief Minister to arrive. Just 2 minutes. Thank you so much. gentlemen, big round of applause. Our Honorable Chief Minister of Karnataka, Shri Basvaraj Bommai. Thank you so much, sir, for gracing us with your presence. I would also like to welcome Shri K. Sudhakar, Minister of Health and Family Welfare and Medical Education of Karnataka, our chief guest. Shri D.N. Jeevaraj, Political Secretary to the Chief Minister of Karnataka State. And Shri Muri Ratna, Minister of Horticulture. Thank you so much. I would also like to extend a warm welcome to all our dignitaries as well. Dr. Arvind Shenoy, Clinical Director, Rainbow Children's Hospital, Marathali. Dr. Dinesh Chirla, Director, Intensive Care Services, Rainbow Children's Hospital, of course, the member of the Board of Directors as well. Dr. Prakash Vemgal, Director, Pediatric, Rainbow Children's Hospital, Bannerghatta Road. Dr. Rakshay Shetty, Head Pediatric Intensive Care Services, Rainbow Children's Hospital, Marathali. And Mr. Nityananda P., VP Operations, Rainbow Children's Hospital, Bangalore. I would now like to request Dr. Arvind Shenoy to kindly give us the welcome address.
Good morning, everybody, and it is my proud privilege and honor to welcome all of you, and very, very proud that we at Rainbow have amongst us our own Chief Minister of Karnataka, Shri Basvaraj Bommai, and I welcome you, sir, and thank you for gracing this occasion. Can I request Dr. Dinesh Chilra to hand him a bouquet? It is also a very proud moment for me to welcome on stage Shri K. Sudhakar, Minister of Health and Family Welfare and Medical Education of Karnataka. May I request Dr. Prakash Vemgal to honor him and welcome him with a bouquet. I would also like to welcome Shri Muni Ratna, Minister for Horticulture for the Government of Karnataka, and he'll be joining us shortly. Also, I'd like to welcome Shri D.N. Jeevaraj, Political Secretary to the Chief Minister of Karnataka State, and request Dr. Rakshay Shetty to please honor him and welcome him with a bouquet. It is indeed a great privilege to welcome all of you here and also thank our People's Chief Minister for being with us, because the need of the hour is, sir, to go forward just as we have in Rainbow and develop quaternary level care for children of Karnataka, including transplants, complex surgeries, better neonatal care, including newborn screening. So we look forward to you, sir, to not only inaugurate this conference, but also take us forward to the pinnacle of pediatric and women's care in our state. With that, I would like to hand over to Dr. Dinesh Chirla, who will be giving us the address.
Good morning, everyone. Honorable Chief Minister, Shri Basvaraj Bommai Garu. Thank you, sir. Thank you for agreeing to inaugurate this conference. Honorable Chief Guest, Shri K. Sudhakar Garu, Minister of Health and Family Welfare and Medical Education of Karnataka. Mr. Muniratnam Garu, Minister of Horticulture. Thank you, sir. Thank you for coming over. And Dr. Shri D.N. Jeevaraj Garu, the Political Secretary, the Chief Minister of Karnataka State, and all my colleagues from Rainbow Children's Hospital who are gracing on the dais, and all the delegates and the faculties who have come for this conference. Thank you all for this special conference on specialty in pediatrics. If you look at the growth of pediatrics over the last 2 decades, At one stage when we were in a, considering whether specialty children's hospital is viable in the country or not, to now we have come to a stage where each state is having a specialty children's hospital. Sir, our journey has started sort of in 1999. Now we are nearly sort of close to 23 years old. We started with a 50-bedded children's hospital in Banjara Hills in Hyderabad on a Children's Day. From there, now we're very happy to say that we have 1,500 beds in 5 different states with total 14 hospitals across the country. With nearly 1/3 of the beds are dedicated to intensive care. Now, we started our journey in Bangalore in 2016. We started with 1 hospital. Now we have 3 hospitals with nearly 400 beds, and very soon we are going to add 2 more hospitals in state of Karnataka. What we would like to say that at one stage, children were being treated just as part of an adult multi-specialty hospital, and there is a good evidence to say that children's outcomes are better in children's hospital. We have now grown not only doing a tertiary hospital, like a newborn intensive care to pediatric intensive care, where now in 2 of our centers, we are doing liver transplant, kidney transplant, bone marrow transplant. 4 of our centers are doing ECMO facilities. And recently, I think, as all of you know, that Rainbow has gone public. We have issued IPO, which has also shown that the children's hospital are financially viable. What is now is important for all of us to say is that our children deserve a best care. And as been mentioned by Arvind, is that newborn screening test, availability of quaternary care across each state, and there should be 1 quaternary hospital in each capital of each state is what should be a necessity. And that is what is the vision of Rainbow Children's Hospital for future. I thank all the chief guests who have made their sort of time during their busy schedule to come and address this audience. And thank you again on behalf of Rainbow Children's Hospital. Thank you.
Thank you so much, Dr. Dinesh Chirla. We now have the lamp lighting, and I request, of course, our Honorable Chief Minister and our chief guest and dignitaries to kindly light the lamp along with our invocation song by Dr. Pavitra and Dr. Sandeep.
Mahaganapati Shri Mahaganapati Shri Mahaganapati Manasa Smarami Mahaganapati Manasa Smarami Mahaganapati Manasa Smarami Vasishtha Vamadevadi Vandita Mahaganapati Mahadeva Sutam Mahadeva Sutam Guru Gohanutam Mahadeva Sutam Guru Gohanutam Marakoti Prakasham Shadam Marakoti Prakasham Shadam Mahakavi Natakadipriyam.
Thank you so much, Dr. Pavitra and Dr. Sandeep. And now the moment that we've all been waiting for, of course, our logo launch, and I request our Honorable Chief Minister, Shri Basvaraj Bommai, to kindly address the gathering. Thank you.
This side.
Could we kindly have a few words from our Chief Minister, please? Sir, a few words.
ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ಇಂದು ಮಕ್ಕಳಿಗೋಸ್ಕರ, ಮಕ್ಕಳ ಆರೋಗ್ಯಕ್ಕೋಸ್ಕರ ಬಹಳ ದೊಡ್ಡ ಬದಲಾವಣೆ ಜಗತ್ತಿನಲ್ಲಿ ನಡೆಯುತ್ತಿರುವಂಥ ಈ ಸಂದರ್ಭದಲ್ಲಿ ರೇನ್ಬೋ ಹಾಸ್ಪಿಟಲ್ ಅವರ ಒಂದು ನೇತೃತ್ವದಲ್ಲಿ ಈ ಕಾನ್ಫರೆನ್ಸ್ ನಡೀತಿರುವಂಥದ್ದು, ಪೀಡಿಯಾಟ್ರಿಕ್ ಕಾನ್ಫರೆನ್ಸ್ ನಡೀತಿರುವಂಥದ್ದು ಅತ್ಯಂತ ಯೋಗ್ಯವಾಗಿದೆ ಅಂತ ಹೇಳಕ್ಕೆ ಇಚ್ಛಪಡ್ತೀನಿ. ಐ ಆಮ್ ರಿಯಲಿ ಹ್ಯಾಪಿ ಟು ಅಟೆಂಡ್ ದಿಸ್ ಇಂಪಾರ್ಟೆಂಟ್ ಕಾನ್ಫರೆನ್ಸ್ ವಿಚ್ ಈಸ್ ಗೋಯಿಂಗ್ ಟು ಡಿಸೈಡ್ ಪ್ರೆಸೆಂಟ್ ಆ್ಯಂಡ್ ಪಾಸ್ಟ್ ಅಬೌಟ್ ಅವರ್ ಫ್ಯೂಚರ್ ಜನರೇಷನ್. In this conference, Sri Sudhakar, our Honorable Health Minister, and our another Minister, Horticulture, Mr. Muni Ratna, are also present. Sri D.N. Devraj, my Political Secretary. More importantly, the dignitaries are Sri Arvind Shinai, Clinical Director, Rainbow Children Hospital, Sri Dinesh Chilla, Prakash Vemgal, Rakshay Shetty, Nityanand. I recognize all their services and presence on the dais. ಎಲ್ಲರಿಗೂ ನಮಸ್ಕಾರಗಳು. ಲೇಡೀಸ್ ಆ್ಯಂಡ್ ಜೆಂಟಲ್ಮೆನ್, ಮಾಧ್ಯಮದ ಸ್ನೇಹಿತರೆ, ಎಲ್ಲ ಸಂಬಂಧಗಳು ಜನ್ಮದ ನಂತರ. All relations are after the birth. But there is only one relation, which is pre-birth. That is mother and a child. ತಾಯಿಯ ಸಂಬಂಧ ಅದು ಒಂದೇ ಭೂಮಿಗೆ ಬರೋಕ್ಕಿಂತ ಮುಂಚೆ ಇರುವಂಥ ಒಂದು ಸಂಬಂಧ. ಮಿಕ್ಕಿದ್ದು ತಂದೆ ತಾಯಿ, ತಂದೆ ಅಣ್ಣ ತಮ್ಮಂದರು ಅಕ್ಕಂಗಿರೆಲ್ಲ ಜನ್ಮದ ನಂತರ. ಜನ್ಮ ಪೂರ್ವದ ಈ ಸಂಬಂಧ ಬಹಳ ಶ್ರೇಷ್ಠವಾಗಿರುವಂಥದ್ದು. ಇಡೀ ಜಗತ್ತನ್ನು ಸೃಷ್ಟಿಯನ್ನು ಮಾಡಿರುವಂಥದ್ದು, ಜಗತ್ತನ್ನು ಮುನ್ನಡೆಸುವಂಥದ್ದು ಇದು ಸಂಬಂಧ. ದ ರಿಲೇಷನ್ ಬಿಟ್ವೀನ್ ಚೈಲ್ಡ್ ಆ್ಯಂಡ್ ಅ ಮದರ್, ವಿಚ್ ಈಸ್ ಪ್ರೀ ಬರ್ತ್, ಇಟ್ಸ್ ಓನ್ಲಿ ರಿಲೇಷನ್, ಪ್ರೀ ಬರ್ತ್, ವಿಚ್ ಈಸ್ ಸೋ ವೆರಿ ಇಂಪಾರ್ಟೆಂಟ್ ದ್ಯಾಟ್ ದ ಹೋಲ್ ಕ್ರಿಯೇಷನ್ ಈಸ್, especially the human creation has been really taken care there, and the future of our world is also ensured in that relation. ಹೀಗಾಗಿ ತಾಯಿಯ ಸ್ಥಾನ ಬಹಳ ದೊಡ್ಡದು. ಮದರ್ಸ್ ಪ್ಲೇಸ್ ಇಸ್ ವೆರಿ ಬಿಗ್. ಫಾರ್ ಅಸ್ ಮದರ್ ಇಸ್ ಮೋರ್ ದೆನ್ ಗಾಡ್. ಇಫ್ somebody asks me to choose between God and mother, I'll choose mother. Because we have seen, we have felt the love, affection and the care what mother has given us. And it is unconditional love the mother gives. All kind of love and affection comes with certain kind of conditions or certain kind of aspiration. But it is the only mother who gives unconditional love, which is the highest virtue of a human being. Now, having said this, it is a little philosophical. Biologically, physiologically, also it is very equally important. The concept, from concept to creation, conception of a child, from a unicellular to multicellular, to a total creation of a human being, the process is really astonishing, interesting. At the same time, it is really, sometimes it creates a lot of questions, inquisitiveness in our minds. Hence, the role of a pediatric starts from the conception. A lot of people, we think that it starts from the child and child. It's before child. Because what happens during the conception will have the effect on the child at the early stage. In fact, me and doctor were discussing about Dr. Shenoy's certain recommendations for our vision document, where he has mentioned the birth deficiencies, which is so very important, because the conditioning of a mother and conditioning a womb of a mother will decide the health of a child which is going to be born. And once birth takes place, once the umbilical cord is removed, then it's on its own. But what it has brought in from the womb has to be studied. That is very important, because that will decide the health of a child and health of a young person which he is going to become, or a young lady who is going to become. And not only that, that will decide the immune system which it is going to have throughout the life. And because it also decides the DNA combination, that is character of a person. Hence, the character of the person also will have a cascading effect on the health. How a certain persons face a normal cold and how others face it differently. It's so very different. Psychologically, it's so very different. The same cold, the same fever. Hence, it is a very, very, very deep genetic study which is very, very essential. Having recognized all this, it is our bounden duty of the society, of the government, to take care of a mother who is going to give a healthy child. Make mother healthy to get a healthy child. Therefore, I request the Pediatric Council and lot of associations what you have, which normally we consider pediatric means doctors for the children. The pre-birth, what you call neonatal or whatever you call technical term, that has to be included in your pediatrics. Lot of things could have been avoided if the mother is taken care. And they had been taken care, but only at the certain sections of the society. The lower rung of the society is yet to get a nutritious food for the mother and the child too. In this country, highest number of blindness because of malnutrition is in this country. Highest number of deficient born child are in this country because of malnutrition. Right from malnutrition to the right kind of medication, to the right kind of care has to be done. The time has come now to build a very, very strong, healthy society. Yesterday I was addressing trade and commerce meeting. I said that unless until we have got a very healthy society which is educated, then only industry can have a very good skilled manpower. So it is a interlinked. So integration of development has to take place. It can't be in a compartment wise. Right from mother care, mother means family, family means poverty, treating the social needs, bringing an economical strengthening of a family, happiness in a family. Then it gives a healthy mother, healthy child, and healthy child, good education to the good economical activity. So this is the integration of development has to be taken place. And my government is planning, not only planning, we have started implementing all these things in these very lines. We have got a very scientific thinking people in our ministers, in our administrators, and we are forward-looking state, forward-looking government, and I want to assure this conference that whatever decisions you make here will be certainly looked into and implemented for the betterment of the society. Claps. You don't even clap at the right moment. You should have that kind of energy and presence of mind. Otherwise, speaker will not be. That shows your involvement now. I have been speaking, but I don't know that whether it reaches you or not. What we are trying to do is, our MMR and IMR, we are on the watch. Last 3-4 years, our IMR has come down by 2 counts. 2 points. I want this IMR, infant mortality rate, should come to single digit. That is our vision. Single digit. That is our vision. Even MMR has to come down to see that IMR also comes down. Both goes together. So we had made a study and we found that our IMR and MMR not to the mark because of 5-6 districts only. So we have changed in the planning. We have got aspirational talukas now. For the first time in the history of Karnataka, there are aspirational talukas where health, education, malnutrition, and women and child care are the 4 parameters we are checking out. And we are concentrating completely with manpower, with money and infrastructure, and see that all these 5 districts have a better facilities so that our IMR will go to single digit. Exactly the aspiration talukas we have done, and we're going to see that IMR is reduced rapidly, and it will be on the mission mode. It will be on the mission mode. And I seek the cooperation of all the pediatricians, both in the service, government service, and in private services, to join hands with us in this national service so that we can build a healthy future. Similarly, my budget has increased for health, medical education, and we have given a special emphasis for malnutrition. I have not only increased the budget, the governments have got different programs, Poshan and other things. What was given to the severely malnutrited child, I am giving to mediocre, less severe children, the same food and same support systems to get a better nutritious food to all these children. The second one, what we have decided is to see that Anganwadis, where the poor children come, they are fed very well. Not only the children who comes to Anganwadi, there are a lot of children who doesn't come to Anganwadi. They are landless labor children, construction labor children, lot of labor children, where they carry along with them to the workplace. We have seen in Bangalore, a lot of buildings, construction will be there, children will be playing there. So those children will also be given the special food to improve the malnutrition of these children. My government is very, very sensitive government where we see the real problem of health, education and other things because of the poverty. The removal of poverty is in this. And we are trying to do so much for that. We are increasing the school buildings, we are increasing the college buildings, increasing the manpower in education, and we are giving them technical skill training right from high school. We are building a very, very strong young generation in this state. This is a technological driven state. So we need young people, even in rural areas. ಹಳ್ಳಿಯಲ್ಲಿಯೂ ಕೂಡ ನಮ್ಮ ಹುಡುಗರು ಟೆಕ್ನಿಕಲಿ ಸ್ಟ್ರಾಂಗ್ ಆಗಿರಬೇಕು ಅಂತ ನನ್ನ ಆಸೆ. ಅದಕ್ಕಾಗಿ ಹೆಲ್ತ್ ಇಂಪಾರ್ಟೆಂಟು. ಅದಕ್ಕಾಗಿ ಏನು ಈಗಾಗಲೇ ನಾನು ಹೇಳಿದೆ, ಹುಟ್ಟುವ ಮಗುಗೆ ಕೂಡ ಒಳ್ಳೆಯ ಆಹಾರ ಸಿಗುವಂಥದ್ದು ಬಹಳ ಮುಖ್ಯ. ಆ ನಿಟ್ಟಿನಲ್ಲಿ ಹಲವಾರು ಕೆಲಸಗಳನ್ನು ನಾವು ಮಾಡ್ತಾಯಿದ್ದೇವೆ. ಡಾಕ್ಟರ್ಸ್ ಎಲ್ಲ ಅದನ್ನ ಡೀಟೇಲ್ ಎಕ್ಸ್ಪ್ಲೇನ್ ಮಾಡ್ತಾರೆ. ನನಗೆ ಇನ್ನೊಂದು ಬೇರೆ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಹೋಗಬೇಕು. ಬಟ್ ಐ ರಿಯಲಿ ಕಾಂಗ್ರ್ಯಾಚುಲೇಟ್ ಎವ್ರಿಬಡಿ who is organizing this thing. Is a need of the hour. So you have thought well. Please have a good discussion, come out with a good solutions. Be a part of solution. Problem everybody knows. But we have to give more time to the solutions. Be a part of the solution. And all of us will decide to play. See, in playing games, there are two ways. Playing games not to lose is one thing. Playing games to win is another thing. Let's play to win this game. Win over all the health challenges of the pediatric children. Therefore, ultimately, the whole life is Tayi Garbhadinda Bhu Garbhadavarigu. That means from mother womb to mother earth womb. The whole life is this. So in between what we do, we will leave the footprints which will decide the future generation. So thank you very much for all the experts to think about the future of generation. Thank you so much, and thank you for inviting me. All the best to this conference.
Let's give a big round of applause for our Honorable Chief Minister, Shri Vasudha Rao, for some real positive words, positive news, and thank you so much. I'd like to welcome back Dr. Rakshesh Shetty on stage for our panel discussion to be continued along with all of our panelists, Dr. Ravi Chandra, Dr. Raghavendra Kumar, Dr. Nagbhushan, Dr. Satish Kumar, and Dr. Karthik N. Thank you.
Discussion.
All right, so we'll just continue with our panel discussion. So we had a case discussion, the first one, where we had a child who was quite unwell, progressive multi-organ failure, had a thrombocytopenia, was also COVID serology positive. So we wondered if that has anything to do with the presentation of sepsis. And we spoke about choice of immunomodulation therapy in this kind of situation. So we'll move on to the next case. Now this case is about a 13-year-old girl who has fever for 3 days, headache, neck pain, shoulder pain 3 days back, which lasted for 3 days, and then had a vomiting and abnormal movements. So the child essentially had 2 episodes of seizures. One lasted for 1 minute, other for 5 minutes. There was a lot of frontal headache, neck pain, shoulder pain. There was no photophobia, and there were a couple of episodes of vomiting. This lasted for around 3 to 4 days. So there are family history. There was a history of tuberculosis in the mother 10 years ago. She received treatment for 6 months, and at that point in time, INH prophylaxis also was given. So she was in altered sensorium, had a primary neurological dysfunction. There was some amount of neck rigidity. Koenig sign was positive, and seventh nerve palsy. And this was a lab report. So what we can see is the CSF does show evidence of meningitis. So when we did a CT scan, what we found was there was multiple necrotic lymph nodes in the lungs, and that was suggestive of tuberculosis. The head CT fortunately had a mild edema, but no other problems in the head CT. And when you look at these reports, there has been a lot of increasing incidences, at least reported in the newspaper and literature, saying that the tuberculosis incidence seem to have increased post-COVID. So this is something I just want to ask our panelists, and I think just want to know from all of you who've been practicing pediatrics, have you seen any rise in tuberculosis incidence post-COVID pandemic?
To answer your question, Dr. Akshay, let us look at the background. When COVID came in, tuberculosis was put to the background for two reasons. Reason one, there were lockdowns, so people could not go to the hospitals. And two, the gene expert machines that were used for the detection of COVID were all for TB were all taken for the COVID pandemic. So two things happened. Number one, new detection of TB cases could not be done. And number two, those children who were on treatment for TB might have had a break in their treatment pattern. And the same thing happened with adults. And let us see what has happened now. When you look at this problem, we will have to look at it from the practicing pediatrician's point of view, at the level of the hospital and at the level of the referral centers. So I would base my answer on, if you ask a practicing pediatrician to say whether tuberculosis has increased in his day-to-day clinical practice after COVID, the answer is not much. But if you look at it at the level of the district hospitals, and I have taken reference from Raichur, Hassan, and the Indira Gandhi Institute of Child Health, where they feel that the cases have started coming in. The postgraduates had not seen TB cases in the last 2 years, but they are seeing the tuberculosis cases. Is it an increase or an apparent increase? Time only has to tell. And a good referral institute like All India Institute from Delhi, I spoke to Dr. Kabra, and they say they have multiple tuberculosis cases, fibrocavitary tubercular meningitis. All those children are seen much more in the wards than what they would have seen before. Now, what should be our stand as pediatricians? Now, the basic thing would be that we should have a heightened level of awareness to screen for tuberculosis in children who come to us. Who are the two age groups? The first age group is those children who come to us with severe LRI. The second group will be those children who come with the influenza-like syndrome, who have prolonged symptoms. So these are the two groups where we should look out proactively for tuberculosis. Number two, we should also use gene expert much more than what it is. Now, there is a statement in the TB world which says TB anywhere is TB everywhere, which means tuberculosis can spread much more than COVID. Now, what has the COVID pandemic done? It has isolated people. To that extent, tuberculosis would have reduced in its number. But if there was a person with tuberculosis at home, he would have been more risk for children and other people in his own home. So both these are possible. The last point that all of us have to remember is to make sure that we have a tissue diagnosis and a culture. Because it is likely that MDR TB is going to increase now, and therefore in the situations where you did investigate for TB, make sure you also take the sample for culture, because that's the only way you can detect the multi-drug resistant tuberculosis. And the last word about treatment. At the moment, there is no change in the way we are going to treat TB. except that in the National TB Elimination Program, you have a shortened course for TB prophylaxis, 1 month of INH and rifapentin. That's only the change, but there is no other change. The case that you put up brings a very cogent point. TBM occurs in 3 stages. The first stage is the stage of non-specific symptoms. But if you look at the case that you have presented, this is a hyperacute presentation. So should we look out TB in situations where we don't look for TB is another area of focus. Thank you.
Thank you so much, sir. That's a wonderful answer. I would want to ask Ravichandra sir about his opinion on these questions.
Of course, COVID gave its own scenario where we went on to a lockdown and repurposing of CBNet, as was already said, because we wanted something for COVID much more important than this one, and thereby a part of the Eliminate TB program got derailed. Having said that, of the number of cases, we treated almost about 4,000 cases in our hospital, all age groups. Pediatric TB was just about 10% of the whole lot. And in none of the 10% did we get in a case of TB, because most of them underwent an X-ray, most of them also underwent a CT. We did not find and most of my population comes from village. My medical college is in Bangalore rural, serving about 450 villages, not from the gentry population which you expect. Surprisingly, TB was not a major thing. Number one. Number two, of course, many of this in the admitted patients, we used a lot of steroids also. So that's another indication for a latent TB to flare up, etc. Again, we did not. In fact, I can only recount of one patient, aged 15 years, more towards an adult, who had a real severe COVID. She also had, we tried everything except for the fibrosis, which landed up post-COVID. We did not find any evidence of it. Again, the patient was from a rural, poor population only. Now, extrapulmonary cases, did we see? I think we just had one case, non-COVID, of a TB meningitis, which in a medical college I am seeing after almost a decade. Earlier, whenever you go for an examination in any medical college, there will always be 1 or 2 TB meningitis. We have not seen that for the last 10 years. I don't know in your hospital, this one, because a medical college hospital, it is a very common thing to occur. For the first time we saw TB meningitis in our hospital. Of course, it was gene expert proven TB in the gastric aspirate, not in the CSF. So we thought it could be most probably a TB meningitis. Then is COVID going to precipitate TB or make a latent TB become manifest TB? I think most researchers have shown that it did not cause any effect on TB. But in the reverse could definitely happen that a person with TB getting COVID, whether it's an adult or a child, could definitely have a worse outcome. In fact, the mortalities has been found to be higher because of 2 factors. One, of course, TB itself has its own destructive ability on the lung. It also causes a lot of mechanical factors which prevent the normal drainage of secretions, etc. And COVID definitely causes most of the destruction in the lower part and things like that. So the mortality has increased. Now in the post-COVID era, again I am in my hospital, we have not seen any increase in this one of the cases of tuberculosis, either manifest or positive mantos and things like that. As far as its application and treatment is concerned in TB and COVID, one point to emphasize is right through either before COVID or during COVID or post-COVID, there's nothing to stop the treatment in any fashion, just because the patient is very sick or anything. And if there's an interaction between drugs that you're going to use for COVID and TB, in the routine case which comes to us, which is generally the rifampicin sensitive TB, none of the COVID drugs are going to interact. Only if it's going to be in XD or TB, the newer drugs for TB that are going to use may interact with certain drugs which affect the heart. Earlier we had a lot of emphasis on hydroxychloroquine in the first wave. These 2 drugs may interact. Otherwise, both the treatments can go parallel to each other.
Thank you so much for sharing your experience, sir. And it was quite nice to hear from you, Nagbhushan sir. So it appears like a lot of tertiary care institutes have reported increase in incidence. And to share our own experience, we have started seeing quite a bit of TB in all unusual places, intestinal TB, TB meningitis. So that incidence seems to have increased. And like you just mentioned, those patients you said who present like influenza-like symptoms. So we recently had a patient who had fever for 1 week. And then it was not resolving, so they came, and it looked like a flu-like illness. We sent a LRTA panel, and it showed paraflu. And then child also had staph. And then child had a pleural effusion, we tapped it, and because the ESR was high, we sent it for gene expert. TB also came positive. So it was quite surprising. The duration of illness was so short. It did look like a staph pneumonia because we've been seeing quite significant amount of staph and pneumococcal empyemas off late over the last 2 weeks, secondary to viral infections. So these, there was also one patient who had hepatosplenomegaly. We sent GA for AFP because the fever was intermittent for 1 month. The GA for AFP came negative, but then when the culture after 1 month came positive for TB. So it appears like, at least in tertiary care institutes, the incidence of TB seems to be increasing, and also like hyperacute presentation, like what you mentioned, seems to be increasing. And I don't know whether it's because of T-cell dysfunction which can happen and persist post-TB, because it looks like at least with long COVID, the interferon response seems to be getting affected. Whether that is causing reactivation of TB, we don't know. We all thought because of masking phenomena, the TB incidence actually might come down over 2 years, but it sounds like something else seems to be happening. So probably time will tell us whether it's apparent phenomena or a real phenomena. So thank you so much for sharing your experience, sir. So I just want to ask Dr. Satish, because this is something, again, a lot of pediatricians also, and maybe we can ask Dr. Ravichandar and Dr. Nagbhushan also. Have you seen increase in incidences of joint pains and arthritis post-COVID? And also later, last Dr. Satish, if that's what you've seen in your practice too.
Of course, in the number of cases that we have seen in our hospital during the COVID waves and post, we have not come across any of the case of arthritis, though of course literature says they can come with the reactive arthritis, or they can, because of its immune modulation as well as causing autoimmune antigens. In fact, the COVID-19 virus shares almost, causes autoantigens against almost 192 proteins of the body. But we are, at least in my personal experience, we haven't seen any arthritis-like phenomena.
So same thing in our rheumatology clinic, the same things are coming. So remember, any child with juvenile idiopathic arthritis comes, we are not doing COVID antibody to find out whether it's post-COVID or not. So, but I have not seen anything increase, as Sir said, because of this lockdown and all, we stopped seeing a lot of patients. A lot of children came back with flare-up of the disease. All of them had mild illness, COVID, but nothing very specifically saying that to say that inflammatory arthritis has increased. The second question is, apart from MIS-C, the plain Kawasaki disease, what I say plain Kawasaki disease means without any complication. Usually they get admitted under the general pediatrics, treated with IVIG and go home. That number, I was just looking back in our hospital, that numbers has gone high. In CMC, usually we see about 25 to 30 children with Kawasaki disease every year. That's what usually we see. I was looking back last year, it's almost 50. So from 30 to 50, Kawasaki disease children which was not gone into ICU. So we can call MIS-C with Kawasaki disease presentation, but not shock. So those type of children got admitted in the ward, got IVIG, aspirin, went home. Few of them have coronary arteries, exactly what we see. So that numbers have increased. So Kawasaki disease definitely increased. Inflammatory arthritis, I'm not sure because we're not doing COVID IgM for any of those children. And other rheumatological illness, I don't think it has increased after COVID.
Have you seen your the manifestations of routine rheumatological illnesses have changed post-COVID, or it's been the same?
Nothing except the Kawasaki disease phenotype, which has not gone to ICU. That increased, but other things has not.
But that's quite interesting because we also have been seeing quite a rise in atypical Kawasaki manifestation. And surprising, there are a lot of patients who are presenting like TSS, and after a month they have developed coronary aneurysm. So that is something we have not seen before. So those kind of manifestations seems to have changed. Is that similar to places?
These are some of the rare cases. I think last time in a meeting we presented a case from our ICU, presented with HLH, post-COVID, HLH going for almost 3-4 months, long term. The child was admitted, whatever the Akshay showed, the same thing. Multi-organ failure, liver dysfunction, anakinra, plasmapheresis, everything. Finally, that child died. But that child started to like have a MIS-C, but went into like atypical Kawasaki. That child had coronary artery involvement also. So, but prolonged course, we cannot call like MIS-C is usually acute 3 days, 5 days, settles with all the things. This child is 3 months. That type of atypical presentation we are seeing, yes.
Thank you so much, Satish. Now, let's come to the more important aspect about behavioral issues post-COVID. And that is something, 2 years of lockdown, children losing out on their school, being at home, seems to have taken a huge amount of toll on children. I mean, with respect to their development. And I'm sure, I think most of the pediatricians would agree, they've seen a lot of behavioral issues, parents reporting. So I just want to ask Dr. Raghavendra, I mean, has this whole COVID pandemic, pandemic per se and the whole after effects of it, people losing their job, parents being at home, children not going to school, how it has affected overall development? And also, have you seen any rise in your practice behavioral issues being reported post-COVID? And how has that changed across various age groups?
Definitely, there is a huge upsurge of behavioral and emotional issues, and the admixture of behavioral and emotional symptoms are also becoming very difficult. Like usually we used to see kids used to have anxiety issues or behavioral issues, emotional issues or behavioral issues. Now it's a mixture of both we are seeing, where kid is more stubborn, but when we dig deeper, it's the anxiety which is making kid more stubborn. And when we dig much more deeper, there are a lot of family issues which emerge, having lost a near dear one or a friend moving out. So there are several issues which are emerging like that. And definitely the affliction is multifaceted. Physical domain, social and language domain, emotional domain, cognitive learning and motor, all the skills, especially under 5 age group children are very severely affected. And under 5, what I am seeing, there are quasi-autistic signs. The autism symptoms are very, very, very common now. And almost like on an average, I see 8 kids in a day in my OP practice, and minimum 3 to 4 kids I see with quasi-autistic symptoms. And there will be attachment issues, father, mother having inconsistent parenting, father, mother having marital discord, and the kid getting affected, plus mother anxiety and depression, plus these issues, and the kid having symptoms. So it's a very curious admixture which I need to follow up and see, which was not very common prior to corona pandemic. So there is definitely a change in the trajectory of these kids. And what the previous studies used to say was, there were studies in Europe where the kids were adopted and kids who were institutionalized, like in orphanages, they were adopted and studied. They manifested these kind of symptoms. So are these kids being like orphans despite being in families? So it's like a very alarming phenomenon. And imagine these kids in families having these symptoms, and imagine kids who are completely underprivileged in broken families. What about them? So it's really very troublesome and very scary.
Just to add to what Dr. Raghavendra said, for a practicing pediatricians, I'm sure these could be very common issues. The first thing could be feeding issues and obesity. We have seen a lot of children who have become obese, a 30 kg child going up to 82 kgs, and all being at home. Number 2 is speech issues. Only yesterday I saw a girl child speaking like Donald Duck. And she was seeing the Cartoon Network for 8 hours a day. She can speak good English, but she prefers to speak like the cartoon. So speech issues have been there. Number 3, school-going issues. Yeah. Children have been at home. They don't want to go to school. Yeah. Because they have lost the connect, and their parents have a lot of difficulties putting children to school. And the last thing is sleep-associated disorders. Children get up at 11 in the morning, have breakfast at 1 o'clock, and sleep at 1 p.m. in the night. Their sleep rhythm is gone. These are all the other issues that a practicing pediatrician sees post-COVID. And finally, helpless parents. Parents didn't send the children out to play because they thought the child would get COVID. And they were busy at home. They couldn't give time to their children, and they put the children to the screen. And now most children are addicted to the screen, which is a very, very unfortunate thing.
Absolutely, sir. Thank you so much for bringing up those points. So I think in the interest of time, we have a last case, but important one. So this is an 11-year-old girl child who currently got admitted with fever, dengue fever. She had a past history of COVID in 2022. Now, the post-COVID, she's been continuously reporting these symptoms, recurrent belching, increased fatigue, poor concentration, cold intolerance, and a lot of anxiety and anger issues. Now, there has been a family history of hypothyroidism. So when I try to look into the long COVID presentations in children, so there has been a very variable reporting in terms of its incidence because people could not define it correctly, but sounds like a portion of children do get affected, and it appears like more and more you're towards an adolescent age group, the incidence becomes quite similar to what we see in adults. So it sounds like younger children tend to have much, it does happen, it's not, it does not happen, but the incidence seems to be much lesser in younger children. Now, the definition of long COVID, it varies because in CDC says about 1 month of symptoms, WHO says more than 3 months of symptoms, and classic definition of chronic fatigue syndrome means 6 months. So that's typically described with EBV infection. So there have been reported incidents of postural orthostatic hypotension, a lot of dysautonomia. So this is like one study which just shows that just standing and going to supine, how much it can change your blood pressure in some of these children, and they report a lot of fatigue and sometimes even fainting episodes. And a lot of these patients with chronic fatigue syndrome, they seem to have allergic manifestations also when evaluated. And this study says that even if you don't document drop in blood pressure and rise in heart rate, when they did a Doppler of the blood vessels, they saw a significant drop in coronary blood flow. In fact, this study showed almost 30% drop in cerebral blood flow when they actually changed their position. So also the problem with chronic fatigue syndrome compared to a lot of other chronic disease, it's the effect on quality of life. It seems like it makes a significant amount of impact in the quality of life. So this particular patient, when we evaluated for chronic fatigue syndrome and center labs, the child actually had a hypothyroidism for which we treated. So sounds like, it seems like an important problem in adolescent age group. The issue also, I think, a lot of to do with whether we don't know whether it's because of COVID, whether it's because of the lockdown and its impact, but sounds like a lot of mood disorders, a lot of fatigue and headache are the most common symptoms reported post-COVID. So I just want to know from Dr. Satish, I mean, you must be seeing chronic fatigue syndrome with EBV and other viral infections. Have you seen similar kind of pattern post-COVID? And how do we actually, because these are very non-specific complaints and children unfortunately don't repeat those, like an adult are unable to report those complaints. They're always vague symptoms, parents report decreased energy levels. So how do we spot this? How as a pediatricians we should think about this particular problem? How should we evaluate and essentially understanding its management principles?
So this chronic fatigue syndrome, I was also looking into literature. There is reported as 1 to 30% of children who has, especially in the adolescent age group. So, but remember that in India, the data is very lacking. We don't have any specific clinic. I don't know how many of you have specific clinic. We follow all the children with the MISC and all we follow. But specifically children who had COVID, mild COVID, who does not need admission, how of them are really following them and finding out. So this chronic fatigue syndrome in our children, like every viral fever, they'll have 2 weeks, 3 weeks, but here they go for a little more long time, which may be non-specific. But from a pediatrician side of view, as Sarah has told about autism, screen timing, loneliness, speech delay, those are things which is more affecting than the COVID. Actually, we are seeing long COVID due in that aspect than the physical aspect. I think we should able to support these children. Now, I see some amount of general pediatrics in my OPD, and I see a lot of children with autism, not talking, not playing, especially screen time. So I think that part we should more help the patients, children and the parents, and recognizing that it called due to this post-COVID.
Okay. So I think this is a nice infographic which I've just put. It was got published in the Nature journal. I think any one of you are interested in long COVID in children, it's worth reading. So what it says is that the most common changes what we've seen post-COVID in children are mood changes, fatigue, sleep disorder, headache, and there have been some amount of balance problems, cognition, and a lot of high incidence of constipation and abdominal pain. This is something we are seeing also quite often. We really don't know whether it's post-COVID or not, but constipation seems to be in epidemic proportions. A lot of them are coming with intercurrent abdominal pain. There have been reports of exercise intolerance, like we said, POTS, orthostatic intolerance, nasal congestion, ongoing respiratory complaints, and a lot of dermatological complaints. In fact, we had one child who had COVID who had manifested it with DKA to the hospital and subsequently had severe hyperhidrosis and was just constantly sweating for a few months. And sometimes this loss of appetite and altered smell can go on. In fact, we had a new infant who was 3-month-old child, had COVID, and then mother reported the child would just not take feeding. So she is correlating all the symptoms of really poor appetite and loss of weight gain subsequent COVID. So sounds like it does happen. This is something we need to keep a close watch on. And I think time will tell us the exact incidence of the post-COVID manifestations with systemic disease, post-COVID symptoms, and its impact in overall child growth. So with that, I'll just wind up the panel discussion. Thank you so much for all of you taking time and joining this panel discussion. And if there are any quick questions, one or two might be I can take up, and we can just wind up the panel discussion otherwise. Okay? None. Thank you so much. Thanks a lot.
Big thank you to Dr. Rakshesh Shetty for this fabulous presentation. And I now request you to kindly hand over mementos to all of our panelists. Dr. Ravi Chander. Dr. Raghavendra Kumar. Raghavendra Kumar. Dr. Nagbhushan. Dr. Satish Kumar. And Dr. Karthik N. Thank you so much. So as we have to keep up with the time, we are not going to be taking a tea break, so we're going to be continuing with our next session. Before I call upon all our chairpersons for the next session, we do have a photo contest that we're running. So if you looked around, we have a photo booth which is just near the registration counter. So make use of it, click some really nice pictures and put it up on your social media handles, and do hashtag CUSP, C-U-S-P, and tag Rainbow Children's Hospital, because you are in for some really exciting prizes. So make sure that you make the best use of the photo booth, which is just near the registration counter. Moving on to our next session, I would now like to welcome on stage our chairpersons, Dr. Kishore Phadke. He is the Professor, Department of Pediatric Nephrology at Children's Kidney Center, St. John's Medical College Hospital, right here in Bangalore. He's been the former head of Department of Pediatrics, St. John's, and started first DM Pediatric Nephrology, MCI-approved course in the country in 2013. He's the Honorable Fellow of Indian Academy of Pediatrics and Indian Society of Nephrology. In 2007 to 2010, he represented the Asian continent as the Assistant Secretary on the Governing Council of International Pediatric Nephrology Association, IPNA. And between 2007 and 2013, he was the Assistant Secretary General, Asian Pediatric Nephrology Association, and he has also been the member of IPNA's Strategic Planning Committee. Let's give him a big round of applause, and I would like to welcome Dr. Kishore Phadke onto the stage. Next up, we have Dr. Naveen D. Kinney. He has an MBBS, MD, DNB. He's a consultant pediatrician for Bengaluru for the last 29 years. He's been the executive board member, CMIC chapter of IAP in 2021 up to this year. He's the national coordinator, IAP website committee in 2018, and also the faculty in many national and state conferences. Kindly put your hands together and welcome Dr. Naveen D. Kinney. Our next chairperson is Dr. Srikanth BK. He's the Associate Professor, Department of Pediatrics, VIMS Ballari. Nodal Officer in SNCU WIMS Ballari, the State Secretary IAP ID Chapter. He also served as the IMA Secretary Ballari Branch from 2021 up till now. Also the IAP Secretary Ballari Branch in 2013 and 2014. And he's a wildlife enthusiast and a bird photographer. And absolutely love that part about him. And the area of interest is neonatology and respiratory medicine. Please put your hands together and welcome Dr. Srikanth BK. Dr. Srikanth is around? Okay. I would now like to welcome our next speaker, Dr. Srikanth Kulkarni. He has an MD in Pediatrics and DM Neonatology from AIMS New Delhi. He's also a consultant in neonatology, Rainbow Children's Hospital in Maruthali. He has an MBBS from Karnataka Institute of Medical Sciences, Hubli, and MD Pediatrics from BJ Medical College and the Sasson Hospital, Pune in Maharashtra. His career objective is to provide high-quality care to tiny as well as sick neonates and meticulous follow-up of infants. Let's put our hands together and welcome our speaker for this session, Dr. Srikanth Kulkarni.
We'd like to invite Dr. Naveen Kini on stage as the chairperson. Welcome, sir. Okay.
So good morning everyone. So today I will be briefly telling about the influenza seasonality and its vaccination status currently. So before going ahead with the seasonality, so let us see the burden of the influenza in the worldwide. If you see, there are huge number of cases across the world has been reported of the influenza cases. Around 3 to 5 million cases are severe illnesses according to the worldwide. And among them, around 2.9 to 6.9 lakh deaths are due to influenza illnesses. So children contribute majority of this burden of the influenza illnesses. If you take adults, the incidence is somewhere around 5 to 10%, whereas the annual attack rate in children is higher. It is almost 20 to 30%. So approximately 4 people die from influenza every 5 minutes around the world. This is the data from the WHO. So if you see the Indian data from the NCDC, so they have compiled the cases from 2010 to 2021 and published in the year 2022. There are around, in the last 10 years, so reported cases were around 1.6 lakhs. Among them, deaths were around 11,000. But this only represents the tip of the iceberg phenomena. Especially in our countries, a lot of cases were not diagnosed, and many of the deaths triggered by flu were not recorded as flu deaths. And flu deaths not seen, many of deaths are not seen by the medical services. So there could be a huge burden of this flu in our country. So children play a central role in the transmission of infection because they are at risk of developing the infection and transmission because of all the factors, school, a lot of play activities they are involved, their exposure is more. So they are the main role for influenza transmission. So if you see the burden of the influenza illnesses in the school-going children, so somewhere around even the attack rates exceeds more than 30%, especially during the outbreaks in the seasonal. So it is influenza attacks were associated with average 3 days of fever and 5 days of absenteeism from the school. So it also contributes to parental absenteeism from the workplace. So nowadays, I think in the recent past, the children started going to the school post-pandemic. So we are seeing a lot of cases of flu. So many could be due to influenza illnesses. So if you see, there are a lot of similarities between the flu and COVID-19. So there are numerous overlaps are there in the risk factor developing flu and COVID. So there are common complications between the flu and COVID-19. Post complications are also similar, and presentation is also more or like influenza-like illnesses. And there are also reported cases, as in the previous discussion we have seen, there are a lot of reported cases of co-infection with the influenza, para-influenza, and COVID-19. So coming to the seasonality of the influenza, so again it varies across the world. So it has been divided into northern hemisphere and southern hemispheres, and India belongs to the tropical and subtropical countries. So if you see in the northern hemisphere, so the influenza activity peaks from November to March. So but whereas the southern hemisphere, the influenza activity peaks from May to the September. So in our country, it's around year-round activity of the influenza cases are there. So it's somewhere around 5 to 8%, and it peaks in between during the seasons. So coming to the vaccination, so what are the different types of vaccines available for influenza? So it's a whole cell vaccine, whole virus vaccine. It has been replaced because of less increased reactogenicity of whole virus vaccines. So now the split virus and the subunit vaccines are available, and there is live attenuated influenza vaccines are also there. Recently recombinant vaccines are also being available. So commonly in the market from our country, these two are available, split virion vaccine and the subunit vaccine. The difference between two of them is the split virion vaccine contains both the external antigen and the internal antigen, whereas the subunit vaccine contains only the surface antigen and lacks the internal antigens. So they both are free from the reactogenic lipids. So what are is there any advantage of one over the other, whether split virion or the subunit vaccines? So a characteristic I told, the difference between the composition of both the vaccines. So head-to-head trials, there are only limited evidences available. So a few of the studies has shown there is a better immunogenicity with the use of split virion vaccine and better effectiveness as compared to the subunit vaccine, but only it's a limited evidence. The similar reactogenicity profile. There are no significant systemic adverse effects noted with both of the vaccine. That's why there is no preferential recommendation of using one over the other. So if you see the vaccination zone, that's very important. Though WHO is the main thing who are classifying these influenza vaccination zones. So basically it's an evidence-based resource to provide recommendation on which formulation to use and when to vaccinate in the countries. So it's India, it comes in the, as I told already, it's in the tropical Asia zone. So, but there are currently which vaccine formulation to use in the country. So whether it is, because only two formulations are available. One is from the northern hemisphere formulation, other one is a southern hemisphere population. So again, same WHO is collecting the data annually, and they will recommend for the vaccine preparations. So for the southern and northern hemispheres, as per their recommendations, so India should use the southern hemisphere vaccine for its vaccination purpose. They feel there is no evidence to recommend the third category of vaccination. So that's why timings, as I told, the southern hemisphere peak occurs from the month of May onwards. So it's preferable to use the vaccine in India in the month of just pre-monsoon seasons. We should start the vaccination in India. So as per the southern hemisphere recommendation. So, but there is a study published in the year 2015 which has shown that there is a lot of variation in the country. There are states because a lot of few states have seen the incidence is peaking in the month of winters. That's especially in the northern part of our country. So this peak occurs in the month of from November onwards. In the southern parts, predominantly in the monsoon seasons, we are seeing the peak. But still, the recommendation is to use the vaccine just before the start of monsoon seasons. So why does its appropriate timing matters? So because it's very important, because efforts to improve the vaccine effectiveness. As the titers wane over a period of time, so it's very important to give the vaccine prior to the start of our season. So what are the recommendations for the use of influenza vaccine? So again, Indian Academy of Pediatric and ACVIP recommends currently to use the previously there were trivalent vaccines, so it now recommends to use quadrivalent inactivated vaccines to be offered to all children from the 6 months to 5 years of age annually. In the first year there will be 2 doses, after that there is a single dose before the onset of the season. So it should be taken at least 2 to 4 weeks prior to the peak season of the influenza illness. So other age group after the 5 years, if there is a high risk children, so if the chronic morbidities are there or congenital acquired immunodeficiencies or laboratory or healthcare persons in the adults age group and pregnant women, it's required to have vaccination. This is the recent recommendation from the WHO as for the use of vaccine in the year 2022 as per the southern hemisphere. It should contain the H1N1, H3N2 on the of the influenza A, and in the influenza B, it's the Victoria and Yamagata lineage to be there in the vaccine. So they will generally tell the manufacturers to recommend to produce the vaccines with these strains, and then they will take around 4 to 6 months time to produce the vaccines. So dosing, there is a recent update was there to use the uniform dosing of 0.5 ml in all the children's above the 6 months of age, basically because of to improve the immunogenicity, and they have seen the few studies have done, they have shown reactogenicity or the side effects is similar with the use of 0.5 ml. So, but still there are 2 brands the government DCGI approved that use the uniform dosage, but still other brands till they get approval from the DCGI, they can use the recommendation based on the manufacturers. So there are a lot of things with the after the COVID. Many parents are coming and asking to us whether the vaccination with the flu will prevent COVID or anything for the children's, because in the children's the vaccine was not available. They were asking these questions. There are again few studies were there conducted. They have shown that 2 or 3, but these are all retrospective studies. Not much of evidence is available. The odds of testing with the COVID positivity was slightly reduced, and they will require lesser hospitalization and mechanical ventilation and shorter hospital stay after the COVID, this one flu vaccination. Influenza vaccine should be promoted to reduce the burden. So what are the postulates? It says that flu shots can offer the possible advantage of viral interference, preventing children from developing severe infection, or cross-reactivity of immunity between the flu and the coronavirus due to similarity in their structure, induces the bystander immunity. These are the postulates, but still currently no evidence suggests that flu vaccine prevents the COVID infections. So what happened, the influenza vaccination coverage, especially during the pandemic, so whether it has decreased or increased. This is a study from New York. They have shown that this vaccination was increased, but it was among the adults and the healthcare professionals, the vaccination. If you see the children, their overall 5 to 10% reduced the influenza vaccination during the time of pandemic. But post-pandemic, there are a few studies, they're telling that parents are willing to vaccinate against the flu because of increased awareness about the respiratory infection among the parents. So these are the guidelines for COVID-19 and influenza vaccination. Currently, WHO says that, and CDC, even the government of India, they can be co-administered, both the vaccines for COVID-19 and the flu vaccine. There's no, initially they told a gap of 14 days is required, but currently we can administer simultaneously both the vaccines at the different sites. So advantages of flu vaccines, as you know, it reduces the burden of the disease, so reduces the less hospital visits and hospitalization, severity of infection it will reduce, less usage of antibiotics and less resistance, and decrease the healthcare burden of the infections. There are few limitations of these vaccinations. Influenza side effects and all I'm not going to discuss. Few limitations are it's most effective when the circulating viruses are well matched with the vaccine viruses, and there should be minimum gap of 2 to 3 weeks before the onset of peak seasons, and the efficacy is somewhere around 70 to 80%. That's why it is very important to choose the vaccine which has a recommended use for the southern hemispheres, because sometimes the strains are different for the northern hemisphere vaccine and southern hemisphere vaccine. So ideal time is 2 weeks before the onset of the season. In India currently, they will recommend to use pre-monsoon period from May to June. Few states it may be variable. So it is the uniform guidelines. It will recommend during the month of May and June to use the vaccine. There are a lot of awareness activities for the flu, even the government of India, seasonal flu and their vaccine, how to prevent and all those things. Yeah, thank you very much.
Big thank you, Dr. Srikanth. Of course, he will be around if you have any questions for him. Thank you. We move on to our next presentation, and I'd like to welcome Dr. Vasudha Rao. She's a consultant pediatric hemato-oncology Rainbow Children's Hospital in Bangalore. She has an MBBS from KMC Mangalore, MD Pediatrics in Grant Medical College and Sir JJ Group of Hospitals from Mumbai, RCPCH Fellowship in Pediatric Oncology from Great Ormond Street Hospital for Children, London, UK. She's also the member of IAP SIOP CCLG, and her special interests lie in brain tumors, neuroblastomas, and leukemia. So today she's going to be presenting on the topic targeted therapy in pediatric oncology. Please put your hands together and welcome Dr. Vasudha Rao. Thank you.
Hi, good morning everyone. So from the really great discussions in the morning session, we've come on to something a little more heavier. I'm Dr. Vasudha. I'm a consultant in pediatric hemato-oncology at Rainbow Children's Hospital. So I'm sure a lot of you might not really identify with this topic. A lot of my colleagues themselves are very sympathetic towards me. They ask me every day, how do you do this? So that's the reason why we're having this talk. A lot has changed for children with cancer. And I think as pediatricians, we really need to know about it, because in the past decade, the kind of advances that have come up, chemotherapy is really not the only go-to right now. So with that, we'll just see. The topic for me is the future really free of chemotherapy for our children with cancer, right? So I'd just like to point out this slide. So this is one of the outcome slides from St. Jude's in Memphis. And if you can see from 1960s to up to now, the outcomes of most of the childhood malignancies, have improved so much, dramatically, right? Pointing out especially to leukemia, from 4% to 1960 to more than 94%. So that is true also in India. For most of the children, our outcomes are about 80 to 85%, which is a really good number. And with collaborative trials, we are heading more and more into better outcomes. So why are we discussing about targeted therapies if chemotherapy is so good? Unfortunately, for certain diseases like sarcomas, neuroblastomas, which are metastatic, we are still quite stable at an outcome of 50 to 60%, which is not acceptable for any child. And when we treat children with cancer, we're always balancing the cure, which is what we are aiming at, against relapses, toxicities like infections, and late effects. So how do we really get this balance? That's where the role of precision medicine comes in. When we talk about precision medicine, we are including immunotherapy, which includes your anti-tumor antibodies. The most famous you all might be acquainted is rituximab. There are more members to the team, inotuzumab, blinatumomab, which I'll be talking about. Immune checkpoint blockade. So the gentleman who got the Nobel Prize in 2018 for this, and which is being used a lot in adult cancers. Adoptive T-cell therapy, chimeric antigen receptor therapy is the poster boy for the adoptive T-cell therapy. We'll talk about it. Cancer vaccine and oncolytic virotherapy. But one of the also components of precision medicine is the targeted therapy. So the targeted therapy, the most common and the most well-known forms of targeted therapy is targeting the BCR-ABL in your Philadelphia positive ALL. So when we started treating, when the Philadelphia chromosome was actually discovered in 1960, over a period of 40 years, in 1990, we actually had a molecule that could target the BCR-ABL fusion protein. And how did that actually help us? If you can see, this is actually a trial from the American group which compares how children have done if they got a hematopoietic stem cell transplant, which all pH-positive ALLs used to require at one point of time, versus how they do now with a targeted therapy. And if you can see, there is absolutely no difference in their outcomes. So we have come to a point where one of the most dreaded malignancies, it's a pH positive ALL, can be managed with a targeted therapy and with chemotherapy together. But is it so simple like I'm making it sound to be? Not really, especially more so for children. Why is that? Because our children are, we deal with younger age groups, they have immature immune systems. Sometimes we deal with metastatic disease, which is really difficult to address with targeted therapy. We have got privileged sites, especially, leukemia always goes to the CSF and the CNS, which are not accessible by immunotherapy. When you compare to adult cancers, childhood cancers have got very few targetable mutations. And of course, we don't have predictive biomarkers as yet to understand what kind of targeted therapy is working and what is not. So to just give you a practical understanding of when are we using this targeted therapy, I'll just discuss 2 cases. This is a 12-year-old boy, unfortunately diagnosed with B-cell ALL at 6 years of life. Had a CNS relapse at 9 years, almost when he was finishing his maintenance therapy. He received some salvage chemotherapy, CNS radiation was given, and remission was achieved. But unfortunately for him, he came to us with a second relapse at 12 years of age. So what is the, usually the way forward for us would be a hematopoietic stem cell transplant. And luckily for him, he also had a 10-on-10 match sibling donor. But how do we get there? In cases of relapse and refractory disease, the cure is a very difficult thing to achieve. So we may try some chemotherapy, but I don't know if he'll really respond. This child has been heavily pretreated, right? That's when our targeted therapy and immunotherapy actually come into the foray. And few years ago, for this kind of scenario, we usually used to offer palliation, which I'm happy to say now we are no longer, because we have got lots of options ahead of us. So we did a salvage chemotherapy for him, but as expected, he did have residual disease. He did not clear completely. It was a partial response. We tried a targeted therapy called inotuzumab, which targets the CD22 antibody. And lo and behold, with 1 cycle, that's 3 doses of CD22 antibody, he went into a complete remission, and we could take him up for a stem cell transplant. So this is where, right now in India as well, we are trying targeted therapies and immunotherapies for these really unfortunate children who experience relapse refractory disease, where your chemotherapy is really of questionable benefit. So what is this inotuzumab? Inotuzumab is an antibody that is actually conjugated with a cytotoxic component called caliciamycin. It goes and binds to your CD22 receptor on your B-cell leukemias. Almost all B-cell leukemias have got your CD22 receptor. Goes inside and actually damages the DNA of the cell. In really heavily pretreated patients, we saw that almost 60% of the children responded to this. And is this a one-stop kind of therapy? Not really. For targeted therapies, this is kind of a bridge to transplant. So this is where we are today, and I'm saying where we are, even in India, we have got all these options available to treat B-cell ALL. Are we using it in upfront management? Not yet. There are still trials going on to understand how these therapies can be incorporated upfront treatment, but right now we are using these agents actually to relapse refractory treatments, which really have shown very good responses. So for us, for the longest of the time, I think rituximab was our go-to when we spoke about antibody therapy. Rituximab, is an anti-CD20 antibody. It binds to the CD20 on the B cell, and it triggers off a complement-mediated cytotoxicity and kills the cell. So in addition to a lot of your benign diseases like refractory autoimmune hemolytic anemia, rheumatological disorders, we are using it increasingly in high-grade Burkitt's lymphomas. And how has it made a difference, you ask? If you can see the slide, high-grade Burkitt's lymphomas are really, really aggressive diseases, and with the addition of rituximab, there was almost a 10% improvement. And for something as dangerous as Burkitt's, 10% is also quite significant. With that, we come to something called blinatumomab, which in India, a lot of pediatric oncologists are beginning to use. So what is blinatumomab? It is a bispecific T-cell engager. So if you look at the figure, the green parts are the ones that hook on to the CD19 receptor on the B cell, and it also engages the CD3 receptors on the T cell. So in part, it's actually making use of our own T cell to direct them towards the B cell ALL and destroy it. Again, this is just a figure that's showing you. So you see the CD19 on your left side, that is on the leukemic cell. Blincyto is our drug, and CD3 is on the T cell. It binds to both the receptors, forms a perforin pore, there's production of cytolytic proteins, release of inflammatory cytokines, and destruction of the cell. Again, how do we have evidence that it works? So this is again a paper from the US where they actually took a lot of relapse refractory patients. Mind you, relapse refractory are a very, very difficult population to treat. And they took these patients and administered blinatumomab versus standard salvage chemotherapy. And you can again see the difference, 41% in those who received only chemotherapy versus 59% in those who received blinatumomab. What is the silver lining to this? Point number 3, there were fewer and less severe toxicities. So this is where we are beginning to actually use precision medicine more commonly. And coming to the much talked about CAR T-cell therapy, I'm sure all of you have heard it, read about it in the newspapers. So what really is this CAR T-cell therapy? So CAR nothing but stands for chimeric antigen receptor. So basically it is the patient's own T-cells that are genetically modified to recognize certain antigens in the body. In the case of leukemia, the leukemic antigens, they are expanded ex vivo and then they are transfused back into the patient. So this is just a process showing, so there is apheresis and engineering of the T cell. Usually a lentivirus is used to help the T cell to recognize the antigen. Expanded CAR T cells are infused back into the patient, which leads to cell death. So this is the biggest success story. So this is Emily Whitehead. She was 6 years at the time of diagnosis. Similar to our patient, came to her physician with the 3rd relapse post-bone marrow transplant. What it really means is palliation. But her parents took a leap of faith at that time, and with her researchers and doctors at Children's Hospital of Philadelphia, she was the first patient to receive CAR T-cell therapy, and the figure speaks for itself. She is 10 years cancer-free. And that is something that has been a kind of leap of faith for all pediatric oncologists worldwide. You ask, these are all good stories, Dr. Vasudha, but is it available in India? It is right now being, trials have started in TMH Mumbai and IIT Bombay, where they are manufacturing their own CAR T-cell constructs, and they're in phase 1, phase 2 trials. And there are a lot of commercial, pharma companies who are also delving with this. So it's only a matter of, if you ask me, about 5 to 6 years when we will be able to offer CAR T-cells to our patients as well. Is it the same case with pediatric solid tumors? A little more difficult than that, because pediatric solid tumors don't give us this antigen so classically. They don't present it to us in a platter. There are a lot of supporting cells around the tumor cell. So really, how do you target them is the question. And again, like I said, they have a very low mutational burden. So is it a no-no for pediatric and solid tumors? Not really. With this case, we'll understand. So this is a 20-day-old infant who was brought with persistent fever, cytopenias, enlarged abdomen, hepatosplenomegaly, crusted lesions on his body, diarrhea, anasarca, chest CT showed multiple bilateral nodules within the lungs. And as you can see in a CBC, he's got a low hemoglobin, low platelets, low albumin, a high bilirubin, and a high CRP requiring blood product transfusions. So any residents in the crowd, what do you think this is? Anybody? An infant coming to you with skin, multi-system involvement. Any guesses? I heard it somewhere. So yes, it is a Langerhans cell histiocytosis. So here we've got a very sick infant with Langerhans cell histiocytosis, and you send the reference to the oncologist. They say, it's okay, no problem, I'll give steroids and vinblastine. But you get the report which says, your child is actually growing Candida albicans in the blood culture. Would you dare to give steroids and vinblastine for this child with liver dysfunction and a candidal sepsis? So this is again where precision medicine comes in. And in LCH, we have, in 60% of the patients have got a BRAF V600A pathway mutation, and we have got, luckily, BRAF inhibitors. This is vemurafenib, dabrafenib. There are different, commercial names for that. And the child was started on vemurafenib. It is not our case. It's a case borrowed from the internet. But it was started on vemurafenib, and after 10 days, you look at the trend of the albumin and the hemoglobin. Soon it was followed with chemotherapy, and the child was absolutely fine later on. So with this, we come to checkpoint inhibitors. You might have heard Sir James Allison receiving the Nobel Prize, and there's a big hoo-ha about a month ago, 10 rectal cancer patients were completely cured, right? So a lot of us had questions, how is this possible? Why are doctors giving chemotherapy, etc.? So this is where we come to checkpoint inhibition. So we know that normally when an antigen presentation happens to a T cell, you need a co-stimulatory signal as well. So what the tumor cell does is it blocks this co-stimulatory signal with a compound called CTLA4. So the T cells obviously cannot recognize, cannot do anything. But what happens with a PD-L1 and CTLA4, on the top right-hand side you can see, with this inhibition, the co-stimulation is again engaged, and it's a way of telling your T cells, come on, get to work and kill the tumor cells. So in adults, it's being increasingly used. In children, we are using it for, again, relapsed refractory Hodgkin's lymphomas. Nivolumab is being used for that. So this is the how precision medicine actually works in pediatric oncology. We need to make the diagnosis, we need to process the sample, sequencing, tumor board preferably, and then disclose the result and go to the therapy. But as you can see, there are lots and lots of challenges. Can we get the adequate tumor sample? How do we interpret germline variants when we are sequencing? Not everyone is a driver mutation, right? Lack of clinical trials, which will hopefully get better as we go ahead. And the biggest question, which I'm sure is on all your minds, is the cost. And the most important problem is universalization of practice. So with COVID vaccines, we saw what kind of a bias was there, thankfully not in India, with developed countries versus developing countries. So that is going to play a big role for us to access the targeted therapy. Clinically, what are the challenges? Are really the side effects not at all there? Not really. So there are some short-term immune-mediated toxicities. There are cytokine storms that children experience during this time. Durability of responses. So we have achieved remissions, but how far is it sustained is the question. One size does not fit all. So we can't use one molecule and use it for all types of cancers. Long-term effects are largely not known. For example, with immune checkpoint blockade, there are re-emergence of autoimmune diseases. So that is again a big question. And we really don't know as yet if there's a rational combination of chemoimmunotherapies or targeted therapies, and how do we go about it. So back to our question, is the future really free of chemotherapy for children? Certainly has a big role in relapse refractory diseases, malignancies with poor outcomes, dose reduction for reducing the long-term side effects for children. Combination with chemotherapy as of now has shown to show better outcomes. The problems are clinical trials and accessibility, and of course for us the cost as well. So this is my last slide. This is a neutrophil actually engulfing the tumor cells. So hopefully we will get there in the next 10 years and try and match up with our own fantastic immune system targeting the tumor cells. With that I will end my talk. Thank you. If there are any questions, I'm happy to take it.
I have one.
Yes. Yeah.
You didn't elaborate on the cost.
Yeah.
At present, how much does it cost?
I was hoping someone will ask that. Yeah. So for the CAR T-cell therapy in the UK, it costs about 2 to 3 crore Indian rupees. But the silver lining in India is the IIT Bombay, what CAR construct they're making, they're trying to provide it for much, much lesser. So it is about 50 to 75 lakhs. So I know, again, this is like, really unreasonable numbers I'm talking about. But when imatinib, the BCR-ABL tyrosine kinase inhibitor, came into the market, one strip was 1.5 lakhs. And today, almost 10 years down the line, it is 4,000 rupees. So it is just a matter of time. I know cost is limitation for most of us, for our patients, because they all come from poor socioeconomic strata, but it is only a matter of time until we realize, hold more clinical trials and actually prove that these are useful. So yes, it will take some time for the cost to come down. But the drug inotuzumab that we used for one course, it is 7.5 lakhs. And a lot of companies, thankfully, are giving compassionate access programs. They're giving 1+1 free and things like that.
Thank you. Thank you.
There are no questions. Thank you very much for your patient hearing.
Thank you so much, Dr. Vasudha, for that excellent presentation. We now move on to our next presentation, and I'd like to welcome on stage N. Kavitha Bhatt. She has an MBBS from Kasturba Medical College in Bangalore. She also is an MD in Pediatrics from Bangalore Medical College. She has a fellowship in Pediatric Endocrinology and Diabetes from the USA. She's a senior consultant pediatric endocrinology Aster CMI Hospital in Bangalore. She has over 20 years of experience in pediatric endocrinology and diabetes, and she's the program director, Pediatric Endocrinology Fellowship Program. So today she's going to be touching on the topic, the truth behind precocious puberty. Is it really on the rise, and whom to blame? Please put your hands together and welcome Dr. N. Kavita Bhatt. Thank you.
Thanks, Melody, for the kind introduction. And I thank Rainbow Hospital. Actually, it's my home. I built up my career there, a good part of my career, and I'm grateful for it. And I thank Rainbow Hospital for inviting me for this program. Could I have the, okay, how do I change this? How do I handle this?
This is forward and this is back.
Sure. Okay. So, I like this topic very much, the way it was worded. So I will first dwell on the truth behind precocious puberty, and then decide on whom to blame or what to blame. So let's first get to the truth. So I will discuss this topic. The outline would be, I'll just dwell very briefly on the hormones involved in pubertal development and some benign signs which we shouldn't overreact, and when should central precocious puberty be suspected and when should we investigate, and how do we treat it? Is there any evidence for decline in age of pubertal onset? And is that the reason why we are treating more and more children with these medications to suppress puberty? And does this treatment really improve adult height and have psychological benefits in children who show pubertal signs early? So these are some of the topics that I'll cover. So very briefly, the neuroendocrine mechanism for puberty initiation and maintenance is very, very complex. I won't go into that. But basically, it is the pulse generator in the hypothalamus, which the hypothalamic neurons, they secrete gonadotropin-releasing hormone in pulses. Each one of us has a biological age when this gets triggered. This pulsatile release of GnRH causes the anterior pituitary to produce pulsatile release of LH and FSH, the gonadotropins. LH causes testosterone release from the testes and estradiol from the ovaries, whereas the follicular stimulating hormone causes growth in the size of the gonads, as well as ovulation, is responsible for ovulation and spermatogenesis. So if you understand this, we will also be able to get, I'll be just touching on some of the clinical clues as I'm going on. See, we look at, when we see a child with precocious puberty, we look at the ultrasound of the uterus, we look at the ovarian volume. The central precocious puberty is associated with bilateral increase in ovarian volumes beyond 2 cc. So that is one of the criteria, supportive criteria for diagnosis of central precocious puberty. And the reason is behind this physiology of puberty. That is, the gonadotropins act on the gonads, and that's why in true central precocious puberty, you would expect a bilateral enlargement of the ovaries, and the cutoff is 2 cc's, which in turn causes the hormones, estradiol in girls, which in turn causes growth in uterus, endometrial thickness. So these are some of the clinical clues. So it's important to have an understanding, basic understanding of the physiology, not able to be interpret and use our supportive clues for diagnosis. So there are some benign signs, we often get referred, or we often see children, very young children with breast development, say 1 to 3 years. And in most of the cases, this is benign. And we really don't have to do anything much. And another thing I would like to tell you, in this age group, it's very difficult to confirm central precocious puberty, especially in girls, because of a phenomenon called mini puberty. The process of puberty, or the physiology of puberty, is replicated in the newborn, in infancy, and it lasts for about 2 to 3 years in girls. So all these hormonal evaluations may be suggestive of puberty, but still we cannot use that to confirm. So in most instances, it's in 1 to 3 year old girl, breast development is benign. What is said to be very useful is a growth rate, a growth acceleration. Now again, this requires very diligent measurements because growth rate itself is very, very fast in infancy and in the first 2 years of life. So using a growth rate, we have to be very, very accurate. So premature thelarche in 1 to 3 year old girls is quite reassuring, and investigations may be confusing. Pubic and or underarm hair in an adult type of body odor, no breast development constitutes premature adrenarche. It's because of adrenal androgens, which gets activated a little prior to the reproductive axis. Now we also, sometimes we come across infants with some mild pubic hair on the scrotum around the labia. So this is also benign, usually doesn't need any workup unless there is signs of virilization like clitoromegaly. So we really don't need to do anything much about these children. So very often we see overweight children whose parents come with the concern of breast development. So when you make them lie down and ask them to stretch their hands up and you palpate, if you're able to feel the ribs, then it's just lipomastia and it's not precocious puberty, or it's not breast tissue as such. So when should we suspect central precocious puberty? We have all these benign early onset variants. It's only when there is progression, you know, when we see progression, but often in clinical practice, we don't have the luxury to observe progression because children may come a little advanced. So, but we have to individualize our approach. So there is progressive breast development over a period of 4 to 6 months or more, which is accompanied by a rapid growth rate. So it's very important to measure height, accurate height measurements. We measure it ourselves. I mean, it's not even the nurses because most of our children come with growth problems of puberty. Accurate growth velocity measurements, we don't have to wait for 1 year. There is something called annualized growth velocity. You know, you measure the height difference between 2 measurements, at least 3 or 4 months interval, divided by the number of days and multiplied by 365, you get an annualized growth rate. So an annualized growth rate of more than 6 centimeters per year is suggestive of a pubertal growth spurt. And in boys, there should be progressive enlargement of both the penis and testis before the age of 9 years. This is a clue that it could be precocious puberty. Very often, I mean, of late, there are studies that show that certain monogenic causes of precocious puberty also occur, and so it's important to ask for a family history of early puberty. By early puberty, we mean periods before the age of 10 years, or a father who recalls that he had an earlier growth spurt. Of course, we need to ask for history of birth asphyxia or any other CNS issues, head injury, birth asphyxia, or CNS infection in our history while evaluating such children with precocious puberty. Now, what type of evaluation is needed? A random LH. I prefer to do it at 8 AM, though current literature says it's random, of more than 0.3 is considered diagnostic. It's a most sensitive indicator of central precocious puberty. But however, you see in medicine, we always have these however this and however that, and when we are approaching our patients, we have to take a whole lot of things into consideration. However, an LH of less than 0.1 to 0.2 does not rule out the diagnosis. So clinical evaluation is very important. And we make use of all the other things also, like a bone age, which I'll come to later. So GnRH stimulation test may be needed if we think signs and symptoms are suggestive. Estradiol and testosterone greater than 30 is also a supportive evidence. And of course, we know gonadotropin independent of peripheral precocity, you will have very high sex steroids with suppressed gonadotropins. Thyroid testing may be recommended, but if hypothyroidism, severe hypothyroidism can cause pubertal signs, but in such cases, they are growth retarded, they are very short, they have delayed bone age. So bone age is another useful investigation. An advance of 2 or more years support the diagnosis. Most of us read our own bone ages because this helps in deciding whether the child is rapidly progressing. It helps in predicting final height. So it really helps us arrive at a plan for the child. Brain MRIs may or may not be needed. The younger age group, they say we need to do it, whereas if the child is early normal puberty, it may not be needed. But however, today we are forced to practice defensive medicine. So what I do, I just write it, and verbally I tell them that it may not be necessary, because we always have surprises in medicine. So these are the medications to treat central precocious puberty. In our country, we just have the Lupron Depot, 1 month preparation and 3 month preparations. The others have yet to come. So is there an evidence for decline of age of puberty? There was a landmark study in the United States that said, that concluded that probably the pubertal onset is earlier in white girls less than 7 years, and in black children less than 6 was what was suggested. But however, the cutoffs still remain the same despite this. So often we are dealing with the gray zone, and this may be the reason that when 7 to 9, we call it as early puberty these days. There is treatment that encourages medicalization, probably for physiological variations. So we have to be selective, and if we have time, it's better to wait and watch. So these are all the indications for treatment would be a complete and progressive. By progressive, to say progressive, we may need an observation. To say progressive, we may have to take a call if the bone age is severely advanced, because then that doesn't give much time left for increase in height, and it may compromise final height. We may, and if the height potential, we do a height prediction based on bone age, Bailey and Pinot method of adult height prediction. So if that is compromised, then we may want to stall puberty. So these are all the indications for treatment. So if we have time, it's better to wait and watch and see if it's a rapidly progressive. So just an illustrative case. We get an 8-year-old girl with breast development and pubic hair. Mother says that she noticed it at around 7 years, 9 months. Family history is negative for early puberty. Parents are of average height with a target height of 162.5 centimeter. Her growth, often we don't get height measurements. So indirectly, I ask questions like, was she of average height in class a few months back, and do you feel the height difference compared to peers has increased? So it gives me an indirect indicator that this child could be having a growth spurt. So this child did have a growth spurt, and on examination, she's in early stages of puberty, just Tanner 1. Her bone age is around 2 years advanced, but her predicted adult height is within the target height. The target mid-parental height was 162.5, and her predicted height as per bone age is 164. So this is reassuring. And she's actually in third standard, and she's quite happy. She's a happy-go-lucky child, and she's really not bothered about all these. So, but parents are extremely worried, they're concerned, they ask whether to, they want the puberty to be suppressed, and they're told by the pediatrician that she'll stop growing early. Pediatrician or whoever are there. And they're not ready psychologically to deal with menses. So how do we handle this? So we need to ask questions. These are the questions we need to ask. Do gonadotropin-releasing hormones increase adult height in children with central precocious puberty? Do girls with central precocious puberty have more psychological problems than prepubertal girls their age? Is prevention of potential early menarche in girls with central precocious puberty necessary? I guess the third question in our culture, it would be deemed necessary, because we are not that accepting of aberrations in the timings and stuff like that. So do gonadotropin-releasing hormone analogs increase adult height in children? So there are several consensus recommendations. When we started before the age of 6 years, if it's indicated, definitely there is benefit. There is no doubt about it. But in children who present before the age of 6 years with pubertal signs. Now, the age between 6 to 8 years is a gray zone. It's a heterogeneous group that may have moderate benefit. Like some children do have benefit, some children may not have. So they need to be evaluated properly and appropriate decision taken. The decision to initiate therapy in girls with onset after the age of 6 years should be individualized, not before. It's after, I'm sorry. So progressive pubertal development with growth acceleration, if we have time, should be documented before we start treatment. But if the bone age is advanced and the child is in Tanner stage 3 or so, then probably we shouldn't be, that itself is an indicator that it's progressing rapidly. And we may not have time to wait. So psychological problems, there is no last word on this. So now coming to the next part of the question. So COVID is blamed for a lot of things. So we are not going to be left behind. So is it really on the rise and who is to blame? Definitely the lockdown and corona. This is Dr. Vaman Kadilkar's Kadilkar's cohort. You know, the referrals for precocity increased from 1.4 pre-COVID to 5.19. So that was almost a 4-fold increase in puberty, precocious puberty with lockdown. So we know whom to blame or what to blame. And then this is in Shanghai. We know China was one of the worst affected, followed by Italy. And there are multiple papers from all these countries which say the same thing, that pubertal onset happened earlier. There was an increased numbers of children coming with precocious puberty to the OPDs. And those children who were earlier categorized as slowly progressive puberty, they showed an acceleration with this lockdown. So this is the data. We can see that pre-COVID and post-COVID, there's been a steep increase in precocious puberty. And I won't go into the mechanism. You know, angiotensin converting enzyme receptors are there in the central nervous system, olfactory bulb wherein the virus gets, and that is believed to be one of the trigger. Lifestyle, BMI, increase in leptin, which plays a permissive role, that is believed to be one of the triggers. So there are multiple triggers. I won't go into the pathophysiology of this, but suffice it to say that there has been a tremendous increase in precocious puberty after lockdown. Thank you.
Dr. Kavita, I have one question again. Is there any correlation between the increased consumption of milk and milk products like cheese, butter, ghee, especially since the cows are being pumped with hormones, and precocious puberty?
Yes, environmental estrogens do play a role, so it's quite possible. However, I'm not aware of any studies wherein they have analyzed the milk and correlated it. But there was a study sometime from the Middle East that correlated the meats there with precocious puberty. They were hormonally treated. It's possible, it's a known problem.
Is it more common in boys or girls?
In girls. Precocious puberty is more common in girls.
How common? Do you have any?
Well, idiopathic precocious puberty almost always is seen in girls. When we see it in boys, we need to think of some pathological cause like a CNS tumor. Now, exact percentages and numbers I may not be able to. Thank you.
We have a memento, Doctor. Big thank you to Dr. Kavita. Let's give her a big round of applause. I know we have to keep time, so you can just, ask your questions offline. Okay, one sentence.
Modern gadgets and exposure to the adult content on the TV, the children are seeing a lot of adult stuff, reading adult stuff, is causing this puberty, precocious puberty.
Yeah, there were some studies quite some time back, but there was no conclusion on this topic. Though there was some suggestion that it could increase puberty, but it wasn't actually proved based on some studies. Yeah, right. Thank you.
One more question.
Yeah.
No, can we take the questions, offline, because we're trying to keep the time and the schedule. Thank you. Requesting Dr. Deepak to kindly come up on stage, and Dr. Kavita, we need you back on stage. I'd like to felicitate you. Thank you so much. Since in the interest of time, I know we have lots of questions, but our doctors are still around, so you can approach them directly and ask all of your questions. Thank you so much. We now move on to our next presentation, which is a debate. Is evidence-based pediatrics the axiom for providing optimal care? And I would like to invite up first our moderator for this debate, Dr. Arvind Shenoy, MD, DM, Neonatology, FNNF, Fellowship in Neonatal Intensive Care, Clinical Director, Neonatology and Pediatrics, Rainbow Children's Hospital, Marathalli in Bangalore. He was the former Chief Neonatologist and Medical Director of Cloud9 Hospital, Old Airport Road in Bangalore, also the Senate member of RGUHS, the Chairman, Child Health Subcommittee, State Vision Group, Government of Karnataka, the Chairman, Low Birth Weight Feeding Group, Clinical Practice Guidelines 2019 NNF, Executive Board Member 2019 to 2020, National Neonatology Forum of India, also the Adjunct Professor of Pediatrics, Manipal University, and the Head of Department of Pediatrics, Manipal Hospital. Dr. Arvind Shenoy, I'm going to hand it over to you in just a bit. Also like to invite on stage our panelists for this discussion. Dr. Saurabh Datta, he's going to be speaking for the topic. He's a professor, Neonatology Unit, PGIMR, Chandigarh, and Adjunct Clinical Professor, McMaster University, Canada, MBBS, MD and Senior Residency from AIMS, New Delhi, PhD in Neonatology from PGI, FRCPC by Academic Certification, Royal College, Canada, the Fellow of National Academy of Medical Sciences, FAMS, Fellow of National Neonatology Forum, FNNF, Editorial Board Member, +1 Frontiers in Pediatrics, and his areas of interest include research methodology, neonatal sepsis, microbiome, retinopathy of prematurity in several publications and presentations, orations, and awards to his credit. And our next panelist, he will be speaking against the topic, Dr. Jagdish Chinnappa. He's the Cluster Head Pediatrics of Manipal Hospital Group, Bangalore region, and he's been the past president of Respiratory Chapter, Indian Academy of Pediatrics, and the consultant of Child Central, Bangalore. I hope you enjoyed this presentation, and over to you, Dr. Shenoy.
Thank you, ma'am.
Thank you.
Thank you, Melody. And good morning, everybody. As soon as I met Dr. Jagdish this morning, he said, I'm shaking hands with you, but telling you, don't be partial to PGI. When I told Saurabh this, he said, that's not fair, because in addition to you, there are 3 other people on the stage who are from Bangalore, so at least somebody should back me. So, having said this, many of us in the audience, and I'm sure the chairmen will agree, belong to an era where there were doyens of pediatrics striding the field, like late Professor Benekappa or Professor Valya or Professor Bhaku. And in any academic argument, the argument was settled when somebody said, look, Dr. Valya said this is how it should be done, and that was it. But these days, when we take a round, even the intern can challenge you saying, sir, it happened to me recently. There was a child with 103 fever, and the resident said, sir, what is the evidence that sponging the baby will bring down the temperature? I'm still hunting for the evidence, but that's just an anecdote. Let's get the ball rolling. So the rules of the debate are already there. First, we'll have the presentation from Dr. Datta for the motion, talking about how evidence-based medicine is important. And then we have our own Jagdish Chinnappa telling us it's not that important, or maybe not important at all. So over to you, Dr. Datta. Please start the...
Okay, good afternoon, everybody. Firstly, thank you, Rainbow Children's Hospital, for this invitation. It's always an honor and pleasure to come back to Bangalore. I have a lot of family in Bangalore, so it's really wonderful to be back in this lovely city. And thank you to the chairperson, Dr. Arvind Shenoy, for that wonderful introduction. So I'm going to be speaking in favor of the motion that evidence-based medicine plays a crucial role in pediatric practice. And what I'm going to do is, this is going to be the overview of what I'm going to say. I'll first talk about what evidence-based medicine is and what it isn't, because there's always a lot of misconceptions about this. Secondly, some examples of studies that actually tested out evidence-based practice and showed that it works. It has a critical role in clinical practice. The third is, do we really need evidence for evidence-based medicine before adopting it? And I'm going to show you that we really don't. It's a self-evident thing. Oh, and finally, if you're saying evidence-based medicine is not good enough, okay, but then compared to what? So this was a landmark paper published by David Sackett, who's, a doyen in the field of evidence-based medicine, published way back in the British Medical Journal, 1996. And I think this is a must-read, this article, for EBM skeptics, those who still have some doubts about evidence-based medicine. It was titled, Evidence-Based Medicine, What It Is and What It Isn't. And because this cannot be read from a distance, I'm going to go over each of the salient parts of this publication in detail. So what is evidence-based medicine? It is the conscientious, explicit and judicious use of the current best evidence in making decisions about the care of individual patients. It is not about a mass of patients. It's about the patient in front of you. The practice of evidence-based medicine means integrating individual clinical expertise with the best available external evidence from systematic research. So nobody is trashing clinical experience. Nobody is trashing a person who is senior and who has seen many more patients. Nobody is saying that don't look at the patient who is in front of you, just look at the conclusions from Cochrane reviews. Nobody is saying that. It is the integration of individual clinical expertise with the best available research evidence. And finally, David Sackett goes on to say, good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. That is evidence-based medicine. When asking questions about therapy, we should try and avoid non-experimental approaches, since they often lead to false positive conclusions. But David Sackett gives a rider. However, some questions about therapy do not require RCTs. For example, successful interventions for otherwise fatal conditions, or cannot wait for trials to be conducted. And if no RCT has been carried out, we may use the next best evidence and work from there. So what it is not, that's equally important. It's not good enough to say, oh, everybody was doing it anyway. All the seniors, traditional practice, we have been doing it anyway. So big deal about evidence-based medicine. That's not the right approach. Second, oh, it's impossible to practice in real life. Who will go and keep checking about evidence? No, that's not the right approach. Third, oh, it can only be conducted from ivory towers and armchairs. It has nothing to do with real life situations. Absolutely wrong. Oh, it is a cookbook medicine. You can't go by a recipe that somebody has prescribed. You have to look at real life situations. Again, wrong. Third and lastly, oh, it's just restricted to RCTs and meta-analysis. No, that's absolutely incorrect. And what it is definitely not is, it is definitely not a nihilistic approach. Nihilistic means, if you stick to evidence-based medicine, you won't be able to practice medicine at all. That's absolutely wrong. The sneer on this person's face, oh, so many Cochrane reviews end with, there is insufficient evidence and more trials are required. So what's the point of the whole thing? Many people have this kind of an approach. But the concluding line of the Cochrane review is not the end of the story, it is just the beginning. The grade guidelines, for instance, provide guidelines with the rider that the recommendation is either strong or weak or conditional, depending on how strong is the evidence base and the strength of the evidence base. That allows the clinician to make an informed choice while performing a diagnostic test or starting a certain line of treatment. It is that informed choice which forms the basis of evidence-based medicine, rather than doing things arbitrary or based on your whim or fancy. So it is not an all or none thing, evidence-based medicine. Evidence-based medicine does not claim that it has definite answers to each and every clinical question. No, it is work in progress, like so many aspects of human knowledge. And the number of questions for which we have definite answers is steadily and constantly increasing. Just because evidence-based medicine does not provide answers to everything is no justification to trash it. For example, taking a completely different look at things, physics explains a lot of things in our day-to-day life, in the universe, but not everything. Does that mean that we stop using physical principles, we stop teaching physics, and we stop using it in our day-to-day life, or take a stand against physics just because it is not capable of explaining everything? Same with evidence-based medicine. Just because answers are not there to each and every question doesn't mean that evidence-based medicine does not or should not play a part in pediatric practice. So how do you prove that evidence-based medicine works? Well, ideally, you would need a randomized controlled trial with people being randomized to an evidence-based medicine arm and not, but simply not practical. So instead of looking at evidence-based medicine as a whole, you can identify a specific evidence-based intervention, compare patients who happen to have received evidence-based interventions versus those who did not, or another way is compare outcomes of patients belonging to a group of physicians that received intense evidence-based education about that intervention versus physicians who just received routine education. Well, there are many such examples. I have chosen some from adult literature, some from pediatrics, and the reason why I haven't really bothered to stick to pediatrics is there's nothing very special about pediatrics. Although the topic says pediatric practice, evidence-based medicine goes across all specialties. There's nothing, children haven't landed from Mars that they're going to be any different. So it's all the same. So for example, an evidence-based guidelines for intensive lipid lowering to prevent coronary artery disease. So this was an RCT on patients in Sweden. General practitioners were randomly allocated to either evidence-based training or routine learning. And on a 10-year follow-up between the intervention and control, there was a significant difference in all-cause mortality, coronary artery disease mortality. For surfactant, the randomized control RCTs involving 114 ICUs, NICUs in the intervention arm had evidence-based quality improvement interventions, and it was found that they more often, those in the intervention arms, received surfactant appropriately in the delivery room or within 2 hours and had better outcomes. Beta blockers after myocardial infarction, 45,000 survivors of myocardial infarction, 50% were prescribed beta blockers at discharge as per evidence-based guidelines, and there was a huge risk reduction in mortality. One could go on and on. I mean, it's actually demeaning to even provide examples to try and now show that evidence-based medicine works in this day and age. So is justification for EBM required at all? So evidence generally is based on large, well-conducted RCTs or systematic reviews. By the time evidence accumulates to cross a tipping point, usually several thousands have been randomized. And further RCTs to now prove the same point would be unethical because control groups would be deprived of standard of care. So EBM generates the evidence, and using it correctly for an individual patient is now the job of the clinician, so the two have to be integrated in evidence-based medicine. So the rigorous process of generating the evidence is evidence in itself. Okay, so evidence-based medicine, if I play the devil's advocate, if I say if it's not good enough, but then okay, compared to what? So there should be proof that the alternate approach has more evidence to back it than evidence-based medicine itself. And again, I would urge all of you to read this tongue-in-cheek, humorous article written by Dr. David Isaacs in 1999, where he said that, oh well, there are 7 alternatives to evidence-based medicine. And what indeed are they? The 7 alternatives to evidence-based medicine. The first is called eminence-based medicine. So eminence-based medicine is measured by radiance of the white hair and the degree of baldness of the person who is talking. It's based on a touching faith on experience, which is defined as making the same mistakes with increasing confidence over an impressive number of years. The second alternative to evidence-based medicines is vehemence-based medicine, and that is measured by the level of stridency. Substitution of vocal cords for evidence is a time-honored technique for browbeating timid colleagues into agreeing to what you're saying. The third is eloquence-based medicine, so measured by smoothness of the tongue, So a silk tie, Armani suit, and a tongue, in conferences particularly, should all be equally smooth. Sartorial elegance is a powerful substitute for evidence, according to this school of thought. Then providence-based medicine, measured by level of religious fervor, where the decision is best left to the hands of the Almighty. Diffidence-based medicine, measured by the level of gloom, do nothing from a sense of despair. Sometimes it's not bad actually, sometimes it's better than doing something unnecessarily. Jurisprudence-based medicine, measured by litigation phobia levels, powerful stimulus to over-treatment regardless of what the evidence says. Like we saw during the COVID pandemic, some people were prescribing about a dozen medicines from zinc to ivermectin to whatnot, regardless of what the evidence said. Confidence-based medicine, measured by the level of bravado, often peculiar to surgeons. I hope none of them are there in the audience. So these are the 7 alternatives to evidence-based medicine. You're free to choose any one of them. Now, luckily, most researchers, unlike my respected opponent, are in favor of evidence-based pediatrics. This is evidence from PubMed. The number of evidence-based guidelines in pediatrics between 1976 to 2021, exponential rise, in great guidelines and evidence-based guidelines which are being used by people all over the world. So, finally, is there anything there to debate? Evidence-based medicine today is an integral part of pediatric practice. We can't think about pediatric practice without evidence-based medicine. I mean, I can understand a debate such as today is being conducted in the 1980s or 1990s, where the term EBM was still fancy, a new term, people didn't really know what it meant. But in 21st century, 2022, it is no longer a subject for debate because it's a settled issue. The only thing left to be debated is, should debates on evidence medicine still be held in this day and age, or should they be consigned to the dustbin of history? That, I agree, is a valid topic to be debated. So summing it up, I think evidence-based medicine is all about integrating rigorously generated evidence with clinical expertise and the individual patient's circumstances. Nobody is, by no stretch of imagination are people saying that don't look at the patient, don't touch the patient, don't combine that with your clinical expertise. The rigor with which evidence is generated is proof in itself that EBM is evidence-based, and evidence-based medicine is certainly more evidence-based than its illustrious 7 alternatives which I've talked about. Thank you all very much.
So Dr. Jagdish, the floor is open for you.
This is what? Can you load the slides? This is the one. Okay. Can you put the slides, please? Okay. Thank you very much, Rainbow and Dr. Arvind Shenoy and my dear opponent and all the esteemed people here and the wonderful audience here. I think I agree with Dr. Saurabh completely, but the key word is but. And the reason I disagree with him on certain points are basically Sat Feras and dog lovers. What are Sat Feras and dog lovers? Dr. Saurabh started his, or rather ended his talk with 7 ways in which EBM should not be practiced. I'm going to outline why 7 ways of how EBM doesn't serve its purpose. Let's start with the first thing. Satabdi, you know very well, is the Sat Feras you take when you get married. So let's start with the first one. Evidence is not available for most common disorders and conditions which we see. There is a paucity of evidence, so what evidence can you use? If you saw the previous 2 talks which were given by Vasudha and Kavita, both of them said no evidence. So there's no evidence available for most of the things. Now let's take a simple thing like severe malnutrition. Just look at what studies have been there in the last 2 years on malnutrition, severe malnutrition, hardly anything. You have no data. You have no evidence of how to manage malnutrition. And let's see what comes out here. Next, this is from Cochrane. So it's not from anywhere else. It says very clearly, coverage of care seeking needs to be increased, and the evidence present here underscores the importance of moving beyond training and deployment. All complicated stuff, nothing of practical value.
So basically, it does not give you answers to most clinical questions. The second problem that you see is that evidence for even a single disease is very partially and fragmented. Again, I can show you here, for example, again here, if you look at management of severe malnutrition, you have just two main reviews, and none of them are of any practical use. So what I'm trying to say here is that very limited evidence, and if you want to look at evidence for a particular topic, even less. Then you go to the next main problem. And what is the next main problem? Evidence is skewed towards funded studies. Where there is money, that's where the evidence comes. Because there's money to do an RCT. The cost of doing a good quality RCT runs into crores of rupees. And you know what is the budget for research in this country from the government? 6,000 crores, which is peanuts if you distribute it across all the institutions. So therefore, there is no money coming in from the government. There's no money coming in from any philanthropic organization. So where will the money come from? It will come from industry. And if the vaccine manufacturers are dumping you with data from day after day, it's because there's profit in it. Otherwise, who's going to do data? Let's look at this particular thing. For example, you look here now. Theophylline is a great drug. I'm sure many of us have used it. It's got a very good, if you look at the profile for even chronic asthma, it's very good. But where is the data? No. You'll have data on formoterol. You will not have data on theophylline. Look at cystic fibrosis. You know, the company spent a huge amount of money in looking at Dornase when simple hypertonic saline, 7% saline was as good. Nobody did any studies because there's no profit on it. And only after many, many years when they found that Dornase was useless, they started moving towards hypertonic saline. So what I'm trying to say is, evidence goes where the money is. Evidence is again skewed. The next thing is, let's look at how evidence is generated. Evidence depends on collection, interpretation, and representation of the data by the principal investigators. Most investigators are reluctant to share data. I'll show you some data on that. Now, evidence is dependent on statistical interpretations. And you have seen so many papers where it's a big confusion. They can twist, you know, they say that there are lies, more lies, and statistics. And therefore, statistics is a big problem. The next thing is that you give the same raw data to two independent individual experts. You'll never get the same thing. You'll never get the same kind of answers to the same conclusions or conclusions to the same raw data. Now, this is a simple thing which came in Nature. And as you can see here, requests for data, that is raw data, were spread about 1,800 manuscripts. And you know how many gave the data? Not even 120. So all the investigators keep all this data within themselves, and then they give you conclusions. So how do you believe it? You can't definitely not believe it. So this is another one which came recently from a stat survey. And you can look here what happens. They don't disclose on time. They don't disclose most of the things in journals. They show it somewhere, and some of the clinical trial results are published. And finally, they say that they have corporate sponsorship problems, and therefore they either delay it or accelerate it depending on how the money comes in. So therefore, all this evidence which is coming out in most of these papers depends on, again, the investigators' honesty. And let me tell you, most of them are now bought out by the industry. Next, large chunks of evidence are ignored because of bias. And let me tell you one more thing, bias cannot be eliminated. There are so many different types of bias. Every one of us is biased in some way or the other. There is one, selection bias. Second, there is publication bias. Then there are even, for example, you look at the journals. They will print only articles by certain groups. They will not look at other groups. And let us look at, for example, in developing countries. First of all, language is a barrier. You take a fantastic paper from Japan, or from China, or from Russia. There's a language barrier. It will never get published in the New England Journal of Medicine or the Lancet, which is what we look at. Then the next problem is they cannot search or look for the correct journal. They do not know the range of journals. And there is an editorial bias there in all these publications. So what is the evidence that we are getting? We are getting all a biased opinion. Next, FARA number 6. The hierarchy of evidence ignores and subjugates clinical experience. We saw this, Dr. Datta mentioned, that yes, clinical experience is important. But then this is very clear. It says that you don't look too much into case reports. I'll ask you a simple question. If you had scorpion bite in a place, in a rural Maharashtra place, do you think you could go to Lancet, New England Journal of Medicine, up to date, or any other place to look for evidence? Dr. Bavaskar, from his clinical experience, used a simple drug, prazosin, to manage scorpion bite, which is now today earned him the Padma Shri. You think that this could have come from evidence-based medicine? This is basically simple clinical experience and looking at the pathophysiology. Next, evidence is valuable in public health interventions, but when you look at individual cases, the evidence is hardly there. The next thing which I want to mention is the days of RCTs should get over now. And the reason for that is RCTs are done in a population, controlled population, at a particular time. Okay, whereas today we have many other things. You have 1 point RCT, but you have continuous data which is available. If you have good EHR, you can monitor data much better and see what's happening to the patients on treatment. Next is you can look at insurance claims. You can look at also basic research. So today we had a talk in hematology where they looked at basic research in the management of malignancies. Revealing talk. So what I'm trying to say is it's basic research translated. Your evidence will come 20 years later. You can't keep waiting for this. Okay. Then next we come to this last two issues of mine. We have to go by the middle path. Okay. As practitioners, we cannot say we are going to entirely rely on evidence-based medicine because it is a dynamic field. And therefore, we have to get the best available dynamic evidence which is available at that point in time. Next is, we also have to use clinical experience. We'll also have to look at the social and psychological issues because these play a great part in healing the patient. And finally, we have to respect patient preferences. And we are therefore not only dependent on evidence-based. And if you look at the title of this topic, it says axiom. Axiom means what? Axiom is the default. I'm sure it is not the default. The default is putting everything together as a practitioner and taking it forward. So it's shared decision making. Now I'll ask a question from the audience. I have 1 minute more. How many in the audience love dogs? Just raise your hands, all of you. Okay. So the large number of you love dogs, isn't it? You like dogs. And therefore, you'll say, oh, the standard is dogs are friendly, dogs are good. That's the evidence, because a lot of people said that. But then, in practice, this is what you see. Okay. All right. So therefore, basically, when I started practice, there was this child who came and asked me, are you a theoretical doctor or are you a practical doctor? And I'm still searching which one am I. But I'm sure that a theoretical doctor has to know about practice, has to know what is happening in the marketplace, in the small clinics and in the small hospitals everywhere. And the practical doctor must know theory as to what is new. So thank you very much for a patient hearing.
Dr. Datta, you have a minute to defend yourself.
Well, Dr. Chinnappa is a dear colleague, and the idea is not to be having a fist fight with him. So the problem with this word evidence-based medicine is that people straitjacket it and put it into very, very narrow definitions. That, okay, I have not got evidence from only RCTs. I have the Cochrane reviews, like the many that Dr. Chinnappa showed, did not show conclusive results. Therefore, evidence-based medicine is all useless. No, evidence-based medicine is a much broader thing in today's day and age. If you read any of the, say, grade guidelines, which go a step beyond Cochrane reviews and systematic reviews, there are guidelines provided even when there are no RCTs, no cohort studies, nothing else. Whatever is the best available evidence being told to the reader as, okay, this is evidence which is maybe weak evidence, but this is what we have in this day and age. And this you have to now combine it with your knowledge of the patient's circumstances, that individual patient's requirements, and take an informed decision. The whole idea of evidence-based medicine is to be taking informed decisions by taking into account what is published. It is that my personal biases, my whim, my mood on that particular day is not going to decide what I'm going to do for the patient. It's an informed choice. I think that's the thing that should get across. If one takes a very narrow interpretation of EBM, of course, one can show many things that are inadequate or the whole lot of lacunae about evidence-based medicine, but that's not the right approach. Thank you.
I think we'll give one comment each from the three chairpersons so that it is fair.
I don't know whom to support. I agree with both of them. Both of them made very valid points. But at the end of the day, it's your clinical knowledge along with the data available which helps us make a decision.
Dr. Phadke?
I was struggling to decide who is right, whether the first speaker or the second person. But then I said, let me find some evidence to decide who is right. So do you think I should do that? This question to either one of you.
Maybe you should do a Google search or a Cochrane review, with Dr. Saurabh Datta and Dr. Jagdish Chinnappa,
Sir.
I come from an institution, so I always support evidence-based medicine. So I am with Dr. Datta here. I always tell my postgraduates, whenever they start antibiotics on something, with fever or for whatever, I always ask, where is the evidence? So fever is not a sign of ceftriaxone deficiency. That's what I always say. So evidence is required. Thank you.
I think with that, I would just like to add two things which I learned from this debate, and I think they are both marvelous. So number one is we need to probably collect data, either in the form of RCTs if we have the wherewithal to do it. But the key point which many of us in India are now learning is we need to collect data. Data is the basis on which evidence is formed. And I think in India we should work towards collecting data. Then we should understand that whatever data comes from outside is subject to certain biases, which Dr. Jagdish said. So when we interpret it, we should remember and recognize that this bias can influence what has come out of this data. And so finally, in this world where we are going to have more and more data, we need to blend our clinical knowledge with the data from our own and from external sources and probably treat the patient. I think that is the take-home message I am taking, and some of the people in the audience may agree with it. And with that, please give them a big hand for a very marvelous debate.
Thank you, sir. Thank you.
Thank you so much, Dr. Arvind Shenoy. We'd like you to felicitate our panelists, Dr. Saurabh Datta. And Dr. Jagdish Chinnappa. Thank you so much. Quite an interesting and entertaining debate and session this was. Thank you so much. We now move on to our next session, which is going to be a virtual session. And I'd like to introduce our speaker for this session, Dr. Sanjay Bansal. He's a consultant pediatric hepatologist from King's College Hospital in London. He has an MD in Pediatrics, DNB in Pediatrics, MR CPCH, also from the Medical School, Medical College, Kolkata. He also has an MD in Pediatrics from the KEM Hospital, Mumbai, CCT Pediatric Hepatology from the King's College Hospital. Also the clinical lead for education and recruitment. His special interests lie in clinical lead for viral hepatitis, liver transplantation, NAFLD, hepatocyte transplantation, acute liver failure, and genetic liver diseases. Let's put our hands together and give Dr. Sanjay Bansal a very warm welcome. Thank you. I think we need your audio on, Doctor.
Yeah. Is it?
Yes.
Can you hear me? Yeah.
Yes.
Okay. Let me share my screen first. Yeah. Okay. And yeah. Okay. So let me start by thanking Rainbow Children's Hospital for inviting me to give this talk. Okay, and thank you, chairpersons, for to be there for my talk. Now, this is a very important topic, and I feel very passionate about it, because in this era of where we have gone through from epidemic to a pandemic, there was a silent epidemic which was going through through the world, and which is the epidemic of obesity. And actually, we want to talk about, I'm going to talk about fatty liver disease, which is one of the complications of these obesity in children. Now, non-alcoholic fatty liver disease has become the most common cause of liver disease in children and adults. And though the fatty liver was first described in 1845 by Addison, but that was a autopsy specimen. But since then, people have noticed that patients with liver disease, some of them have got fatty changes in the liver biopsies or in the autopsy examinations. But in 1980, in a seminal paper, Ludwig first produced the concept of non-alcoholic steatohepatitis, which is the second stage of a NAFLD. From the NAFLD, patients goes to have NASH when they start having inflammation. The term NAFLD was first coined in 1986. And in children, the first patient who was shown to have similar changes of NASH was first described in 1983. But it was for the last 20-30 years, people knew that most of these patients have got metabolic disturbances, like metabolic syndrome type things, and they used to call metabolic syndrome-associated steatohepatitis. But in 2020, the adult hepatologists in the international consensus have now terming this NAFLD as a MAFLD, which is a metabolic dysfunction-associated fatty liver disease. Following that, in 2021, the pediatric hepatologist group also had followed the trend, but what they said that this pediatric MAFLD is slightly different from the adult MAFLD, and I'll talk about that later. If you look at this slide, you can see that incidence of obesity is rising exponentially in England, and so is we are seeing the number of cases which we refer to us for the fatty liver disease. This is a chart which was shown, the data which was compiled by the World Obesity Federation. This is data from 2016, where you can see the world is shown in different colors. The red and the orange, red and the dark reds are the ones where the incidence is very high, whereas the green and the blue ones are where the incidence is still quite low. So the Western countries and more affluent countries had a much higher incidence of obesity. And they had predicted that by 2030, the number of obese or adolescent children will grow up to 254 million. And out of that, 62 million people will be in, children will be in China, more than 27 million children will be in India. If you look at the epidemiology, in UK, 1 in 5 children at the time of primary school entry are overweight or obese. And by the time they finish their primary school, which is about like 4 years, 5 years time, the incidence increases to 1 in 3. In young adults, in UK, it was estimated that 1 in 5 young people have got steatosis or fat in the liver, but 1 in 40 has evidence of fibrosis by the time they reach 25 years of age. The overall prevalence of NAFLD is 77.6% from the general population, but if you look at the children who are obese, the incidence increases 5-fold. In a study on autopsies from California, they showed that the incidence of NAFLD increases as the age increases, and the incidence was 0.7% in children who were 2 to 4 years old, but it increased to 17% to people who are in their teens. But in obese children, the incidence again had gone up to about 38%. So if you see that incidence of NAFLD is going up, as well as if the patients are obese, the incidence of NAFLD increases significantly. Overall prevalence worldwide is in general pediatric population, it is about 3 to 10%. And this is just to give you an idea of different countries reporting different incidents of NAFLD. But you have to realize that here the denominator by which they are identifying NAFLD is different. Some studies they have used ALT as a identifying tool. In some cases they have used ultrasound. In some cases liver biopsy. However, the definition of NAFLD is it is actually a diagnosis of exclusion, where which defines that if there is evidence of chronic hepatic steatosis in children, and you should be excluding other causes of fat in the liver, such as genetic causes, infections, drugs causing fat accumulation, and alcohol consumption, especially in the teenagers, and malnutrition. These are the other terms, a few other terms which has been used to describe fat in the liver. As I was talking about the MAFLD, which was in 2020 was taken up by the Pediatric Hepatology group, they had identified that in children, there are actually 3 groups of patients. Okay, the type 1 patients are there where you have fatty liver associated with the known systemic disease, like Wilson's disease, like patients with congenital disorders of glycosylation, like some patients with cystic fibrosis or single gene defect. Okay, whereas type 2 is a pediatric MAFLD, which is similar to the adult population, where you have got a pediatric patients who have got a metabolic dysfunction associated liver disease. And the type 3 is a group because in these children, we haven't found a cause of fatty liver. So this is an undiagnosed fatty liver. But in this group, some patients may be identified, may be diagnosed with something else, and they can either move to type 1 or type 2 later on. And what is the criteria for diagnosing pediatric MAFLD? So you need to show there is an intrahepatic fat accumulation by either doing ultrasound or liver biopsy or MRI scan, or so either these 3 ways you can show whether the fat accumulation is there. But in addition to that, you should have the criteria is one of the 3 criteria, which is excess adiposity, pre-diabetes or type 2 diabetes, or evidence of metabolic dysregulation. And for the metabolic dysregulation, you need to have at least 2 of these metabolic risks should be present, which is increased waist circumference, hypertension, hypertriglyceridemia, low serum HDL, impaired fasting glucose, and the triglyceride to HDL ratio of more than 2 to 2.25. Okay, sorry. Okay, now if you look at the natural history of non-alcoholic fatty liver disease, so coming to that if you have got fat in the liver, does it cause any problem? As long as there is only fat and it doesn't cause any inflammation, that will be fine, because it is not going to cause any liver dysfunction itself. But it's only thing when it starts causing inflammation, will lead to fibrosis or scarring, then you can go into the other next stage. So non-alcoholic fatty liver can progress to non-alcoholic steatohepatitis, where there's inflammation. And then if the body tries to repair it by more scarring, there will be more and more and progressive scarring leading to cirrhosis or end-stage liver disease. And then patients can go into hepatocellular carcinoma. And this conversion from one stage to other stage is not a dynamic, a static phenomena. It is a dynamic. It goes one way, and things can improve also. But it can take anything from 5 to 10 years to 20 years to go from non-alcoholic fatty liver disease to the completely end-stage liver disease. Fortunately, at King's College Hospital, we never had to transplant any patient for NASH or NAFLD. But in USA, they had the UNOS data had identified 330 patients who had transplant for NAFLD. And out of that, there were only 14 patients were there who were less than 18 years of age. But if you look at the overall data from in that 330 patients, the overall survival was only 70%. So 30% mortality, which is very high for a transplantation program in a particular for a particular condition. 38 patients, 81% required retransplantation, and out of these 38 patients, 13 of these patients had a NASH recurrence or NASH complications related to that. Okay. The outcome of retransplant was worse for patients who had a NASH cirrhosis compared to other liver disease patients. Coming to the little bit about the pathophysiology, basically you have obesity or dyslipidemia, which actually these things does cause insulin resistance, and if the insulin resistance is there, the increased lipogenesis happens and decreased lipolysis, leading to free fatty acid accumulation, which gets deposited in the hepatocytes, causing fatty liver. Now, these also on the other side, adipokines are activated, which actually activate the pro-inflammatory pathway, leading to release of cytokines or chemokines, which along with the oxidative stress causes inflammation, and patient goes on to the NASH state. Whereas gut microbiome, the gut-liver axis also can activate the TLR, toll receptors, and actually contribute to the pro-inflammatory pathway also. Now, there are certain predisposing factors, which is genetics, intrauterine factors, and I'll talk about these in subsequent slides. So the GWOC study, the first GWOC studies on this adult NAFLD patients had identified 5 loci which were associated with the risk of NAFLD. And the most important correlation was met with PNPLA3 148M genotype, which was shown to be a major determinant of the steatosis, and also showed a novel interaction between the dietary components with the sweetened beverages people take with the severity of the steatosis. In the pediatric population, there was a recent paper which was published in May, which actually identified, confirmed the involvement of PNPL3 for steatosis, but they have identified a novel SNP, which is associated with more of a fibrosis. So that should be looked further into it. The early factor, the intrauterine factor, has been found to be very interesting. We always used to think about it that, okay, fine, everything starts when the child is in the womb, and if the pregnant mother's health will decide what's happening. And it has been shown now that the maternal obesity, the infants who are born to obese mothers have got more inflammation, and they are more susceptible to develop non-alcoholic fatty liver disease later on in the life. Coming to the diet, there are certain risk factors with regards to diet, which is causing non-alcoholic fatty liver disease. As you know that this is a age of fast food and canned drinks. So all these fast foods we have got are littered with more unsaturated fatty acids and also high fructose and sucrose. Both of these are a high risk factor for NAFLD. And also, though it says that the total calorie intake is an uncertain factor, but overall the total calorie intake is also important. So there is always a challenge in this particular in this particular field, because this is mainly a diagnosis of exclusion, and also in pediatric, because there are a lot of genetic conditions are there, and a lot of inherited metabolic disorders can mimic or coexist with the diagnosis of NAFLD. So it needs to be teased out properly. And also there's always this thing whether the patient has got only steatosis or there is associated fibrosis or not. So people are always trying to look for what is the way to find out whether the patient has the extent of injury to the liver. Histology, liver biopsy can tell you a lot about what's happening with the biopsy in the NAFLD in adult patients had shown a different type of histopathological changes. It was mainly accumulation in the central lobular area, the fat accumulation, and there was ballooning and lobular inflammation, which was and there's a perisinusoidal fibrosis in the adult, which used to be now being called as a type 1 changes. Where in pediatrics, the fat and is there with portal inflammation, and the fibrosis is periportal fibrosis. And in pediatrics, they are usually associated with much more severe fibrosis as compared to the adults. Okay, this is just an example of the biopsies. You can see from there are 6 biopsies on the right. You can see showing fat accumulation as well as expansion of the portal tract and the portal inflammation. Now, you cannot do biopsies in all the patients, and that too regularly to assess what's happening to the liver. So people have been looking for non-invasive biomarkers in non-alcoholic fatty liver disease, and the search is still going on. People have used different markers for inflammation, fibrosis, apoptosis, and oxidative stress to use as these inflammatory biomarkers. In the serum, most of the single markers have been not very correlating with the degree of fibrosis or steatosis, but ELF test, which combines this pro-collagen type 3 and terminal peptide, and this is metalloproteinase 1 inhibitor and hyaluronic acid. The combination of these 3 has shown to predict the fibrosis stage quite appropriately. So it has been now being used more regularly in these type of patients. Then there was this particular pediatric NAFL fibrosis index was actually identified by Nobili, and then subsequently what they did is they combined the ELF plus 3 of the parameters from this PNFI, and actually found that if you combine these 2, the area under ROC curve increases significantly, and it can not only decay, it is very helpful to identify fibrosis, but also it is good to distinguish clinical significant fibrosis from the little or no fibrosis, and also it can pick up advanced fibrosis. Coming to the imaging, can we do something else? So ultrasound, the routine ultrasound can tell you what is the structure of the liver is, whether there is heterogeneity or not, and whether there is any focal lesions or not, or the spleen is big or not. But FibroScan can tell you liver stiffness. But also nowadays, the FibroScan comes with the CAP measurement, which can actually very reliably predict or pick up your fat in the liver. So it also can differentiate with the patients who have got fat as compared to those who don't have fat, and also between different grades of steatosis. Though it is not as good as MRI-PDFF, which is a protein-derived
I'm not sure
fat
if you
fraction.
can hear me.
Yeah.
Sorry to interrupt, Dr. Sanjay. We'll have to wrap it up. So if you could quickly, wrap it up.
Okay, yeah. So this is okay. I will quicken it. So MRI is the most. This is now the I think is replacing the liver biopsy as the main sort of a tool for identifying fat. The management mainly it is so this is I just wanted to tell you that this everything in the blood test and the investigation is there on this particular link on the Buspagan website. So what are the investigations somebody needs to do, and when the patient needs to be referred to a specialist pediatric hepatologist. And the most important modification you can do is the diet and lifestyle modification, because that is the one, it has been shown that if you lose your 7 to 10% of your body weight, it causes a reversal of NAFL in most pediatric patients. Okay, people have identified different diets, but Mediterranean diet had shown some promise, but still not proven in pediatric population. We need to look for other management of other complications of the obesity, which can cause other problems, and that should be, especially the mental health problems, should be looked at properly. Vitamin E and metformin doesn't have any role. Again, here, other trials which has been done, the ones which has red ones are the ones who hasn't shown any good response, but IBAT inhibitors and the thyroid hormone receptor agonists are shown to be more effective. Now, the most important thing which I wanted to show you is that this particular project, which was done in Leeds, which is the Henry project, which was the early intervention project. By doing that, they were actually involving the family as well as the community, and showed that by over the 4-year time, there was a decrease in the obesity in children between 2 to 15 years of age in Leeds, as compared to increase in the rest of the UK. And in Amsterdam, this is a very well-known program which they are doing it since 2012, where this is reduced. Their aim is they want to eradicate, they want to decrease the child obesity in Amsterdam to a very significant degree, and actually they have decreased. They have been able to decrease it from 21% to 18.5% by doing this is a whole system approach involving not only the schools, but the community and the government, and there's a lot of initiative from the government also. And I think this one program should be, actually this is a very ideal program, should be taken up by everybody else in the world. In conclusion, it is a group of different disease phenotype, and it still remains a diagnosis of exclusion. We need to improve the non-invasive biomarkers, but management, it remains the diet and lifestyle management. But early intervention plan is the most promising thing, because this is not a one person's problem, but it is everyone's problem, especially society.
Thank you so much.
That's it. Thank you.
Thank you. Big thank you, Dr. Sanjay Bansal. Do we have any questions from our chairpersons? We'll take one quick one.
I have a question for you, sir. We see a lot of obese children in our practice. What are the investigations that you recommend that we do, and in whom do we do them?
Okay, so any child who's obese with the abnormal liver function test, even if once you have, so any child with the obese child with the abnormal liver function test should be investigated for NAFLD. Or if the patient has had a ultrasound, because a lot of time we have got patients who are referred to us where somebody has done ultrasound because of something else and found that there's fatty changes on the ultrasound scan, and then they are investigated for that.
So do we check every obese child with an LFT? Do we do an LFT in every obese child?
No. So usually what happens, most of these obese children are actually being, if they are having a blood test. Okay, if the patients are just obese and there's no other problem, then they should be initially started with the weight management program and other things. And if you have found that there's a patient's signs of a liver disease is there, spleen is big or liver is big, then you should be investigating. But otherwise, most of the time we have seen that the patient had a blood test done because of something else. The patient had a chest infections or the abdominal pain, and that's why the patient was investigated, and they found that the liver function test was abnormal. So if the patient is getting blood done for something else, then you should definitely include liver function test to see what's happening to the liver. But if the patient hasn't got any other indication for any blood test, I wouldn't say that you need to do a liver function test. But actually the intervention for the obesity or weight management should start at that time. But anytime the child is going for any other procedures and having a blood test done, that time you should do a liver function test.
Thank you, sir.
Thank you once again for joining us, Dr. Sanjay Bansal. That was quite an intriguing and interesting presentation. Thank you. We now move on to our final session before we break for lunch. And I would like to invite our moderator for this session, Dr. Priya Shivali. She has a fellowship in neonatology IAP, certified in maternal infant young child nutrition from IIT Bombay, certified in bioethics IAP and Indian College of Pediatrics, consultant, neonatologist and pediatrician of the Narayana Super Speciality Hospital in Bangalore. She is the Honorable Secretary of IAB BPS 2021 to 2022. She's also won Best Branch in 11 awards as Secretary in 2021. She's the co-chairman of Inaugural Committee of National Pedicon 2017 in Bangalore, convener of MC Committee of State Pedicon 2017 and 2020, Scientific Committee convener Bangalore Pedicon in 2020, National Trainer of NRP Basic and Advanced 24/7 for 20 problems in 2020. Clinical Clues, Pediatric Dermatology, NC, ECD, and EPIC module contributor. Please give her a big round of applause. Dr. Priya Shivali, who's going to be the moderator for this session. And I'd like to welcome our speakers and panelists for this session. Dr. Monica Reddy, MBBS Government Medical College from Nagpur, MD Pediatrics, Topiwala National Medical College and BYL Nair Hospital, Mumbai, Fellowship in Pediatric and Adolescent Endocrinology, Rainbow Children's Hospitals, Bangalore, Consultant Pediatric and Adolescent Endocrinology, Rainbow Children's Hospital in Bangalore, Executive Board Member, Pediatric Endocrinology Association of Karnataka, and her area of interest lie in pediatric diabetes, bone health, and adrenal disorders. She's going to be speaking about hypertension, think beyond the heart. And also Dr. Anthony Robert Charles. He has an MBBS from St. John's Medical College in Bangalore, MS in General Surgery, Mumbai, TMHS, MCH Pediatric Surgery, AIIMS, New Delhi, Consultant Pediatric Surgeon, Rainbow Children's Hospital, Bangalore, and former Associate Professor, Pediatric Surgery, St. John's Medical College in Bangalore. He was awarded the Best Teacher Award, University of Sydney in 2009-2010. He delivered various orations at state and national level, an active member of IAPS, executive member and secretary, and publications in national and international journals. Please give him a warm round of applause, Dr. Anthony Robert Charles. And he's going to be speaking about major surgeries in pediatrics. And I will hand it over to our moderator right now. Thank you.
Thank you. At the outset, I would like to thank the Rainbow Children's Hospital, Dr. Arvind Chennai, sir, and Dr. Akshay for this opportunity. The first session is on hypertension, think beyond the heart. We very well know that identification of hypertension is very important, and we all are aware that children go in hypertension in a bit late, but we need to recognize the early signs and symptoms so that we treat before the child lands up in hypertension. So we need to be aware of the signs and symptoms of different systems. I would request Dr. Monica Reddy to go ahead with the talk.
Good afternoon, one and all. Thank you so much, ma'am, for the warm introduction. I must say it's really an honor to be sharing this dais with eminent physicians and academicians. So quickly proceeding with my case, because I know everybody is hungry right now. So this is my case. Yeah. So a 9-month-old boy was admitted in our pediatric intensive care unit with history of fever, cough, and runny nose for 5 to 6 days, and history of hurried breathing since 1 day. So assessment in the PICU, so airway was patent, and the child was tachypneic with a respiratory rate of 70 per minute with increased work of breathing with subcostal retractions. Temperature was normal, GCS was 15/15, peripheries were warm, there was tachycardia, heart rate of 152, and at the onset, at the admission, the BP was within the centiles. Now, let me quickly go through the course. So, on day 1, because of the increased respiratory distress, the child was put on to high-frequency nasal cannula. And bronchiolitis was suspected, hence the respiratory biofire panel suggested RSV and adenovirus. And then gradually, on day 2, with increased distress, he was put on to non-invasive ventilation. And here, on day 2, the blood pressure started dropping in, the hypertension started happening. So with fluid correction as well as catecholamines, still it was a refractory shock. So here, the hydrocortisone had to be given. Now, like this refractory case of a catecholamine refractory shock. So what could be the etiology? So meanwhile, we were searching for some clues. So coming to the clues, so there was an interesting observation made that the child's skin color appeared to be a bit darker from the parents. So this is the clinical picture of the child. And then on inquiry, like when we asked the mother said that there has been hyperpigmentation since past 6 months, which has been progressive. And there has been no previous hospitalization, no previous illnesses, no episodes of hypoglycemia, no failure to thrive, no pain in abdomen or vomiting, no previous blood transfusion. So quickly digging deeper, so this was the 6th born of a 3rd-degree consanguineous marriage, and previous 4 siblings were fine. So the 5th sibling, girl child, had expired at 3 years of age with probably a cardiac problem, and the child also shared a similar hyperpigmentation. So this is the 6th born child. So birth history-wise, fine, like full-term normal delivery, uneventful, and developmentally also normal. Anthropometry-wise, like his parameters, weight, length, and head circumference were doing fine actually, 15 to 50th centile. There was no failure to thrive. On head-to-toe examination, so these are the clinical pictures. As you can see, so there was hyperpigmented palmar and plantar creases, oral mucosa, and the gums were hyperpigmented. And genitalia also hyperpigmented, but no signs of precocious puberty. The testes were prepubertal. And systemic examination was fairly within normal limits, except for the respiratory system, which was showing some bilateral rales. So on lab investigations, in the first place, only like going by the electrolytes, because with this kind of hyperpigmentation, we were suspecting Addisonian hyperpigmentation. So only on day 1 and day 2, there was some mild hyponatremia, but on successive days, the electrolytes were fine actually. There was no hyperkalemia. And on day 1, the mild respiratory, like acidosis, was corrected gradually with respiratory support. So the next step, now here, what were our thoughts at this point of time? So this is a child with progressive hyperpigmentation, consanguinity present, and there is a history of sibling death, mild hyponatremia at admission, and refractory hypotension. So were we looking at something pertaining to adrenal defect and adrenal insufficiency? So we started on hydrocortisone, 100 mg per meter square per day, and for further evaluation, then we had to stop for doing the hormonal assays. So this was our first differential, 21-hydroxylase deficiency, because this is one of the commonest causes of adrenal insufficiency. So the points in favor for 21-hydroxylase were the age of onset and mild hyponatremia, but against were, like in classic 21-hydroxylase, we expect a salt wasting, which was not there in this child, and also no virilizing features in this. So we thought probably it could be a simple virilizing or a non-classical CAH. And then we went ahead with the workup for this. So in the labs, we found that the cortisol was low, testosterone was in the normal range, 17-hydroxyprogesterone, what we would have expected to be high, was surprisingly normal here. And the electrolytes were normal, aldosterone was normal, renin was mild elevated, and ACTH was very much elevated. So definitely this was Addisonian hyperpigmentation. And here, by these labs, we could say that 21-hydroxylase congenital adrenal hyperplasia at least is ruled out. Now, what were our further thoughts? Now, there is high ACTH, low cortisol, a normal aldosterone, however, with a little bit of elevated renin, and a normal testosterone level. So here we are looking at a primary adrenal defect, which is affecting a glucocorticoid axis primarily. So these were now our differentials changed to, probably we were looking at, so some of the differentials are like familial glucocorticoid deficiency. This is also known as ACTH resistance syndrome, autosomal recessive inheritance, and most commonly the mutations are seen in these two genes, MC2R and MRAP, and it presents with isolated glucocorticoid deficiency. So, and usually the kids present with adrenal crisis during the period of intercurrent illnesses with hypoglycemia or shock. The second differential what we were considering is Algrove syndrome. Now this is a triad, as you are aware, of ACTH resistance, lacremia, achalasia, but in this child we were not seeing any other features. The third thing, adrenoleukodystrophy, it was too early to say. And also now the other differentials were like partial STAR deficiency, the higher up enzymes in the adrenal steroidogenesis pathway, and partial CYP11A1 deficiencies could also present with a similar picture wherein we get isolated glucocorticoid deficiency without any biochemical or clinical mineralocorticoid pathway defects. So we had to go ahead with the clinical exome, the genetic workup, searching for answers. So here in the clinical exome, we found glucocorticoid deficiency type 4. So this is a type of familial glucocorticoid deficiency type 4, but here there may or may not be a presence of mineralocorticoid deficiency, and this is the gene, NNT. So this is like, there have been very few case reports all over the world literature on this. There have been like about 18 to 20 cases of NNT gene mutation, what we have found here. And so the phenotype classically would be, so it may present with or without mineralocorticoid deficiency and caused by a homozygous mutation in the NNT gene. And this is characterized by the inability of adrenal cortex to produce cortisol in response to ACTH hormone. And usually the affected individuals will typically present in the first few months of life, and they may have failure to thrive, recurrent illnesses, hypoglycemia, and shock. So, so these are the adrenal manifestations, but also when we reviewed the literature, this was something informative. Like NNT mutations, they can, because they are responsible. So basically this NNT, nicotinamide nucleotide transhydrogenase, is involved in reactive oxygen species detoxification. So it may have extraadrenal manifestations as well. So review of literature when we found, so the same mutations were seen in 18 other patients, and most patients were diagnosed pretty early, 8 to 18 months, and 5 patients had mineralocorticoid deficiency at the onset, and one patient had other issues. Some patients have other issues also, like congenital hypothyroidism, 2 had cryptorchidism. And follow-up like of these children, like some children had precocious puberty, testicular inclusions, interstitial cell adenoma, azoospermia, and hypertrophic cardiomyopathy. So having this knowledge at hand, then we started actually screening the child for other issues which are involved with this NNT gene mutation. So this child was started on hydrocortisone and fludrocortisone, and the family was advised for stress dosing during illnesses. So we went ahead with 2D echo to rule out any hypertrophic cardiomyopathy, which was normal. Thyroid functions were normal, and also ultrasound scrotum was normal because we were trying to rule out any testicular inclusions. And further plan was to do genetics in parents and siblings, but because of financial reasons, like we are not able to proceed through that as yet. So the main purpose of presenting this case today is to give a message that when the clinical cues do not give us a particular idea, I think we need to think more laterally. So with this, I would like to end my presentation. Thank you.
Thank you, Dr. Monica, for that excellent presentation. It's one of the, I think, the rare diagnosis. Congratulations on an excellent workup. But definitely, nobody thinks of such illnesses initially. As we go on, I think, with the workup, it's been diagnosed. So for CAH, we definitely know the neonatal screening holds the utmost importance. I think we have to go ahead with the neonatal screening to rule out the possible cases.
Correct.
Thank you. Thank you so
Thank
much,
you so
Dr.
much.
Monica. Yeah. Calling on Dr. Anthony Roberts, sir. So, sir will be enlightening us on major surgeries in pediatrics with minimal instrumentation and maximal benefits. We all know the expertise what Dr. Anthony Roberts, sir, has, and it was pleasure working with him earlier. Over to you, sir, to enlighten us on the minimal intervention.
Dear chairpersons, Dr. Fatke, my teacher, Dr. Arvind, Dr. Akshay, and Dr. Vasudha, thank you for this opportunity to present cases in front of pediatricians. That is a memory for me more than 30 years ago when I used to present cases to Dr. M.K. Chandrasekhar and Swarna Rekha and Vasudha Rao. And it's quite an experience, so I ran away from pediatrics. Unfortunately, today you're forcing me to present in front of not one or two, but a vast number of pediatricians here. Going back to the debate between Dr. Jagdish and Dr. Datta, the question which Jagdish raised of the child asking, are you a theoretical doctor or a practical doctor? I used to struggle with that question, but recently I got my answer from an 8-year-old child getting discharged who said very emphatically, I think you're the joker doctor. So I just hope I live up to that this afternoon. I'll try and keep my cases very, very fast. Almost like Shankar Mahadevan's Breathless, because I'm the last thing standing between you and lunch. Okay. So when one has very little to speak about, they make the title very large. So as you can see my title, it is really impressive there.
It says major surgery, minimal instrumentation. That is my pediatric surgery department, and I work at the Rainbow Children's Marthalli. Right, so I'm going to run through some cases really quickly. Basic cases. So this was an antenatally diagnosed diaphragmatic hernia, counseled, prepared, came to the NICU, was well prepared for surgery. It came up, and it was a non-emergent surgery, as we know, in diaphragmatic hernia, and went home uneventfully. All of this is very straightforward. I just put the picture there to show we are working from the chest. We are pushing the colon back through the hole in the diaphragm there, and that goes in, and the recovery is fairly uneventful. Yeah, oh, sorry. How do I go back? Can I go back on this? Oh yeah, I got it. Sorry. Yeah. So then we quickly go on to another case. This is a slightly older baby. This is a 5-month-old girl child who was again antenatally diagnosed with a cyst. Postnatally, we thought it's an ovarian cyst. They were being managed conservatively. Suddenly became very, very ill and vomiting, and it showed an ovarian torsion. So we had to take up for an emergency laparoscopy. And there again, we went in there, reduced the size of the cyst, brought it out, removed the torsion, as you can see there. This one we are working as a lap assisted, where we put in the scope, bring everything out, work on it, and then put it back inside. Of course, there's no correlation between these two. I can see the professors shaking their heads and rolling their eyes, saying, what is this guy talking about? Then we go on to case 3 very quickly. This is a common scenario, much older child, which our PICU and medic scholars for. Pneumonia not getting better with the collection, multiple loculations, usual debate of do we try ICD, it goes on. Then finally they come up there, we put in a small scope there and do a decortication. Lung comes up, and most of the time we're able to get away unless there is a really bad disease which is there. My cases are going faster. Okay, this is Dr. Saumal and I would treat this child together, child with recurrent UTI. And here again, I won't go into the clinical details, but you can see the reflux going up. And on the operative side, you can see a small camera, and you can see stents in the ureter, and the ureter has been re-implanted. Most important question is, what is your connection? Why are you jumping between 4 different cases, not spending time explaining any case at all? Is there a connection at all? And that was actually the eye roll, but it's not been working. So I rolled my eyes myself. Well, there is a connection. The connection is the IPL ad which used to come. The original IPL ad was divided by teams, united by a certain fissure. Right? So then I said, these are 4 different diseases. These are 4 different age groups. These are 4 different organ systems. We're looking at the chest, we're looking at the ovary, we're looking at the bladder, and n number of, and of course, like these stars sitting there, we have that many pediatric subspecialties sitting here. And each of you in your own specialty will have a child who might need something to be done. And the good news, the basic message I want to leave today with those images and with this slide is that whatever subspecialty you may be in, if you needed help, this is a great time, because innovation has come wherein the instrumentation has got right even for the newborn baby right up to adulthood. And that is why I've put in there the thing of all of you are divided by specialties but united by the 3mm instruments, who are the actual stars of this. When laparoscopy started in children 15 years ago, that was the size of the instruments. You can see most of our needle holders and applicators were bigger than the newborn child. So it almost sounded like a joke to try to operate using these instruments. And this is a reality. But luckily, market adapts to demand. And therefore, now the 3mm instruments are literally of that size if you look at this thing, and 3mm is the diameter. And we're able to do most of our work, as you saw, different systems. We're able to anastomose, all of that using these instruments. And really the array of tools. So this is not a surgical tool workshop, but I think it's good for me just to make people visually grasp what is possible when it comes to different organ systems. So in conclusion, why talk about it? Why bring this topic into this CUSP workshop? One, I think it's different organs, diseases, regions can all be sorted using the same tool, because that is merely a tool. What is required is the skill to adapt it. And better access and magnification. Magnification is really important for us, because no matter how, like Dr. Datta said, the surgeon is a peculiar animal with a certain arrogance and all that. No matter how arrogant a surgeon may be, naked eye versus a magnification which is 4 or 5 times, increases the accuracy, increases the outcome. And therefore, that I think is a very humbling factor for a lot of us to get used to, that this is one fallacy of the work which laparoscopy has actually helped us to go beyond. Reduced tissue injury and disruption is not a theoretical difference. I think Dr. Saumil will agree. Ureteric reimplant, one of the most, Dr. Fadke, the standard one is where we used to cut open the bladder to go in and operate, which is still being done in the majority of centers. But electromuscular coordination, when you cut across half the face of the bladder, definitely suffers. Whereas when we put in a 3 mm puncture port inside it, you're not disrupting the neuromuscular integrity, and therefore the neurogenicity of the bladder risk is much lesser after this surgery. So simple things like that for tissue injury. And of course, the surgical stress response, which comes in with a big incision and handling of things, is also negated. Of course, there are cases where you can't do this, where you have to still go with the open, and earlier recovery and discharge is what we want. And of course, the last advantage of all is the child with the red top has undergone a ureteric reimplantation. That one has undergone a laparoscopic pyeloplasty. That's the child with the ovarian torsion. This is the child with the pyloromyotomy. All of them have a slightly different umbilicus, which is smiling in different ways. Apart from that, they have fantastic bellies. And they will grow up to be doing whatever they want. They might end up getting a tattoo or a piercing done later to deface it, but at least that's not going from the surgeon's side. It's something which is coming out of choice. Yeah, so let's love the umbilicus and let's love the port. Thank you.
Thank you so much, sir. I think with this surgeries, the pediatrician is happy and the parents are also happy.
Yes, absolutely.
So thank you so much for enlightening on this minimal intervention. Request the chairperson.
Thank you.
Thank you so much.
Once again, thank you to Dr. Anthony Robert Charles for that very crisp presentation. Big thank you to our moderator as well, Dr. Priya Shivali and Dr. Monica Reddy, who earlier gave us the presentation. I now request Dr. Prakash Vemgal to kindly felicitate our chairpersons. If you could kindly come up on stage. We start with Dr. Kishore. Dr. Naveen. And Dr. Shrikant. Thank you so much. Well, I know all of you are rushing out of the auditorium for lunch. Yes, we will break for lunch right now, but just to remind you once again, we do have a photo booth, which is just near the registration counter. Make sure that you use that photo booth, click some really nice pictures, and post them on your social media. Please use the hashtag CUSP, C-U-S-P, and do tag Rainbow Children's Hospital as well. And the one with the maximum number of retweets and likes will walk away with some really amazing prizes. So make sure that you make the most out of the photo booth, which is just near the registration counter. Thank you so much, and have a great lunch. We'll see you right back after lunch.
We are ready.
We too as well.
Look up to the rainbow where the colors become one. Red, yellow, orange, green is for good health and the care we need. Blue, violet, indigo is for happiness and peace to all. Look up to the rainbow where the colors become one. Look up to
Rainbow Children's Hospital and Birthright by Rainbow Hospitals.
बहुत लंबे सांस लो, दवाई लाओ।
Yes, doctor.
मुंह खोलो, अब चलो तब सो जाओ।
We don't treat children until they feel at home. That's why we have a children-centric atmosphere with high-caliber pediatricians and skillful nurses who know how to make them comfortable. It takes a lot to treat the little. Rainbow Children's Hospital.
ಜೋರಾಗಿ ಉಸಿರು ತಕೋ, ಮೆಡಿಸಿನ್ ಕೊಡು.
Yes, doctor.
ಬಾಯಿ ತೆಗೆ ಅನ್ನು. ಗುಡ್ ಗರ್ಲ್, ಈಗ ನೀನ್ ಮಲ್ಕೋ.
ಮಕ್ಕಳ ಜೊತೆ ಮೊದಲು ಗೆಳೆತನ, ನಂತರವೇ ಚಿಕಿತ್ಸೆ. ಅದಕ್ಕಾಗಿ ರೈನ್ಬೋನಲ್ಲಿ ನಾವು ಮಕ್ಕಳಿಗೆ ಅನುಕೂಲವಾದ ವಾತಾವರಣದಲ್ಲಿ ಡಾಕ್ಟರ್ಸ್ ಮೂಲಕ ಅತ್ಯಾಧುನಿಕ ಚಿಕಿತ್ಸೆ ಕೊಡ್ತೇವೆ. ಇಟ್ ಟೇಕ್ಸ್ ಅ ಲಾಟ್ ಟು ಟ್ರೀಟ್ ದ ಲಿಟಲ್. ರೈನ್ಬೋ ಚಿಲ್ಡ್ರನ್ಸ್ ಹಾಸ್ಪಿಟಲ್.
We are ready.
We too as well.
Look up to the rainbow where the colors become one. Red, yellow, orange, green is for good health and the care we need. Blue, violet, indigo is for happiness and peace to all. Look up to the rainbow where the colors become one. Look up to
Rainbow Children's Hospital and Birthright by Rainbow Hospitals.
Ladies and gentlemen, I'm sure you're enjoying your lunch, but we're going to be starting our afternoon session in the next 5 minutes. Thank you. Have the mic, please. Check. Welcome back. Good afternoon. I hope you all enjoyed a nice lunch. I know we had to crunch the lunch time because we're running way back in time, but I'm sure you had a good lunch. Thank you for joining us once again for the afternoon session. I'd like to invite our chairpersons up on the stage before we commence the afternoon session. Dr. Hem Kumar, Lead Consultant, Pediatric Intensive Care Unit, Rainbow Children's Hospital, Vijayawada. Could we kindly have Dr. Hem Kumar up on the stage? Also like to invite Dr. Nagabhushan, Visiting Professor, Rainbow Children's Hospital, Bengaluru. He has been the National Convener, Asthma Training Module from 2007 to 2012 and 2019 to 2020. He was also the Editor-in-Chief for Asthma by Consensus in 2011 and in 2019. Also the National Co-Convener, United Airways Module, IAP, and contributor to the IAP textbook and Atlas Recent Advances. Let's give them both a big round of applause. Thank you. And finally, Dr. Satish H.S. He has an MBBS Diploma in Child Health Fellowship Pediatric Intensive Care. Dr. Satish is a renowned pediatrician in Shimoga and currently practices at Ashoka Sanjeevani Hospital in Shimoga for the last 14 years. He has worked as a child specialist and gained proficient skills and knowledge in the segments. He has pursued the degree of MBBS, Diploma Child Health and Fellowship Pediatric Intensive Care. Also, I'd like to invite our speaker for the afternoon, kicking things off, Dr. Prabjot Kaur, DM in Pediatric Neurology from AIIMS New Delhi, also an MD DNB Pediatrics LHMC from New Delhi, MBBS LHMC New Delhi, Consultant Pediatric Neurologist, Rainbow Children's Hospital in Bangalore. She is a lifetime member of ICNC, lifetime member of AOCN, member of Indian Epilepsy Society, member of ILAEYES, publications in national and international journals. She also has 4 book chapters, reviewer for national journals, and her areas of interest include epilepsy, neuroimmunology, pediatric movement disorders. Kindly put your hands together and welcome Dr. Prabjot Kaur. She will be speaking on fever-related seizures and encephalopathy spectrum. Thank you.
Welcome back to the afternoon session. I think there is not even one person in this audience who has not managed a child with fever and seizures. And some of you would have got that extended spectrum of fever with seizures and encephalopathy. What's new? Let us know from Dr. Prabjot Kaur. Thank you.
Thank you. A slight error in the designation, so we'd like to request Dr. Satish once again to forgive us for that. So he's the medical superintendent and consultant pediatrician and intensive visit, Sarji Hospital, Shimoga in Karnataka. Thank you.
A very good afternoon, everybody. So I'll be talking about fever-related seizures and encephalopathy spectrum. So what I'll be covering is the common fever-triggered epilepsies with related encephalopathy. So what we are discussing about will be basically conditions which are beyond our routine CNS infections, which result in seizures in most of the cases. We will be discussing approach, which will be case-based, and management of these cases. So fever-triggered seizures are one of the commonest neurological emergencies that we see in pediatrics. Fever, seizures, and encephalopathy is also not uncommon. These are the wide spectrum of conditions, and by and large, they are mostly acquired, but we can have genetic etiologies also. So if you look at the entire spectrum of fever and seizures, so it's a very, very wide spectrum. So commonly what we see are febrile seizures. A small spectrum of febrile seizures, a small portion of febrile seizures is the genetic epilepsies. So things like Dravet syndrome due to SCN1A mutations, that is a very small proportion of fever-triggered seizures. Other than that, we have refractory epilepsies like IHHE, FIRES, AEST, which we will be discussing in detail. So if you look at the pathogenesis very, very broadly, so what we have is that fever results in a pro-inflammatory condition in the brain. And these inflammatory markers, they increase the neuronal excitability. So the neuronal excitability in itself is also increased by fever. It results in changes in the resting membrane potentials, increased synaptic transmission and vesicular transport. Other than that, there are genetic influences for both of these conditions. So the neuronal excitability per se due to inherited channelopathies and all, and also the pro-inflammatory states, the production of these inflammatory factors is also influenced by genetic factors. So all these conditions, all these factors, they result in acute onset of seizures. Now what is also seen that whenever we have prolonged seizures, in itself it produces a pro-inflammatory state in the brain, which further increases the seizures. So all these factors, in addition, lead to long-term epileptogenicity. So if we look at the spectrum of fever, seizures, and encephalopathy, so we have a group of febrile seizures. So simple febrile seizures, complex febrile seizures, or rarely Dravet syndrome. Then we have a group of conditions which present with predominantly status epilepticus. In this, we will know about fires, NORS, and IHHE. And there is a group of conditions in which encephalopathy is predominant, with or without seizures. So conditions like acute necrotizing encephalopathy of childhood, reversible splenial lesion syndromes, and AESD. So we'll be discussing these mnemonics. Sound odd, but we'll go through them. So febrile seizures, all of us are very familiar with. So they are fever-related seizures seen in kids between 6 months to 6 years age group. They can be simple or atypical. Febrile seizures plus is the term that we use when we have febrile seizures occurring in a child who is more than 6 years old. In case we have febrile plus afebrile seizures, especially which are going beyond 6 years of age, this is termed as genetic epilepsy with febrile seizures plus. And a small group of these kids will present with severe refractory epilepsy following a febrile infection, commonly following the vaccination, which is Dravet syndrome. So going beyond this, when we look at the status epilepticus predominant conditions, so there are two terms here. One is new onset refractory status epilepticus, and the second one is fires. So new onset or NORS, so it is basically new onset severe refractory epilepsy in a person who does not have any baseline neurological conditions or epilepsy. Now, subcategory of this NORS is fever infection related refractory epilepsy syndrome. So in this, again, there is an acute onset of refractory epilepsy, but it is usually following a febrile illness, which should be present between 2 weeks to 24 hours prior to the onset of seizures. Fever may or may not be present at the actual time of onset of seizures. So we'll just look at a case. So this was an 8-year-old girl who had presented to us with high-grade fever for 7 days, had 5 to 6 episodes of generalized seizures, poor consciousness, had to be mechanically ventilated, had a refractory status epilepticus, multiple anti-seizure medicines, midazolam infusion, and beyond that also we did not have a good seizure control. So the fever improved by the next 48 hours. Initial labs and cultures were all normal, CSF normal, PCRs were also normal, giving us no indication of any infection. The initial CT scan was normal. The EEG showed a burst suppression in the background, frequent epileptiform discharges and ictal runs, electrographic seizures, as well as clinical seizures. So how do we go about it next? So what should be our next plan? Do we go ahead with MRI brain with contrast? Do we start empirical ATT? Do we do an autoimmune workup, upgrade antibiotics, give steroids, IVIG? So what would you guys do about it? What will you do next? Any takers? Okay, fine. So we have autoimmune. So before that, I would want to go ahead with an MRI brain. Why? Because at this stage, we do not know, are we dealing with the cerebritis, which is not picking up on your CT scan, which is not showing up on the CSFs? Is there any underlying structural abnormality, a focal cortical dysplasia, migrational abnormalities? Is it an inherited inborn error of metabolism, which is resulting in epilepsy? Or is it a clinical radiological syndrome, something like an acute demyelination syndrome, acute necrotizing encephalopathy of childhood, and others? So for this child, we went ahead with MRI brain and contrast. So the MRI was essentially normal with few diffusion changes in the perinsular regions, very non-specific changes. So all our differentials that we had kept earlier, they go out of the window. So then we go ahead with an autoimmune workup. It was again negative. The baseline metabolic workups again negative. So if we look at the syndromic diagnosis, we have an acute onset, fever-triggered, probably acquired super-refractory status epilepticus in a child who is developmentally normal. So this is essentially what is the presenting or the presentation and evolution of the condition known as fires. So what is FIRS, or fever infection-related epilepsy, refractory epilepsy syndrome? It is a fulminant onset of bilateral focal generalized seizures or status, usually preceded by fever in school-age children and in neurologically normal children. So the thing is, immediately following this acute status, the child goes into a state of chronic epilepsy, and there is always some amount of moderate to severe neuropsychological impairment for these children. Imaging studies in acute stages are mostly normal. Long-term images may show generalized white matter atrophy or cortical atrophy and mesial temporal sclerosis. So most of the investigations that we do in the acute stage for FIRS are usually normal. It is notoriously resistant to treatment. So most kids will require multiple anti-seizure medicines, will require coma initiation for status. Ketogenic diet is one thing which has been shown in multiple studies to be effective when started in the early stage, reduces the overall seizure burden in these kids. Of late, in the last couple of years, immunotherapy has come to the mainstay in the treatment of FIRS. So anakinra is recommended now that should be started within first 2 weeks of onset of neurological symptoms. Hence lies the importance of trying to diagnose it early, trying your best to try to find out whether it is an infection or a genetic condition, so that you can go on to the next level of immunomodulation as early as possible. So this was another 1-year, 5-month-old girl, had come with 2 days of fever, left focal status, controlled with midazolam infusion. The initial labs, CSF and fundus were all okay. So the EEG showed hemispheric dominance of discharges, unihemispheric dysfunction. So when we did the CT, the initial CT showed that there is a hemispheric edema involving the right hemisphere completely. MRI done subsequently showed again the same thing, cortical edema on FLAIR images along with deep gray matter involvement, and cytotoxic edema on the diffusion weighted images. So the MRI was normal. We discharged this child after 1 week of seizure control, but at the time of discharge, she had left-sided hemiparesis, which was persisting. In follow-up, she continues to have intermittent focal seizures. So this is infantile hemiplegia with hemiconvulsion syndrome. It occurs in previously well kids who are less than 2 years of age. It is a clinico-radiological syndrome. So to make a diagnosis, we need to have radiology in addition to our usual investigations that we do. So presentation was like in this case, acute onset focal status, post-ictal hemiplegia, hemispheric cytotoxic edema. Usually after a seizure-free interval of few months to years, these children will have refractory focal seizures, will have variable residual hemiparesis, and hemiatrophy on neuroimaging. So usually it is idiopathic. Sometimes we may find underlying structural abnormalities which the child may previously have. So this case was this next child. I had seen this child at the age of 23 months of age. So at this time, he had regression of all milestones after acute febrile illness at 14 months of age. Pre-morbidly, this child was walking independently. So at this time, at the time of presentation, there was no neck holding. There was no meaningful response to parents. Had polymorphic epilepsy on multiple seizure medicines. So when we go back to the history, the child had acute onset fever at the age of 14 months with seizure multiple episodes, generalized. And after this, the baby was a little dull. So in the admitting hospital, he was evaluated. All things were found to be normal. So this is something that we would usually see. A child is having fever, 2-3 episodes of seizures. We think it is a simple febrile seizure or a complex febrile seizure and leave it at that. So 2 days later, this child has a refractory status epilepticus with polymorphic seizures. CSF PCRs were negative. He was not responsive to your usual seizure medicines, midazolam and phenobarbital infusions. The MRI which was done at that time showed bilateral diffuse subcortical diffusion restriction. So this is a pattern which is known as acute onset delayed diffusion restriction. So this child was given steroids, IVIG and rituximab, but continued to be encephalopathic and have a chronic epilepsy. So this is known as AESD, which is acute encephalopathy with biphasic seizures and delayed diffusion restriction. Again, a fever-triggered condition, usually in small children. So what happens is, with the initial fever, these kids will typically have 1 or 2 seizures or a prolonged febrile seizure, after which they either come back to the normal baseline state, or they may have some level of disturbed consciousness, alteration in sleep, some confusion, beyond which, after day 3 or 4, they start having again refractory multiple seizure episodes, following which there is loss of all milestones. And again, the MRI pattern is classic. So it is again a clinical radiological syndrome. We want to diagnose it because we want to plan our workup accordingly. We prognosticate our parents accordingly. Okay. So this boy was an 11-year-old boy, had an acute onset encephalopathy over 24 hours. Doubtful history of seizures, some posturing prior to intubation, and there was a history of low-grade fever with the upper respiratory tract infection. So we could do a CT for this child, which showed bilateral thalamic hypodensities, which are symmetrical bilaterally, had transaminitis in his lab workups. The rest of the labs were normal. We started this child on dexamethasone, but unfortunately, we lost this child within 24 hours because of extensive brain edema, involvement of the brainstem and the cerebellum. So this is imaging which is very characteristic for acute necrotizing encephalopathy. Again, a clinico-radiological syndrome, usually characterized by a prodromal stage of a very innocuous kind of infections, upper respiratory tract infections, diarrhea, vomiting, following which there is sudden onset severe encephalopathy, following which there is a recovery phase, a lot of neurological sequelae. So usually the course is like this. Investigation-wise, we may find elevated CSF proteins without any pleocytosis. Neuroradiological findings are characteristic. We characteristically see bilateral thalamic symmetrical involvement and these type of lesions which are known as target sign. We have the innermost layer of necrosis followed by active cytotoxic edema, or ongoing inflammation, and followed by an outer layer of vasogenic edema. So elevation of ASTs with normal ammonias may be seen, and we should exclude other resembling diseases. Now there's a subgroup of ANE, which is known as ANE type 1, in which we may get a family history of similar disorder or recurrent encephalopathy in the same child. This ANE1 is usually associated with RANBP2 mutations. So any child which we are diagnosing as ANE1 should be offered a genetic testing. So usual triggers are influenza and H1. So influenza vaccination may have protective effect. Treatment-wise, dexamethasone or steroids have been tried, not very good results. These days, we have emerging evidence that tocilizumab may be effective when used early. Genetic testing should be done for ANE1. High mortality rates, almost 30%. Intact survival is seen in less than 10% cases with high neuromorbidity in survivors. So last of these group of lesions is reversible encephalopathy with splenial lesion syndrome. Usually again the same story, prodromal minor illness, 1 to 2 days later you have a encephalopathy. Frequently we'll see seizures, sleep disturbances, delirious behaviors. CSF may be normal, may show mild changes. Hyponatremia may be associated. So characteristically what we see again is the imaging will give us the diagnosis. We see T2 and FLAIR changes in the splenium of the corpus callosum. So the good thing is this is one of the conditions which has got a good outcome. Usually we do end up giving steroids, but it has been seen that with or without steroids, these children tend to do well. So just a word about genetic syndromes. Many of the genetic epilepsies or genetic conditions may be triggered by acute febrile illnesses. Common one of which we know are channelopathies like SCN1A and SCN2A. Other than that, PCDH19, STXBP1, SCN2 mutations. Newly DMLL1 mutations are associated with these kind of presentations. Mitochondrial cytopathy, especially ALPers associated with Polg mutations, can present like this. So when we want to investigate a child who comes to us with this kind of presentation, you have fever followed by encephalopathy and seizures, we should try our best to try to find out whether it is an acquired cause. Is there something treatable? So we will try to look for all infections, send blood cultures, CSF cultures at the earliest, any additional testing which is clinically indicated. CSF PCR panels definitely should be done because it saves us a lot of time. We go to the next line of therapy sooner rather than waiting for cultures. CSF should be done in all cases, baseline metabolic profiles, and in case it is an immunocompromised host, we should do additional testing as needed. So the next line of testing or the next line of investigation is the neuroimaging. It becomes a must because as we have seen that most of these things we can diagnose on MRI. It helps us to plan our workup. It also helps us to plan our treatment part as well as prognostication part. Once we are done with the first line investigations, second line investigations are largely dictated by how our MRI looks. If the MRI is normal or non-specific or has AEST or IHHE pattern, we go ahead with metabolic testing for any inherited IEMs. We do autoimmune workups. And in case it is specific like acute necrotizing encephalopathy or RES-LES, we do try to look for respiratory pathogens, metabolic study, and genetics as it is indicated. Okay. So third line investigations is usually genetic testing when we have a clinical situation which is consistent with the genetic etiology. In case we have a very strong suspicion that probably these seizures are caused by a focal etiology or a focal lesion, something like a something like a FCD, we should go ahead with the PET. Serum and CSF cytokine profiles whenever necessary. Muscle liver biopsy or even brain biopsy may be needed to reach a diagnosis in some cases. So treatment-wise, we follow our standard SRSE protocols. Neuroprotection is of the utmost important. Additional therapeutic options include ketogenic diet, which is one thing we should try and start early for patients who once we are aware that these children are going to go into SRSE. So we have started midazolam infusion. We are still seeing that the seizures are not controlled. Ketogenic diet should be started early. Other than that, therapeutic hypothermia is another thing which we can do in our settings. Cannabidiol, we don't have availability in our country. Other than that, VNS, magnesium sulfate, ECS, and that is electroconvulsive therapy and deep brain stimulation do not have a lot of evidence in childhood epilepsies. Beyond that, immunomodulated therapies are very, very essential. We should try to start that early. We should target that we should be at least 48 hours down the line after the child is with us. We should be able to give at least some thought of immunomodulatory therapy. So broad spectrum, methylprednisolone or IVIG, we can give upfront. Plasmapheresis if we have antibody positivity. Other than that, in a condition like FIRES or ANEC, we should consider early administration of anakinra or tocilizumab. So take-home points is that, see, it's a very wide spectrum. We end up encountering febrile seizures and fever-related seizures commonly, but once they are progressing, we should be aware of these conditions. We should always try our best to look for infections or treatable etiologies. Early imaging is essential so that we can arrive to a diagnosis. Early immunotherapy, again, very, very essential because it can result in decrease in seizure load in one of these refractory epilepsies. So that will be all. Thank you. Any questions, I'll be happy to take.
Madam has given, in short, she has given a complete picture of cases with fever and convulsions. The most important thing is to make a diagnosis. So that you can do specific treatment and explain the parents regarding the prognosis. So if any of the general pediatricians, if you are in doubt, please contact pediatric neurologist. No, because since I have been practicing since last 20 years, and now we have a pediatric neurologist in our place, and it has helped us a lot to make more specific diagnosis. And just I wanted to know when to do EEG and what should be the choice of neuro imaging, CT versus MRI. Please highlight.
So CT is always best when we do it in the immediate stage. We have an idea of at least the acute treatable conditions, any hydrocephalus, space occupying lesions. Beyond that, in case 36-48 hours, we are not finding that the child is not improving, we should go ahead
for
with
all
MRI.
cases, you do CT and then go for MRI, or?
We usually do CT upfront, sir.
CT for all cases?
Yes. So we should try to do CT. And other than that, if you ask the investigation of choice, it is MRI. But a child who is acutely presenting with status, it is not possible to take for MRI every time. And EEG, if any child with status, once you have gone to up to at least midazolam infusion or you're seeing that multiple seizures are coming, we should hook up the child to EEG.
When a child is on a ventilator, how do you go with EEG?
We can, for ventilated kids, we can do EEG. It is not a contraindication. Yeah.
Okay.
Yes. Thank you.
Any questions from audience?
Yeah, thank you. Let's give a big round of applause to Dr. Prabjot for that. We now move on to our next session, which is going to be a virtual session, and I'd like to introduce the speaker, Dr. Daiva Kumaran. He's the head of department and consultant pediatric neurologist, Paris South University Hospitals, Paris, France. He is the national coordinator for neuroinflammatory diseases in children in France since 2007. He is in charge of the national cohort of demyelinating diseases in children. His research focuses on immunological mechanism underlying demyelinating diseases. He leads the Neuroimmune Diseases Group in the European Reference Networks, RITA, and the European Consortium on Acute Demyelinating Diseases with anti-MOG antibodies. Let's put our hands together and welcome Dr. Daiva Kumaran. Can we connect to Dr. Daiva?
We are looking forward to hear you, Dr. Devakumaran. Please go ahead.
Hello, I don't know whether you hear me. I'm just
I think you need to switch on your camera.
Oh, okay.
Yes,
yeah.
Perfect. Thank you.
So I'm trying to share my screen. I don't know whether you see the screen because I don't see anything. Do you see the? Oh yeah. Okay. Okay, great. And again, I would like to thank the organizing committee to have given me this opportunity to share with you our experience on diagnostic challenges and therapeutics on immunoencephalopathy and encephalitis. And as you may have seen that I've added the term of encephalitis because the recent criteria have been challenging and these words are used interchangeably. So for the sake of my presentation, I will mostly talk about encephalopathy instead of encephalopathy. So these are my disclosures. And you know that there are many kinds of aggression that can occur during any kind of situation. And the most frequent situation that you can all see is the infection. And among infection agents, you can see have viruses. And these viruses can enter into the brain and go and attack the neurons, inducing brain damage. And they can also induce during their infection immune stimulation of immune cells and secretion of mediators such as cytokines and chemokines. And sometimes we can have also immune cells that are reacting against our self-antigens, and particularly the brain antigens, and then inducing again secretion of mediators such as chemokines and cytokines again, and induce a big inflammation in the brain. This is what we are going to see in my talk. So what kind of immune cells are involved? This is important because we need to know the physiopathology of the disease that we are treating. And of course, it can also help us to use a specific therapeutics that are specifically oriented toward the disease. So as far as the innate immunity is concerned, you will have monocytes and macrophages and dendritic cells. They are mainly activated during infections, but in recent data are showing also that they can also be activated during the other autoimmune diseases. You will of course have B cells. They are the precursors of plasmocytes. Which are the main cells that are going to secrete the antibodies. And of course, you have the T cells, which are TCD4 or TCD8. And among TCD4 cells, you have T regulators, TH17 and TH12 cells, which can be dysfunctional and give some diseases. So can I move myself? Sorry, the slides, please. So what I wanted to say is that, of course, it is going to be very naive to say that one kind of immunity is going to be the sole activator of the neuroimmune diseases, but they are interacting between them. So sometimes can help us to understand why one specific treatment is not working in some specific diseases. So recently, Cerrucci and all have established diagnostic criteria for autoimmune encephalitis, specifically in children. In that presentation, in their work, what they have shown is that they have added a new kind of practical things, such as the possibility that encephalitis can be subacute, and whenever it's subacute, it should not be less than 3 months. It should not be more than 3 months. And then they have added other clinical evidence of neurological dysfunction. Usually, we know that the altered mental status or level of consciousness, focal neurological deficits, and seizures not explained by previously known seizure disorders or conditions. Among them, they have added also the cognitive difficulties, acute developmental regression, movement disorder, eccentrics, and psychotic symptoms are added as other clinical evidence of neuroimmune disorders. And of course, for the paraclinical evidence for neuroinflammation, we will have the assessment of CSF, looking for meningitis, abnormal MRI, abnormal EEG, and of course, whenever it is possible, when the situation is very complicated, the brain biopsy, which will help us to show there are immune infiltrates in the brain, or it will help also to exclude other disorders. Of course, the must is the detection of autoantibodies, such as the NMDA receptor or any kind of other antibodies. And more than those practical things, I think the main and the important thing is the exclusion of other etiology. And from there, we will have three different situations. First of all is going to be the definite antibody-positive autoimmune encephalitis, where we'll have more than 2 clinical features, more than 1 paraclinical features, and of course, the positivity of antibody. If the antibody is negative, but we have the other 2 criteria that are expected, we're going to call it probable antibody-negative autoimmune encephalitis. And the most challenging part is going to be where you are going to have clinical evidence of neuroimmune disorder, but no preclinical evidence and no antibodies. These are really the most toughest situation that we can handle. So first of all, let's go and see if some examples of the neuroimmune diseases affecting B cells. So these are situations where the child can come with this kind of abnormal movement affecting the face and the mouth, and they can also have abnormal movements of the limbs, and these are called oral dyskinesias and dystonias, or even choreoathesis for some of these presentation. And of course, you have most probably guessed that these are anti-NMDA receptor encephalitis, which is the second most frequent encephalitis after ADM. In this French study that we have performed with our in our center, we have shown that the median age of these children was 10, and the first presentation can sometimes be tricky. Of course, it can be sometimes seizures, which can be either partial or generalized, and sometimes can be only behavioral changes. And all these symptoms can get all together, giving a complete clinical syndrome with psychiatric movement, seizures, movement disorders, and in children that can be also sometimes decreased level of consciousness and loss of language, which can be very important in these situations. And what is important to notice also, because it is different from the adults, is that the tumor is really rare in children. It is between 3 to 5% of our kids where we can find this specific tumor, which are the teratoma, ovarian teratoma in girls, and testicles for boys, and in adults it's going to be more than 50, and this can explain also sometimes the difference that we can see in the treatment strategies that are proposed in adults and children. Relapse rates are quite rare. The diagnosis is mainly made by detecting anti-NMDA receptor antibodies in the CSF. Initially, with Professor Angela Vincent, we thought that the serum would be enough. Finally, we understood that the specificity and sensitivity of these detections is very low in serum. So nowadays, we should absolutely do only in the CSF. EEG is always abnormal. We haven't seen in children specific pattern, but adults have described extreme delta brush, the situation that can be seen. CSF is mostly abnormal with meningitis, and MRI can be abnormal. It's only 1/3 of our children had abnormal MRI. And usually we are waiting for or looking for lesions in the temporal lobe, as it is said to be a limbic encephalitis. But the reality is that it's rarely affecting the limbic regions, but it can be mostly in the posterior fossa. Sorry. The 2 words for the physiopathology. What I wanted to say about the physiopathology is that the presence of these antibodies induce a reduction of the NMDA receptor on the surface of neurons, which would induce modification of calcium influx in these cells. And by doing that, it degrades the neuronal networks, and it would go, which can explain the disease symptoms. The most important thing that I wanted you to show is that there is no neuronal death, or that means that for the outcome, this is important, and we should not leave the child if even though it takes more time without any treatment, if they are really very in a bad situation. So as I previously said, the motor outcomes really good. 85% of our children have recovered completely in the motor area. only 15% of these children had a more severe motor sequelae. The recent study that we have performed in 82 children with anti-NMDA receptor has shown that cognitive disability is more than what we have expected, with 45% of them having severe difficulties. And these difficulties mostly are focused on attention deficits and language difficulty after 2 years of follow-up. 70% of our children had difficulties in academic performances, and 54% needed psychiatric and psychological follow-up. The prognostic factors for bad good outcome has been studied in a recent meta-analysis with the adults. And what they have shown is that the younger age, ICU hospitalization, extreme death brush pattern, the EEG, specifically in adults, late treatment more than 30 days and maintenance treatment with IVIG seems to be associated with bad outcome, while adolescent plasma exchange is the first line. Use of steroids and IVIG or IVIG steroids and plasma exchange seems to be associated with a good outcome. One word on the post-herpes simplex virus encephalitis, anti-NMDA receptor encephalitis. This is a situation that can occur after HSVE. We historically knew that 30% of HSVE can relapse, and we initially thought these relapses were related to viral infection, viral reactivation, which was not the case. And recently, we have shown, and of course, it has been confirmed by our Spanish colleagues, that 27% of these affective relapses are mainly anti-NMDA receptor encephalitis, which is probably due to a molecular mimicry between the virus and the NMDA receptor. It occurs mostly 1 or 2 months after HSVE, and even if you have given earlier the treatment with aciclovir. Our Spanish colleagues have shown that the younger patient is the outcome is severe. So this is the treatment strategy that I'm proposing actually. We will do plasma exchange with IVIG. Of course, there are centers where it's cannot be performed, and in those centers, we will of course ask to start at least with steroids until we find the time to get this patient into a good center in a center where we can do the plasma exchange. We'll wait for 1 or 2 weeks, and we'll monitor the Rankin score. If it is stable or aggravating, then we'll go for rituximab, which is the anti-CD20 against these cells. Treatment, and we'll wait again for 4 weeks, and we don't see any modification. We'll go for methotrexate IT with depomedrol, which is going to be an injection, monthly injection, at least 3 times. And if it doesn't work, then we will propose bortezomib, which is a treatment which is specifically acting on plasmacytes. And today we have some experience with tocilizumab treatment. It seems to be also working. The main thing between those 2 treatments is the rapidity of the clinical outcome that it seems to be slow. Inebilizumab is a recent treatment that has been proposed in other clinical disorders, and it is an anti-CD19 treatment, which is mostly focused on plasmacyte again. And the others are actually doing a clinical trial, and we may start this study also for children. Just an example of the bortezomib treatment. Here we have a child who had a Rankin score of 5. He had all kind of treatment that I previously said. And 2 years after, when he came to our clinic for a second opinion, we started the treatment bortezomib with a Rankin score of 5. And we saw that the child recovered after the 3rd injection, and progressively he went on getting better. And we had it after a discussion with our oncological colleagues with the dexamethasone, and really is now with an Rankin score of 2 to 1, even though he's not normal, he has really recovered well. This is after 2 years. This is the why I wanted to present this case specifically. So another disease where the B cells and TCD4 cells can be abnormal. Here is Hugo with a boy of 6 years old. He complained of gait difficulties and fatigue since 2 days. He had otitis media 10 days before. During the ER, during the examination, he had no fever. He was a bit sleepy with a left facial paralysis and bilateral pyramidal syndrome with CSF, abnormal CSF with meningitis. And this is the MRI that he had. You can see that there are lesions on the deep gray matter, which seems to be a bit symmetrical, not completely symmetrical, and white matter lesion, extensive light matter lesion, which did not take GAD enhancement. And you have also guess that this patient had an ADM presentation, which is a acute demyelinating encephalomyelitis. And though these are the lesions that are frequently seen in this condition, subcortical lesion, infrafrontal lesion, large lesions, and deep crate metal lesions, which can give some problem, diagnostic challenges with metabolic diseases such as the mitochondrial disease. So rarely the gadolinium is enhancing, and sorry, it's not under my control, so it's going on. So GAD enhancing is rarely seen when we compare to adults. ADM presentations are frequently more than 50% of adult patients have a GAD enhancing lesion. This patient had also anti-MERV antibody positivity. These antibodies are directed against myelin oligodendrocyte protein, which is a rare protein which is expressed on the myelin sheath or in the CNS. So the definition of ADM is a polysymptomatic clinical event affecting multifocal areas of the CNS, as is my previous person who talked. This is also a radiological and clinical syndrome. We absolutely need to have alteration of consciousness, which can be either a little modification of behavior, sleepiness. Of course, coma is really easy to help the diagnosis to be performed. MRI features, as I previously said, and these clinical situation and even radiological situation can fluctuate during 3 first months, and doesn't mean that we need to change the diagnosis of that because patients can recover completely and have a new relapse during the first 3 months. That doesn't mean they have another diseases, but you need to think about the ADM. This is the most frequent encephalitis. That's why I wanted to make a point with this disease. And most of them are actually anti-MERV positive, and this is actually MERV antibodies and the ADM are part of the what we call MOGAD, which is the MERV antibodies associated diseases. And this is also a new challenge that we are getting more and more, because ADM presentation can be the first episode of multiple sclerosis. It can be also a first episode of neuromyelitis optica spectrum disorder, where you can have affection of the eye and the spinal cord with specific diagnostic criteria that I'm not going to talk today. And it can be also positive for anti-MERV, as I previously said. And they can also be seronegative and be only monophasic. So the clinical presentation, as I previously said, the sex ratio is equal between girls and boys and children. And you can see here the most frequent presentation in children is going to be optic neuritis and ADM. And the presentation is going to be dependent on the age. When the child is less than 10 years old, the presentation is most oftenly be ADM presentation, while they are, it can be optic neuritis if they are more than 10 years old. There is a quite frequent recurrences that can happen, and depends on the cohort that has been studied. In some cohorts, 17 to 47% of recurrences have been observed. And when we look for the outcome, the motor outcome is again good, but visual outcome can be abnormal in 30% of our children, and cognitive difficulties have been observed in 26% of our children. So there have been some studies that try to find whether there are prognostic factors for relapses. What our German colleagues showed is that if the antibody titers are higher and persisting, then it can be a prognostic factor for relapse. Other presentations such as optic neuritis, ADM presentation, and ADM-ON presentation is quite frequent in children. That means that the child begins with an ADM presentation and then will relapse as an optic neuritis several years after, and will only have relapses with optic neuritis. And the older age of presentation is also seen to be a prognostic factor for relapses. Prognostic factor for poor outcome is the transverse presentation in children. And what we have seen also is that whenever there is a deep gray matter lesion with younger age, these patients are associated with poor academic performances. So these are the recommendations from the European Pediatric Demyelinating Disease Consortium for the treatment for MOGAD and even ADM. We will start with the steroids. These diseases and ADM are very corticosensitive, and these are the treatment studies that we propose. We'll start with IV steroids, and then if it doesn't work, then in France we'll go for the plasma exchanges. while in Germany, for example, they go for IVIGs. Once the patient seems to respond well to these steroids, we will leave them with the steroids for at least 3 months, not more than that. Otherwise, they have lots of side effects. If the patient relapses, then we'll propose a long-term immunosuppressive treatment. And the long-term suppressive treatment, you can see that we'll propose azathioprine, mycophenolate, Vitax, or IVIG. Why these possibilities? Because we didn't see in our retrospective study that any of these treatments seems to be highly effective comparatively to the number of relapses. Maybe IVIG may have a bit of an effect on the EDS score, which is the score for the disability, but not on the relapsing score. So another important point to notice is that if the patient is stable over 2 years without any clinical relapses or radiological modification, then it can decrease and de-escalate and stop the treatment. So another interesting case is this is the girl of 8 years old with seizures and hemiparesia. She came with an CSF, with a really abnormal CSF with meningitis and orthogonal binding positivity. Here is the MRI. You can see that the limbic region is affected, and maybe she would have a limbic encephalitis. Of course, we have performed all antibody exploration, which came back negative. She spontaneously recovered, but she had fever and progressive neurologic degradation with this kind of lesions, with long, extensive spinal cord lesion, with Gardner's lesion, and the brain involvement, which is not very clear cut. But I mean, the lesion space is not very clear, but it was quite infiltrative. And we thought, as you maybe MOG positivity, but we really looked for MOG antibodies with the two kind of techniques that we are doing, which is the CBA and the immunofluorescence and interacting immunofluorescence, which was negative. Again, the CSF remained inflamed. And finally, when we performed the medical history and personal history of the child, she had relapsing aftersys, recurrent fever, and MRI is most likely as a neuroblastoma disease. So she's now on azathioprine and without any relapses, but she has big sequelae, motor sequelae actually. So another disease affecting TCD8, Vincent, 8 years old, is a boy with a familial history of thyroiditis. He complained of headaches with meningitis, with no fever, with CSF going, showing meningitis, and he recovered spontaneously. The PCR for EBV PCR was negative, but serology was quite bizarre with positivity. And then he came back 1 month later with febrile contacts, with modification of his behavior, apoptosis, and he complained of diplopia, and the ophthalmologist said he had bilateral papillary edema. And you can see the MRI, it's not very, very clear. It looked like there's some kind of lesions, and kind of lesions. And then we started IV steroid treatment. He did not recover completely, but he came back 3 weeks later with loss of weight, meningitis, CSF inflammatory, was inflammatory splenomegalia, and of course he had the bicytopenia, positive PCR, EBV, BT, and NK lymphopenia with this kind of lesions, which are not quite similar in lesions that I've shown previously for ADM. And finally, he had a HLH, hemophagocytic lymphocytosis with MUNC 18.2 mutation. So these are the diagnostic criteria for hemophagocytic lymphohistiocytosis. It should be clinical and biological, and neurological involvement can affect 45% of these children, but 7% may start only with neurological involvement, such as our previous child. So we need to be very careful whenever we are going to talk about ADM. Of course, when they are seronegative, we can have this kind of children with similar age and similar kind of clinical presentation, and abnormal CSF or not abnormal CSF, and lesions that can be quite similar to. And some of these can be HLH, and some of these can be ADM. And that's why we performed previously a study comparing the MRI of these children, and we found that the symmetrical lesions and affecting periventricle, located in the periventricle area, and with less lesions on the brainstem, and less hypo T1 signal can maybe help us to differentiate both of these situations, although it is not specific lesions. The treatment, of course, is different between ADM and the HLH, because the hematopoietic stem cells transplantation, which is the curative treatment for HLH, but it can also respond to the treatment of steroids or alemtuzumab. So what I wanted to conclude with those cases that immune encephalitis may be severe onset. We need to make the right diagnosis quickly in order to establish treatment and also to try to put a specific treatment. Neurological symptoms may precede some systemic or non-systemic diseases. And if brain does not explain, then we need to look out for outside the brain for the diagnosis. Thank you very much, and I am open to questions.
Thank you so much, Dr. Deva, for that presentation. Any questions from our chairpersons? We'll take one question from the audience. Can we just hand over a mic, please?
My question is regarding the therapeutic options for autoimmune encephalitis. So many times if the antibodies are non-positive, when it is seronegative, would you prefer to go ahead with IVIG or plasma exchange? Like, how do you choose? You had given plasma exchange bar IVIG as your first line therapy. So how would you choose between these two? Is there any categorization or like how to decide on further plan if it is seronegative?
Yeah. Oh, thank you very much for this question. And I think it is very simple, because when the physiopathologically the treatment, the best treatment is going to be the plasmapheresis, because you are going to exclude all proteins and immunoglobulins by doing the plasmapheresis. The problem with plasmapheresis is not very accessible to everyone, and every center does not have a plasma exchange in France even. So whenever it is possible, my first priority is going to be the plasmapheresis. If it is not possible, then we can discuss, or if it is seronegative, we can discuss about two treatment, of course, IVIGs, but you do know that the problems that we have actually with IVIGs, we don't have enough quantity of IVIGs to be given for everyone. So I would rather start with steroids, because it's large, and even if you think of autoimmune encephalitis, I will go for the steroids, and then IVIGs, of course, which can be a good option. It is possible to get it easier.
Well, thank you so much for the question. And let's give Dr. Deva a big round of applause for this brilliant presentation. Thank you so much for joining us, Dr. Deva.
Thank you.
Before we move on to our next presentation, which is going to be a panel discussion, I'd like to hand it over to Dr. Pavitra Vishwanathan. She has a little surprise quiz for us, so I'm going to hand it over to you. I also request our chairpersons to kindly take your seats in the audience for just the panel discussion, and we will have you back on stage. Thank you.
Hello, everybody. We had actually planned to conduct this quiz in 3 parts, but in view of lack of time, I'm going to conduct it in 1 session. Hope all of you have your phones in your hand. It has a good internet connection? No? Unfortunately, that's all you will need for this quiz. Okay? So we have got exciting prizes waiting for you. We'll have around 9 questions, and we'll have leaderboard at the end of every question. Okay, and at the end of the quiz, whoever has the most points, the first 3 winners, you'll get a good prize. All right? The website is ahaslides.com. Okay, you can either use the code DJPW0, or you can scan the QR code that has already been shared to you in the delegates group. Hope all of you are joining. We'll start it once we hit around 50 players. So be quick. Rakshay sir, Deepak sir, you are not joining? You don't want prize? Not for you. They can join at any point in time. Okay, we are going to start the quiz. The faster you stay. The faster you answer, the more points you will get. Those who have attended our ventilation workshop should be able to answer this easily. Looks like Dr. Pradeep is on the top. Five seconds more. Hope you guys have arranged it in order. Okay, this time Dr. Purushothaman is taking the lead. Those who have heard our neurologist talk, you must be able to give this the right answer. Excellent. Okay, Dr. Jana is leading right now. Dr. Purushothaman is closely following. Okay, so this has got nothing to do with knowledge. It's purely luck. Okay, we'll do spin the wheel later. Dr. Reshma is leading. Sonic workshop participants, you should be able to take the lead in this question. Let's see who's taking the lead. Dr. Jana is back up, and we have Dr. Nikit. Interesting emoji. Somebody keeps clicking that crying emoji. I don't know who. Who wants to cry? Dr. Khan is in the lead now. Okay, this is a surprise spinning wheel. I don't know who's going to win. It's not under my control. Who's Dr. A.S.? Dr. Arvind Shenoy? Seriously? Congratulations, sir. You're our surprise winner. Do you guys know who these scientists are? Dr. Vasudha mentioned them briefly during her talk. I think I've already given you guys a clue. Right? In 2018, they were awarded Nobel Prize for their work on immune checkpoint inhibitors. Dr. Jana is still in the lead. Dr. V is following, but there is a vast difference. 2 more questions to go. Let's see. Okay, let's see. Dr. Kishore is closely there, just 10 points difference. Okay, last question. Thank you all for participating. Let's see who the winners are. Dr. Kishore took the lead at the last moment, right? Followed by Dr. Jana and Dr. V. Can you guys please stand up? Congratulations to all three winners. You can collect your prizes at the end of the day, just before the vote of thanks. Thank you.
Thank you so much, Dr. Pavitra. Who doesn't like a quiz? You really kept everyone hooked on. Thank you so much for that. Congratulations to everybody who participated and the winners as well. We now move on to our panel discussion, and I'd like to invite on stage our moderators, Dr. Deepak Ramesh, and his academic qualifications include an MBBS from JSS Medical College and Hospital, Mysore, DCH from Maulana Azad Medical College, Delhi, DNB Pediatrics, Rainbow Children's Hospital, Hyderabad, Indian Fellowship in Pediatric Critical Care Medicine, Rainbow Children's Hospital, Hyderabad, International Fellowship in Pediatric Intensive Care, Birmingham Children's Hospital, UK. He is currently a consultant pediatric in intensive care and pediatrics, Rainbow Children's Hospital, Marathali. Please give Dr. Deepak a very warm round of applause. Thank you. You can kindly take your seat. Yeah. Our next moderator is Dr. Vinu Narayan. She's a consultant medical genetics, Rainbow Children's Hospital, Bangalore, Center for Human Genetics, Bangalore, Manipal Hospital, Old Airport Road, Bangalore. Her educational qualifications include MD Pediatrics, BJ Government Medical College, Pune, Maharashtra, DNB Super Speciality, DNB SS Medical Genetics, Sri Gangaram Hospital, New Delhi. Special training from the McCusick Short Course in Human Genetics at Jackson Laboratory, Bar Harbor, Maine, United States. And her area of interest includes neurometabolic disorders and intellectual disability, inborn errors of metabolism, prenatal diagnosis of genetic disorders, and newer therapeutics of genetic disorders. Please put your hands together and welcome Dr. Vinu Narayan, our second moderator for the panel discussion. And of course, on to our panelists, I'd like to invite on stage Dr. Indumati C.K. She has her MBBS from the Ballari Medical College and Research Institute, DCH BMCRI, DNB Pediatrics, St. Martha's Hospital. She's a former professor of pediatrics, St. John's Medical College Hospital in Bangalore. She's currently the professor and HOD of pediatrics at the Bowring Hospital. She enjoys teaching undergraduates and postgraduate students, and her areas of interest include pediatric infectious diseases, especially pediatric TB and primary immunodeficiencies, and special interest in BCG and NTM, non-tubular microbacterial diseases, MSMD. Another round of applause for Dr. Indumati. Kindly take your seat, ma'am. Our next panelist is Dr. Satish Kumar. He's a consultant pediatric rheumatologist, professor of pediatrics, Department of Pediatrics, Christian Medical College, Vellore. He has quite a few important achievements in his belt. He has Pediatric Rheumatology Fellowship from 2006 to 2008, Hospital for Sick Children, University of Toronto, Canada, Jeff Carr's Lupus Fellowship from 2008 to 2009, Hospital for Sick Children, University of Toronto in Canada. He started the Pediatric Rheumatology Service in CMC Vellore along with Dr. Debashish Danda, Assistant Editor of IJRD Pediatric Section, Reviewer of Pediatric Rheumatology and Rheumatology Journals, and has over 90 national and international publications. His areas of special interest include the Kawasaki disease, pediatric lupus, juvenile idiopathic arthritis, systematic JIA and MAS, and pediatric uveitis. Big round of applause for Dr. Satish Kumar. And our final panelist for the panel discussion, Dr. Girish 8C. He's the head of pediatrics and pediatric critical care, Fortis Hospital, Richmond Road, Bangalore. And of course, his achievements in educational qualifications include MBBS, Mysore Medical College, MD Pediatrics, University of Delhi, Residency in Pediatrics, State University of New York, Brooklyn, Fellowship in Pediatric Critical Care, Children's Hospital of Los Angeles, Locum Consultant in Pediatric Critical Care at Queen's Medical Centre, Nottingham, UK, Leeds General Infirmary, UK, National University Hospital, Singapore, American Board Certified in Pediatrics and Pediatric Critical Care, and CCST from Royal College of Pediatrics, UK. Our final panelists, please give them a round of applause. And of course, handing it over to our moderators for this panel discussion. Thank you.
Thank you very much. Can I have the slides, please? So this is an interesting session where I am going to present a case which we managed, and I'll give them a brief history and the management part. Then we'll ask our experts what exactly they think of the management and what else could be done. And then finally, once we get all the expert comments, Dr. Vinu will be telling us what is the basic pathology. So, can we have the slides? Okay. So we have a 2.5-month-old girl who presented with fever of 4 days, decreased activity and poor oral intake for the past 2 days. She was born via a term vaginal delivery with a birth weight of 2.5 kgs, and there was a 48-hour NICU stay because of respiratory distress. She is on breast feeds and there is no history of prior hospitalization. So she had an interesting family history. So this is the 3-generation chart which you can see. Father had chronic pancreatitis from 20 years of age, for which he's on Creon supplements. Paternal grandfather had diabetes mellitus, and grandmother had breast carcinoma. This child presented to us on day 4 of illness with irritability, tachypnea, and mottled appearance. Her airway was clear. She was maintaining saturations in room air, but was having respiratory rate of 50. Heart rate was around 180 with just about normal blood pressures, mostly hypotensive, with all peripheral pulses palpable. She was slightly irritable, but otherwise there was no focal neurological deficit, and she was febrile. So our initial categorization was that she was unstable and it was a non-life-threatening condition. So when we did the systemic examination, the abdomen was soft, spleen was firm with 3 centimeters, bowel sounds were sluggish, CNS, she was irritable with no focal deficits. Bilateral air entry was equal, and S1, S2 was normal with no murmurs. Anthropometry, weight was 4.5 kgs. Length was 56 centimeter, head circumference 46 centimeters. They were predominantly in the normal range. Pallor was present. There was no icterus, no obvious neurocutaneous markers, and no petechiae or purpura. So we admitted this child in the PICU, and we've worked up. She came to us with a hemoglobin of 7.7. Total counts were mildly on the lower side, 2,550. Platelets were 35,000, CRP was 43, and mildly elevated liver enzymes were present. So this was a time where dengue was prevalent. So our initial diagnosis was dengue with a secondary infection or a direct sepsis. We admitted the child to PICU, resuscitated with fluids, and started the child on antibiotics. Within the next 8 hours or so, we got dengue ELISA report positive to be IgM. So we continued the same line of management. On the next day, we found that her hemoglobin had dropped further to 6.6. Total counts had dropped to 1,770 with predominantly lymphocytic count. Albumin was 2.6 and lactate was 0.9. We thought it possibly is a worsening infection, so we gave the child a PRBC transfusion, and we started GM-CSF in view of low WBC count in the face of sepsis. We also upgraded the antibiotics to meropenem and amikacin. So we also collected few samples before we sent, we transfused the child. The next day, his hemoglobin had improved. WBC count was marginally better. Platelet counts were more or less stable. Procalcitonin was elevated. Albumin was okay, but lactate became 3. And because the child was persisting to have fever, this was almost day 7 of illness, we thought that this was just after the peak of first wave of COVID. We thought it might be a MISC sort of a presentation. We sent COVID IgG, which was positive. The child also developed persistent irritability with some hemodynamic instability. So she was also started on noradrenaline infusion. Considering that there was hemodynamic instability, persistent inflammatory markers, and fever, we also gave the child IVIG. The next day, hemoglobin again dropped. Platelets were still dropped significantly from 87 to 27,000. Total counts were more or less same. CRP was not changing much. Bilirubin, which was initially normal, had gone up to 2.3. SGOT, SGPTs were again elevated. Albumin was 2.1 with a still high lactate. So the child was still irritable. Noradrenaline requirement had come down, but this day the child developed a brief episode of seizure. So this is what got us more worried. So we had sent further workup before we transfused the child to see where the young child having severe anemia, whether there was any evidence of thalassemia or other hematological issues. Peripheral smear showed a pancytopenia with microcytic hypochromic blood picture. The reticulocytes were only 1%, which was significantly low for her anemia. Electrophoresis was predominantly normal. Folic acid, iron levels were just about normal. Ultrasound abdomen done showed hepatosplenomegaly with gross ascites, gallbladder wall edema, bilateral pleural effusion with enlarged periportal lymph nodes, more or less like a dengue picture. 2D echo was done, which was normal. So this was the X-ray on day 2 of admission. We have an X-ray which is showing some sort of patchy opacities in the lung, and abdomen basically showing gross ascites with hepatomegaly. So further course, on day 5, the child continued to have multiple episodes of seizures and persistent hypotension. She required multiple the anti-epileptics and increased doses of inotropes. We were thinking what else to do at this time, but then despite escalation of treatment at that point, the child succumbed. We could not resuscitate the child. So this was the journey of the child in our hospital. So we had sent, this is a snapshot of all those investigations which we had done. So basically whatever I told you. So day 1, day 2, the progression of the labs. So now I would like our experts to comment on what do you think is the possible etiology and anything in the management.
Thank you for the presentation. So I will start discussing from a pediatrician point of view, then I will start discussing about what as a rheumatologist, what I will think of. As a general pediatrician point of view, to summarize whatever he told, this is a 2.5 months old child, non-consanguineous parents, developed a short history of fever, then with hepatomegaly, presented with pancytopenia. So when somebody comes like that as a pediatrician, we all suspect this child has got septicemia with DIC is a possibility. Second possibility, we always think somebody has got pancytopenia, malignancy is also a possibility. These are the two possibilities usually think from the general pediatrician side. And dengue, of course, short presentation, dengue, rickettsial infection, all can present with similar presentation. Fever, short history of fever with pancytopenia and hepatomegaly. So this child was started like that, and they started evaluating. They got dengue serology positive, and they started dengue, but after that, the platelets and hemoglobin white cell count doesn't come up at all. It was having persistent pancytopenia. You can see here, little bit came up, but never became normal. So whenever the dengue goes, dengue, we have a classical natural history of dengue. 3 to 5 days, everything should resolve. This patient has not resolved at all. This child has not got his platelets back after supportive treatment. When something is going like that, we should suspect what they suspected, same thing, dengue with secondary infection, or we should suspect HLH in that point, because that changes the whole management. So what I'm finding missing is only one test to differentiate these two, sepsis with the DIC, dengue with HLH, or sepsis with DIC. The one test we have to do in the ICU setting everywhere is ferritin. Ferritin is available everywhere. The one test which I couldn't see it here. That makes a lot of difference. If any ferritin more than 10,000 is equal to HLH, whatever the cause you call. You cause dengue, you cause sepsis, you cause malignancy, you cause primary HLH. Anything dengue, anything ferritin more than 10,000 is equal to HLH. We have a lot of papers on that. From the ICU side, they had taken all the ferritin more than 10,000 and they found out how many of them really had HLH. So you should think of HLH in this child. So ferritin is the one thing, because if the ferritin is more than 10,000, we should give immunomodulation, especially at least you should start with steroids if you are still thinking of dengue. And the other thing is, if the ferritin is very high and thing, because the age of presentation is very early, it is 2.5 months old child, presenting like with the fever, dengue, whether he has got primary HLH is another question. So these two possibilities, so sepsis with DIC, dengue going with HLH, or underlying primary HLH, whether this child has got, these are the three differential diagnoses from a rheumatological point of view I can think of.
all these comments.
I think unfortunately I'm in the second position. Dr. Satish has already told you, but yeah, that's what I wanted to, probably I think there are a lot of postgraduates. So today as soon as I came, Dr. Vasudha asked me, Madam, have you got your diagnosis? So I said, yes, you may have got the diagnosis, but I don't think the diagnosis is important here because I am sure that there are a lot of postgraduates here, so it is more like how you are going to approach a child. Because day in and out, that is what we do to, teach our undergraduates, teach our students how to approach, and as being a basic pediatrician, you may or may not have the, specialist sitting with you. You may not have a hematologist, you may not have a rheumatologist, but being a basic pediatrician, I'm sure that you can come to a sort of a reasonably good conclusion and you could treat before you really call in the specialist. So yes, like as Dr. Satish said, yes, the first diagnosis is this child, a 2.5 months old baby with a birth weight of 2.5 kg who has been reasonably gaining weight, doing very well. But probably if you really exactly go by, if you look at the NEJM, for example, they will say this child had a respiratory distress at birth. So is there something, any relation between a neonatal presentation? But it seems to be very unlikely because this is a well child, this is a term baby and weighing 2.5 kg. And it is very unlikely this child had any other cause for respiratory distress. So that is how you could have to see probably in the newborn period anything related. The second thing is they said very interesting family history of some, pancreatitis. So that may be just a red herring trying to trap us. But maybe, not exactly in this child, but if you have a history of, say, for example, a pancreatic insufficiency in a family member, suppose this child comes with some sort of a cytopenia, pancytopenia, maybe after ruling out all the other conditions, not exactly now, after ruling out all other conditions, if the child had come with failure to thrive, maybe you could have thought of some sort of inherited pancreatic problems. But anyway, this looks like an autosomal dominant, even if it is, doesn't really fit into that. So don't really give too much of importance when there is a family history, whether it is going to be significant in this child or not, maybe we need to look into that. And coming at 2.5 months, yes, I think it is just the first thing is a sepsis. So it could be a gram-negative sepsis, ELBS, so they can typically present with a multi-organ. That's the first common presentation of a sepsis who can come with a multi-organ rather than really looking into multi-systemic disorder. And second, I think as Dr. Satish said, any child who has got a pancytopenia, who is not responding within about 2-3 days, it is a HLH, either primary or the secondary HLH. And probably Dr. Vasudha was showing one of the children this morning, like an LCH, who can present with a pancytopenia, hepatosplenomegaly. I think that's all I can think of. And very, very rarely, like if you have ruled out all the other causes, then whether this child has any PID presenting with cytopenias, I think anyway it is, as of now, it is too far-fetched.
Sitting here gives me an advantage because I can just combine whatever they said. And so basically this is a 2.5-month-old child who was apparently normal at birth and seems to have thrived reasonably well, comes with a severe sepsis with no obvious focus. Usually we expect them, either they have UTI or pneumonia or something, which was not there in this case. So I would start off thinking that it may be, sepsis. Of course, we start broad spectrum antibiotics. But on the second or third day, if your microbiologist has not called with any culture report, I will seriously think about some viral infection. In this case, there was IgM, dengue was positive, but NS1 was negative. So that gives me a clue that it is probably far down. Probably the child had dengue infection, but further down. So as a complication to dengue infection, if there is any infiltrative process in the bone marrow, because persistent pancytopenia gives me that. And also his COVID IgG was positive, and last 2 years we have all been talking about HLHS type of MISC. So that is also one possibility. And there is no evidence to say that this child has any congenital immune deficiencies. But still, I would still keep a possibility of a fungal infection in this case. But persistent cytopenia makes me think that there is some sort of bone marrow infiltrative process, whether it is primary viral infections, which is very rare unless it is a severe parvovirus infection, which happens very rarely. But other than that, I would consider it as a complicated dengue, and as Dr. Satish said, one of the possibilities HLHS following any viral, post-viral HLHS. And of course, MISC, HLHS type of MISC presentation. These are the two possibilities.
Thank you for the experts. So it turned out to be not so
is ferritin.
difficult.
I just want to emphasize again, please do ferritin when they don't respond to antibiotics.
So
think beyond sepsis.
That's what we had done. On day 2, when we got the child to be persistently pancytopenic, we had sent ferritin, which was 23,000 in this child. So we are seeing patients with dengue with high ferritin. So we waited one more day to start the steroids. It was next day 28,000. We did start steroids. By the time we had done a bone marrow as well. The aspirate unfortunately showed only few histiocytes, but marrow confirmed histiocytosis. And marrow report was suggestive of HLH. So our diagnosis was HLH. We had started steroids. We also started etoposide for the child based on the HLH from 2004 protocol. But by that time, the parents also did not want escalation of treatment, and unfortunately, the child succumbed. Though we had started treatment and they did not want escalation, we had sent genetics of this patient. So Dr. Vinu is going to talk to you about the genetics.
So let's go through the journey of the final diagnosis. Though we had sent off the genetic testing by day 2 of admission in the pediatric intensive care unit. Can I have my slides, Faizan? So it was very clear that there was some amount of multi-system involvement by day 2 or day 3 with the preliminary investigation reports available and the history related to the kid. And then the background family history, though it was a non-consanguineous family, and there was background family history of breast cancer. It was essentially an early onset cancer in the paternal grandmother, and the father had adult onset pancreatitis. So this is something that we need to recapitulate on the case. So we proceeded with simultaneous testing in the proband and in the parents. So we did a trio whole exome so that we had the segregation results ready along with the child's results. So the genetic testing confirmed the diagnosis of familial hemophagocytic lymphohistiocytosis type 2 due to a homozygous mutation in the perforin gene, that is PRF1 gene. And in addition to that, there were 2 more variants in the gene that is supposed to cause cystic fibrosis. So one of the mutation was a likely pathogenic one. It is being reported previously in patients with various phenotypes related to cystic fibrosis. And the second variant was an uncertain one. So we had a variant, but we were uncertain about the implications of this variant, whether this would result in a phenotype contributing to the autosomal recessive cystic fibrosis or not. So coming to the parental segregation, both parents as expected were heterozygous carriers of the perforin gene mutation. And we need to be very careful in understanding about the cystic fibrosis segregation here. So the father was carrying the likely pathogenic mutation that has been previously reported, that is at the amino acid position 309. And the mother was a carrier of the variant of uncertain significance. Moving on. So, of course, this was a straightforward familial HLH diagnosis, but are we dealing with a second diagnosis was a question that we had to handle. Though the child has succumbed, it was very important for us to close the case in terms of offering testing for rest of the family members, prenatal diagnosis, genetic counseling, and so on and so forth. So, a little bit about HLH. We all know about HLH, that it's a disease of excessive inflammation and tissue destruction due to abnormal immune activation. And essentially in familial HLH, the mutations are in one of the 4 genes, that is perforin, STX11, STXBP2, and UNC13D gene. All of them are autosomal recessive, but there are anecdotal case reports of autosomal dominant HLH being reported in patients with mutations in STX11 gene. And so this is the pathway. I'm sure the experts here are, most of you are aware of this pathway, wherein there is a cascade of activation of the cytotoxic T lymphocytes. And all these 4 genes are implicated in this pathway, that is the perforin gene, the STX11, the UNC group of gene.
The perforin has a role in inhibition of the activation process of these cytotoxic granules in the T lymphocytes. So hence, if there is a mutation, the reverse happens and there is an overactivation of this immune pathway resulting in immune dysregulation and destruction of the target cells. So this child did fit into the diagnostic criteria for HLH as already discussed by the experts and Dr. Deepak. And we need to understand that there are two types of HLH. One is familial HLH and one is the HLH being part of a complex manifestation like Griscelli syndrome and Chidiac-Higashi syndrome, or could it be primary immunodeficiency syndrome as rightfully suspected by our experts. Now, there are about 5 types of familial HLH and 2 syndromic types, that's Griscelli and Chidiac-Higashi, based on the gene involved. And most of them have infantile onset of symptoms. And so it is important to establish a confirmed genetic diagnosis. Of course, the likelihood of recurrence in a genetic HLH is about 25%. And also to be very sure that we are offering hematopoietic stem cell transplant for a HLH rather than a HLH-like condition. And to assess whether there's any risk of HLH to rest of the family members. And about 1/3 of the HLH cases are found to be genetic in etiology. And in a review of 2,700 patients with HLH, it was found that 8 out of 100 patients had biallelic mutations resulting in autosomal recessive HLH. And interestingly, 1 out of 100 patients had mutations in 2 different genes, what we call it as digenic inheritance. And coming back to our gene, that is perforin 1 gene, it is being implicated in early onset, and in fact, even in utero onset of HLH has been reported in the past. So coming back to our case, so the first part is very clear cut. Now, what about this CFTR gene mutation? How are we going to solve? Now, recapitulating the history, the father had pancreatitis, the grandmother had breast cancer. So we were thinking of, are we also dealing with some sort of monogenic or inherited pancreatitis? Is there a link between the pancreatitis and the child? Rightfully, madam had those thoughts. And then, of course, is there an add-on diagnosis of some sort of familial cancer syndrome due to a mutation in the grandmom was a question. And is it a straightforward case of cystic fibrosis? So is it a dual diagnosis or multiple diagnosis in the family? Now, we need to understand this is a known entity in cystic fibrosis called a cystic fibrosis related CFTR related disorder. The definition goes like this: CFTR related disorder do not confine to the full genetic or functional criteria for cystic fibrosis diagnosis. Rather, they have a single mutation rather than biallelic mutation. Alongside, they may have one organ system involvement rather than all the set of symptomatic criteria confined to cystic fibrosis. And there may be some amount of evidence of dysfunction of CFTR. In fact, they may have negative IRT that we do in newborn screening test, and they may have a negative sweat chloride test as well. They may manifest with just isolated obstructive azoospermia or chronic rhinosinusitis, chronic pancreatitis, or pulmonary disease quite late in life in adulthood. And they may have just a single mutation rather than homozygous or compound heterozygous mutation. So, well, so we are aware of this entity now. Coming back to our 309 mutation in our patient, now when we went back to literature, we found that in a small island somewhere between Madagascar and Mauritius, wherein we have these French descendants, this particular mutation is seen in this population, wherein a couple of adults close to 70 years old have been reported to have cystic fibrosis with a positive sweat chloride test having just a heterozygous mutation at the 309 amino acid position. Interestingly, they had a polymorphism at position 49. Now, polymorphism is a change in the gene which is present in more than 1% of population, and essentially they do not result in disease pathogenesis. But again, they may be seen in combination, more commonly in combination with certain mutations. So this was one additional supportive entity to our diagnosis. And again, this same variant has been reported in an adult male patient from India having congenital bilateral absence of VAS difference. Of course, CBVD occurrence in cystic fibrosis is not an uncommon entity. It's a very known entity, but with respect to this particular mutation in heterozygous state, having CBVD was the first time that has been reported in 2020. 20. And again, the same mutation in combination with delta F508 mutation, which is a very common mutation in cystic fibrosis, has been reported in milder forms of cystic fibrosis and also in salt depletion cystic fibrosis. And also there are some anecdotal reports wherein we have this entity called as autosomal dominant pancreatitis due to heterozygous variants in cystic fibrosis gene. So with all this background information, we get back to our mutation report, that is the 926, which is nothing but our 309 position in combination with an uncertain variant, and getting back to the history of our child. Unfortunately, newborn screen test results were not done or were not available. The parents were not aware about it. So we didn't have the luxury of immunoreactive trypsinogen report. And we couldn't afford to do a sweat chloride test in a really sick child for a short stay in the hospital. So with this in hand, we were more or less quite sure about familial HLH. And definitely it was not possible to completely ignore CFTR-related disorder. So we considered that it is a possibility the child had CFTR-related disorder, but we are unsure whether the current manifestation is related to add-on blended phenotype of cystic fibrosis, or probably in future the child is going to develop a CFTR-related symptomatology. Could it be pancreatitis? Could it be adult onset bronchiectasis? Or that was not sure of, and it was confirmed the father carrying the same variant, actually the dominant pancreatitis was nothing but a genetic pancreatitis due to that particular heterozygous variant. So we did look back to the database where we have a database to let us know whether these variants have any specific medicine. So we have these newer drugs called CFTR modulators, the Ivacaftor group of drugs. Unfortunately for this 309 variant, these drugs do not work well. So the literature review was basically targeting on how best we could help the father to treat the adult onset pancreatitis in addition to the Creon therapy. So in terms of genetic counseling for the couple, so definitely there is a 25% chance of the offspring being affected with familial HLH in each and every pregnancy. It's a bit dicey about cystic fibrosis related disorder. There is a 25% chance that particular 309 mutation the child may inherit, but we are unsure about the phenotype because we have seen a lot of phenotypic variation. It is not possible to predict the phenotype, the severity, age of onset if the variant is present in the offspring. And 50% chance of having the gene and developing autosomal dominant pancreatitis in the adulthood. So there were ethical challenges in offering invasive prenatal diagnosis. This is part 2 of the story where recently they had consulted for the same because we had offered for HLH, but for cystic fibrosis, it's a very difficult situation. We had to explain them all the variability and everything. And for dominant disorders, essentially offering prenatal diagnosis, especially when there is some partial treatment, it is an ethical issue. So conclusion, a high index of suspicion is necessary for having a dual diagnosis in the background of related or unrelated family history. Dual diagnosis and blended phenotypes have implications on management and prognostication, and recurrence risk and challenges in genetic counseling when more than one genetic disorder and variable inheritance pattern is present in an individual or family is quite challenging actually. And in this family, we did offer genetic testing for the paternal grandmother in order to evaluate for familial breast cancer syndrome, because this is an actionable condition. We can offer surveillance to the kids of that grandmother and the siblings, if at all, if it is a genetic breast cancer syndrome, and of course prenatal diagnosis for future pregnancies for this couple. Thank you so much.
Can I make one comment? Yeah, just I want to make one comment about this diagnosis and for the treatment aspect. Whatever she showed a table for diagnosis of HLH, that classification criteria is only for primary HLH, it's not for the secondary HLH. So dengue child, don't wait for the criteria to be fulfilled. We don't need bone marrow for hemophagocytosis to confirm the child has got HLH. We will lose time. So only ferritin is enough for secondary HLH. Primary HLH, they need that criteria. Second, the treatment aspect also, if it is primary HLH, we have a very nice treatment protocol given by HLH 2004. Starts with etoposide, cyclosporin, and dexamethasone and intrathecal methotrexate. 8 weeks you have to do a bone marrow transplant. For secondary HLH, we don't have any treatment protocol. We always start with steroids, plus or minus IVIG. 48 hours you see the child is improving, especially dengue and all, most of the time will respond only to steroids. If they don't respond, we add cyclosporin, then we wait for a couple of days. If they don't add, then we'll go for IL-1 inhibition or etoposide. Whenever it goes up to the level of etoposide, we always involve hematologist in our team to give etoposide. As a rheumatologist, we don't give etoposide at all. So the treatment is different for secondary HLH. The diagnostic criteria, we don't have a diagnostic criteria for secondary HLH. Thank you.
Thank you, everybody.
Thank you so much. I request our panelists to kindly come back on stage, requesting Dr. Sridhara MS to kindly felicitate our panelists. Thank you. Have Dr. Sridhara. Our first panelist, Dr. Indumati C.K. Dr. Satish Kumar. Oh, okay. You can take one more. And Dr. Girish H.C. He's being so humble and polite. Thank you so much. Thank you so much. I request our chairpersons to kindly come back onto our stage. Dr. Hem Kumar, Dr. Nagbhushan, Dr. Satish H.S. And I would also like to welcome Dr. Sumita Nayak. She has a MBBS from Bangalore Medical College and Research Institute, MD Pediatrics BMCRI, DNB Pediatrics New Delhi. She is currently working as a consultant pediatrician at the Children's Clinic Bangalore, currently the CIAP EB member of Indian Academy of Pediatrics. She's the national faculty for IAP workshops and conferences, and she's also the author of 2 books in pediatrics, chapter author for IAP publications. Let's give her a big round of applause. Dr. Sumita Nayak. Thank you. We now move on to our next presentation, and I would like to invite on stage Dr. Chandrika Bhatt. She has her MBBS from MD Pediatrics, RCPCH Fellowship, Pediatric Rheumatology from UK. She's a consultant, Pediatric Rheumatology Services, Rainbow Children's Hospital, Marathali. She completed her MBBS from Kasturba Medical College, Bangalore, and MD Pediatrics from Grant Medical College and Sir JJ Group of Hospitals, Mumbai. Subsequently, she completed her fellowship training in pediatric rheumatology from the prestigious Bristol Royal Hospital for Children in United Kingdom. And of course, she's also published articles in international and national journals. So please put your hands together and welcome Dr. Chandrika Bhatt for this session.
So good afternoon, everyone. So when I started off as a consultant in pediatric rheumatology here, I was excited about managing refractory joint arthritis, refractory SLE, refractory vasculitis. But what I actually realized along the way, the biggest problem in our practice is recurrent fever. And fever that has no focus can really be frustrating. It is on our mind all the time. It's frustrating for us, it's frustrating for the family. And as we all know, patients can have multiple hospital visits before we can figure out what is actually wrong with them. And along the course of time, because they have an option of visiting multiple people, getting multiple opinions along the way, they are confused, we are confused as to what is going on, and this obviously leads to a lot of frustration and financial burden for the family. But I think overall, most of us would agree that these children probably have a diagnosis which fits into 3 broad categories. That is some infection. It can be an occult infection, atypical infection, or malignancy. But also more importantly, what we are seeing post-COVID, especially immune dysregulation, is something people are increasingly now being able to identify and manage. So going back to a bit of basics, so what is the purpose of the immune system? So as we all know, these are the 3 predominant functions of our immune system in dealing with infections of different kinds. in tissue repair, and most importantly, also in tumor surveillance. So obviously, when there is a dysregulation of the immune system, you have diseases coming up as a result of aberrations of these functions. So you can have autoimmunity, atopy or allergy, autoinflammatory diseases, immunodeficiency, and lymphoproliferative diseases. And what I will be talking about today is one subset of this, which is autoinflammation. So all of you, sorry. So all of us know that these are the 5 cardinal symptoms of inflammation, which is heat, redness, swelling, pain, and loss of function. So in all autoinflammatory diseases, you will have these 5 features happening at different time intervals and in different intensities. So what exactly happens in autoinflammation? So there is persistent inflammation, which cannot be explained by any underlying infection, neither by an underlying malignancy. There is no autoimmunity. So when we say autoimmunity, that means you can demonstrate an autoantibody. So when we say ANA is positive, rheumatoid factor is positive, that indicates there is some degree of autoimmunity going on. But if you cannot demonstrate an autoantibody and there is persistent inflammation, this is what we call autoinflammatory diseases. And these come up due to aberrations in the innate immune system. So as we all know, there are 2 components of this immune system, innate and adaptive. So when something goes wrong with the innate immune system is when you end up with an autoinflammatory disease. And this is very much like being on a self-combustion mode. So when the car, the petrol pump of a car sets itself on fire and undergoes self-combustion, that is what happens in autoinflammatory diseases. So these are all the lists of autoinflammatory diseases that we have. Obviously, I won't go into the list of all of these, but to just simplify for you, I'll go through a few cases along the way. So this is a 6-year-old girl who came to us with a history of fever for 3 days. There was a history of mouth sores at the onset of fever. She also had some cervical nodes sub-centimeter in size, and her tonsils were enlarged. And this was during an outbreak of hand, foot, and mouth disease. So obviously, this is what the child was thought to have initially. But then when we went in the history with the parents, she had multiple episodes of fever from the age of 4. And along with each of these episodes, she had recurrent mouth ulcers as well. And all the time, there is a documentation from her pediatrician that her tonsils are enlarged, and there is some degree of cervical lymphadenopathy as well. She's got multiple rounds of antibiotics, and these parents came with 2 huge files, actually. In between, she's absolutely well, normal growth, normal development, going to school, doing very well otherwise. So as you can see, that is the graph of her fever pattern in 2019 and 2020. Initially, it was not very frequent, but still, compared to other children, you can still say 7 episodes of fever in a year. But in 2020, almost every other month, every 4 to 6 weeks, this girl has had these episodes of fever. So actually, the family was very disturbed because they couldn't plan their vacation. Whenever they planned a vacation, this girl would have an episode of fever, again go to the pediatrician, start on antibiotics, and this went on. And going into her family history, as you can see, this affected girl's paternal aunt also had the similar history, started at 3 years of age, and the father said that she outgrew by the age of 10. So any guesses what this is? So then going into her labs, we thought of evaluating her a bit, having tabulated her previous investigations. So every time she's had fever, obviously she's not had bloods because sometimes she would get better in 2 to 3 days with oral antibiotics. But on a couple of occasions that she had, CRP and ESR was borderline elevated. But when she came to us in November 2020, again the CRP and ESR both were elevated. Otherwise, her complete blood count was normal. So we also had a look at her peripheral smear because there's a history of recurrent fever to rule out any ongoing lymphoproliferative disorder, but that was also normal. We also sent a PID panel, although she was a well-thriving girl. That was unremarkable, and sent a clinical exome for periodic fever syndrome. Now, the clinical exome came back for negative for periodic fever. So any guesses now what the diagnosis is? So this is still a periodic fever syndrome called PFAPA, which is periodic fever after stomatitis, pharyngitis, and cervical adenitis. And I'm sure most of you in your OPD practice must be seeing a lot of these children who come with recurrent bouts of tonsillitis. In yesteryears, people were doing tonsillitis. They had a very low threshold for doing tonsillectomy. So probably a lot of these children did have PFAPA in the past, underwent tonsillectomy, and for some reason after tonsillectomy, they don't have any further episodes. So although no trials to prove this, but a lot of people advocate tonsillectomy for PFAPA. So this girl, like I said, genetics were negative. So we decided to try only with intermittent naproxen, but she still kept getting episodes of fever, and school absenteeism was becoming a concern. So we went ahead with tonsillectomy, and now she's fever-free. So what is PFAPA? This is one of the most common periodic fever syndromes. There is no single gene implicated. It's of polygenic inheritance. So you would generally see children having high-grade fevers between 38 to 41 degrees Celsius, lasting for around 3 to 7 days, and episodes occurring every 2 to 8 weeks. And some people believe that probably PFAPA is on the spectrum of Behçet's disease. So you have recurrent after stomatitis on one end of the spectrum, PFAPA in between, and Behçet syndrome as the severe end of the disease spectrum. So this, along with in PFAPA, what is very prominent is actually after ulcers may not be very common, but you would see tonsillar enlargement and some degree of cervical lymphadenopathy. Even if you don't treat them, they do very well. They usually outgrow by the age of 10. But if the episodes are very frequent, then it makes sense to either start them on preventive medication if it's too frequent, or just rescue medication if it is infrequent. So rescue medications, we try usually ibugesic or naproxen. And if it's still not working, you can just try 1 dose of steroid on the first day of fever, provided you're very sure there's no infection, which can be challenging. And preventive, people have tried colchicine or cimetidine, but tonsillectomy works very well for this condition. So moving on to the next case, this is a 10-year-old girl who came to us with a history of fever for 11 days, along with pain, abdomen, and vomiting for 3 days. She had very significant neck pain. Almost it looked like she had some degree of meningism. And this rash on her trunk, which I'm not sure you all can see very well, but it is an erythematous annular sort of rash on her trunk. And these were her initial labs. So her full blood count showed some degree of leukocytosis. CRP was 225, ESR of 75, all are elevated. Urine routine was normal, liver enzymes were normal, so was albumin slightly borderline low at 3.2, and COVID serology was positive. So quite obviously, in the pandemic era, everyone initially would think of MISC, and rightly so, this girl was diagnosed as probable MISC and started on low-dose steroids. But going back into her history, her parents said that this girl actually had a history of recurrent fever episodes and quite similar in symptomatology. So at the age of 5, she had fever for more than 2 weeks, along with this same type of neck pain, wherein she couldn't move her neck at all, and the same rash on her abdomen and trunk. She was treated for possible enteric fever. Cultures were negative, but because fever persisted for 2 weeks, they went on giving her antibiotics, after which she was fine. Then again, at the age of 7, she had a history of fever for 10 days, abdominal pain and vomiting again. This time, she did not have the rash or the neck pain. Again, treated with antibiotics, apparently got better. Then again, at the age of 8, she comes back with fever lasting for 10 days, pain, abdomen, vomiting, and this time she has all the symptoms, rash, and again the same type of neck pain. And then again, at 9 years of age, similar symptoms with fever going beyond 10 days, pain, abdomen, vomiting, rash, and neck pain. So any guesses what the diagnosis here is? Sorry? Vasculitis, okay. So this is her family history. So as you can see, her mother also has similar symptoms, although now her episodes have decreased in frequency. But the maternal uncle actually has vasculitis, and he also had a similar symptomatology at a young age, but now has ended up with frank vasculitis. And the maternal grandmother also had the same symptom. So any guesses what this condition is? So we then sent her genetics, quite obviously, and what she actually has is a periodic fever syndrome called TRAPS, tumor necrosis factor-related associated periodic fever syndrome. But because this girl had infrequent episodes, we did not start her on regular medication. We decided to go only with rescue medication with steroids during flares. So generally, they may need a short course of steroids until the fever episodes settle down. But if the episodes are too frequent, then we usually start them on an anti-TNF. So TRAPS is not that uncommon in the Indian scenario. So onset is usually in the first decade of life, wherein fever can last between 5 days to 2 weeks. And this is what is quite characteristic of TRAPS, that fever episodes are quite prolonged. It can go up to 2 weeks or sometimes even 3 weeks in these children. Although periodicity is not very fixed. So it need not be very cyclical in that, as in this case, this girl probably had just 1 or 2 episodes every year, but some of them can come back with very recurrent symptoms wherein you have to start them on preventive medication. And myalgia can sometimes be quite debilitating for these children. And a lot of times that in areas where they have the rash is where they have underlying myalgia as well. And this, if the symptoms are quite severe, so that might be another reason to start on preventive medication, even if it is not too frequent. Periorbital edema with conjunctivitis is another common manifestation of TRAPS. And the main reason why we go ahead and start them on preventive medication is the long-term risk of developing amyloidosis. And inflammatory markers are usually elevated during episodes, but TRAPS is one periodic fever where even in between episodes, if you do inflammatory markers, it may not be completely normal. So like I said, about an attack with NSAIDs or glucocorticoid, but if it is too frequent, we can go for anti-TNF or IL-1 and IL-6 blockade. So moving on to the third case, this is a 3.5-year-old girl who came with a history of fever for 3 days. She had this rash on her palms and soles, erythematous flushed sort of a rash, soft cervical lymph nodes less than 1 centimeter, and one of aphthous oral ulcer. So she had some labs done initially at admission. As you can see, her WBC counts are also quite high. Her hemoglobin is 9.5, platelets elevated at 6.25 lakhs, ESR, CRP both quite high. And her procalcitonin was also positive, ferritin almost in the normal range. COVID IgG was positive, her USG abdomen and echo was normal. So she was being treated for occult bacteremia with IV antibiotics. But again, going back into the history of this girl, so in the month of April, she had a history of very high-grade fever, also had some degree of dysuria at that point in time. Elevated counts, CRP again quite high. Urine routine but was normal. Culture showed no growth. She was still treated for probable UTI with IV antibiotics. Fever resolved and she was then discharged. April to September 2021, she had no fever episode. She was absolutely well, gaining weight, milestones also appropriate for age. But going from September to March 2022, she's had fever every month, lasting for 5 days, ranging between 100 to 101 degree Fahrenheit. The same rash coming on her palms, oral ulcers occasionally. She's had 2 courses of once actually again IV antibiotics and then oral antibiotics, and otherwise she's been absolutely well between episodes of fever. So looking at her growth chart, there was no weight loss. She was steadily gaining weight, and there was no associated symptom of joint pain, abdominal pain, vomiting, blood in stool, no genital ulcers, headache, or redness of eyes. Again, any guesses what this is? So as you can see, when I'm discussing the cases, all of them have one common thing. There is recurrent fever, and there are fixed symptoms with these episodes of fever in all these children. So that's why we sent a periodic fever panel in this girl as well. And I started her on a short course of steroids. But as we tapered her steroids and stopped, there was a recurrence of fever quite immediately, which was a little odd for a periodic fever syndrome, along with the same rash that I described. So then I started thinking that whether she probably has systemic onset JIA, which is also a type of autoinflammatory disease. So we restarted steroids, this time with the plan of giving it for a longer duration along with methotrexate, which is what we use as first line in systemic JIA. But again, as I started tapering her steroids, she had a flare again with very high inflammatory markers, fever, rash, everything coming back. And we had to start her on tocilizumab. And just after 1 dose of tocilizumab, this girl was fever-free. So as I thought the clinical picture was looking more like systemic onset JIA, we got the results of her genetics back, and she had a mutation in RIPK1. And in fact, quite surprisingly, this is a very newly described periodic fever syndrome only in 2020 by 2 separate groups in US and China. So it's called CRIA, which is cleavage-resistant RIPK1-induced autoinflammatory syndrome. So they, and surprisingly, it is just serendipity, tocilizumab is the drug of choice for this condition. We didn't have the report before we started her on this drug, and she's been in remission since then. So I'll move on to the last case. This is a 9-year-old boy who came with a history of recurrent fever for 3 months. So again, similar history of recurrent fever lasting for 7 days, 103 to 104, quite high grade, no response to antibiotics. And he was given 1 dose of steroid by a practitioner, responded quite well to that. And then came back again a month later with fever. This time he also complained of joint pain, but there was no joint swelling with it. Inflammatory markers were pretty much normal in this episode. He was tested for TB because this was the 2nd episode of fever, and no response to antibiotics. So he was then referred to a higher center, wherein again he was evaluated with some bloods. But this time, as you can see, the platelet counts have started going up. It's 7.5 lakhs. ESR is 70. He had no response to antibiotics, and steroids were trialed for 5 days. So again came back on 11th of June with fever. And this time when they did an ultrasound abdomen, there were multiple nodes. So he underwent an extensive TB evaluation. Everything came back negative. And that's when I saw him. Again, considering a history of recurrent fever with some rash, thought of the possibility of systemic onset JIA, and started him on steroids, but also sent a genetics panel because he did not have any other symptoms to confirm a diagnosis of systemic JIA. And again, quite surprisingly, he turned out to have a condition called DADA2, which is deficiency of adenosine deaminase 2. And It's quite lucky for this boy because usually we pick up these children when they have stroke. That is the biggest risk associated with this condition. And if you pick up these children before the onset of stroke, you can prevent the onset of stroke with immunomodulation. So it's a combination of vasculopathy, inflammation, immunodeficiency, and bone marrow failure that occurs in this condition. So this boy, we started on etanercept along with steroids, and he's not had any episodes of strokes, and as you can see, he's doing quite well. So to briefly summarize, so I've said so many things, but how do we group these autoinflammatory diseases together? So they can either be monogenic or polygenic. Monogenics are the one which we send genetics for. So based on the cytokine implicated, whether it's interleukin-1, interferon, or NF-kappa beta, based on the system affected, it can affect any system in the body. Based on the symptom constellation, like I said, age of onset, the rashes that they have, and very periodic symptoms based on special features like periorbital edema, conjunctivitis, chronic complications like amyloidosis, hearing loss, or based on specific triggers. So some of these periodic fevers are triggered even by vaccination. So please go into the history if a child has recurrent fever. And these are different rashes that you can get, erysipelas-like rash, urticarial rash, and most of the times these urticarial rashes are non-itchy. So that is a very important clue if a child comes with recurrent fever and a urticarial-looking rash. And this is how, these are all the autoimmune diseases you need to know that come with recurrent fever. And based on the duration of fever is how we classify them as to having FMF when it is short-lived, HITS or PFAPA when it's 3 to 7 days, and TRAPS is usually of a longer duration. So now the most important question is, when should you think of an autoinflammatory disease in your busy OPD? Obviously, it's not quite a common disorder, but if you have a child who comes with recurrent unexplained fever, more than 3 episodes, very high grade lasting more than 101, each episode has a predictable pattern or a very characteristic course, and they have fixed associated symptoms. You may not have all the symptoms coming in each episode, but if more than 3 times you have the same symptom coming back with fever, please think of an autoinflammatory disease, and very specific triggers like cold or vaccination, and family history of autoinflammatory disease. So challenges, most of us think that we may not encounter a rare disease, but rare diseases are not that rare. 1 in 10 children actually have a rare disease. Unfortunately, little time is devoted to rare diseases, and we don't have the time to sit and dig into the history all the time to know if the child we're seeing has a rare disease or not, and we never think we may be the ones to see something new. So the key message I would like to convey is, if you see a child with recurrent fever, but who's well in between, fixed symptoms, and periodicity may not be fixed, it's more recurrent than periodic in periodic fever syndrome. Forgotten symptom in parents. Parents may not remember that they had recurrent fever when they were a child because they may not have heard it from their parents. So please ask for a detailed family history on both the paternal and the maternal side. And you need very baseline tests to suspect. Just look at inflammatory markers during every episode of fever. And these can be associated with other immune diseases as well. And perseverance. You may not get the answer in the first 2 or 3 episodes, but just persevering and going beyond and testing these children can make a big difference. So this, I would like to end my talk and open to questions, if any.
Thank you. Thank you very much, Dr. Chandrika. Are there any questions? Do we have any time for questions?
So we actually don't know what, if there is any specific trigger. Like I said, some of them can have a trigger, like exposure to cold or vaccination, but most of them don't have a very specific trigger to each episode. There is a group of condition called CAPS. So they have specific triggers, or hyper IgD syndrome can have a specific trigger with vaccination. But otherwise, it's just some unexplained immune system activation that happens very periodically in these children, especially with underlying genetic mutations.
Thank you. Thank you, Dr. Chandrika.
Thank you.
Give a big round of applause to Dr. Chandrika Bhatt for that impressive presentation. Thank you. All right. We now move into our final session before we break for tea, and it's only just going to be a quick 10 minutes tea break. I'd like to invite on stage Dr. Rakshay Shetty, Head Pediatric Intensive Care Services, Academic Director, Department of Pediatrics, Rainbow Children's Hospital, Bangalore, and also the founder of Pedi Stars India. And he's going to be presenting the topic, Dengue and COVID, can they coexist? Please put your hands together and welcome Dr. Rakshesh Shetty. Thank you.
All right, so good evening, everyone. So before we break for tea, I'm going to spend next 15-20 minutes on this topic, can COVID and dengue coexist? And I'm sure most of us here, almost always if we land up doing a report, we find both COVID serology positive, dengue positive, and half times we can't figure out what is causing what. So what I've just tried to do is go into a bit of a literature and find out okay, what is available, what's the current understanding about this particular situation. So can actually dengue and acute COVID-19 coexist? If at all they do coexist, how do we diagnose this co-infection? And what are the difficulties in diagnosing this co-infection in terms of lab investigations? Now, if they occur together, can they alter each other's course? Can dengue make COVID worse, or can COVID dengue make worse? And how does a dengue behave post-COVID? I mean, has its manifestation changed? So if you had a past dengue infection, and if you have an acute COVID now, does it change its course? And can dengue and MIS-C, can they both coexist? I'll try to answer these questions over the next 15-20 minutes. So, there were initially in 2020, quite a few case reports started coming in South America, Thailand, and India, standalone reports where they reported patients having both COVID as well as dengue. And subsequently, there was a bit of a case series published in Argentina, again looking into the, reporting the findings of patients who had dengue plus COVID. So what they found there was almost all of them, when they're co-infected, tend to have fever as a manifestation, whereas when they had only COVID, 50% of them were asymptomatic. So it sounds like fever is the most common manifestation. Along with that, many of them had headache. Apart from that, they did not find any mortality difference when there was this kind of a co-infection. So when they looked into the co-infection cases, they found that 20 to 60 is a kind of an age group where it gets affected, and they tend to have a moderate severity. Okay, so now what happens when they have both these symptoms? Now we all know the SARS-CoV symptoms. Many of them have fever, dry cough, they have fatigue, they have dyspnea, they have abdominal discomfort and poor appetite. We all know the symptoms of dengue. They tend to have fever, vomiting, skin rash, retroorbital pain, diarrhea. But when they have both these infections, it sounds like they have a combination of symptoms. They have fever, headache, myalgia, arthralgia, again quite non-specific, and cough. So this is how the biomarkers look when you have co-infection. Now what they found out is, based on these reports, you can have, so two things can happen. Either you can have one disease which manifests, that's just a dengue out of COVID, or it could be COVID manifesting and dengue not manifesting. If that happens, the outcomes tend to be quite okay. But if both diseases tend to manifest together, the outcomes need not be okay. And what they found out was the mortality actually goes up. So what happens in COVID, we know the IL-6 level goes up. That's why we have high CRP. And what happens predominantly in dengue is IL-10 level goes up. So you tend to have a combination of symptoms. So when you see a patient who looks like dengue or a COVID, and if you find that certain things are odd, for example, in a patient with dengue, you find the ALT levels are going up, then you should probably think whether the child has a coexisting COVID or other viral infections. What they've also noticed is there's a higher incidence of increased creatinine in this group of patients. And we all know that in COVID, what happens is the neutrophil predominates. There's a little bit of leukocytosis, but when you look at the neutrophil lymphocyte ratio, that tends to be very high. Whereas what happens in dengue is that we see the total WBC count goes low. So you might see combination of these when they present together. So if these two diseases do manifest, then what happens is, again, you'll have a conglomeration of both the complaints in terms of their organ involvement. And we know the hallmark of dengue is bleeding and vascular permeability. So whereas the hallmark of COVID is more of thrombotic complications. So they do involve hematological systems, but their manifestations are a bit different. So they can have more of a vascular permeability like what we see in dengue. Along with that, they might have a significant liver damage. Like I said, the ALT levels can go up. And importantly, lung manifestations can come, and the encephalopathy part becomes much more significant. So this organ involvement happens in kind of combination with the varying severity. So this is again to just summarize what I just said. When you have both the infections together, you tend to have some laboratory features which kind of coexist, and of which it sounds like ALT levels are kind of important and creatinine levels are important. And if you see a typical dengue-like patient and we see these levels to be abnormal, you should probably think of having a COVID test. Now the obviously question comes, how do we diagnose? How do we diagnose those both infections, dengue and acute COVID-19 infection happening together? So initially what happened was there were some amount of reports coming up saying that the false positivity rate of the dengue rapid test. Now this was the initial report which came saying in 2 adults who are 55 year plus, initially they presented with a fever, cough and myalgia, and their dengue rapid test came positive. But subsequently the patient developed dyspnea, and when the COVID test was done, COVID test came positive, and they realized that it's actually a COVID patient, not a dengue patient. So whereas sounds like if you can have the reverse also can happen. For example, you could be dengue, but the COVID serology positive rapid diagnostic test can come positive. So this is a study which was done in Calcutta, and what they did was they took all the serum samples which were preserved in a dengue proven cases before a pandemic. Okay, so patients, none of us were exposed to COVID-19 by then, and then they looked into, if I take the serum test and do COVID test, what happens? So they found out that quite a few patients did actually turn COVID positive with a rapid diagnostic test when they checked those samples which were dengue positive. So this was a combination of patients, none of them were NS1 positive, but all of them had either dengue IgM or IgG positive, and the COVID IgG was the most common report which came positive in these samples. So then subsequently quite a few studies done trying to understand this cross-reactivity. So they try to see in these various combinations. So what it appears is that the rapid diagnostic tests, have in both ways are quite notorious. So you could have dengue and the rapid test done for COVID can come positive. You can have COVID and the rapid diagnostic test done for dengue can come positive, and that can confuse the picture in making us believe they have 2 infections. So why does this happen? So there are 2 things what people thought why this might happen, because one was antigenic similarity. So there are some antigenic component which is shared between dengue virus as well as the COVID virus, and when you develop when you are exposed to, let's imagine, SARS-CoV infection, you actually produce antibodies even against dengue. Okay, the reason for that I'll just show in a separate diagram later, but that's possible. Second possibility is when you're using the antigen for testing, these antigen again can are shared between both dengue as well as SARS-CoV, and that can actually lead a false positive serological test coming positive. So if that's the case, then how do we actually make a diagnosis? So this is a study which looking at a bit more advanced tests like ELISA. So when they used ELISA test, they found that this cross-reactivity is very minimal. And again, subsequent studies also confirm the same, looking at a bit more advanced setting beyond rapid diagnostic test. So it sounds like if you do an ELISA seems to actually sort out a problem, and the chance of false positive rate of ELISA is much more minimal. And this is again the same thing being elucidated, saying that these advanced tests are much more better in terms of identifying the co-infection. So now let's go to this question, can they alter each other's course? So this was the initial report which looked into the dengue incidence during COVID pandemic, and it's our experience here too that we saw significant drop in the dengue rate during the COVID pandemic, and this was reported worldwide in all those places where dengue were endemic. And the reason probably was because of decreased human movement, and the social behavior which changed during the pandemic probably also led to a decreased incidence of dengue. Now, people started looking into the impact of, let's imagine, of being exposed with the SARS-CoV and then developing dengue later. That means you have a serology for COVID positive, and then what happens with, and if you catch dengue later, now for example, all of us have been probably exposed to SARS-CoV now. If you catch a dengue infection, what happens? Does it change its manifestation? This is a study from PGH Chandigarh, so where they looked into their own cohort, and what they noticed was a difference. They felt that if you are actually exposed to SARS-CoV, you tend to have a milder dengue infection. So they found out that the interleukin levels were lesser, severe dengue incidence was much higher in those who are unexposed. The chance of encephalopathy, liver dysfunction, acute kidney injury, progressive organ dysfunction was much more higher if you were not exposed to SARS-CoV. So this was quite interesting. Whereas there's one more report which came from Pakistan. So what they did was they looked into the rate of incidence of dengue and mortality. But what they found out was the mortality significantly increased in 2011 in an era where it's been a post-pandemic, the rates had gone up and the death rates were much more higher. So it sounds like there's a bit of a conflicting reports. So why does this happen? So one of the theories what have been proposed is probably because of what we call as antibody dependent enhancement. So we all know that secondary dengue is much more harmful. Now, if you have a SARS-CoV infection and that has some cross-reactivity to dengue antibiotics, these dengue antibodies can create a problem. It can probably mimic an infection which is very close to a secondary infection, and that secondary infection can actually lead to all kinds of problems like antibody-dependent enhancement, where these antibodies actually facilitate virus travel into the cell, replication, and then cause a manifestation which is very similar to dengue. So which means if it does this, the antibodies produced by SARS-CoV, if it does ADE, antibody-dependent enhancement, it potentially can lead to a severe dengue. So what's the impact of past dengue infection on SARS-CoV? So if you had already dengue infection and then you're going through a pandemic of SARS-CoV, being positive for dengue, is it protective or is it harmful in terms of SARS-CoV? So this again is a conflicting reports. Now initially the reports when it came from Brazil, they looked into all those places where dengue is endemic in our country and a lot of South American countries. They found out that actually the mortality was much more lower because of SARS-CoV in their population. They said this improvement in decreased aggressiveness of SARS-CoV in these countries potentially could be because you've been exposed to dengue virus before, and that might be providing some partial immunity. So this is pretty much similar to what I just mentioned before. So one of the postulation was what happens is because of your past dengue infection, so you have memory cells. And when you are exposed to a SARS-CoV infection, these memory cells which are already there, because of antigenic similarity, the memory cells produce these antibodies. And these memory cells which produce antibodies because of the antibody which has some cross-reactivity against COVID, probably binds to the receptor domain, and that might prevent the SARS-CoV from attaching to the ACE receptors. So that way, they felt that probably this dengue infection was actually protective in nature by producing those antibiotics, and that is preventing the SARS-CoV from entering into the cell by blocking its receptors against the ACE inhibitors. But subsequently what happened was a lot more conflicting reports started coming. So there is one study which is again published from Amazon, Brazil. And what they found in their cohort was the symptomatic COVID became more in post-dengue and they did not find increased mortality. But a subsequent study done, they said, again, the symptoms were more in those who had dengue earlier. They found that the use of corticosteroids was more in them, but the mortality was much lesser. They could not understand this phenomena. So it sounds like there are a bit of conflicting reports. So that part looks confusing. So one of the reasons why that might happen, again, probably depends upon what these antibodies do. Do they cause antibody-dependent enhancement or are they protective in nature? So there is a lot of confusion in terms of, it could be the serotypes of dengue. We all know 4 dengue serotypes exist. So each of those serotypes might have a very different kind of manifestation. In some, when the antibodies are produced, they might be protective, like the way I mentioned, which can prevent the SARS-CoV from entering into a cell. Whereas in others, it probably can cause antibody-dependent enhancement and lead into a worse infection. So that is one postulation which people are thinking. Now the question comes, that we've been seeing quite a bit of MIS-C and we've been seeing dengue, and most of us have been seeing a combination of these two diseases. I think we had couple of cases discussion in the morning, and also the panel discussion in the morning. Also, I had a couple of cases where this kind of manifestation is happening, and we are not really clear if it's a dengue or a MIS-C. So I'll just go through one case because there's not much in literature available to say whether it actually alters its manifestation, the post-dengue, in terms of having both dengue and MIS-C together. So this is a 13-year-old boy, previously well, presented on day 1. He had a moderate grade fever with chills and rigors. And then he developed vomiting, which is non-bilious in nature, and then had loose stools. And then some amount of myalgia, pain abdomen, which is diffuse and non-localizing. He was irritable and was having irrelevant talk. And in the OPD initially, he was given oral antipyretics. And then subsequently, he was admitted in the outside hospital, received ceftriaxone and Lasix. There were bibasal reduced air entry, there was hepatomegaly, he was conscious, extremely irritable, and had no tremors. And there was no rash, there was jaundice, there was headache, and then you subsequently came to us. Now what we can see here in the referral hospital is you can see the WBC counts are high, you see predominantly neutrophil predominance, platelet counts are quite low, and along with that you see NS1 positive. Okay, so the NS1 is also positive, and we also see a combination in terms of the WBC counts being high, which is not what we typically see in dengue. We see the WBC counts going low, and you see a significant neutrophil predominance. And what we see here also, urea creatinine being abnormal, bilirubin levels being high, we see a low albumin, we see SGOT, SGPT elevated, and COVID serology, IgG is also positive. And we see a ferritin levels extremely high, it was more than 1.2 lakhs, beyond that they could not quantify. So this was the ultrasound abdomen, echo, and pleural fluid findings. What you can see is hepatomegaly, you can see gallbladder wall edema, effusion, and ascites. And ejection fraction was moderate dysfunctional LV, and there was moderate PAH too. Then, so this was quite confusing. So we were thinking in terms of possibility of infection versus inflammation, the same differential diagnosis what we discussed throughout the day, thinking about MIS-C, secondary HLH, sepsis, and dengue as a predominant possibility. These are all the workup done. And subsequently, CPK levels were very high, LDH levels were very high, lupus anticoagulant came positive but didn't seem quite significant. So this is how the entire course went through. Though he showed some initial response to the immunomodulators, that response was not sustaining. The bilirubin levels did initially come down, ferritin levels did actually come down, but subsequently the patient only worsened. So we did give him methylprednisolone, we gave him anakinra, we gave he was on mechanically ventilated, the liver enzymes were just increasing, and the bilirubin was worsening despite the OTPTs were coming down, which is saying that the liver is probably going to necrosis. And at this point in time, we thought we should get a CRRT done. By then his sensorium was worsening, so we thought we'll get a CT scan done. So what we found in the CT scan, and then subsequently when we did a plain chest CT, was an evidence of fungal pneumonia. Okay, it was extensive fungal pneumonia in the child. And then we did a BAL, and in the BAL we grew Aspergillus fumigatus. This was really surprised us because this patient is coming from community, not even from, he's never been hospitalized. He's not an immunocompromised patient. He's a 13-year-old boy, well thriving until then. So this is what really surprised us. Subsequently, just rapidly progressed to purpurofulminans, septic shock, MOTS, and died. So it sounded like he had severe dengue, secondary HLH, disseminated Aspergillus pneumonia, refractory shock, and purpurofulminans. So it does make us wonder whether there is some kind of immune dysfunction which happens because of COVID. Like we discussed in the morning session, we discussed that the immune dysfunction, MIS is just one component of immune dysfunction which can happen because of COVID. It sounds like it can cause persistent immune dysregulation. So this is a study which I actually showed in the morning too, that there are studies which looked into the interferon levels in patients who had long COVID, in patients who had mild COVID, in patients who had other SARS-CoV, other human coronavirus infections. And when they compared with healthy volunteers, and this is the findings of these healthy volunteers. What you see is in those with mild COVID, it generally the immune dysregulation settles down by 3 months, but then those with long COVID, it sustains up till 8 months. That's what we know, that at least till 8 months, the immune dysregulation can happen. So it's possible that they might have a lot of T-cell dysregulation, and that makes them much more vulnerable to have a complicated illness, develop fungal infection. So that is something we can only speculate as of now. So right now, I think, like I just mentioned, it appears like there is some kind of interaction between dengue as well as SARS-CoV. It's possible that the various serotypes can have a different manifestation. The antibodies produced could be protective versus it can cause antibody-dependent enhancement and worsen the outcome. So that is something we should probably be doing research and learning more about it. So with this, I would just conclude my talk saying that dengue and acute COVID-19 infection can present. They can present with mixed features, mixed organ involvement, mixed biomarkers, and mixed clinical manifestations. So think about it when the ALT levels are much more higher and the WBC count is not what you expect for that particular illness. And we know that a rapid diagnostic test, which we use very commonly, can be fallacious in this context in the post-pandemic setting. And ELISA probably would be a better way of diagnosing dengue in the post-pandemic setting. And antibiotic cross-reactivity, we've just explained about protective antibiotic versus antibody-dependent enhancement, and that can change how this disease can manifest, and whether you can have increased infections an altered manifestations of dengue, that only time will tell, because it appears like that post-COVID, the immune dysregulation can happen and that can persist until 8 months. With that, I'll conclude my talk. Thank you very much for patient hearing.
Thank you, Dr. Rakshay. Just continuing from the morning talk,
yes.
I think what is known about long COVID in relation to COVID in children is, unlike other viral infections, if you have the Epstein-Barr virus, only severe Epstein-Barr virus causes immune dysregulation. But in COVID, even mild infection can cause immune dysregulation. And your talk and the previous talk, maybe there is one link that is missing, and that is the host's immune response. Why this boy behaved like this is something that we might try to know in future. Thank you.
Thank you.
If there are any questions from the audience on this interesting talk? That means all of us are eagerly looking forward to tea. And thanks Dr. Rakshay and Dr. Chandrika Bhatt for that very interesting 2 topics. Thank you.
Let's give Dr. Rakshay a big round of applause. Thank you so much. Request you to kindly stay back and felicitate our chairpersons, Dr. Satish HS. And Dr. Sumita Nayak. Thank you so much. We're going to take a very quick tea break. In just 10 minutes, we will be back. But reminding you to kindly head to our photo booth, which is just right next to the registration counter, and make sure that you click some really nice photographs, uphold it on your social media handles as well. And of course, the one that receives the maximum number of retweets and likes will walk away with some really amazing prizes. So make sure that you use the hashtag CUSP, CUSP, and do tag Rainbow Children's Hospital. We'll see you soon. Thank you.
We are ready.
We too as well.
Look up to the rainbow where the colors become one. Red, yellow, orange, green is for good health and the care we need. Blue, violet, indigo is for happiness and peace to all. Look up to the rainbow where the colors become one. Look up to
Rainbow Children's Hospital and Birthright by Rainbow Hospitals.
Welcome back. I hope you enjoyed your quick, short tea and coffee break. We move on to our next and final few sessions for this evening. I'd like to welcome our chairpersons up onto the stage. Up first, Dr. Swarna Rekha Bhatt. She has an MBBS from St. John's Medical College, Bangalore, MD Pediatrics from PGI, Chandigarh. Her achievements include being the editor, 4th and 5th edition Achar's Textbook of Pediatrics, the Best Teacher Award, NBE, in 2014. She's delivered various orations at state and national levels. She's an active member of NNF at state and central levels, and she's got publications in national and international journals as well. Please put your hands together and welcome Dr. Swarna Rekha Bhatt, our first chairperson for this evening's session. I would now like to call upon Dr. Shiv Prakash up onto the stage. He's a pediatrician and pediatric intensivist, and he's an associate professor and Unit 2 chief at Saptagiri Institute of Medical Sciences and Research Center since 2014. Indian Medical Association, Indian Academy of Pediatrics, IAP Critical Care, IAP Infectious Disease Chapter, and Bangalore Pediatric Society. Let's put our hands together and welcome Dr. Shiv Prakash. Thank you. And I'd like to invite Dr. Amresh Patil, our final chairperson for this evening. He's a consultant pediatrician at Amar Hospital, Gangavati, also the Honorary Secretary of Indian Academy of Pediatrics, Karnataka, from 2021. Please put your hands together and welcome Dr. Amresh Patil. Is Dr. Amresh around? I'm sure he's going to join us in a bit. I would now like to invite our speaker for the evening session, Dr. Saurabh Datta. He's a professor in Neonatology Unit Chandigarh and adjunct clinical professor, McMaster University, Canada. FRCPC by academic certification from the Royal College, Canada. Fellow of National Academy of Medical Sciences. Fellow of National Neonatology Forum. Editorial board member, +1 Frontiers in Pediatrics. And his areas of interest include research methodology, neonatal sepsis, microbiome, retinopathy of prematurity. And he has several publications, presentations, orations, and awards to his credit. Please put your hands together and welcome Dr. Saurabh Datta for the first of the evening session. He will be speaking about the pitfalls in diagnosis of neonatal meningitis. Thank you.
Thank you for that kind introduction. And it's always a privilege to be speaking where Professor Swarna Rekha Bhatt is one of the chairpersons. She's always been a role model for many of us in the field of neonatology and a great source of inspiration to us. Well, I'm absolutely sure that all of you at some point of time would have done a lumbar puncture or been asked to interpret a lumbar puncture in a young infant. And since this is a gathering which goes across all subspecialties of pediatrics, I chose this topic because I thought it would be of universal interest. How do you interpret lumbar punctures in neonates and young infants? So what I'm going to cover over the next few minutes is, in whom should a lumbar puncture be done? Are there neonates at such low risk of meningitis that we can avoid doing a lumbar puncture? This is a thought that crosses everybody's minds who looks after newborn infants. Thirdly, does delayed analysis alter the CSF findings? It's not always possible to get a CSF analyzed as soon as you've done a lumbar puncture. So if there's a delay, does it alter the CSF findings? That's a day-to-day problem we all face. Number 4, how do we interpret CSF findings? That means cell counts, glucose, and proteins. Nothing fancy, the usual cytochemistry. Fourth, do CSF parameters change with age? By age, I mean that within the neonatal period or early infancy, from week to week, do these CSF findings change? How do we interpret traumatic lumbar punctures? Because traumatic taps are very common in the neonatal period. The subarachnoid space being so small, the traumatic rates are much higher than in older individuals. And lastly, how long does it take for an abnormal CSF finding to normalize after you've given antibiotics? So these are all very common day-to-day issues that I'm going to cover. So who requires a lumbar puncture? Now, is lumbar puncture necessary for evaluating all neonates who present with suspected early onset sepsis, EOS, early onset sepsis? That's the question that I'm going to answer first. So here are a bunch of studies, all limited to suspected early onset sepsis. And I'm not going to go over each of them in detail. I would just beg your attention for the rightmost column out there. So that gives the incidence of meningitis in early onset sepsis, defined as CSF culture positive. And as you can see, there are a whole lot of zeros in that column, 0% incidence of meningitis in early onset sepsis, except the last one where you have symptomatic culture positive early onset sepsis where meningitis rates are higher. So without, going too much into details, the moral of the story from this slide is there is no need for lumbar puncture in asymptomatic babies with risk factors of early onset sepsis. That's number one. You don't need to do a lumbar puncture if there are only risk factors of early onset sepsis for which you're starting antibiotics. And that holds true even if the rupture of membranes is very prolonged or the proven chorioamnionitis or whatever. As long as the baby is asymptomatic, you don't need to do a lumbar puncture. Second is you don't need to do a lumbar puncture in preterm RDS without risk factors of early onset sepsis. So sometimes, we do start antibiotics in patients with RDS just to cover sepsis. In those cases, you don't need to do a lumbar puncture. But a lumbar puncture is required in symptomatic, clearly symptomatic early onset sepsis, or if the blood culture turns out to be positive in these patients with early onset sepsis. So there's only one subset in which you do need to do a lumbar puncture if it is early onset sepsis, clearly symptomatic or blood culture positive. Okay, is it necessary for evaluating cases of suspected late onset sepsis? So this is data derived from well-designed studies, prospective non-case controlled designs, these are cohort studies with reasonably big sample sizes. And you can see across, the column on the extreme right-hand side, that's the prevalence of meningitis. You do get a substantial proportion of patients who have meningitis in late onset sepsis. The ballpark figure is somewhere around 10%. If you just eyeball these figures. We have a study which actually at the time of making the slide, which was some time back, it was still an ongoing study. This has been completed. We have close to 300 subjects and we have a prevalence of around 8% meningitis, all culture proven meningitis, and these also happen to be proven by molecular tests, so they were also PCR proven meningitis. So figure around 10% is a kind of a take home message from this slide. So therefore, a lumbar puncture must be performed in all cases of suspected late onset sepsis because it is not possible to predict in advance who is going to turn out to be blood culture positive. And there is a high incidence of meningitis even when there are negative blood cultures. So anyone whom you're suspecting late onset sepsis, you have to do a lumbar puncture. But the problem is that if you give a message like this, there are some patients we all see in clinical practice, very mild symptoms of late onset sepsis, maybe just a little bit of abdominal distension, 1 or 2 apneas. Your diagnosis is a bit plus minus, baby is otherwise looking well, and you really wonder, should I really be subjecting this baby to a lumbar puncture, which is a relatively invasive procedure? That thought crosses our minds, very often. So we try to answer this question. Are there some neonates at such low risk of meningitis that the LP can be safely avoided? Because if that is the case, then you can say, okay, late onset sepsis, but if these criteria are fulfilled, you don't need to do a lumbar puncture. So to try and answer this question, we did this study on 300 lumbar punctures for suspected late onset sepsis or symptomatic early onset sepsis. This is published in 2020 in American Journal of Perinatology. We collected information prospectively on all these 300 infants for a whole lot of characteristics, various demographic characteristics, 17 clinical signs, various laboratory tests, sickness severity scores, organ specific localization, and so on and so forth. And we found that the diagnosis of definite or probable meningitis is associated with 13 variables that we had collected. there were 58 subjects which did not have a single one of the above variables known to be associated with meningitis. So we felt that, okay, this was a group which was very low risk, not a single of those variables which could be associated with meningitis. And to our surprise, even amongst them, 29% had definite or probable meningitis, which came as a surprise because we tried out in various ways to identify a low risk subgroup in whom we could say that the meningitis rate was less than 2% or less than 1%, where we could safely avoid doing an LP. We couldn't identify any such group. And what we concluded is that there is no subgroup in which an LP can be safely avoided if there's late onset sepsis. Howsoever, within quotes, well-looking the baby may be, howsoever close to term the baby may be, you have to do a lumbar puncture. There's no getting away from that. Okay. Now, does delay in analysis of CSF samples affect the WBC and the glucose? So, even in we have looked at turnaround times reported from even, the best of centers in the world. From the literature, it appears almost nobody is able to consistently get their cytochemistry reports, say, in less than 45 minutes or an hour. That's the amount of time it takes world over. So, we did a study in which from the same CSF sample, we did the cell count and glucose and protein within half an hour. So we took steps to it gets done within half an hour. And then from the same sample, we repeated it at 2 hours and again at 4 hours to try and see whether there's a change in the cell count and glucose and protein with time if you delay analysis. And this is what we found. So the blue lines are the CSF glucose. And at the bottom, you can see baseline 2 hours and 4 hours. So there is a drop in the CSF glucose with time. The red line is the CSF WBC count. And as you can, very well imagine, the WBC count shows a very steep drop from, baseline to 2 hours and then to 4 hours. And similarly with the polymorphonuclear count. The drop is so much that it completely alters your diagnosis. You'll be making a wrong diagnosis of meningitis if the glucose drops a lot, or you'll be failing to make a diagnosis of meningitis if your cell count drops a lot. Luckily, it is possible. We actually made linear regression equations that if you know how much was the delay, by using those equations, you can actually back predict how much the true glucose and the true WBC count would have been at baseline. So to be able to make some sense of the value that you've got in your hand from the lab. So you can look up this paper for those equations by which you can actually back calculate what was the true glucose and the cell count. So this is actually the linear regression equation out here for, from the cell count and dextrose. So in a nutshell, you need to analyze your CSF samples very quickly. Secondly, how do we interpret CSF findings? So we've always been taught that there are certain cutoff values or threshold values of WBC, glucose and protein, and these are the popular accepted cutoff ranges. In term neonates, more than around 20 to 25. Different authors have different, thresholds. Preterm neonates, 25 to 30. Glucose values are mentioned here. Protein values are mentioned here. These are what are popularly used in literature. So we did a systematic review and meta-analysis of all articles published on the CSF cytochemistry and diagnosis of meningitis. This was presented in 2019 in the World Congress and is currently under consideration for publication. So in a nutshell, we started off with a whole lot of articles and finally we excluded based on full text. And we included 20 articles in our meta-analysis, which had about 30,000 subjects. So it's a fairly big information size that we had. And what we found, the pooled diagnostic performance of these 3 critical tests. So WBCs, if we take the standard cutoffs that are reported in literature, the pooled sensitivity is only 77%. That means it has a false negative rate of almost 23%. 23% of the patients are going to get missed. Pooled specificity is also 77%. That means the false positive rate is also around 23%. Glucose is quite hopeless actually. Its pooled specific sensitivity is only 62% with a confidence interval crossing the value of 50%. That means it may not be much better than even tossing a coin, doing a CSF glucose. The pooled specificity is also not very impressive. Protein has a reasonably better pooled specificity, and again, not a very impressive pooled sensitivity. The number of studies evaluating the combinations of the above, that means cell count and glucose and protein, is actually so small that they cannot even be analyzed. You can't put them together into a meta-analysis. So the conclusion from this slide is that these three tests that we rely on so much are actually not very great tests. We need much better tests than CSF, WBC, glucose, and protein. And these cutoff values that we have always been taught, which are there in all textbooks, again, are probably not the best cutoffs. So none are satisfactory, and we desperately need better tests. So what do we do with traumatic lumbar punctures? So most textbooks still mention that you use these formulas of 1:500 or 1:700 and things for within quotes correcting the WBC count and getting a corrected WBC count. Well, there have been two major big studies trying to look at whether this correction of the WBC count actually should be done or not. So this first one, published in PIDJ in 2008, had more than 6,000 lumbar punctures in neonates, of which 40% were traumatic. And they tried out different ways of correction that had been reported in the literature. I'm not going to go into details. These are all there in standard textbooks. So there are different ways of correcting the WBC count using various formulas. So the only thing I want you to focus on, so on the left-hand side, you have the uncorrected WBC on the top row, and the various ways of correcting with traumatic lumbar punctures. I just wanted to focus on the the last but one column, the area under the curve. The area under the curve is one consolidated figure that gives the trade-off between sensitivity and specificity for any particular test. So the higher the area under the curve, the closer it is to the value of 1, the better is the test. Now here you can see that whether it is uncorrected or whichever method of correction you use, the area under the curve is virtually the same. It doesn't change. I mean, it's 0.78, 0.77, and so on and so forth. It doesn't change. So there is practically no difference whether one corrects or does not correct, and there's no difference between the various methods of correction. Why does this happen? It's because with the different methods of correction, what you gain in specificity, you lose in sensitivity, and vice versa. So you can't improve both sensitivity and specificity by doing any method of correction. And since while diagnosing meningitis, you want to have a high sensitivity, you don't want to miss any patient with meningitis, the dictum now that it's better not to correct. Just even if there are RBCs present in the CSF, you still count whatever WBCs you have and just use it as such. Don't correct for the number of RBCs. Here is another such study, even bigger than the previous one. Traumatic lumbar punctures, more than 20,000 lumbar punctures, of which 14 were traumatic. And the bottom line is that again the areas under the curve, irrespective of the methods of correction and irrespective of whether you corrected or not, were all the same. So whatever you were gaining in specificity, you were losing in sensitivity, and vice versa. So you might as well not correct. So same story. And so now the UK NICE guidelines clearly state that if you have a microtraumatic lumbar puncture, that means you're getting RBCs on your CSF, don't correct for the number of RBCs. Just take the raw WBC count and use that for interpretation of or diagnosis of meningitis. Okay, now do CSF findings change with age within the neonatal period? I mean, within that whatever 4 weeks or up to maybe 8 weeks for premature babies, do these findings change? We know that neonates have higher protein and higher WBC physiologically and lower glucose than older age groups. But what happens within that period? Well, there are a number of studies showing CSF protein with age, and as you can clearly see, the protein declines with age. And of course, it would be naive to believe that it would remain constant and then one fine day it all changes into the values that you use in older children. It has to be a continuum. That means there has to be a progressive decline, and that's exactly what all these studies show. Similarly, WBC count with age. Again, it would be naive to believe that the cutoff would be 25 or 30 constant for a month or month and a half, and bingo, all of a sudden one day it changes into the cutoff used in the pediatric age group. So here too there is a gradual decline in the WBC count. Glucose values also gradually increase with age. So what does this tell us? That CSF, WBC, protein and glucose change with postnatal age in a matter of days. And a single cutoff for the entire neonatal period is unrealistic. We have been using a single cutoff all these years and using it for any age. We have to use a bit of our common sense that these cutoffs have to gradually become more pediatric-like the older the neonate is within the neonatal period. So how much time does it take for abnormal CSF parameters to normalize after starting antibiotics? A very important question for two reasons. One is, suppose you have not been able to do a lumbar puncture in time, that means before starting the antibiotics, baby was unstable, and you were able to do it, say, only on day 4 or day 5. Do the findings change so much that you now cannot rely on them? That's one question. Second is, okay, you did your first lumbar puncture in time, you're giving antibiotics now, and for some reason you repeat the lumbar puncture, say on the 2nd week or the 3rd week of life, and you still find some abnormalities. What does that really mean? So to answer that question, this study was published by Greenberg in 2011. So among those who had initially abnormal parameter and whose CSF culture cleared in a repeat lumbar, for some reason they did a repeat lumbar puncture, what was it that they found? So this was from a large administrative database. This was not a planned prospective study, so it has some limitations. But this is what they found. For culture, those who were culture positive to begin with, the median time to clear was 4 days. Neonates with culture positive meningitis. With protein, that's the amount of time it takes for the protein to normalize. You can see how it goes down. So it goes on and on for 40 days, 60 days, the protein is still abnormal. Glucose, time for it to normalize, again, it takes quite a while, 20, 40 days. WBC count also, it takes a long time to actually normalize. It is not something that normalizes within days. It takes weeks for these things to normalize. So the time, the green box there, the time taken for parameters to normalize, protein takes the longest. It remains abnormal for a very long time, even after you have treated the patient with meningitis, followed by WBC, followed by glucose. Culture is the one that turns negative most quickly, that is a median of 4 days. And in the initial days, there is actually hardly any change in the WBC, glucose and protein. So for the first 4 or 5 days, you can safely defer the lumbar puncture if the baby is unstable, and still get a perfectly valid report on the lumbar puncture and use it for diagnosing meningitis. Only thing that will change is your culture. Culture may become false negative, but WBC, glucose and protein do not change that quickly. They take actually weeks to normalize. And it also means that you cannot use these parameters to judge improvement because they take such a long time to normalize. So don't be worried if you happen to have done a repeat LP and things have still not yet normalized. It doesn't necessarily mean that the patient is deteriorating or hasn't responded. So to sum up, do not do lumbar punctures for asymptomatic early onset sepsis or RDS without risk factors. Perform lumbar punctures for all symptomatic patients with early onset sepsis or late onset sepsis. There is no low risk subgroup in which it is safe to avoid doing a lumbar puncture if they have suspected late onset sepsis. We need better tests than CSF, WBC, protein and glucose. They do change with delayed analysis. Treatment based on positive WBC, protein, etc. does result in both over-treatment and under-treatment because they are not perfect tests, and they change with postnatal age and gestation. There is no advantage of correcting for the presence of RBCs in the CSF. And finally, antibiotics do rapidly turn the culture sterile, but the WBC, glucose and protein, may take a long time to normalize. If you are unable to do a lumbar puncture before starting antibiotics, try to do it within 3 to 4 days, maximum 5 days, and you'll still get a reliable result. If you're repeating the lumbar puncture for some reason, do not rely on non-resolution of the CSF parameters to judge non-response. So these are some, common issues that we face in our day-to-day interpretation of lumbar punctures, and these are the pitfalls which we should avoid. Thank you all very much.
Hello. Thank you very much, Saurabh. As expected, wonderful, with a lot of evidence behind it. And I think very, very clear-cut messages for the audience. Can I ask a few questions, or we are 1.5 questions? Okay, sorry. No, it'll be quick because I know he's going to answer quickly. Lumbar puncture has always been a bane for residents. Is there any data to say an ultrasound-guided lumbar puncture is going to be more beneficial, less traumatic?
Yes, ultrasound-guided lumbar punctures do result in less traumatic lumbar punctures.
Okay.
One very small tip I have for all the residents out here, because I find that happening with my residents in PGI.
Okay.
When you're doing a lumbar puncture on a neonate, sit down and do the lumbar puncture. Don't do it standing. Sit down on a stool. Get your eyes to the level of the spine of the baby.
Absolutely.
To avoid a parallax effect, and then do the lumbar puncture. Because in a newborn infant, even a 5 degrees tilt of the needle compared to the back, you will end up hitting one of the epidural plexuses. So you have to be bang on straight, and the only way you can do that is your eyes at the level of the spine. So it's a very small thing which I find residents don't do, and that results in traumatic lumbar
Thank
punctures.
you. Good for the residents' back also. Do you want the baby to be sitting up, or do you want the baby in the lateral position?
Well, they say that the sitting up position for an otherwise stable baby is just as good as being in the lateral position. And in fact, there's some evidence is probably even better. Maybe the subarachnoid space actually distends in the lumbosacral and making it easier to do. But I have never actually personally tried it or seen anyone doing it.
All right. Yeah. Thank you so much. There are a lot of questions, I'm sure. But I think we'll leave it at that. But I still want to say that was an excellent talk.
Thank you.
Thank you, Saurabh.
Thank you.
Well, thank you so much once again, Dr. Saurabh Datta. I'm not letting him go because he has to be back for our panel discussion right now. And we move on to the next session. I'd like to invite our moderator up on stage, Dr. Arvind Shenoy, the Clinical Director, Neonatology and Pediatrics, Rainbow Children's Hospital, Marathali. And of course, Dr. Saurabh, you can join Dr. Shenoy as well. Next up, Dr. Dinesh Kumar Chirla, Director, Intensive Care Services, Rainbow Children's Hospital. Our next panelist, Dr. Prakash Vemgal, Director, Pediatrics, Bannerghatta Road. Dr. Prakash Vemgal is the Director, of course, of Pediatrics and Neonatology Department at Rainbow Children's Hospital, a specialist in the area of neonatology, pediatric critical care, and general pediatrics. It was his love for children that motivated him to pursue a career in the field of pediatrics. His prior experience includes heading the Neonatology and Pediatrics Department at Fortis Hospital, Bangalore. He's a member of the Royal College of Physicians of Ireland and Royal College of Pediatrics and Child Health, UK. He also has a fellowship in neonatology from University of Melbourne, Australia, and a fellowship in pediatric critical care from the University of Toronto, Canada. In his illustrious career, he has treated extremely low birth weight premature babies, complex sick children, and children with various infections. And he is a diligent medical scholar and has many articles published at various medical journals of repute. A round of applause for Dr. Prakash Vemgal. Thank you. And our final panelist for the panel discussion, Dr. Babu S. Madarkar. He's a consultant and neonatologist and pediatrician. He's a highly qualified neonatologist. He has done his MBBS MD from PGI Chandigarh and DM Neonatology from Delhi University. He is a member of MNAMS, New Delhi, and recipient of the Certificate of International Program on Preterm Nutrition from Westmeads University, Australia. He's also lactation consultant and member of the IAP and NNF. His areas of expertise include handling low birth weight babies, hypoxic babies requiring conventional and high-frequency ventilation, neonatal emergencies, complex neonatal emergencies, and common surgical cases requiring NICU. He has worked as a consultant in many corporate hospitals. Our final panelist for this panel discussion, and I'm going to hand it over to our moderator, Dr. Shenoy. Thank you so much.
Thanks, Melody. Can we have the slides up, please? At the outset, we are really fortunate to have such a wonderful panel. Dr. Ranjan Kumar Pejawar, who was also one of our star panelists, unfortunately could not be present here, and we'll try our best to make up for him not being with us. The rest of the panelists have been kind enough to take over some of the questions which should have otherwise gone to Dr. Ranjan. Now, why have such a panel discussion? Probably our aim in life as neonatologists is to give the parents a healthy baby with an intact neurological outcome. Survival is no longer what we are looking at. Intact survival is what all of us are looking at. And we know that a lot of illnesses can damage the little baby's brain. And so let's look at some of them. So we will look at sepsis, we'll look at BPD, we'll look at hypoglycemia, and we'll look at asphyxia. And then, if time permitting, we'll look at IVH and PVL. And these gentlemen on stage will be each lead discussants, and the others would add on. So having said that, I think we should go to sepsis, because I thought it would just tie in with the talk which you've just heard from Dr. Saurabh. And what are the interventions, Dr. Saurabh, which we have to avoid neurological outcome in sepsis? As all of us know, studies from India have shown that sepsis, even without meningitis, causes adverse neurological outcome in neonates. Dr. Datta.
Is it working? Yeah. So I've just taken the help of, jotted some thoughts on this slide. As you rightly mentioned, we all know that meningitis, of course, there's a clear-cut association with poor neurodevelopmental outcomes, but this realization has dawned over the last decade that even sepsis without meningitis has poor neurodevelopmental outcomes. Partly it is because sepsis is associated with a whole lot of other things. So you have shock with sepsis, with poor perfusion. You can have hypoglycemia with sepsis, etc., etc. Hypoxemia with sepsis pneumonia causing that. But the thing is, even when sepsis does not have all these attendant things, does not have hypoglycemia, hypoxia, hypotension and so on, even then it is an independent predictor of poor neurodevelopmental outcomes. And that is probably mediated through inflammation. So inflammation is now recognized as a huge factor that by itself affects the oligodendroglיה in the brain and affects developmental outcomes. So here's a little bit of information. So this was a systematic review and meta-analysis, the top one in 2019, 14 observational studies, and they found that neonatal sepsis, after adjusting for various other factors, has an odds ratio of 3. That means a 3 times increased risk of neurodevelopmental impairment. Sagore Mukhopadhyay, she's an Indian, she's working in the US. She has published some really stellar, wonderful articles in the last few years. And I would suggest that at least the residents should try and read these 2 articles. The first was culture positive early onset sepsis, which she published in 2020. Again, showing that there's an increased risk of neurodevelopmental impairment. The second one was late onset sepsis, and these are huge numbers of patients, so you can't ignore these studies. Also increases the risk of death and neurodevelopmental impairment. There is data from a Korean network, again showing the same thing, late onset sepsis associated with
cognitive delay. And this is the important thing, that sepsis causes white matter injury even in the absence of meningitis. So there is a pro-inflammatory microglial activation by these cytokines. There's a whole inflammatory cascade going on in the brain even when there is no meningitis, leading to neuronal loss and dysmyelination and all these bad effects occurring 18 months, 36 months down the line. We always knew for a long time that histological chorioamnionitis, the mother having chorioamnionitis, is associated with white matter injury and causes periventricular leukomalacia, and again probably mediated through similar pathways. And this happens even when the baby itself does not have early onset sepsis. That's the important thing. Mother just has chorioamnionitis, baby is fine, but baby goes on to develop impairment in the long run, all mediated through inflammation. And meningitis, of course, that's a no-brainer. I mean, no pun intended. There's direct damage plus inflammatory injury. So about 15 to 25% of survivors will have moderate to severe neurodevelopmental impairment with meningitis, and this is data from developed countries. In developing countries, it's probably even worse than this. So that's the story of sepsis with NDI.
I was just wondering, after listening to Dr. Chandrika, what about ghost, genetics of the host?
Genetics of the host, yeah. That's an important thing actually, because we do know that there is a lot of polymorphism in our TNF-alpha interleukin responses to sepsis. So it would not be surprising that certain individuals who mount an exaggerated inflammatory response to sepsis may actually end up having worse outcomes in the long run if it's an unregulated inflammatory response to sepsis. But I haven't actually seen any data specifically related to this. There is data related to short-term mortality, where people have tried to look at genetic polymorphisms which mediate your TNF-alpha and other interleukin responses, showing higher mortality. But I haven't looked at data with regarding long-term neurological outcomes. But it wouldn't be surprising if that were true.
Yeah, I was just wondering, yeah, very, very thought-provoking. Thank you, thank you. I think you've given us a good thing. Dr. Chirla, now we are talking about interventions which can reduce mortality as well as morbidity. What about IVIG?
Yeah, see, IVIG is something, was quite sort of, famous during the 80s and early 90s when general concept was the transfer of immunoglobulin from mother to baby happens after 32 weeks, so they are relatively immunodeficient. The preterm baby with sepsis, probably support them. There's a good study which has come up called INS study, International Neonatal Immunotherapy Study, which was conducted. More than 1,000 babies were recruited, and it didn't show any differences in the outcome. So as you know, when it comes to sepsis, the outcomes are related to multiple issues. It is not just sort of one sort of therapy which is going to make, so you have to support the child in multiple ways. And there were two types of immunoglobulin which are looked at. And a lot of this interest came from adult study, which sort of adult Cochrane review showed that probably in adult sepsis it might be some beneficial initially it showed. So there are polyclonal IVIG and there IgM enriched IVIG. So when both were looked at in the neonatal study, and the Cochrane review showed that really doesn't make any difference in the sepsis. And after the debate, there was somewhere the Cochrane has written that please don't do further studies as far as this is concerned, from morning instead of this thing. There was something recently in 2020, the ALSONET reviewed sort of prophylaxis IVIG. Does it make a difference? Then again looked at some of the, does it make a difference in neck? Does it make a difference in the BPD? Does it make a difference in sepsis? There probably a drop in sepsis by 3% and 4%, that is what it says. Again, not a very significant thing. So something to make a recommendation for prophylaxis IVIG. So I think at this stage, if something has to be looked at is this IgM enriched IVIG, something is there a role is what is being talked about. So if the message is to be given, I said there's no role. Again, as a clinician, we come across a neutropenic child who is septic, on a septic shock, do we have a role? I think a lot of us who manage very sick children, we talk about this. Again, when I looked at the literature, there is no clear guidelines on that matter, unless someone has anything to sort of support it. But the Cochrane has not further subdivided into this. So, but at this stage, I think the message is IVIG has no role in neonatal sepsis or septic shock.
Wonderful. Would any of the other panelists disagree on this? No? Okay. Let's move on. So, the other thing which made a big difference in children with meningitis was the use of steroids. I know you gave a wonderful talk, Dr. Datta, but I would like to ask Prakash whether there is any role for steroids in neonatal meningitis.
Well, if you look at the steroid usage in neonates, extrapolated from the pediatric population when they started using it and showed a difference, the same thing probably people did try in the early 90s and thought that probably when we use steroids in babies who have meningitis, whether it would decrease the mortality as well as the sensory neural hearing deafness, which some of the kids would develop. I could find only few articles which probably didn't recommend at all. In fact, it says that there's no usage of steroids, especially in bacterial meningitis in neonates. At the same time, we were trying to use steroids for the babies who had chronic lung disease. And that studies were all stopped during that early 90s and 2010. And when you look at some of the articles, this is one of the articles which they looked at the clinical trial involving 52 babies, use of dexamethasone plus antibiotics or just antibiotics, and there was no change at all in both the groups. So, and there was one observational study involving 263 infants, but they were less than 3 months old. But the downfall of this study is they used only in 8% of these children were involved with glucocorticoid administration. So there is clear no to use of steroids in newborns with bacterial meningitis.
Before we go to that, I was just wondering whether Dr. Datta you'd like to comment. Is it because the inflammation, see you showed very nice data that the cellular changes last a very long time. Would that mean inflammation lasts a very long time? And that's why short-term therapy with steroids doesn't work?
Oh, I don't know. The cells may be very crude indicator of inflammation. Inflammation is such a complex thing that I don't think we can really conclude that. And the cells do come down, gradually. It's not that they never come down, they do come down. We must also remember that the organisms causing meningitis in the neonatal period are very different from those causing beyond, say, 2 months of age. Your Haemophilus and your pneumococcus and your Neisseria to a lesser extent in India are not the organisms in the neonatal period. So maybe that also is a player in this whole thing of why steroids don't seem to work as well in the neonatal period.
Dr. Babu, when we were residents in PGI, one of the important causes of exchange, indications for exchange transfusion used to be done was for sepsis, especially scleromatous babies. I don't know, I think things have changed back home, maybe, but we'll come to Dr. Datta. So what is your opinion on, does exchange transfusion in any way help us reduce morbidity and mortality in sepsis?
Thank you so much, sir. Theoretically speaking, what actually happens is when we read the textbooks, it is said that exchange transfusion helps in the mode of help that we get from exchange transfusion is that it helps in removing the bacteria, bacterial polysaccharides, and all those bioactive agents from the blood. And at the same time, we are able to offer complements and immunoglobulins and all other factors. This might be more, it looks very promising theoretically. But when we see through the studies, most of the studies that we have are all observation studies, wherein the end results are confusing and dubious. So in no way can we deduce the inference or conclusion from all the studies to advocate exchange transfusion as a mode of treatment. But at our personal levels, what we do is when we don't have any resort, when we treat the babies with all kinds of antibiotics that we have and babies still suffering from infection, we are not able to identify the bacteria, we tend to do exchange transfusion as a last resort. One noted study which was done in 2015 from Delhi showed a promising result in terms of decreasing mortality, but the time of doing exchange transfusion was very important. Time of doing exchange transfusion, as mentioned in the study, was just before baby goes into MOTS. And how to identify, we don't know. So it's very, very confusing, and maybe it doesn't I mean, lead us to any conclusion. When we saw feasibility of doing exchange transfusion in babies, even, I mean, smaller babies, in a PGA study, babies who were more than 1 kilos were enrolled, and DVT was done for various, at various ages of infection. It was seen that it was feasible to do exchange transfusion without causing any cardiovascular disability. And it was also seen that by end of 14 days, there was shift of decreasing in mortality, but then it was not statistically significant. And additionally, it was also seen when we do their blood levels and see there was improvement in immunoglobulin levels and complement levels. But does that translate into a clinical outcome is still not known. And one of the other study, when I came across a study wherein a 10-year-old data was collected, and it was seen that exchange transfusion did improve the outcome. But then again, it was a observational data collected, and we still are in need of more robust literature to come to a conclusion and put it into the guidelines.
Thank you. A quick word around the panelists. Do you still do exchange transfusions for sepsis? Do you think this is our equivalent for the PIs who's immunotherapy?
The rate of doing exchange transfusions has drastically dropped over the years. We still do occasionally, typically in patients who have obvious sclerema. And again, it's not a completely safe procedure, although it's mentioned there, because we have found that in babies who are hemodynamically compromised and all that, doing an exchange transfusion can destabilize the baby further. The other problem that happens is that there's a sharp drop in platelet count when one does a DVT, because you're not providing platelets in the blood. And many of these kids already are thrombocytopenic. So occasionally we have seen platelets drop drastically, and then even, they're having clinical bleeds. So it's not a completely safe thing. The rationale for using a double volume exists only for jaundice, because there is a certain amount of volume that you need to replace to drop bilirubin levels. So if you're doing it for sepsis, one could even do a single volume exchange transfusion if one thinks that the baby will not be able to tolerate a double volume exchange transfusion. So yes, I agree with Dr. Babu that the last word has not yet been said about DVT, and it's very unfortunate that in this country we have still not done one big multicentric randomized controlled trial to settle this issue once and for all. They're all small studies from here and there, all leading to confusing conclusions. So in PGI, once in a while we still do DVTs in patients who have sclerema and who we think will be able to tolerate the procedure.
Dr. Dinesh, would you like to comment? Because that would be cheaper than giving IgM-enriched immunoglobulins or using IL-6 inhibitors and so forth.
So I tell you, we used to give that in Sion also. We do a lot of double volume exchange during our TM training program. But I don't remember doing any time in the last 20 years. I think a couple of babies that when you push to the wall and say, kuch to karo. But I think, see, as I told, IVIG also doesn't work. When to do is the question. So is sclerema indication? Probably. And once they go to hemodynamic instability, that's just pulling out how much volume of blood and pushing in, that's when they become further unstable. And that is the reason why I think as a unit we never sort of bought the theory. So having said that, what is the alternative? Like, we sometimes are stuck with some of the children who, how do we clear? Like we have, like what in the pediatric counterpart of these children have cytokine storms, bacterial sort of overload, what looks like theoretically very promising that you are able to take off something and give something fresh. And for bigger children now, availability of CRRT, availability of something to take care of this bacterial load is available now. And maybe that could be an alternative is what I am thinking. For smaller baby, it could be there. But if you ask straight question, are we doing? We're not doing now.
Prakash, you want to add before I close the topic?
Yeah. Recently, I heard a talk from one of the guys from London. He's adult intensivist. They have devised a CRT for a small babies, like for neonates. And that was the machine which they tried to use for Miss C in neonates. This was a couple of months back. Probably that would be the opening part of it, whether we can try that bit of it in, instead of exchange transfusion. My question is always that when it, in a unstable baby who is severely septic shock, by doing an exchange transfusion, you're probably going to destabilize the child. And it's entirely different concept what we do exchange for hyperbill. So the physiology is normal there in a newborn baby, whereas you have a destabilized physiology, in a septic baby. So that's the problem I always face, and probably the baby which we probably come across with the machine which we can do a CRT is what we're looking forward.
So the basic bottom line is, as of now, we really don't have anything on hand in severe sepsis to either improve immediate or long-term outcome. I think further studies are required, as the Cochrane would say. So, Dr. Chirla, the other thing which Barbara Schmidt's landmark work showed was actually BPD as a risk factor for adverse neurodevelopmental outcome. You may say BPD affects the lung, how does it affect the brain? So, Dr. Chilra, what would you like to say about this?
See, I remember during our training program, someone saying BP doesn't happen in India. From that time to for now, sort of saying that, and what I would like to say is that now we are saying typically the 24 to 32 weeker, and we are saving baby size that as small as 24 weeker, and the survival across the country has increased. And it is during this phase of lung development when we are inducing these toxic gases into the baby, giving high pressures, high volume, that is where we are seeing the problems of BPD. What happens with bronchopulmonary dysplasia would be long-term ventilation, long stay in the hospital, exposure to high oxygen, which itself puts the child at increased risk of neurodevelopmental impairment. And that is the reason why there are so many interventions. As the biggest challenge for neonatologists who manage a small preemies is to how to prevent BPD. If you look at the literature, you will find that there are multiple factors, right from mechanical ventilations to infection, which could be antenatal and postnatal, like what Saurabh was saying about chorioamnionitis and how it can sort of change, induce inflammation. As much it induces inflammation in the brain, it can induce inflammation in the lung and create BPD even before you start ventilating. Similarly, and genetic factors are again why some babies who are not on much high ventilator initially and then start deteriorating after, and that is why some genetic factors do cause, and especially based on how early, because that's what new BPD and old BPDs are. Earlier we had very high pressures being given, and we had bigger babies, so it was mainly airway injury and pulmonary fibrosis. But now the more problem is now more of the way we are managing these smaller babies, so we are having problems of more of pulmonary vascular hypertension in these babies. So a lot of children with BPD, we are seeing learning deficits, behavior problem, visual-motor integration impairment, delayed speech, and so these are, and long-term lung issues also with them, coronary pulmonary diseases in adults, and the cost of treatment is also sort of high. So majority of sort of our interventions are to sort of reduce sort of BPD, and this is sort of question is, can we predict BPD? And that is how sort of as a neonatologist you would have the different type of scoring systems. So there is question is, can you diagnose BPD? That has also sort of changed sort of various ways. Now I think 2019 they have come to some consensus based on modification of what happened in NICGH data, where they said if there is no requirement of oxygen if you are in room air at 36 weeks, then or no respiratory support, then there's no BPD. And accordingly, we have grade that if you are on less than 2 liters, grade 1, more than 2 liters, or non-invasive, grade 2, or grade 3 is when. The reason we need to know this grading is you would be able to sort of understand the long-term neuro disability based on that. And the reason this graph is being shown is that whatever we have done so far with BPD, we were not able to reduce the incidence of BPD because two things. We are able to show save smaller babies, and there are multifactorial things which are sort of these things which are contributing to the BPD. So yes, so whenever a child has bronchopulmonary dysplasia, they end up in being on sort of respiratory support for long, and it's not only the lung, the intermittent episodes of hypoxia which happens, the intermittent pulmonary vascular hypertension which happens, and the poor weight gain which a child goes through, all this contribute to the neurodevelopmental disability. Yeah, I think I'll pass it on to the next one.
You may be wondering why we are talking about neurological outcome but not talking about the brain. What point I learned from today's CUSP workshop is cytokine storm anywhere in the body seems to affect the brain. Whether it is due to sepsis or if it's in the lung, I think it seems to affect the brain. And thank you, Dr. Dinesh. I think it's a point well made. Quickly passing on to the other panelists, would you like to add to what Dr. Dinesh has said? Do you like to tell us about whether gentle ventilation is the solution or?
Well, if we look at how we used to ventilate, over the last 5 to 10 years, gentle ventilation has made a huge difference in terms of the outcomes, especially moving out from invasive ventilation to non-invasive ventilation and using more of non-invasive ventilation in babies. Antenatal steroid has made a huge difference when given at early before the baby is born. So this is just a flow chart where basically it tells what is the difference which has made using gentle ventilation. Okay. If you look at that, we look at volume targeted ventilation than pressure now, and that has made a difference basically in decreasing the incidence of BPD in some subgroup of BPD patients. And the saturation targets, we looked into 2 saturation targets, 85 to 96, and 85 to 95, 89, and between 90 to 95. And if you look at that, the saturations which we target, that probably would contribute to decrease in incidence of BPD, mainly because we know that oxygen is not only harmful, it can release oxygen-free radical injury and cause lung injury too. And of course, surfactant has made a huge difference, but if you're giving surfactant, you give early. And we have moved from intubation and surfactant to more of giving surfactant and extubating and getting them on non-invasive ventilation. So we all know that babies who are so small, if you handle them gently, probably reduce some of these comorbid conditions.
Thank you. Dr. Babu, would you like to talk about steroids? Because I think we have been asked to wind up. So I think we'll talk about steroids in BPD, and then we'll move on to each of the participants to talk about the other things. Go on.
So when we discuss about steroids, usage and pendulum is like a pendulum which keeps on moving to and fro, not only to and fro, here and there. We have issues with respect to usage because we do not know what steroid we have to use, when to use, what dosage you have to use, because we are at the risk of giving baby early complications and as well as late complications. Now, if we see the usage of, if you see through the literature from last 20 years, the steroids have been, like whether it is dexamethasone and or hydrocortisone, has not been consistently or showing benefit in terms of BPD improvement as well as the long-term neurological outcome. If you see the graph here, it is actually taken from a recent meta-analysis which included 62,000 babies from 62 studies, and which used 14 types of modalities of usage of steroids. And the modalities were like early use, moderately early use, moderately late use, intratracheal use, or budesonide nebulization, and all so on and so forth. It has been seen when dexamethasone used in moderate dose, which is defined as 2 to 4 milligrams, in moderately early phase, which is 7 days to 14 days, has been shown to decrease the requirement of oxygen at 36 weeks of age. But then there is a risk of having hypertension. This is what we have currently, but then this pendulum might still move from here. We still are lacking in terms of final conclusion to give with this respect.
Thank you, Dr. Babu. See, the reason for bringing this up is that if you heard the earlier part of the day, steroids, when used, were lifesavers. They modified the immune system. But here, the important point which has been brought out is that if you use steroids in the neonatal age group, you actually have an increased risk of cerebral palsy. So playing around with the immune system doesn't seem to be that great an idea. It has significant drawbacks, especially if you use steroids. So coming back to the panelists, we know cytokine storms, probably inflammation, result in brain injury. Trying to curb the storm by using immune modulators doesn't seem to help. So what next? How do you prevent neurological injury? I know this is not part of the questions I've given to you earlier. So question passes to each of you in turn. You'll have to do an extempore.
See, I think we can't say that no for steroids completely. There will be, I think if you look at the literature, we have gone from using very high dose steroids, which is causes neurodevelopmental disability, to then coming to a study like DART study, where said probably there is some role, to now there was a nice study, Premilox study, which has come up, where they started using early hydrocortisone from day 1 to day 10, and they followed it up to 2 years also, and didn't show that there's a neurodisability as much, and maybe tendency towards less BPD. But somehow the way the study was conducted, it didn't gain that much of popularity, and there was some increased risk of GI perforation and concerns in that. So especially when it comes to preterm babies, because of overall, I think, immaturity and other things, we are still hunting for the right dose of and the right steroids. That is our biggest challenge. And I think whether the type of immune response which the preterm babies mount, we probably are not still aware about. That is the reason why we have a big challenge in finding. But I still think there would be, we still need a research to find the right timing for steroids, because otherwise long-term ventilation itself is a risk factor for neurodisability. So at this stage, if you look at literature, people are still looking at combination of surfactant with steroids and installing that, and maybe there could be a role of that. There is one. So whether there could be a vehicle where the steroid could be given in a better form, and that will help us in reducing the BPD. That could be one way. Second is maybe giving hydrocortisone early or late is a debate, which could be something which is there. So I don't think we can give a message that there's no role, but we use it with caution is what my message is.
Well said, Dr. Dinesh. But what about antenatal steroids, Dr. Datta?
Antenatal steroids?
Yeah, because
do we have a section on that, or?
We do have, but I'm not permitted to show slides.
Okay. Yeah, so antenatal steroids, there's been this controversy generated about dexamethasone versus betamethasone. And the reason why this controversy arose is that in animal studies, betamethasone has been shown to be superior to dexamethasone in terms of neurological outcomes. There is better synaptogenesis, better myelination, etc., if you use betamethasone as opposed to dexamethasone. However, in human studies, that has not been replicated. So there's now a fairly large body of data which has been meta-analyzed in human studies, both head-to-head comparisons between DEXA and beta, as well as in network meta-analysis, indirect comparisons between DEXA and beta. And a difference has not been demonstrated in human studies between dexamethasone and betamethasone. The second question, single dose versus multiple doses. Multiple dosing with antenatal corticosteroids, there is concern that it impairs long-term neurodevelopment. So as far as possible, one has to try and avoid multiple doses of antenatal corticosteroids, because there is a concern. Even head growth, developmental scores, everything have been shown to be poorer when multiple courses have been used. So I think the bottom line is, don't be so worried about whether you're giving DEXA or beta. And in fact, the government of India recommends dexamethasone in India. But be careful about giving multiple courses of antenatal corticosteroids.
Definitely, well said. I mean, there is a role for antenatal steroids. Postnatal steroids also, there may be a select role, as Dr. Dinesh said. Prakash, what would be your take on use of steroids?
Well, we heard, whatever Dr. Dinesh and Dr. Saurabh has said that. My question is to you. We heard the lecture from Jagdish Chinnappa and as well as Dr. Saurabh. How can you do a randomized control trial when you have landed up in this problem? So are we going to get clearance from the ethics committee to conduct such a study when we clearly know that dexamethasone is going to harm the babies in terms of their neurological outcome? Now, unless until we do a study, we are not going to come to a conclusion which is best and how do we use this. So my dilemma is whether we go more clinically and see whether there's an outcome, or whether we should do a big randomized study and then come to a conclusion. That's all it is. It's more confusing for me to decide one or the other way.
See, whenever I have a confusion in the unit, I turn to Babu. Question goes to you.
So it is given in the literature, so that if you have to show that if you have to nullify the benefit of steroids, you have to do 15,000 more studies which are consistently showing negative effect on the baby. Then whatever existing result that we have, it will be nullified and we will be at 0. So we have so much of data which shows antenatal usage of steroid for benefit of respiratory system, for benefit of, steroids for respiratory benefit. But then when we say neurological, there is a lot of debate which still is going on. We need to come to final conclusion. One recent study by ACT trial, wherein steroids are given at the community level. Now we know at the hospital level, when we give steroids to preterm babies who are less than 34 weeks and all, we see the benefit in terms of decrement in IVH, RDS, and so forth happens. But when given in the community level, it has been seen the mortality rates and neurological affection is more in babies who have received steroids. So we still need to find in a broad way, we still need to come to a conclusion.
I'd like to clarify, I was in touch with the day. The second part of the trial has shown some benefit. So antenatal steroids are there very much, but I congratulate all 4 people, it's just 0 seconds on the clock, for bringing out some very, very important points in this discussion. Number 1, as we have learned throughout the day, cytokine storms are dangerous. They not only affect mortality, but they affect long-term neurological outcome. Number 2, even some established therapies like antenatal steroids or postnatal steroids can have significant side effect on long-term neurological outcome. And number 3, you must remember that whatever happens to the baby, the effect can be on the neurological or intact outcome. So these are really good learning points which I have learned. Those of you in the audience who have some time and who occasionally do so YouTube, there's a very nice lecture by Dr. Alan Jobe, Professor Alan Jobe, where he has addressed this question of antenatal steroids. What is the dose? Are we giving it appropriately? Are we giving the right preparation? And all these questions have been answered, and for those who are interested, they could look it up. Meanwhile, I think it's time to give all our panelists a very big hand. Sorry, madam, you're chairing this session. Would you like to add on, the chairperson's apologies? Okay, so maybe later. Thank you so much. A big hand to the panelists, please.
Thank you so much, Dr. Shenoy, for being an excellent moderator, and to our panelists as well for giving us some really great insights. We now move on to our next session, which is going to be a virtual session. And I'd like to introduce our speaker for this session, Dr. Stephen Holland. He's the Director, Division of Intramural Research, Chief Immunopathogenesis Section, National Institute of Allergy and Infectious Diseases, National Institutes of Health, Bethesda, USA. His work is centered on the pathogenesis and management of chronic granulomatosis disease, as well as other congenital immune defects affecting phagocytes, including those predisposing to mycobacterial diseases. He was chief of LCID from 2004 to 2016 and was selected as DIR director in 2016. He has served as the president of ICHS from 2006 to 2008. Let's give a big warm round of applause to Dr. Steve Holland, who's going to be joining us right now. And of course, he's going to be speaking on the topic of diagnosing immunodeficiency in the era of genetics.
Good morning. Can you hear me okay? Am I coming through?
Loud and clear. Thank you.
Very good. So I see that my screen labels me as Dr. Sanjay Bansal. I apologize to him for anything I say that is not what he would say. But let me go here. There we are. So my job today is to talk to you about primary immune deficiency in the era of genetics. And the simple answer is that there is no simple answer. And I will spend the next several hours trying to drive that point home. But actually, I'll be done in just a few minutes. So let me start out by pointing out that the prevalence of immune deficiencies is really it looks like it's quite variable. In this really important paper from 2020, the authors looked at the rates of immune deficiency from countries around the world. And what you see is that the rate of primary immune deficiency in the United States is somewhere between 5 and 10 per 100,000, whereas the rate in many other countries, including India, is somewhere down at less than a tenth of that. Of course, we know this isn't true. We know that virtually all countries have likely similar rates. Some might be a little higher, some a little lower. But this kind of disparity simply reflects the difference in our success of screening and of recognizing these diseases. So I point this out because in the United States right now, the rate of tuberculosis is somewhere between 1/2 and 1/4 of what the rate of primary immune deficiencies is. Now, I realize there's a difference between incidence and prevalence, but what I try to tell my trainees is that if you've been screening for tuberculosis, you definitely should be screening for an immune deficiency. And I suspect that similar things will be true in India if they are not true already. Now, let's talk just a little bit about the how we think about these immune deficiencies. It was 1970 when the International Union of Immunologic Societies formed a committee to put together a list of what were all the immune deficiencies. And you can see the list of the people who were on that committee, the luminaries of the 1970s. And in 1990, this committee was taken over by the IUIS. And this graph here is to show you the change in the number of recognized genetic immune deficiencies between the years 1980 and 2021. And what you see is a staggering increase in the number of immune deficiencies that are, for the most part, genetically determined or were thought to be genetic when they were identified. And it is no surprise that the reason that that rate has been so extraordinary and has been going up at the rate it has is because the cost of sequencing has been going down. And here you just see the cost of sequencing of a full human genome now below $1,000. And although that may still be a cost that is difficult for some individuals, for systems, it is a cost that I think should turn out to be fairly affordable. And as you know, it is going down further. If you're interested in this topic in particular, this publication on human inborn errors of immunity comes out every 1 to 2 years. The last iteration was done by Stu Tangy, shown here in the upper right corner. And this really is the compendium of all the recognized diseases that we think are underlying causes of immune deficiency. And the concern is that each year, new diseases are being added. So as an example, what are the additions in 2022? Well, I won't go through what each table is. You'll have to go and suffer through that on your own. But just to point out that in each category, new diseases have been added in the last several years, and those have been added precisely because we now have the capacity to do the sequencing to identify these individual diseases. Okay, so now coming into the topic that I was given, I don't think there's any controversy about this. Nobody thinks that genetics isn't an important component of how we do it. It alters, it informs every aspect of how we talk about primary immune deficiencies, except common variable immune deficiency, and that is, as you know, is sort of like a large pie that has been being pulled apart each year as yet another syndrome that was in the CVID bundle is pulled out and given a genetic etiology. But it's also how we determine prognosis. If you say someone has X-linked SCID and has severe X-linked SCID in a newborn, that's a completely different game than saying, you know, XLA or something else. We believe that these genetic determinations are critical. It's also how we counsel families in terms of the risk of recurrence or the ability to use a family member as a donor. And it really does determine the therapies that we use. There are some diseases that can be fixed with gene therapy, some with enzyme replacement therapy, and then some that need transplant. And you really need to know the underlying genetics in order to do that. So what are the questions about the use of genetics in diagnosing immune deficiency? I think there are several critical questions, and let me just list a few of them. One of the first is, do you really want to do the genetics before you see the patient or only after? And then if you're going to do them after, are you going to do a single gene? I really think this is XLA. Or are you going to do a panel, an immune deficiency panel, a whole exome, or a whole genome? Those are each different. There are obviously cost differences, speed differences, and there are differences of how much information you can get from it. Do you want to do the patient only, or do you want to do a trio? Do you want to do an entire family if they're available? And then I think what we as physicians are always troubled by, how hard do we want to push for a genetic cause? That is, I know this child has an immune deficiency. I really think he or she needs to transplant. Do I really need to know exactly why? We transplanted these children for decades before we knew about specific genes. We also had unsuccessful transplants for decades before we had specific genes. And then there are some other questions that really are still the sort of details that we have to agonize over. What platform are you going to use? That is this issue about should it be you know, a long read, short read? Should it be a panel or an exome? What does it cost? And that will vary from place to place and time to time. Who pays for it? That's really a big question. Is it the patient? Is it the health system? Is it the insurer? And then what is the turnaround time? If you need to make a decision within a week about what to do with a patient, then many of these things that might take weeks to months will not be viable. Who interprets the data turns out to be, I think, a much more complex issue than getting the data. Sequencing now is very easy to accomplish. There are centers all over the world that can do whole genome sequencing in days to weeks. And yet, who actually will read that data? Who will interpret it for you? Who will put it in the context of an individual patient? That is not quite as simple to find. And I know because I've had to look for it. Then, as you saw early on, we are constantly identifying new diseases because we've identified new associations with genes. Those have to be put back into the analysis. You know, if I analyze somebody's exome 4 years ago, before certain diseases had been identified, I might have missed something that was there. So how often do you or your provider go back and reanalyze the data to make sure that you are catching something that might have been overlooked before? And then, of course, the ethical and legal issues with the data. The United States has had a variety of complex problems around insurance because of our unique approach to funding medical care. The ability to provide coverage for all individuals is difficult, and the way that we do that when a pre-existing or genetic condition has been identified has been a topic of great concern. If that's an issue for you or your patients, you need to think about that ahead of time. And then there are these issues of paternity, incest that come up as you begin to do genetics. Unfortunately, I really can't answer many of those questions for you. There are a lot of variability in terms of payers. The platform will be largely what is available in your area and who can do it quickly. How urgent your need is will vary from patient to patient. And then not all patients are interested in having genetic diagnostics. There's a huge burden that comes with knowing that someone is a carrier of a genetic disease, and lots of guilt, lots of problems with marriage, with family structure. These are issues that have to be considered on a case-by-case basis. And then you always have to worry a little bit about the quality and the skill of the analysis, and that will vary from place to place. So I can't answer a lot of those questions because they are so dependent on what happens with each individual case. So precisely because I can't answer those questions, let me answer a few things that I can. And I'm going to tell you what our experience has been over the last 5 years. And when I became director of the intramural program here at the NIH, I really felt that we had to take the genetic exploration of disease to the forefront and to try and do it in a methodical, prospective way. And so we started out doing whole exome. Now we do whole genome and chromosomal microarray when we're worried about copy number variants. Those are not always easy to identify on whole genome sequencing, and they were not possible to analyze on whole exome. And our approach is that every patient who comes into our institute, that's about 1,500 to 2,000 patients a year because it's a small research program, every patient, regardless of their underlying condition, is offered a whole genome sequence. And you might say, well, why would you do that? Why would you, try and get sequencing on people that either you think you know what's going on or people that don't have obvious problems that need to be solved genetically? And it's precisely because I don't think we know very well what we're doing. We need a better denominator. We need to understand issues like penetrance within families. Just because somebody says, I'm healthy, does not mean they don't carry a gene. And it does not mean that we don't have to figure out what that might mean in terms of generations down the road. We had to put in place a professional group, and that meant hiring professionals to do this kind of analysis and reanalysis. And then precisely because it's returning the data to the patients and to the physicians that we had to go about setting up a large group. And those genetic counselors have been critical to our program. So here are the data that were just published in the last month. And at the top of the screen is Morgan Similuk, who is a genetic counselor and has put this program together, and Jayan, who is a genetic epidemiologist and genetic counselor, and then at the bottom, Magda Valkevich, who is a medical geneticist. And we looked at, we've had now several thousand, about 5,000 patients come through our program, but this report that was just published is our first 1,000 people going through. Some of those, of course, were people that we had diagnosed previously, and so we had followed for a long time, but we went back to do their genetics on this platform to figure out what was going on. Here you can see, the simple breakdown of what 1,000 people look like in this sort of structure. Our age at enrollment, the ethnicity, the status, how many were living or had died, and then how many of these cases were proband only, trio only, or something else. I want to draw your attention to the fact that 75% of these cases were proband only. I don't know that that's the best way to do things, but it is really the way that patients come to you. Patients come to you because they're sick, and we have to respond to individual patients, which is what we have been trying to do. So what did we find in our first 1,000 patients? Well, we had a diagnostic rate of about 33%. So that's pretty well comparable to what most programs that are doing prospective genetics are finding. Out of those 327 probands, 361 molecular diagnoses were rendered. That's a reminder that the rate of finding a second diagnosis in someone who has one primary Mendelian defect, the rate of finding a second diagnosis there is about 5%. 17 of these probands had copy number variants. That is, they would not have been picked up on exome screening. They would have to go to copy number variation or whole genome screening. And then 32 of these probands, so almost 10%, had secondary findings, that is, had mutations in other genes that the American College of Medical Genetics thinks people have to be told of. BRCA2, some of these things that are actionable in terms of screening for cancer in particular, were identified that had not been suspected. 31 people had multiple diagnoses, as I mentioned, and then it was on reanalysis, that is on going back through our genetic database, that we found new diagnoses, and in 9 of the 22 molecular new diagnoses that we found, those were absolutely new disease gene associations. And then finally, you know, all of us are complex compositions of multiple different components. We're not all simply immune system genes or all neurologic genes. So in almost a quarter of the diagnoses of the patients, we found genes that were not involved in immunity, but sometimes might be masquerading. In one in particular, where we found a Charcot-Marie Tooth mutation that was confusing us about what had been happening in terms of a girl's CNS infection. Not surprisingly, the people who have more molecular diagnoses are younger, more male, and have more severe disease. So this is just a breakdown of some of our cases here. Not important to go through the bunch, except to point out that it's obviously heavily weighted toward the kinds of diseases that we see, lots of APOSED and ALPS and chronic granulomatous disease. I'm only going to mention that genetics will only take us so far. And most of us, when we think of genetics, we think of Mendelian genetics, single gene defects that are part of the inborn system. But there are somatic problems, and I'm only going to mention in brief one called somatic TLR8 deficiency, in which typically young boys have mutations in the TLR8 gene, which is X-linked. And these somatic changes, typically somatic changes, show up in childhood as neutropenia, fever, and you can see their splenomegaly and bone marrow failure. This is not easy to pick up on standard genetic screens because it is mosaic and at a relatively low rate. So you really need to do deep reads in order to find it. Another example of this in adults is somatic mutations in UBA1. This disease is called VEXAS for vacuoles, E1 ligase, X-linked, autoinflammatory, and somatic. And you can see that this is a disease that typically comes on in men in the 5th, 6th, or 7th decade. And in this one, the allele fraction is higher, but it's only present in myeloid cells. And you can see that the disease, the mutation is missing in fibroblast T cells or B cells. So this is a late onset disease that is genetic, but not inborn. Finally, there are lots of diseases now that mimic molecular diagnoses. And the most vivid example right now are autoantibodies against type 1 interferons, interferon alpha, interferon omega, that are associated with life-threatening COVID infections. These tend to be occurring in older men, and they tend to be associated with much more severe disease, landing people in an ICU. So anti-cytokine autoantibodies are yet another mimic of genetic disease that we have to keep in mind. So I would argue that whenever you're thinking about genetic disease, you need to think about mimics of genetic disease as well. So coming back to our initial questions, should you do genetics up front or only after meeting the patient? Should you do a single gene panel exome trio or family, and then how hard you push for a genetic cause? I can't answer those things for you. Those will have to be things you determine on a patient-by-patient basis. Although I think that genetics is changing how we think about our diseases. However, no matter what you do, genetics isn't everything. And sometimes genetic answers are not the right medical answers. Sometimes we really need to be looking at the patient, doing what the patient needs done in order to understand what it is that the patient is most concerned about. And I will stop there, and I'd be happy to take any questions. Thank you.
you, Dr. Steven, for this wonderful discussion and taking to this nascent stage of genetics in genetic disorders. This is being a nascent stage, and you're told there are a lot of untold questions, but it's going to be a promising one and futuristic one. So this is what it opens up a Pandora box, and what are the opportunities to treat also. Thank you for the wonderful detailed discussions and discussion and elaboration on that nascent and wonderful topic. Any questions from the audience? Thank you.
Any questions? Okay, do you have a question?
Yeah.
Okay, please.
I do realize in a small cohort of your patients, there were copy number variations. I'm interested to know, was it related to any chromosomal deletion duplication, or was it CNV related to a monogenic disorder?
They were almost all CNVs related to intergenic or intragenic deletions. They were not associated with large chromosomal rearrangements.
To be more specific, I was interested in understanding, did any of your patients have 22q microdeletion? Essentially, that's what I was trying to understand.
Yeah, that's a really good question. No, surprisingly enough, they didn't. And I'm worried that that reflects a bias in our referral pattern. But I completely agree with you. I had expected to see more. And we designed our array platform with good coverage for that region. And I'm puzzled why we didn't see it as well.
And I want to understand your take on newborn screen with TREC assay. We have seen patients with positive TREC assay probably heading towards a SCID diagnosis. But I've read in literature that 22q microdeletion also can have positive TREC assay. So have you come across any cases wherein positive TREC assay leading to a 22q deletion confirmed diagnosis?
So that's a really important question. Let me just say, we do not have a neonatal program here at the NIH, so I'm not the right one to answer that. We don't do TREC assays here just because we don't do the deliveries. But I do believe that there are programs around the country where 22q deletion has been picked up through the TREC assay. And those patients, I think, once that molecular diagnosis is made, have not been sent on to bone marrow transplant, of course, and some have been referred to thymic transplant, and many of them, I think, are just followed more expectantly. I'm not the right person to address that set of questions, though I'd be happy to refer you to the people who are handling those cases.
Thank you so much.
Thank you.
Thank you, ma'am. As you mentioned in one of the slides, the cost was too much, more than $1,000 million in 1918. It has come down. So with more and more options, we see in the future we'll be getting more and more gene findings, I guess. So that's it.
Absolutely right.
If there are no more questions, thank you for this wonderful discussion. Thank you.
Thank you so much. Big round of applause for Dr. Stephen Holland for that fantastic session and presentation. And thank you so much for taking time out and spending time with us on this Sunday. So we're down to our very last virtual session, and I'd like to introduce our next speaker and our final speaker for CUSP. But before that, right after the virtual session, we do have some really fantastic entertainment for you, so please make sure that you stick around. Dr. Joseph Carcillo, he's the professor of critical care medicine and pediatrics, the University of Pittsburgh from USA. And he studies sepsis and multiple organ dysfunction. He has authored over 340 PubMed manuscripts in this regard. He's also a founding member of the ACCM Task Force Guidelines for Hemodynamic Support in Neonatal and Pediatric Septic Shock, the Surviving Sepsis Campaign, the SCCM-ESICM Pediatric Multiple Organ System Dysfunction Syndrome Definitions Task Force, and the SCCM-EISCM Pediatric Sepsis Definition Task Force. He's presently funded by the NIGMS to study pediatric sepsis phenotypes and the NICHD to study the role of GM, CSF, and anakinra study in these phenotypes in the PRECISE trial. So let's put our hands together and welcome Dr. Joseph Carcillo. He'll be speaking about sepsis and MODS. Where are we now?
Thank you very much. Can you hear me? Can you hear me? No?
Yes, we can. Yes, we can.
Okay, good. Now, unfortunately, my slide, for some reason, I'm having trouble getting it up to be the large size. Do you have my talk? Let me see if I can stop share and do this again. Maybe I can bring it up by doing it this way.
Hello.
Hello, can you hear me?
Yes, doctor. Doctor, you just have to go to slideshow.
Yeah,
mode.
I'm trying to get my talk so that it is large screen rather than the small for you. Do you have an idea why I can't?
Dr. Carcillo, we'll share the slides from here. We can share the slides for you.
You can? Okay, that would be great. And then you can put it in the presentation mode, because mine right now are 6 across. Do you have my slides?
Yes, we do. We are just sharing it. A moment, please.
Okay, so I'm gonna stop share then. Okay.
Sure.
Okay, and can you bring them up so I can see them?
We're just getting the PPT up, Dr. Carcillo. Just 2 minutes.
Okay.
Is it
visible? There it is. Very good. Yes, please. Okay. Next slide, please. Okay, so when we think about multiple organ dysfunction in children, we have a kind of thought process of a one size for all multiple organ dysfunction. We remove the infectionitis, control hyperglycemia, prevent lung trauma with protective ventilation. We titrate our drug dosing. If a child has a lymphoproliferative disorder, we treat that. If there's immune deficiencies, as Dr. Holland pointed out, we treat those. If there are coagulation disorders, we treat those. We keep fluid overload to less than 10% and reverse shock daily. Next slide, please. But the real question for us today and where we are today is we're thinking about can we target inflammation in multiple organ dysfunction. In this paper by Dr. Horvat in our institution, we looked at the ferritin cutoff levels and the C-reactive C-reactive protein cutoff levels associated with mortality. And we found that children in the hospital who had a C-reactive protein over 7.3 milligrams per deciliter or a ferritin greater than 373 nanograms per ml in yellow had a higher mortality of close to 6%, 6 to 7% compared to children who had neither C-reactive protein nor ferritin above these levels, who had 0% mortality. And you'll notice on their PLOD score, which is a measure of multiple organ dysfunction, that they had more multiple organ dysfunction than did patients who did not have elevated CRPs and ferritins. And when both were elevated, you can see a remarkable increase in mortality risk to 24% and a PLOD score to 15 compared to no mortality if CRP and ferritin were less than that, and a PLOD score of only 6. Next slide, please. We now are thinking about several phenotypes of inflammation that can be driving this. And they're driven by both environmental factors and also genetic factors, as Dr. Holland pointed out. First is immune paralysis. These are children who have persistent infection or infection that they can't get rid of. In general terms, they usually have a lymphocyte count less than 1,000. 2 times in the first week. You can do more sophisticated tests like monocyte HLA-DR expression and whole blood ex vivo TNF response. In the lower left corner are those who have thrombotic microangiopathies or thrombocytopenia-associated multiple organ failure. These patients will present with acute kidney injury, new onset, as well as thrombocytopenia and an elevated lactate dehydrogenase. They can be related to 2 hits, liver failure, multiple mutations in ADAM signaling or inhibitory complement. And then the sequential multiple organ failure is for lymphoproliferative disease patients. This can be brought on by patients on immune suppression who get Epstein-Barr virus or multiple genetic disorders. And then all of these are interacting with the development of macrophage activation syndrome, which can be defined by hyperferritinemia, hepatobiliary dysfunction, and DIC, and uncontrolled inflammation related to hemolysis, frequent blood transfusions, or multiple mutations in signaling. Next slide, please. In terms of how many of these patients and what their makeup is, when we look in the United States in our PICUs, 100 out of 400 severe sepsis patients have one or more of these inflammation phenotypes, and they can overlap. 81% have a single phenotype, 16% have 2 of the phenotypes, and 3% have 3. Next slide, please. There we go. Now, the relative risk of developing macrophage activation syndrome is much higher if you have immune paralysis or thrombotic microangiopathy, thrombocytopenia-associated multiple organ failure, or sequential multiple organ failure compared to multiple organ failures. You can see going up to 7-fold, 14-fold, and 38-fold. Next slide, please. Risk of mortality is also much higher. The risk of mortality goes up 2-fold compared to multiple organ failure without immune paralysis, and then over 4-fold for multiple organ failure with TMOF, thrombocytopenia-associated multiple organ failure, or sequential liver failure-associated multiple organ failure. Next slide, please. So let's go a little more in depth. Immune paralysis provides the patients who are presenting with persistent or nosocomial infection-related MODs. You can recognize them at the bedside by an absolute lymphocyte count less than 1,000 2 times in the first 5 days, an absolute neutrophil count less than 500 that will not go away. Or if you do fancier tests, you can measure HLA-DR expression less than 30% or less than 8,000 per cell for greater than 3 days, or a whole blood ex vivo TNF response to endotoxin less than 200 for greater than 3 days. This can be related to immune suppressant agents such as dexamethasone or radiation. Next slide, please. When you measure immune insufficiency this well, you can see that nearly 100% of MODS patients who have 3 organ failure will have immune insufficiency. In red are the ones who persist with multiple organ failure in 3 days. In yellow are the ones who persist with multiple organ failure in 3 days. And in green are the ones who do not. So children with 2 or less organs failing, 40% of them have immune insufficiency. But children with 3 or more, all of them have immune insufficiency and immune paralysis. Next slide, please. Superinfection occurs in 100% of children who have 3 or more organ failures for more than 3 days. Next slide, please. In this study, Richard Hotchkiss gave rodents either frozen splenocytes or irradiated splenocytes. The irradiated splenocytes have apoptosis, the frozen have necrosis, and when he then injected them into rats, he found protection against sepsis if you had frozen splenocytes, but he found sensitization to sepsis if you had apoptotic splenocytes. Next slide, please. And he did an ELISpot test where red represents the ability of the cells in the blood to make interferon. And what you see here is that the sham cecal ligation perforation animals on the left made interferon. When you stimulated their blood cells with endotoxin, you can see in the center panel that the ones that were pre-treated with apoptotic cells did not make interferon. And then you see the ones given necrotic cells make tons of interferon. And so the production of interferon is protective in sepsis. And if you expose patients to radiation or chemotherapy or prevent them from making interferon gamma, they are at higher risk of mortality. Next slide, please. When we look at our patients, these are children. We found in the upper panel on the left that the children who have prolonged lymphopenia less than 1,000 for 14 days have normal neutrophil counts, and they have a high risk of developing multiple organ failure and death, whereas the patients without prolonged lymphopenia do not. And when you look at the actual histology on the right, you can see in the 2 upper panels that those without multiple organ failure have no Herc staining, very little apoptosis, if any, in their lymph nodes. But on the right, you can see a lot of apoptotic bodies in the patients who develop multiple organ failure and lymphopenia, mimicking the model of Hotchkiss. And below, you can see on the left set of panels, a very good lymph node follicle, a nice spleen follicle, and on the right, and a nice thymus follicle, and on the right, you can see that the follicles are completely ablated in patients who die with lymphopenic sepsis. Next slide, please. This can actually be recovered with granulocyte macrophage colony stimulating factor, and there are now studies going on looking at IL-7 and other lymphocyte check inhibitors. When you look in panel A, when you look at patients who have monocyte deactivation, measured both by a low ex vivo TNF response less than 200 and a monocyte less than 30%, you can see the dark filled-in circles are the ones who go on to develop nosocomial infection. And when you look at the panel below, the lower panel of A, you can see they also are prominently the ones who die. In panel B, we did a randomized trial in this paper and showed that treatment with GM-CSF recovers the ex vivo TNF response of these patients from their blood compared to placebo. Rather, placebo, it takes till 10 days, and with this treatment of GM-CSF, it takes 7 days, and it ablates or prevents nosocomial infection. Next slide, please. This protocol study, this was an informed consent protocol study. If you had a neutrophil count less than 1,000, and an absolute lymphocyte count less than 1,000, or monocyte deactivation greater than 3 days. The protocol was to give G-CSF for neutropenia, the prophylax for PJP and fungus if you had low or lymphopenia, and then treat with GM-CSF or if you were on cyclosporin or FK506 to hold or taper these drugs if your monocyte was deactivated. And if there was no deactivation, then to treat with steroids, methylprednisone, if your IL-6 levels were high. So if you had hyperinflammation without immune depression. Next slide, please. Amongst the patients who received the immune phenotype-directed therapy, which was 36 out of the 50, we saw a marked improvement. The risk for death was 13-fold higher in those who did not receive the immune phenotype algorithm compared to those who did. And the risk for secondary infection was 24-fold higher. Next slide, please. So the diagnostic tests and treatments to consider in children with immune paralysis, persistent nosocomial infection, is to look at neutrophil, NK cell lymphocyte numbers, gamma globulin levels, neutrophil, NK cell lymphocyte function, stop dexamethasone, give G-CSF for neutropenia, give low-dose GM-CSF if it's not myeloid leukemia. And then there are studies looking at IL-7 for lymphopenia, if not lymphocytic leukemia, and there are viral antigen-specific T cells or NK cells that are given for specific viruses. And you can also consider a white blood cell or NK cell infusions. Next slide, please. The thrombotic microangiopathy phenotype can be picked up as thrombocytopenias associated with multiple organ failure. This is new onset thrombocytopenia, thought to be due to thrombotic consumption. These patients have an elevated lactate dehydrogenase, renal dysfunction, plus or minus schistocytes. Their Adams-13 levels less than 50% of control. And they also can have elevated complement activation, which can be measured by C3 or C5 complement activation or by SC5b9. It's thought to be related to autoantibodies, circulating inhibitors such as free hemoglobin and cytokines for Adams-13, and then for the atypical HUS pathogenic variants, it's thought to be related to genetics in the complement cascade. Next slide, please. The baboon model on the left shows us nicely that if you ablate Adams-13, which used to be called the von Willebrand factor cleaving protease, you can see platelet and fibrin thrombi, and particularly von Willebrand fragment multimer thrombi. And this has been also shown in human studies of patients with TTP. Next slide, please. You can also get this syndrome in genetically normal pigs by giving them first hemorrhage and then giving them sepsis. So a two-hit hypothesis can also stimulate the release of ultra-large von Willebrand fragment multimers from the endothelium, and a consumption of the Adams-13 or von Willebrand factor cleaving protease, giving you deposition of fibrin and von Willebrand fragment multimer and platelets. And you see this in the lung, you see this in the kidney in this particular picture, and we'll show you in the next picture where you see it also in the brain. Next, please. So this is a study in children. We looked at children who were lymphopenic. We looked at children who were thrombocytopenic compared to those who weren't. And we noticed that if you didn't recover from thrombocytopenia after 7 days, you died with multiple organ failure. And if you recovered your thrombocytopenia after 7 days, you didn't. When we looked at the histology of the children who died, if you look at panel 1, 2, and 3, this is H&E staining of the brain, kidney, and lung, and it looks normal. But if you stain for von Willebrand fragment multimer, you can see occlusion of the microvasculature in the brain in number 4, the glomerulus in number 5, and the pulmonary arterioles in number 6. Next slide, please. These patients who had this picture were then randomized to a study of plasma exchange. And in the ones who did not receive a plasma exchange, you can see in the open circles that their PLOD score or multiple organ failure progressed over time, whereas the ones who received plasma exchange, their PLOD score or multiple organ failure improved. And part of the mechanism, although there are many mechanisms, but part of the mechanism in panel B is you can see that the patients who receive plasma exchange have an increase in their ADAMS13 activity as plasma exchange removes the inhibitors and autoantibodies against von Willebrand factor cleaving protease and restores them, allowing the patient to break down their platelet von Willebrand fragment multiple thrombi. Whereas in the open circles, this is not done. The ADAMS13 levels remain low, and the patients progress to thrombotic microangiopathy. Next slide, please. There have been two propensity trials now, one in Turkey and one in the US. In this thrombocytopenia-associated multiple organ failure network, the Turkish investigators showed a reduction in PLOD score over time if you received plasma exchange versus did not. If you next, please. And in propensity analysis, it was associated with significant reduction in mortality or improvement in survival. Next slide, please. And in the American or US study, similar results were found. If you did plasma exchange here determined as TPE in dark circles, you can see that the change in multiple organ dysfunction was significantly over time with a change of -10, compared to if you didn't do TPE, then patients with thrombocytopenia-associated multiple organ failure did not change their MODS over time. Next slide, please. And again, in propensity analysis, you saw approximately a 40% reduction in mortality with the use of plasma exchange, 40 to 50% improvement in mortality with plasma exchange. Although baseline MODS was still also a predictor, plasma exchange remained independently associated with a twofold reduction in mortality. Next slide, please. So the diagnostic tests to consider in patients with thrombotic microangiopathy are TMOF or lactate dehydrogenase, serum creatinine, urine output, ADAMS13 activity, soluble C5b9 activity, C3 activity, C5a activity, genetic evaluation for atypical HUS predilection, early withdrawal of calcineurin inhibitors, individualized use of early plasma exchange of ADAMS13 activities less than 57% of control, rituximab if unsuccessful in reversing dialysis dependence, an individualization of use of eculizumab if complement mutation or antibody to complement is present, and also consideration of defibrotide. Next slide, please. The third phenotype is the viral lymphoproliferative disease-associated sequential liver multiple organ failure leading to macrophage activation. These patients present with respiratory failure and then progress to hepatorenal failure. With viral lymphoproliferative disease, they have an increased ALT, creatinine, and a high soluble fast level over 200. Next slide, please. You can see when we look at our autopsies out of a study of 117 children in our hospital, and then we rank them in the order of their soluble fast and fast ligand levels. You can see the patients with the highest soluble fast ligand levels, over 500, all have massive destruction, necrosis of the liver associated with lymphoproliferation, and in one case, histiocytosis. If you place soluble fast ligand in a dish with living hepatocytes, it will destroy them. You then see that the next three with soluble fast ligand levels over 200, they showed lymphoproliferative disease without necrotic tissue in the liver. And then you see the remaining 5 deaths we had in this cohort with soluble fast ligand levels less than 200 had no necrosis or lymphoproliferative disease. In panel B, you can see infiltration of lymphocytes with fast-mediated apoptosis of the liver. In the next set of panels, B and C, you can see a patient with histiocytosis-related lymphohistiocytosis, And then the final one, you can see a patient with hepatitis, again, with fast mediated death. Next slide, please. Macrophage activation syndrome occurs from any of these pathways and can also occur on its own. It is recognized as combined hepatobiliary dysfunction and disseminated intravascular coagulation. And on bone marrow biopsy or on liver biopsy, you will see hemophagocytic histiocytes or hyperplastic histiocytes. You have an increased ALT and bilirubin, increased INR and decreased platelets, and increased ferritin, more than 500 nanograms per ml. Next slide, please. In this animal study, the Metcalfe health model shows that this can be mimicked by in rodents by first giving a viral antigen, alive or dead, and then a bacterial antigen, live or dead. This will cause hyperferritinemia, hyperlipidemia, cytopenia, and hemophagocytosis. But if you give a bacterial then viral antigen, or a bacterial then bacterial antigen, or viral, this does not occur. So this macrophage activation syndrome that we see in sepsis, separate from genetics, can be simply related to a viral challenge followed by a bacterial challenge. Next slide, please. It's shown in children that this can also be related to DNA viremia, reactivation of DNA viruses. In these children, when you take children with sepsis and you provide them with ferritin levels less than 500, 500 to 999, 1,000 to 3,000, 3,000 to 10,000, over 10,000, you can see a progressive increase in the number of circulating DNA viruses. Next slide, please. In treatment with IVIG, methylprednisone and plasma exchange can restore platelet counts and reduce ferritin in these patients and save their lives as well, compared to HLH protocols, which only attain 50% survival. And that's because IVIG, methylprednisone, and plasma exchange are less immune suppressive than using HLH protocols of etoposide and cyclosporin and dexamethasone. Next slide, please. In hyperferritinemic sepsis, it's driven by the inflammasome, both hemoglobin, free hemoglobin, viral DNA, stimulates TLR9, and that stimulates the NF-kappa beta pathway. The free hemoglobin stimulates the iron responsive element. Both increase ferritin. Ferritin itself can induce pro-inflammation and an anti-inflammatory state. So you have hyperinflammation, but also the ability to kill infection. Hello? Good call. I'm giving a talk in India right now. Can I call you in like 20 minutes? Sounds good. Sounds good. Thank you. Bye. Sorry, guys. So the cannot fight the infection. Next slide, please. Now we can treat this condition with a drug called anakinra to turn off inflammation. In this adult trial, we see that if your ferritin level is greater than 2,000, your mortality rates are higher than if it's less than 2,000. Next slide, please. And here you can see that if you treat this group of patients who have ferritin levels over 2,000 with anakinra, you can improve survival to the same level as patients who don't have hyperferritinemia. Next slide, please. So how does this work in practice? This is showing you two patients, one patient who presented with MODS and hyperferritinemia, and we treated the child with anakinra, and you can see the ferritin levels come down. Then we stop the anakinra, the ferritin levels go up. Then we restart the anakinra, the ferritin levels go down. This kid actually was referred to Dr. Holland, interestingly, and he performed genetic tests and took care of her for at least a year after this process. In the lower panel, you see a patient who has adenovirus. This patient was very sick on ECMO. For the adenovirus, we treated with cidofovir, and for the hyperferritinemia, be treated with anakinra. You can see that the hyperferritinemia had a minimal response until we added cidofovir to kill the virus. Then the ferritin levels came down dramatically. The child had a perforation of her heart on ECMO and then received large blood transfusion for that. And that kicks the ferritin up again. And then when the ferritin went up, we used plasma exchange and gave IVIG and it came down again, continuing with cidofovir. And both of these children are doing well today. Next slide, please. The diagnostic test for hyperferritic sepsis and MAS includes sequential ferritin and CRP levels, iron transfer and saturation, ALT and AST, MRI scan for iron overload or T2 image, DNA virus, PCR, invasive fungus, mannans, and beta-glucan tests. Consider chelation if your transfer and saturation is over 45%. If you meet 5 out of 8 criteria and hemophagocytosis, treating according to NK cell count and cytolytic activity. Next slide, please. Here, what you see in the top left corner is if your MODS and your presentation of 5 of 8 criteria is related to sepsis, you treat that with IVIG, plasma exchange, and methylprednisone. You do that because you have lymphopenia, so you have a low NK cell number, a low CD8 cell number, which are preventing the turning off of inflammation and the killing of viruses. So you have to remove the sources of lymphopenia. But when the lymphopenia recovers, then the patient's 5 of 8 criteria where macrophage activation syndrome will go away. When you move to the right panel, at the top, you see the non-malignant proliferative disorders. These are patients who have genetic defects where no matter what, their NK cells and CTL cells will not work. They have genetic defects in perforin and granzyme, and they get lymphoproliferative disease. These patients require chemotherapy to kill the activated CD8 cells, regardless of their condition, and ultimately will need a transplant. These patients fit the criteria for the hemophagocytic lymphocytosis syndrome. When you go to the lower right panel for malignant proliferative disorders, these patients have, doesn't matter how good their NK cell or CTL cell activity is, they just have malignant CD8 cells, lymphocytes. They could be B lymphocytes or they could be T lymphocytes. If they're B lymphocytes, they're treated with rituximab, Cytoxan. If they're T lymphocytes, usually with a different set of drugs, including etoposide, but basically chemotherapy. When you go to the left lower corner of macrophage activation syndrome, these patients have rashes, arthritis, and autoimmune disease of drug exposure. These are rheumatologic patients. They have normal numbers of NK cells and CD8 cells, but they have reduced activity. So not absent activity as they do with primary HLH, but reduced activity. And these patients respond to basically the same therapy as sepsis, anakinra, plasma exchange, and methylprednisone. Next slide, please. So when you look at this process, then we have different therapies for the different processes. For the immune paralysis, to overcome the lymphoid depletion and apoptosis, we use GM-CSF. Clinical trials are now in place to use IL-7. For the TAMOF and the thrombotic microangiopathies, we use plasma exchange. And then if it's Adams-13 related to monoclonal antibodies, for the long term, they might treat them with rituximab. If it's complement related for the long term to get them off of dialysis, they might use eculizumab. And there's now a new complement inhibitor that doesn't approach the terminal complement, but the mannose binding lectin complement, which is kind of exciting because eculizumab can cause secondary sepsis, whereas this one does not. If it's sequential multiple organ failure, really these patients fall more into the primary HLH group or the post-transplant lymphoproliferative disease group, and they're generally treated with rituximab for B-cell activity or chemotherapy for T-cell activity. And then the macrophage activation therapies, we include methylprednisone, IVIG, and plasma exchange. And if that doesn't work, then people use other anti-cytokine therapies, including anakinra, tocilizumab, and ruxolitinib, and other sorts of things. Next slide, please. So in conclusion, when you look at sepsis, you should reverse shock, remove infectionitis, control hyperglycemia, prevent lung trauma, titrate drug dosing, reverse lymphoproliferative disorders, reverse immune deficiency, reverse coagulation disorders, keep fluid overload less than 10%. Next slide, please. You want to reduce inflammation, whatever you're doing in your therapy, you want to see that your high CRP and ferritin levels are being reduced to low levels, to CRPs less than 4 and ferritin less than 500. Next slide, please. And here is the general picture for you to look at while we're open for questions. You can take a peek at this for a few minutes, but I'll just run you through it again. TMOF, low platelet count, AKI, high LDH, considered daily plasma exchange, eculizumab, immune paralysis, neutropenia, lymphopenia, anergic, hold immune suppression, give low dose GM-CSF. We didn't talk about leukocytosis and pertussis, but for that we used leukapheresis. And then for the lymphoproliferative liver, then respiratory then liver disease, for PTLD, you can give rituximab, hold immune suppression. For viral without lymphoproliferation, you can use interferon alpha, IVIG, Medrol. For primary HLH, your HLH protocol. And then for macrophage activation syndrome with high ferritin, hepatobiliary dysfunction, and DIC, plasma exchange, methylpred, IVIG, and anakinra. Next slide, please. Thank you for the opportunity to speak with you today.
Thank you, Dr. Joseph Cicillo, for wonderful presentation and also highlighting especially the immunological and immunotherapy, especially related to the macrophage activation syndrome associated with multi-organ failure and also secondary HLH and other immunology related things. I think it is a next level of research activity you have done, I think. It's a wonderful presentation. Can we take any questions from the audience?
Well, enjoy your party.
So we have been following your research for quite some while, and you have been clear about the phenotypes that you are saying. The issue is, like, in resource limited setting, we might not be able to exactly identify what is the phenotype using laboratory diagnosis. The HLA-DR expression, the interleukin levels, they are not available everywhere. So as you said, if you're suspecting this particular disorder, you use this, that's fine. What I was wondering is, we see a lot of dengue, which is going into hyperferrinemic sepsis and MODS. So we do follow the same protocol. We do see whether there is an evidence of microangiopathy, then we do plasma exchange. If there is any role of IVIG, Solu-Medrol, we give these things. But what I was wondering is the chelation therapy that you mentioned in hyperfertinemia. So most of our dengue patients, sometimes when they are so sick, we give PRBC transfusion just for the bleed. And you had mentioned that you will check the serum iron levels, you will check the transferrin saturation, and then you decide on chelation therapy. Has it been useful in your cohort?
That's a wonderful question. That applies, the chelation therapy does not apply to acutely bleeding patients who are giving blood to. So as you know, when you take care of your dengue patients, it's a self-limited disease. It applies more to the children who are getting chronic blood transfusions for chronic hemolytic diseases or for chronic bone marrow failure. Those children can be coming to you with hemochromatosis related to iron overload. So I would not do chelation for dengue. For dengue, it's very interesting. It's the dengue patients will routinely have high ferritin levels and do fine, and that's because the ferritin is being triggered through the iron responsive element through the hemolysis. But if you look at it, the ones who don't do well with dengue are the ones who have very high C-reactive proteins and high ferritins. So if you have a high C-reactive in protein and ferritin, that's telling you that you have a high ferritin from hemolysis, but now also from inflammation. That's macrophage activation syndrome. And in those patients, absent a study, I would treat them as though they have macrophage activation syndrome. So if you just have a high ferritin without a very high CRP in a dengue patient, I would treat them like you do anybody. But if you have a high C-reactive protein, I would consider adding steroids to the picture to try to reduce the inflammation. But I would not do any chelation therapy for dengue.
Dr. Carcillo, that was a wonderful session, and you have tried to put everything, simplify everything in a very short time in such a complicated subject. I have just one question before we let you off, and that is, how different is immune response, immune paralysis in neonates as compared to children? And do we know
Yeah, that's
enough?
wonderful.
Do we know enough about it still?
Yeah, it's a wonderful question. So the therapies in the neonate that are very exciting to me and would be exciting to me for India as well would be pentoxifylline. Do you have that? Do you have pentoxifylline in India? Pentoxifylline. It's used for...
Yeah. Yes.
So to me, pentoxifylline is really, for the neonate, the best approach. Because pentoxifylline will turn off the TNF response, but have no immune depression effects. There's a Cochrane analysis, and there's been multiple studies done, and all the studies have been done, none have shown harm. All have shown benefit. The argument is whether or not it's a mortality benefit or not. So to me, I think pentoxifylline is the right medication to use. Now, as far as the GM-CSF is concerned, in the trials in newborns, where the placebo group recovered their neutrophil count, GM-CSF was not helpful. But in the trials in newborns where the placebo group did not recover their neutrophil count, GM-CSF was helpful. So the trick is figuring out which neonates to consider. And if you have neonates who continue to be lymphopenic in the first 7 days, those patients are the ones that should probably be entered into clinical trials to see if the new drugs like IL-7 will help them or GM-CSF will help them. If you chose to do it on your own, it's okay. I don't think there's been no harm associated with GM-CSF in those neonatal trials. Just some show benefits, some don't. But in all cases, I would use pentoxifylline for any newborn with MODS and sepsis. And then the other thing about newborns is you have gestational alloimmunization of liver disease or GALD, which used to be called neonatal hemochromatosis. So based on that, any patient who has severe neonatal hemochromatosis, you would do a whole blood exchange or a plasma exchange if they could tolerate it. But in general, they don't tolerate because there's so little. So you wind up giving them IVIG to block the antibody against the maternal antibodies against the liver that are leading to the destruction of the liver and the hyperperitonemia. Does that answer your question?
Sort of, yes.
Well, ask it again. Maybe I didn't answer it correctly.
All right. Big thank you to Dr. Joseph Carcillo. Let's give him a big round of applause. Thank you for that excellent presentation and taking time out on a Sunday. Thank you.
Enjoy your party.
All right. I now request Dr. Arvind Shenoy to kindly come up on stage and felicitate our chairpersons. Please do.
Slowly walking up.
That was not too slow, though.
Sorry, I just wanted to make a kind of comment to congratulate the Rainbow team for the CUSP, and hopefully, as they plan, we will continue to have more CUSPs. But the more important comment was, I'm just using that clinical case scenario which was discussed. I think clinical is still important. For example, in that baby, there was a hemoglobin of 7.7, which is an outlier. Obviously, this was not a simple infection that we were dealing with. But I think the way forward seems to be inflammation and genetics. So if anybody wants to specialize, go ahead with genetics. But at the same time, I think it's we are still in the very early stage as far as genetics is concerned. There are very few people who know how to interpret it. So I don't think we should be doing it unnecessarily. We should ask the specialists and decide when to do it, and we should ask the specialists to decide how to interpret it rather than scaring our people.
While they quickly snap up pictures, requesting you all to kindly take the seats in the front. Yeah, we have come to the end of CUSP. Of course, we've got entertainment. So request all of you to kindly come up a little up in the front and take the seats. Thank you. I would now like to call upon Dr. Shetty, Rakshay Shetty, to kindly give away the prizes to our quiz winners. We had Dr. Kishore, who actually won the first prize. He's already collected it. So congratulations to you. Next up, Dr. Jana. Next, Dr. Vaishnavi. Congratulations. And our surprise winner, Dr. Arvind Shenoy. Congratulations. Okay, we're not going to bite, so once again, I'm asking you to kindly take the seats in the front. It's going to be an amazing piece of entertainment that we have for you that's following up. And I'm going to hand it over to Dr. Rakshay Shetty for the vote of thanks.
All right, so good evening, everyone. So we are at the fag end of CUSP. I think I'll take an opportunity to thank everyone who were instrumental in making this successful. I think at the first thankfulness should go to all the audience. It's almost 8 o'clock and still quite a few of you are staying and attended the event till the end. And it's the audience which makes this conference successful. Thank you very much for coming and spending the entire Sunday with us. I would also thank our Honorable CM, Sri Bomaiji, and our Honorable Health Minister for coming today for the inauguration. And I would also thank all the faculty members again sparing the entire Sunday and spending with us and sharing their valuable knowledge. And this conference is essentially because of effort of Dr. Ramesh Kancharla, our chairman, and its constant encouragement made this conference possible. So a huge round of applause for him. I would thank Dr. Arvind Shenoy and Dr. Dinesh Chirla for being organizing chairperson and motivating us enough to ensure that the quality of the conference goes on well. So many thanks for you, sir. I would also thank Dr. Prakash Vemgal for being with me as an organizing secretary to ensure that this conference went smoothly. So thank you so much. And a special round of applause should go to Dr. Vasudha and Dr. Chandrika Bhatt for putting an enormous amount of effort in running the show. It's essentially their hard work in terms of getting a scientific program, communicating, and ensuring that everything was done. And should feel proud at the success of this conference. So at the end, I would also thank Dr. Babu, Dr. Sandeep, Dr. Rashmi Adiga, Dr. Deepak, and Dr. Pavitra for ensuring that the workshops went very smoothly. And in fact, the workshops were very well attended and very well appreciated. Thank you so much for all the hard work in ensuring that this workshop went well. So Mr. Nityanand has been a huge source of support during this event. And it's all because of his hard work. A lot of those things were well placed and we didn't have any hiccups. Ensured that the whole event very well. Thank you so much. And I also thank Mr. Sandeep for his support. And at the last, I think Mr. Faraz, Mr. Karthik should take a great, I think they deserve a great applause because they ensured that this whole event went very seamlessly. and went through the minutest details. A lot of attention was given to the details and made sure not only the conference, the entire experience of the conference also went very well. So I would also thank Mr. Faizan and Mr. Pradeep for all their effort in ensuring this is done. So we are ending the academic activity, so I would request all of you to stay. We are going to have some amount of cultural activity, so there's going to be a nice sand art, and there's going to be stand-up comedy. We're going to serve food too, and I hope you all have a great evening. Thank you so much.
Thank you so much, Dr. Rakshesh Shetty. And of course, now it's time for us to let loose, let our hair go wild, and it's time for some amazing entertainment. Of course, we're done with the serious part. And I'd like to extend a big, big thanks to Dr. Rakshesh Shetty for giving me the opportunity to host CUSP for the second time, and it's been an absolute pleasure and honor. And thank you so much for that. Yes.
Can I just thank Dr. Rakshesh?
Yes, please.
I think the person who needs to be thanked the most is Rakshay, our own Dr. Rakshesh Shetty. I think he deserves a standing ovation.
Much needed, much needed. Thank you for that. Yes, and your entire team, it's been an absolute pleasure to collaborate with your team, and I can just say keep shining and keep going. So thank you so much, Rainbow Children's Hospital. Good job. So I would like to introduce, of course, our very first piece of entertainment. And he's a doctor. In fact, it was really funny because he approached me right when we were going to finish our final session. And I really thought that he has a session going on. I'm like, which session is this? But he's like, no, no, I'm the one who's going to be entertaining. So I'd like to hand over the mic to Dr. Jagdish Chaturvedi. He's a stand-up comedian. He's an ENT surgeon, author, and medical device innovator. And he's performed for numerous corporate companies in top hospitals across India, and also featured in TEDx Talks, Ink Talks, Canvas Laugh Club, and many more. So let's put our hands together and welcome this doctor, Dr. Jagdish. All yours.
Thank you very much. Thank you. Please give a big round of applause over here for your lovely hostess over here. All right, guys, I know your bar count is about to open and you're all very tired. I'm also very interested about when the spirits will call me. But before that, I just wanted to check, are you guys in a mood for a short set of stand-up comedy? But this sounds like a seminar, you know, like a CME. How many of you have attended stand-up comedy before? Give me a cheer. Okay, some of you have attended. Okay, so no hand raising, okay? All right, so stand-up comedy is, you know, if you want to show the response, because I get feedback, so you either laugh, clap, or cheer, all right? Can we get that example, right? So all of you ready for stand-up comedy? Give me a loud cheer. Yes, wonderful. Thank you very much, guys. My name is Dr. Jagdish Chaturvedi. I'm an ENT surgeon and a sinus specialist. Those with allergy, give me an achhi. Oh, nice. Some laughing achis were there. Some good achis are there. I have got a portable ear, nose, throat device. I will just screen you after this. I got some patients today. But thank God I'm not a gastroenterologist, actually. Yeah, that joke takes some time to spread. Don't even think about gynecology. But don't get me wrong at all, okay? I know we are all of the same fraternity. I'm not being desperate for patients at all, actually. I'm at Fortis Hospital, Banagatta. How many people from Bangalore? Bangaloreans, give me a cheer. Oh, namaskar everyone, namaskar. I'm from Fortis Hospital. I have no shortage of patients. Somehow I'm blessed with a lot of patients. Like if you come any day, come to my OPD, you'll see a line of patients. But the problem is, you know, patients don't come to me for my ENT skills, my surgery. They don't come to me for that. They come to me for a totally different reason. You know what that reason is? My name, Dr. Jagdish Chaturvedi. Paidaishi Budau Name, you know. Old name. It reeks of seniority. It reeks of experience, you know. Like if you close your eyes and picture someone called Dr. Jagdish Chaturvedi, you will see the image of L.K. Advani. That's the kind, it's not a name that goes with this young, hot, good-looking guy, right? It's a joke, ladies. In joke, I can look funny. Yeah. Even when I was born, the nurse who was assisting my delivery, she was also confused. Lale, such a cute baby. What's his name? Jagdish Chaturvedi. Good afternoon, sir. Yes, sir. You know, like I've been called sir all my life, right? And, you know, patients, they think it's a very senior doctor, right? So they think, okay, we can pay 1,000 rupees, 1,500 rupees, you know, we'll get all the diagnosis, all that experience. They come with so much hope to look at some balding gray hair or something like that, right? And they come into my OPD chamber, they look at my baby face and they're like, Dr. Jagdish Chaturvedi. Like, I am Dr. Jagdish. They're like, sister, in Dr. Jagdish's room, what is Varun Gandhi doing? Or fat Imran Hashmi, or side view Himesh Reshamia. or somewhat Rohit Sharma, you know. Yeah, so popular faces, but not mine, you know. Yeah, that's a problem. You guys look like a fun audience. I'll just do a quick demographics, okay, as a doctor over here. All the youngsters over here, any youngsters, PGs under the age of 35, give me a loud cheer. Nice. That is the sound of denial. Yeah. Yeah, see, they don't know what's going to come next, right? Okay. I'll show you. Okay. All the mature people, senior, well-to-do people over the age of 35, give me a loud cheer. See, that's not exactly motivating them, okay? Let's do this again. All the senior people, come on, more established people, give me a loud cheer. Okay, this is the sound of reality. Okay, all married people, give me a cheer. That is the sound of pain. Characteristic pain. Oh! From there to there. Like, see, the problem is, see, I'm 38 years old, I'm married, I have 2 kids. For me, pain everywhere. Yeah, but I never thought at such a tender, young age, in my 30s, I will experience something called as a generation gap. You know, I thought when I'm 60, 70, I will not connect to the youngsters. I cannot have a normal conversation with these people who are screaming at the back. They're a few years younger to me. I can't have a normal, I don't know what words they use, what they mean, what they're trying to say. You heard the way these guys talk, you know, the moment you go to them, bro, what's up, bro? Hey, bro, what, bro, yo, bro, you know. Someone behind me, I'm like, who is it, bro, eyebrow? I'm like, what about your eyebrow? Illa macha, eyebrow, they're moving like this. And encouragement is a whole different level. I can never decipher their encouragement. See, I grew up in the 80s. If I do a stand-up show or a play, my age group people encourage with such elegance. Jagdish, do a good job. Macha, do a good job. Go. Enjoy. You know, our school also used to say, come out with flying colors, you know. So elegant, you know. At the most, they will say, break a leg. These youngsters, have you heard their encouragement? I did a college show 2 weeks ago. I'm going on stage, okay? All these college kids, they're encouraging me before going, no? If I'm going on stage, they're like, bro, kill it, bro. Destroy it, bro. Fire there, bro. Cheer there, bro. I'm like, what am I supposed to do there? Like, I forgot what I was supposed to do. That's encouragement for them. But I don't want to feel this old, guys. Like, I want to feel young. I want to feel like, you know, I'm still with the youngsters, right? So one day I did a surgery. My boss asked Jagdish, how was the case? I said, bro, killed it, bro. Destroy it, bro. Fire there, bro. Cheer there. Yes, he wanted to kill and destroy me after that. We can't be this cool in our medical fraternity, you know, like, I can't be doing a surgery, you know, relative is saying, "Hamare babuji pe surgery kiya, kaise kiya, bro? Khalas. Khatam, bhasm, rak." I can't do that, right? No, surgery is happening, relatives, nam chikkappa mele surgery madidra, engaittu, kittak bittidini, volak bittidini. Yeah, if I do that, patients will beat me. Yeah, that's why I'm doing comedy for security reasons. Yeah. This is a good fallback. Here you have a reason to beat me. But yeah, guys, don't you think, like, I noticed this, okay, see, especially post the pandemic, I've noticed people are just a little more angry nowadays. Don't you think? Little more tolerance has come down. Anything they're angry for, anything they're arguing for, anything they're taking personally. Pick any topic, andar ka arnab jag jata hai. There is one inside all of us, you know. Becomes alive, dimag ka kangana ho jata, you know. It happens, you know, just... Anything you say, there has been like, I don't know what you're saying. No, you take your words back. How take words back? First you said something, then take it back. You know, it's very, very confusing. And you know what's a new hobby nowadays? When people get angry, they go beat up doctors. Not a joke. It's like pop hopping. No, doctor maar ke aate hain. Chal, come here. Oh, new hospital there, macha, nice glass and all. Oh, hospitals stop made glass buildings nowadays. Concrete, you know, it's like that. And during the pandemic, a lot of doctors got assaulted, right? And I'm at Fortis, so I was thinking, like, you know, it will not happen to us. See, our brain protects us, you know, it tells us, hamare saath nahi hoga. It will not happen to us, right? Happens to some other people. But, you know, one day I got really scared because a senior doctor in my own hospital got assaulted. And I got terrified. Because they had come looking for Dr. Jagdish Chaturvedi. You know, they passed in front of me only. They thought this is a senior doctor, right? My parents got scared. He's like, don't go to work for a few days, man. Next time they won't make that mistake, right? And I started thinking, now what will I do? Next time if they come, they're going to know for sure, right? So what shall I do? I was coming up with techniques and tactics. You know, one day I came late to my OPD. 3-4 people very angry. Where's Dr. Jagdish? Why is he late always? I am standing right behind. Where's Dr. Jagdish? Where is he? You know what I did? I removed my steth and apron. Like, where's Dr. Jagdish? Kidhar? Where is he? Elli tara pauro. You know, he's never come. They're looking, you know, they've gone to the toilet, sir. He's a little old. No, sir, he's gone. Increased frequency micturition. You know, later on also, if they find out, they will have some empathy, right? He was looking for himself only. Papa, you know. Yeah, but that may not work all the time, right? And then, you know, I started doing some research because, see, that's what doctors do. If you find any clinical problem, you do research and you find out the solution. And actually, I started researching a lot about anger, how to diffuse anger. Any neurologists, pediatric neurologists here? Give me a cheer. Yeah. Yes, they're very nice. Yeah, see, not angry at all, you know. So I'll tell you, I actually looked through some scientific articles, and ma'am, you might want to validate this or give this as a thesis to some student. I found a very interesting thing. You know, when somebody is angry, and you were to suddenly confuse them, the anger goes away. Our human mind cannot process anger and confusion simultaneously. We can get angry about why we got confused in the past. Simultaneously, it does not happen. It's a very interesting feature of the mind, right? I was like, yeah, we should use research to save. That's scientific, right? One day again, you know, somebody got angry and, you know, 2-3 family relatives, they were not happy with the outcomes. They came into my, you know, chamber. They cornered me, 3-4 people. One was about to, you know, pick the chair and beat me, right? So angry he was. Suddenly I used this research. He's about to beat me. I'm like, Abbe, Deepak, tu? He's like, Deepak? Who's Deepak? Are you Deepak? Yeah, who's Deepak? Yarappa, Deepak? No, I'm not Deepak. Do I know you? Like, we are the same school. Which school, Ra? You know, anger, confusion. Diffused. And you may be right because 1 in 3 Indians is a Deepak. How many Deepaks say, give me a cheer? Bujh gaye. No. Bujh gaye. Not many are left, you know. But you know, see, I know 10 Deepaks, 4 are left. And, you know, but I've always felt, I'm not generalizing to all of the Deepaks. I know you all might have your own lives. But my Deepaks, that I know 10 of them, you know, I have seen that every Deepak is frustrated and sad and you know, heartbroken, you know, everywhere. I have not seen a happy Deepak. I have not seen a successful Deepak. In film industry, the most, okay, maybe in the medical world, but in the film industry, the most successful Deepak I've seen is Deepak Tijori. Or Deepak Kalal, you know. That's the kind of names, right? But always, you know, some of the other girl is making a Deepak jealous, you know, somewhere. Always have seen that, you know. And I'm thinking why they do that, and today I realize, okay, maybe tabhi to Deepak jalenge, you know. Yeah. Trying to look at your PJ levels. But okay, this is also not foolproof. Then I thought, okay, you know, maybe it's the way we present ourselves to the patients. You know, maybe it's the words we use. Why are they getting so agitated and angry, you know? I started analyzing the words we use, you know. Suppose like, I'll give you an example. Patient comes to me in the OPD chamber. Say, hey, doctor, you don't know the diagnosis? If I say, no, I don't know, he will get angry, right? But if he comes and say, doctor, you don't know the diagnosis also, say, I know, it's idiopathic. Oh, it's idiopathic? I have read about this, yeah, it's idiopathic. He does not know that idiopathic means not even I know, my father also doesn't know, you know. Nobody in the world knows what it is, right? So he says, hey, doctor, you did that surgical complication. If I say yes, they'll get very angry. Yeah, he's accepting it. But if he says, doctor, you did that surgical complication, I said, no, it's iatrogenic. Oh. Macha, itra, macha. Itra, you know, you can use the right words, you know, they won't get angry. But this is also not foolproof, right? And I never knew what the foolproof way is, like how to not get beaten up. But you know, see, I'm also an inventor. And one thing I've learned is when you're in the middle of the situation, your mind does wonders. It comes up with techniques and tricks you can never think of. I was about to go with this Deepak strategy, right? But one day, you know, it could be a very ugly situation. They were angry at the hospital and all of that. They barged into my OPD chamber, 5-6 people with lathis, you know, about to beat and did all of that. And suddenly my brain came up with an amazing technique. This technique, this is a true story, okay? I had a very close shave and I used this technique and it worked like a charm. And I can guarantee you, anybody in this country cannot get beaten up. Nobody can lay a finger on you if you use this patent protected technique that I came up with in the middle of that situation. You know, 7-8 people angry, shouting, screaming, coming, taken the lathi about to beat me. You know what I suddenly did? I stood up and sung the national anthem. Loudly. Because they suddenly stopped and they had to stand. Until help arrives. The help was also standing. Till I finished, you know. And in this whole process, if anybody moves and they are anti-nationals, and I will have a bigger reason to beat them. Yeah. Itna desh bachayega, you know. And this is not a joke, guys. There is a section 3 of the IPC. If somebody is reading out the national anthem and singing it, you cannot disturb or stop or insult the national anthem. It's a non-bailable offense. You can use that to your protection. So please learn the national anthem correctly. Because if you sing it wrong, you will get beaten up twice. Go to your nearest theater, they play it before every movie, learn it properly. And it has worked for me, by the way, you know. They not only stood, they were also confused. They were like, what is this? Double effect, you know, so it's good. But as I see, there are 4 reasons why I came, like I thought about why are we angry? There are 4 reasons. One of is, our upbringing, our childhood also, right? Our schooling. How many of you went to school? Give me a cheer. A few of you, I knew that. No problem. Okay, I went to school. How many of you are backbenchers? Backbenchers, give me a cheer. No, I knew pediatrics, never backbenchers will take. All frontbenchers take pediatrics. Few of you are there. Okay, good. You're keeping up our hope. I studied here in Bangalore, South Bangalore. I was a backbencher. At the 6th standard, I was the president of the Backbencher Association of Janagal. And I was known, like people used to talk about the tactics. Backbenchers, they have superior hearing, better vision, better core strength, all of that, right? And I used to be a very noisy, child, when the teacher used to teach, I used to make all sorts of sounds. Like, hey, who did that nonsense, fella? Who did that? What year it came? Chitrana. Give to me after the class, I say. This is kind of constantly making noise. Teachers teaching, I'm going on talking. Say, who's talking behind my back? Nonsense, fellow. Who's talking behind my back? And I would get up and say, madam, we are not talking behind your back. We are talking in front of your back. The back is in front of us. Why do you say talking behind my back? You should say, I don't like people talking in front of my back or behind my front. Technically, right? And she was the English teacher. So she gave me a compliment. She said, outstanding. So, I became an outstanding student. But teachers are vicious characters. No offense to teachers over here. But teachers never forget a problematic child, All the teachers got together. This kid in the 6th standard sounds like a professor creating problems. What do we do? How do we shut him up? And they're like, what? We'll embarrass this child publicly. Annual day function is coming. We'll give him the mic, make him the MC of the annual day function. He talks in front of 2,000 people. Think 10 times before talking in the class. You guys know what an MC is, right? It's masters of ceremony. Master of ceremony, somebody who invites the chief guests and all of that, right? And an annual day function, I had never taken the stage. They gave me a mic and they're like, you have to be the host for the night, you're the MC for the day. And I was supposed to invite an IAS officer and his wife, very angry looking. And I'm supposed to invite them on stage, but I was an outstanding student in English, so I had a doubt, but you guys look very educated, okay? Guys, what is the female of lion? Some of you know that, okay, very good. What is the female of tiger? Tigress, okay, more people know that. What is the female of Mr.? Hey, who did? And then everybody became Nagar House. Mistress, yaar heltra paile. I heard it. See, I am in 6th standard, I can make that mistake, okay? See, I was outstanding. Okay, but you guys are way beyond that. For people who don't know what mistress is, it is pati patni or wo ka wo. But I went by that same logic with lion, lioness, tiger, tiger. It's a true story, okay? Lion, lioness, tiger, tigers. Gives me great pleasure to announce on stage very important chief guest, Mr. Rangegowda and his mistress Rajalakshmi. In front of 1,000 people, Audience like MC Gali, they're like giving me awkward looks. And I didn't stop. They're like, yes, mistress. What do you want, mistress? What mistress? Everybody's upset, angry. I'm not understanding what I did wrong. I'm like, correct only, The elderly lady below the stage, shouting at the top of her voice and scolding me. She was the head mistress. Like, you are the head of mistresses. I'm giving you the same respect I give her. So why are you getting angry? Not able to understand, not able to comprehend. I just said that, I'm sorry ma'am, I won't do again. But rest of my emceeing was good. They're like, this guy has talent, he's able to talk, he's able to do all of that. So they, to encourage me, made me the MC the next year also, with the same chief guest. And I realized that last year I was actually correct. Because Mr. Rangegowda never came back with Rajalakshmi after that. Came back with Vijay Lakshmi. It's Vijay, Some of these things, they can scar you, they can scar your memories and all of that, right? And make you very angry, when you grow up. The other reason I think why we get so angry is, because what we all carry, right? We have the smartphone, right? This is one of the reasons why we're all so angry nowadays, right? How many of you have a smartphone? Give me a cheer. Everybody has, of course, and they're full of apps. Apps. Everything there is an app for. One day, I was thinking, what is there an app not for? And I found an app for that. It's called Apne App Dhoond Lo. It's a legit app, 2.5 stars on Google, You know what these apps do? They take away the emotions, They take away the emotions. They remove the emotions from it, right? Like, I'll give you an example. Like, they make us a little more heartless. Okay, how many of you love traveling in train? Train travelers, give me a cheer. Achhe din aayenge. It'll happen. Metro, na? Yeah. I used to love traveling the intercity train, And you know what I used to love? this is one guy, every time when you stop in a station, is selling idli, vada, dosa very passionately. There's always this guy, right? Chai, chai, garam, chai, idli, vada, dosa, sambar, bedam, pani varle. Such passion to sell. Voice modulation. So much fun it was. You can sell anything like that, it sounds very good, no? Hospital le, aspatre banne. Vaccine lagale, vaccine. Covishield. I see. Ventilator lele. CPAP. So a lot of things. Anything you say sounds interesting to people, right? They're like, oh, I want to buy that. What is that? Bhaiya kya hai? Saste mein do, Has that feel to it, And as a kid, I used to be so motivated with this guy. Like I used to call in the same time, like chai. I'm like, chai. People in the train are like, what is this jungle calls going on, right? But I never had the guts to tell my father, I want to be this. Because I know within 2 minutes, it'll be like, he'll be like, why? This is what I'm paying for your education, But today, the same thing, who is doing in a very proud way, in a very fashionable way as a unicorn? Swiggy, Zomato, Tarkare, Big Basket, Grofer, Daskatis, book my show. Walk a must item on your Tinder. Bumble, नहीं मुझे अभी मारो PUBG. नहीं आज कौन मरा? Who died? आरोग्य सेतु app. Who have you ever gone to your neighbor's house, auntie ji? Anybody died in your house today? No app you see, hey, macha, in our society 5 people died, ra. Hey, walk opposite direction. No, all sorts of things they're doing. They're removing the emotion, man. The 5 people have died in your phone. You look like one dot over there. Takes away, makes everything a data point. That's the whole reason why, we lose our human emotions. And we lose our contact details. Because these apps, software, your phone number, email address go. For the last 3 months, every day morning, 7 o'clock, I get up with an unknown number, girl from the other side. Very good morning, sir. Shobha calling from personal loan department. Do you want a loan? I'm like, Shobha, I want to be alone. I don't want a loan. Every day morning. I have tried everything. What all techniques I can do, I have tried. One thing that worked for some time is, suppose somebody calls from unknown number, sir, very good morning, sir, Shobha from personal. I'm like, Raju, dud sikta, Raju, dud sikta. 10 Rajus, they keep it. More than 10 Rajus, they're my patient for sensorineural hearing loss. Then I treat them. But that doesn't work in, it's too loud, right? I can't do that in front of a patient. Like a patient is sitting in front of me, I can't be like, one nimsha. Rajanan! Hey, a patient, very well. I can't do that. So I came up with quieter ways. Quieter way to do it is pick the call, disconnect it. Pick the call, disconnect it. Then money gets cut. But sometimes they call from toll-free numbers. But you are like, why do you pick the call? Just block it. No, it's an unknown number, block it. Why do you pick? But sometimes it could be patients. Sometimes it could be inquiries for shows like these. But guys, sometimes it makes for such interesting, adventurous conversations. 3 weeks ago, I'll tell you, middle of the day, lunchtime, I'm having lunch. I get a call from an unknown number. There's a girl on the other side. I pick the call. This is how she greets me. She's like, hello? You only. Me? Yeah, you. Like, who's this? First tell me, khana khaya. Like, yeah, I'm eating. Pani piya? I'm like, haan piya. Pyas bhuji. I'm like, hello? Who's this? Are you some high school, are you some friend of mine pulling a prank, or are you some high school crush? Give me a clue. You want a clue, naughty boy? I'm like, yeah. Are you You also got calls. You want a clue, naughty boy? I'm like, yeah. So, are you alone? I'm like, yes. Is anyone around you? I'm like, no. Are you ready? I'm like, yes. So, very good morning, sir. Shobha calling from personal loan department. I called you 3 days back. Like, Shobha, tu. You're about to give me clue. Like, sir, ye sab Shobha nahi deti. Buda ho kahinge, like that. Dimag ka kangana nahi hoga to kya hoga, This is what happens, right? Mind goes crazy, right? The third reason I think why we get so angry is because of this entity called friends, How many of your friends give me a cheer? Only these few. And they are not cheering, they're asking, who? Few people lifted their hand became like snake, But by this age, you realize there's nothing called friendship, Yeah, there's nothing called. There's like, for any other relationship, you have an Aadhaar card and a friend, anybody, anytime. The problem with friends is, they have the knack of giving you some very bad advice, but sounds intelligent. It'll be very bad advice, the worst thing to tell you, but it'll sound so intelligent that you do it. Like my own friend, knows me from childhood, we studied together, grew up together. He tells Jagdish, I've noticed one thing, your jokes are not connecting to youngsters. Say some young jokes. I'm like, what are young jokes? Talk about the things these youngsters do. What do they do? Talk about some dating platform. Oh, talk about Tinder, Bumble. Go on Tinder. I'm married, I have 2 kids. If I go on Tinder, I will actually need Tinder. He's like, no, man, you'll understand perspective, context, and all of that. I thought, okay, maybe he's trying to make me understand, maybe I'm not connecting to the youngsters, so I tried it. So I went and made a profile on Tinder. For people pretending not to know what it is, it's a dating app where you can be a leftist or a rightist. If your views match, you match, right? So I put a profile on Tinder. Within 5 minutes, I got a match. It's a joke. It can happen. Girl is like, what's a doctor doing on Tinder? I'm like, my doctor se pehle insaan hai. I can also explore life like everyone else. No, what kind of doctor are you? I said, ENT. Oh, ear, nose, throat, my favorite. When I take a bath, my ear gets blocked. So I said, what happens? Sometimes wax gets stuck inside the ear, and when water goes inside, the wax swells up. So you take Solivax eardrops, 3 drops in the morning, 3 drops in the night for 7 days, and then come back to me in the OPD for 1 week for syringing. Unmatched. 1,000 rupee consultation gone. Friend. That's why I don't believe this saying. Have you heard this saying which they tell you from childhood, a friend in need is a friend indeed? Do you know that's an incomplete saying? There is a very important line that comes. Nobody tells you that. You have to experience that in life. Today on this auspicious day, I'm telling you the full saying. A friend in need is a friend indeed, but you will be in that need because of that friend's deed. That is the whole saying of friend in need. I went to my friend, like, you get my 1,000 rupees out. Now only I want, okay. He's like, no, I'll get you 2,000. Like, how? There are other apps. Hey, it's like, another app is there. There are patients and doctors can connect to each other. Library, Practo, M-Fine, all of these. You'll get a patient there, man, you'll get 2,000 rupees. I'm like, okay. I created a profile there. I got a patient, her name was, Shweta. She wrote to me, doctor, I have an appointment with you at 7 o'clock. Can we postpone it to 7:30? I'm like, sure, Shweta, you're my only patient for the last 1 week. And if you say 7:30, we live in Bangalore, right? I will leave home accordingly at 1 o'clock. True story, She got so impressed with my answer, she gave me 3 kiss emojis. 2 that face and that heart smiley one, 4 hug emoji, emoji after emoji. I'm like, what did I write to her? Then I realized my over-smart phone auto-corrected Shweta to sweetheart. In consultation, dating is happening. Dating consultation is happening. Dimag ka kangana. Andar ka arnab. It's so confusing. These apps make your world, right? And the 4th reason, the most important reason why we get angry, especially as Bangaloreans, is traffic. Because I was born in Bangalore, raised in traffic. My mother tongue is pam, pam, pam. I was going to see patient Shweta before she puts a case on me. So I wanted to be on time, right? And I don't want to fight in road traffic accidents because, so it's, Bangalore, anyway, you don't have much speed to hit each other. At the most, hey, aste, You go, where to go? You can't go anywhere. You have to stand there and keep doing that, right? But there's just youngsters are there, right? Some of these youngsters, they have this car. No, I'm driving like a nice Indian citizen on the road, right? And suddenly this car comes from front, cuts in front of me, presses the brake suddenly. And I hit my car from behind. And suddenly people appear. Yenagata paile. Oh, viral reel agata macha. Million views agata kana. And even if you don't want to fight, you have performance pressure. They're judging you, Is he a man or not? They're judging you over there. But I don't want to fight, because a strange thing happens in, road traffic accidents. Have you seen the way people behave? There's a whole different etiquette in road traffic. Have you seen suddenly people become like, they leave their their advanced English language and go to rudimentary animal language, Have you seen the moment you're in road traffic accident, 2 accidents? Lie! Hey! Yeah! To that you can't say, yes sir, please tell me sir, how can I help you sir? No, it's not a language match, The reply will be, yeah! Why you came? Why? That's what happens. Another neurologist, ma'am, scientifically strange thing happens. I'll tell you. When people in road traffic anger, when they get angry, they throw a medical diagnosis at you, followed by treatment. In anger. Have you noticed it? The moment you have this road traffic, some brawl over there, suddenly they throw a medical diagnosis. Abbe ande? Blind or what? Can't see. 3.5 myopia. Myopia. From there. Can't hear what? Deaf. deaf, take Siemens hearing aid, promo code is also there. Mentala, go to Nimans Gangadhar is there. Dr. Gangadhar getting reference. On the middle of the road, you know. And anybody from Delhi people give me a cheer. One clap came. You're from Delhi, oh man. And then all the more reason. See, something scientifically strange happens to people from Delhi NCR when they get into some road traffic accident. Like something very strange happens. And I don't know what happens neurologically. They have early onset dementia, sudden onset Alzheimer's. They forget everything and they look at you and say, "Tu janta main kaun hu? Tu kaun hai be? Tu kaun hai janta main kaun hu? Tera baap kaun hai? Mera baap kaun hai? Hamara baap kaun hai?" You know, kisi ko nahi pata. Everybody's. I didn't want to get into this because I know I'll first of all miss that appointment and the patient, you know, my ratings will go down and all of that. So I learned the art of intimidation, which means how not to fight. Okay, it's very important. How to scare someone so much with your appearance that they run away. And I followed one person in our country whom nobody fights with. Nobody dares to take panga with this guy. He is the bhai of Bollywood. And nobody takes any panga with this guy. And I follow this guy so much, like I studied everything. He's literally my role model. You know, like all his minor things that he does, like literally walk in his footsteps. You know, like, you know, koi buck karta bahut gussa ho jata hai. I don't like the buck, you know, it's like, the buck stops there, right? What I learned from this bhai of Bollywood, no, you know, he does three things that people, you know, get scared to fight with. One is wears a jacket all the time, you know, always wears a jacket. Keep sniffing something. Like you've taken something the NCB is looking for, you know. People are like, no, we won't fight with that, don't know what he's taken, right? And third is, you know, look very stiff and strong, you know. Always look like your eyes are like this. You don't know what this guy will do, right? So I saw there were two youngsters, like college-going kids. I was like, I'll just scare them, they will go away. So I came out of my car, closed my door. I walked towards them in slow motion. They're looking in the rearview mirror. They're like, my God, whom have we fight with, you know? This guy's coming with a jacket. I'm sniffing my nose. I come in front of the car. I keep my leg on the bonnet, okay? I'm looking into their eyes. They're scared, they're terrified, you know? And then I learned something from Haryana. Happened to me 3 weeks ago. If you want to scare someone so much that they immediately run away, just try to take out a gun from your jacket. Their real one comes out, here only pretend. So I was like, I'll do that, this guy will run away, right? So I'm looking angrily, I can see his soul, right? I put my hand inside to take out a gun, you know. He gets so scared, so terrified. He comes out of the car, opens the door, looks at me and says, "Abbe Deepak, tu?" I'm like, I got confused. Like my joke on me only. The other guy comes out, starts singing the national anthem. So I'm standing till he finishes the song. I see there's a girl sitting behind. I thought maybe I'll talk to her. She looks at me, smiles, my phone rings. She's like, "Very good morning, sir. Shobha from Accident Loan Department. Do you want a loan?" So with that, guys, thank you very much. You've been a wonderful audience. Thank you. Okay, I usually don't get so many laughs and claps, so let me just kind of record this to show my friends. So let's do this one more time, guys. Thank you very much, guys. You've been a wonderful audience. Thank you. Thank you, thank you. Lovely, lovely. See, this is why I love performing to our Indian audience, to our own brothers and sisters, because, you know, jo chahiye mang lo. You know? They give it. You try to take it out, they won't give. But with that, thank you very much, guys, and I had a great time. And over back to your host, and thank you, and hope to see you again. Bye-bye.
All right, I think we can give a bigger round of applause. And I was just dying to say this. Let's give it up to JC. Jagdish, it was an absolute amazing session. Thank you so much for that. And now, I think we've all been waiting for this particular artist to show us his skills, because I've been waiting to see what exactly he's going to bring forth to all of us, and I'm sure you're going to enjoy it as well. So I'd like to introduce you all to Venu Gopal. He's going to be working out from there. He's going to be creating his art from there, but of course, we will definitely get him back on stage in a bit. So he is an international sand artist from Hyderabad, and of course, he uses sand with his hands, of course, to create emotions and expressions through art. He's performed for our Prime Minister, Narendra Modi, many celebrities, and he has participated in multiple events and television shows, also at the Isha Center for Mahashivaratri and Rally for Rivers. And he has been the first winner in 2016 for a national TV reality show, and he holds 4 world records. Let's put our hands together and welcome Venu Gopal. with Rainbow Children's Hospital. You'll have a quick look at what's we're going to be creating. Any guesses? Absolutely right. Of course, a tribute to beloved Apu, as we all know him, Puneet Rajkumar. Fantastic human being, fantastic actor, great tribute. Connecting Rainbow Children Hospital, of course, and taking us back to Puneet Rajkumar's childhood. That was exactly what he created for us. Take us through a day in the life of Rainbow Children's Hospital, starting with, of course, the hospital itself. Bringing families together, starting off with the couples, the husband and wife, as they make their way to, of course, Rainbow Children's Hospital. joy and happiness, as you can perceive, from doctor to patient. Beautiful moment when the child is conceived. Indescribable moment for both doctors, families, couples, when the child is conceived. A total moment of joy when the baby is born. And nothing compares to this world more than mother's love. of course, in the very able and capable hands of all the doctors at Rainbow Children's Hospital. Doctors are always there when it comes to illnesses, when it comes to accidents, making sure that your child is truly taken care of with the best facilities. Those appointments and meetings with our doctors and specialists, making sure that we take utmost care of your child. No matter what your child goes through, we have all of our doctors and specialists attending to give you the best care for the family, for the child. Whatever the services you require, we are there for you.